हेलो।
हेलो। हेलो हेलो।
हेलो वन, हेलो वन, वन। हेलो चेक। हेलो। ठीक
हेलो
है।
चेक। हेलो, इधर का साउंड देखो। हेलो चेक। हेलो। हेलो चेक।
हेलो चेक।
हेलो
हेलो।
चेक। हेलो।
ठीक
हेलो
है।
चेक। हेलो, इधर का साउंड देखो। हेलो चेक। हेलो।
साउंड ठीक है सतीशा।
हेलो चेक। मेरा
हाँ, आप ही का बोल रहे हैं।
ठीक है।
हाँ, ठीक है रहा।
कोई दिक्कत नहीं ना? ये देखो, वीडियो सब चल रहा ना
एक
ऐसे हाथ।
मिनट राकेश भैया लॉगिन कर
हेलो।
लो।
हेलो चेक।
वीडियो
हेलो,
दिखाने हैं।
इधर का साउंड देखो। हेलो चेक।
हाँ, साउंड
हेलो।
ठीक है। ठीक है सतीशा।
ठीक है ना? वीडियो वीडियो ये हाथ
हाँ,
मेरा
आप ही
देखो
का
तो।
बोल रहे हैं। वीडियो
ठीक
देखिए।
है।
हाँ,
वीडियो
ठीक है रहा। ठीक।
हाथ रुक रुक नहीं ना रहा है, चल
कोई
रहा ना
दिक्कत
पूरा?
नहीं ना,
हाँ, ये
रुक नहीं
देखो
रहा।
वीडियो सब
हाँ,
चल रहा
वीडियो
ना
ठीक है,
ऐसे हाथ।
राकेश
हाँ।
भैया लॉगिन कर लो।
हेलो चेक।
वीडियो
हेलो,
दिखाने हैं।
इधर सुन देखो। हेलो चेक।
हाँ, साउंड
हेलो।
ठीक है। ठीक है सतीशा।
ठीक है। वीडियो वीडियो ये हाथ
हाँ,
मेरा
आप ही
देखो
क्या
तो।
बोल रहे हैं। वीडियो
ठीक
देखिए।
है।
हाँ,
वीडियो
ठीक है रहा। ठीक।
हाथ रुक रुक नहीं ना रहा है, चल
कोई
रहा ना
दिक्कत नहीं
पूरा?
ना,
हाँ, ये
रुक नहीं
देखो
रहा।
वीडियो सब
हाँ,
चल रहा
वीडियो
ना
ठीक है,
ऐसे हाथ।
राकेश
हाँ।
लॉगिन कर लो।
हेलो चेक।
वीडियो
हेलो,
दिखाने हैं।
इधर सुन देखो। हेलो चेक।
हाँ, साउंड ठीक है। ठीक है सतीशा।
अरे रिपीट हो रहा है हमसे, तुम सिर्फ बात करो तो, और कुछ नहीं बात करो। हेलो चिट्टू। हेलो। हेलो। देखो। हेलो चेक।
हाँ, साउंड ठीक है। ठीक है सतीशा।
अरे रिपीट आ रहा है, रिपीट। हेलो।
हाँ, बोलिए सतीशा।
अरे हमसे सिर्फ माइक में बात करो ना, रिपीट हो रहा है तुम्हारा साउंड।
नहीं, वो
बोलते
यूट्यूब
रहो।
पे चला रहे थे भैया। राकेश भैया उसी में यूट्यूब खोले हुए थे।
ओ, अभी
हाँ।
ठीक है ना?
हाँ, अभी ठीक है। हल्का बढ़ाइए तो। नहीं नहीं, ये
बढ़ाए।
बात है। हाँ, ठीक है।
हेलो चेक। हेलो हेलो, ठीक है।
ठीक है, ठीक है, ठीक है, ठीक है, ठीक है।
ठीक, वहां से कम बेसी कर सकते हो।
हाँ, ठीक है। ठीक।
ठीक। हेलो चेक। हेलो ठीक।
हेलो चेक, 1 2। हेलो चेक। हेलो चेक, 1 2। हेलो चेक।
हेलो।
हाँ, बोलिए सतीशा।
नहीं नहीं, ठीक है।
हाँ वो हम साउंड उधर से हल्का सा कम कर रहे हैं, जब देना होगा बोलिएगा। ठीक है, कम कर दिए हैं, हल्का हल्का है। हेलो 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 वन। हेलो।
हरी और देख लेंगे। इसको ऑन करो ना। ऑन हो गया, ठीक। Good morning, all. So we are starting with pre-conference workshop that is on meniscus repair. So I'll request Dr. Rohit Kulkarni for his talk. Hands-on workshop will be after the conference in the evening. So right now it will be only lecture. So Dr. Rohit Kulkarni, please.
Good morning, everyone. At the outset, I would like to thank Arvind Gupta sir and the organizing committee for this wonderful opportunity. So today I'm going to talk about pearls and pitfalls in meniscus repair. So not going to go into too much of details, but we all know that the meniscus is a fibrocartilaginous complex consisting mainly of type 1 collagen fibers, and they are oriented in a circumferential fashion. There are radial tie fibers and some superficial fibers which are randomly oriented. We know that according to the zones, there are three zones of the meniscus. According to the vascularity, there are three zones of the meniscus: the red, the red-white, and the white zone. The important functions of the meniscus are load bearing and transmission, the transmission of hoop stresses, joint lubrication, and they also contribute to stability, especially they are important rotary stabilizers. So this is how the hoop stresses, the axial load is converted into hoop stresses with the help of the menisci. Meniscus tears, as we know, are traumatic as well as degenerative. Traumatic tears are mostly due to axial loading as well as pivoting activities of the knee, whereas degenerative tears could be atraumatic or due to repetitive microtrauma. There are different types of tear patterns in the menisci, such as longitudinal tears, radial tears, bucket handle tears, horizontal tears, flap tears, complex tears, and those tears which are there at the meniscocapsular junction, and these are called as ram tears. Depending on the tear patterns, we can divide the menisci into four types. Grade 1 is meniscus, which is centrally located, and there's a small punctate lesion or an intra-substance intensity. Grade 2 is a lesion which runs horizontal but does not exit the meniscus surface or the articular surface. Grade 3 is the one which reaches the meniscal surface, which is called as a complete tear, and grade 4 is a complex tear. So factors helping in healing of the meniscus: age of the patient, probably location of the tear. Peripheral tears, obviously in the red zone, have a higher chance of healing, and simple tears have a better chance of healing than the complex ones. So age as an independent factor should not be considered a contraindication for meniscus repair, and your aim should always be to go for repair first. Treatment protocol, we all know: conservative versus surgery, repair versus meniscectomy. Alignment correction is important, and you can add some biologics to your repair. Is there a role of conservative treatment at all? Probably for small tears less than 1 centimeter, mostly in the red zone. Grade 2 asymptomatic tears, stable peripheral tears after doing the instability surgery, because many of the times they could be associated with ligament injuries. And asymptomatic tears in elderly patients with advanced OA, where it could actually be kind of a futile exercise if you try and repair those. So quite a few papers commenting on the conservative treatment of the menisci. So always try to remember that repair as the first policy, especially the traumatic tears in the red zone and the red-white zone. The white zone tears could be balanced, and you can consider partial meniscectomy in complex tears with questionable healing, failed repairs, or symptomatic degenerative tears in advanced OA like we saw previously. So why meniscus repair? Because without the meniscus, there is a 75% decrease in the contact area and 235% increase in the contact peak pressure transmitting through the knee joint. And the long-term outcomes of arthroscopic meniscus repair are significantly better than outcomes after partial meniscectomy in terms of slowing the osteoarthritic process and return to pre-injury levels. So what are the pearls for a good meniscus repair? The first and foremost thing is have adequate armamentarium ready with you with zone-specific cannulas, your all-inside devices. And of course, for outside in, you need not have a lot of things, but at least some basic stuff such as fibers, wires, and needles. And depending on the zone, choose your repair technique. If you're doing an anterior horn tear, you can do an outside in kind of a repair. For the body, you can do an inside out kind of a repair or an all inside repair. And for the posterior horn, you can choose an all inside kind of a repair. Another important point is freshening of the meniscal edges. So shave off the perimeniscal synovial tissue, and then you can use a rasp, something like this, a diamond rasp, to freshen the meniscal edges. So a good paper here by Tapaswi sir and Dr. Anshu Shekhar about the safety incisions. And these are important when you're doing inside out kind of a repair on either the medial side or the lateral side. For me, pie crusting of the MCL is the most important step, especially when you are repairing the medial meniscus tears. And the pie crusting technique, it helps you to have a better visualization, and that is extremely important when you're doing your meniscus repairs. So have your surface and surface landmarks ready, and you can do pie crusting at the femoral end, which I prefer because it has got better chances of healing, and multiple small punctures will open up the joint space and it will reduce the risk of iatrogenic cartilage damage. So this is how you can do it. Mark your surface markings, and it opens up, the joint space opens up nicely. Regarding the tear-specific pearls, so HCTs, which we do, it's very important that you freshen them nicely, and then you take small, all-inside kind of a, you can use a all-inside kind of a device and try and repair them and close the fish mouth. Or you can also use something which like a first pass or scorpion device and then take knots and repair these devices. These tears. So these are the bucket handle tears, and they classically appear like this. I'm going to talk about that later. But what you can do that after reducing, you can take a reduction stitch, and that's mostly at the junction of the body and the posterior horn. And then for the rest of the body, you can do something like an inside out kind of a combination. Here I'm taking horizontal to cover a larger span of the meniscus, but remember that the vertical mattress stitches have a better biomechanical advantage over the horizontal ones. And so even the bucket handle tears, they give you nice kind of a stability after completing the repair. For the ramp lesions, I would say it's very important to establish the posteromedial portal. And while looking at these ramp tears, you can establish a window between the PCL and the medial femoral condyle. And then you can pass your scope through there and visualize the ramp area. Then you can establish the posteromedial portal. And once you see the tear, you put a cannula there because that is probably going to be your working portal if you're going to do a lasso kind of a device. And you can, sort of freshen up the ramp edges. That is very important. Once you use that, you can introduce your lasso device through the posteromedial portal and take bites through the meniscus and the posterior horn, through the capsule and the posterior horn of the meniscus, and then pass your nitinol wire. After that, you just retrieve these threads through the posteromedial portal, and that will help you in, passing your sliding knot. So looking at it from the outside, if you look at the sliding knot, this is how you can retrieve the threads. And then you can, so that's the outside picture. And then you can pass your sliding knot and you can just gently push it in. And then it sits nicely like this over the meniscus. This is while viewing from the posteromedial portal. Once you have taken a couple of stitches, you can view through the posteromedial portal and see how your ramp repair is looking like. You can already see the ramp is closing down after taking a couple of stitches. I normally complete the ramp repair by taking an all inside kind of a stitch for the remainder of the ramp. And once you sort of take your all inside stitch, your ramp, while you're tightening the, sorry, I'll just run this video here. As you're tightening your all inside device, you can see the capsule nicely closing. And this can be done in a bit of extension in around 15 to 20 degrees of knee flexion rather, so that the ramp is well reduced in that particular position. Radial tears almost act like a subtotal meniscectomy, and that is because the circumferential fibers are, disrupted. So there are a lot of suture configurations available, such as side-to-side tears, ripstop, hashtag, and this is a good paper by Jorge Chela, commenting on meniscal radial tears and the different tear patterns, different suture configurations which you can use. So for ugly looking tears like this, these are called as oblique tears or parrot beak tears. They sometimes extend into the red zone. Many a times you are just tempted to, sort of do a meniscal balancing in these cases, but always try to repair those as your first policy. The next pearl I would say is a combination of techniques wherein you can, use your inside out and outside in kind of a technique, and you can also save on a bit of cost. So for tears appearing like this, it's better to shave off the flap portion of the meniscus, and then you would be able to visualize the meniscus a bit better. After that, you can use a combination of techniques such as inside out and an outside in, and then have a stable kind of a repair in the end. So alignment correction, is it important? Yes, because concomitant alignment correction has better healing rates in meniscus tears following repair. Adding biologics, we can do that. We can use a fibrin clot, we can use PRP, or we could also use something like a microfracture. Coming to the pitfalls, yes, it does come with its own set of pitfalls. So inadequate visualization for me is probably the most important pitfall. So make sure that you get good visualization before going ahead with a meniscus repair. Suture mishaps such as suture slippage, over tensioning of the meniscus. So be very gentle when you are tensioning. Always use a probe to give a bit of counter and then gently tension. Otherwise, there are chances that your meniscus might get extruded. There is a risk of neurovascular injury, and that is why it is important to establish the medial or the lateral safety incisions so that you can withdraw your flexible meniscal needles safely. Post-op failures, we tend to keep these patients non-weight bearing post-operatively for a period of 4 to 6 weeks. So that is what is recommended in the literature. So if that is If there is non-compliance with the bracing, then you might end up with a failure. So the failure rates in the literature have been documented from around 15 to 20%, on an average 19.5% in some meta-analysis, and around 20 to 21% of reoperation rates. Higher retear rates probably in bucket handle medial meniscus tears and those tears like we saw, which are there in the white zone. So take-home message today probably would be menisci are extremely important stabilizers of the knee joint, and they increase the meniscal tears, increase the joint stresses and advancement of early OA. Identify the hidden lesions such as the ramp and root tears, which are commonly missed. I've not commented on root tears because my dear friend and colleague is going to speak about those in the next lecture. Concomitant axis correction gives better results. Meniscus healing is still questionable in patients with degenerative osteoarthritis, so always tread with caution in these cases. And policy of repair first and exercise later as far as possible. Thank you.
May I request Tapis Sukla to for his lecture?
Good morning, everyone. So this is going to be a very basic presentation on the meniscus repair techniques. I'll try to go it as quickly and comprehensively as possible. So we have already discussed meniscal vascularity, anatomy, and the deciding factors on whether to go ahead with repair or partial meniscectomy. Let's go straight away with the meniscal repair techniques. There are basically three techniques that we need to know. One is outside in, inside out, and all inside. Let's take it one by one. Now, first, let's start with outside in technique. It is a very cheaper alternative for your meniscus repair. It is good for your anterior horns reaching up to the mid body. It is not that technically demanding. All you need are some 18 gauge needles. Then take bites to the torn as well as the remnant meniscal fragment. Use 2 needles, pass sutures through the lumen of the needles, retrieve the sutures outside, and then tie them up on the capsule. That's all you need to do for your outside in repairs. Inside out repairs are again a very good, cheaper alternative for your meniscal repairs. All you have to do is use the double lumen cannulas. They come in various curves and various shapes and various bends so that you can actually maneuver and reach all the different parts of the meniscus. They are good for your body and the posterior horns of the medial meniscus. It becomes very tricky to use inside out repairs in the lateral meniscus tears, but I believe you can actually do it. It is almost impossible to use them for your anterior horn tears. All inside devices, they come in various by various brand names. This is one Sure Stitch by Ceronics. It is very handy to use, although it is costly, and yes, cost is a very defining factor in the use of your all inside techniques. But for posterior horn tears, we have no other alternative but to use them, especially for your lateral menisci. So now let's take a case scenario and learn each technique step by step. We've got a 20-year-old male, injured knee 6 months back while dancing. There's a history of previous ACL reconstruction surgery done 6 years back. Now, the patient has presented with the symptoms of locking and instability. On examination, Lashman test was positive. Medial joint line was tender. X-ray shows relatively maintained joint space. However, as you can see, the femoral tunnel is not as ideal as we would like it to be. These are the MRI images. MRI images does show us a complete graft tear, and as you can see here, probably this is the double PCL sign, which is almost pathognomic for your bucket handle tear of the medial meniscus. So the plan in this case was to go ahead with revision ACL reconstruction, medial meniscus repair, and IT band tenodesis. So this is your bucket handle fragment in the intercondylar notch, and this is your torn ACL. The first step is to try and reduce the bucket handle fragment. Okay. Once you've reduced it, then you have to look for our techniques, to repair it. For making sure the biology is on our side, use the diamond rasp for rasping, do your trephinations so that the vascularity increases. Then we have to do our reduction stitch. Now this is your inside out repair. Now for inside out repair, we are using double lumen cannulas. Make sure you place them appropriately. You've got two needles that you can use. One, as sir was discussing, you can pass it in two configurations, either a vertical mattress or horizontal mattress. In a vertical mattress, one needle goes through the remnant as well as the capsule. The another one goes through the torn fragment and the remnant. Here I'm using a vertical mattress configuration. Pass both the needles, retrieve the sutures outside. Once you have retrieved, you can take a safety incisions. This is again a double lumen cannula, vertical mattress configuration. The first needle is going through the capsule and the remnant. The other is going through the torn fragment and the remnant both. Retrieve the sutures outside. Take your safety incisions. Make sure that there are no neurovascular structures. And then tie them up on the capsule outside. This is how your inside out repair is done. After this, the attention is turned to the posterior horn. All inside meniscal repair devices works beautifully here. You have to take first bite either through the capsule or through the torn fragment. Deploy your peak anchor. Take another bite to the remnant fragment. And then deploy your another peak anchor here. We'll be using these in the workshop. You get a thread outside, just pull on it and the torn fragment reduces automatically. Just one pearl here. While doing this, make sure if your meniscal fragment is everting, use your probe. And if it has already everted, use another stitch to counter the eversion. This is again, we taking the bite through the body of the meniscus. Deploy your peak anchor. Don't worry when you're taking out the needle and if the fragment is losing its place. Do not worry because it's going to fall back once you pull on the thread and the two peak anchors come together. You pull on the thread. Now this is the last technique, which is our outside in technique. All you have to do is use two needles, one through the capsule and remnant, one through the torn fragment. You pass sutures through each the needle and then you shuttle them. You have to be a little patient. It is not that difficult to do. I've already withdrawn the above needle. Now this needle would be withdrawn and our fiber wire would be passed. And then again, after retrieving the sutures outside, we can tie them up on the capsule. After tying, this is going to be your final repair. Your entire bucket handle is beautifully sits in its place. You've taken care of the biology, do some microfractures. But here in this case, I was already doing a revision ACL reconstruction, but I didn't go ahead with microfractures. Pass your graft. And then you're done. So the take home message is always try to preserve the meniscus, go for meniscal repair. Choose your repair techniques based on the zone of injury, and a stable and well-aligned knee are prerequisites. Thank you.
Hmm. Good morning, everyone. First of all, let me take this opportunity to thank the organizers for inviting me here for this wonderful meeting. I think the regional conferences like these are absolutely necessary to spread the knowledge of arthroscopy far and wide all throughout the country. And I really thank the organizers again for organizing this wonderful conference. I'm going to talk about meniscus root repair step-by-step technique. Basically, I also have a talk in the conference on meniscus root where I'll be covering all the theory part. So this is going to be just a surgical demonstration. First of all, I'll be talking about the history of root tear. It's a very interesting history if you go back and read the literature. The first recorded meniscus root avulsion injury dates back to 1935, when there was not even an MRI available. He utilized plain radiographs to describe it as an ossification of the internal semilunar cartilage. That's what they called the meniscus then. And that probably was an avulsed root, which was seen as an ossified cartilage or ossified semilunar thing. In 1991, Pagnani et al., after the advent of MRI, described the first reported case of root tear in literature, where he reported a case of medial meniscus subluxation associated with an avulsion injury to the posterior horn root. In 2004, it was Dr. Rob Laprade who first described a transosseous surgical repair technique using bone tunnels for lateral meniscus root avulsions. And that's how root tears came into vogue, and the root repairs came into vogue after that. So what exactly is a root tear? If we were to describe it, it is a tear which is characterized by a radial sort of a tear within 1 centimeter of either the anterior or the posterior meniscotibial attachment, or by a complete avulsion of the meniscus from its tibial attachment. How has it been classified? If we look at the classification, which is again being described by Dr. Rob Laprade, type 1 is a partial radial tear near the root. Type 2 is a complete radial tear which lies within 1 centimeter of the root attachment. A type 3 is one which is associated with a bucket handle type of a meniscal tear. Type 4 is an oblique tear which extends into the root, and type 5 is a root avulsion. So here I'm going to describe a type 2 tear, which is basically the commonest sort of tear that you'll see. And we're going to go through the step-by-step technique of repairing these type 2 tears. The first step is verifying the presence of a posterior medial meniscus root tear. Generally, it is medial meniscus that you will be encountering as the posterior root tear with arthroscopic visualization and probing. So that's how you would see the root tear. Basically, you have to do a little bit of pie crusting on the medial side to open up the medial space so that you get good visualization of the posterior part. And as you, I'm so sorry. So as you then visualize this tear, you have to do a little bit of release, because there is going to be some scar tissue which is going to keep the torn part adhered to the capsule. So you have to release the root tear, then inspect the root tear and debride the root attachment with a curette. So you use a curette to make sure that you are debriding and removing the cartilage where you want to make your tunnel. So you're going to make a transtibial tunnel there. The exit of the tunnel inside the joint is going to be exactly where you want to attach your root. The next step is going to be placing 2 simple or luggage tack sutures through the torn meniscal root. So you use your antegrade suture passing device to take bites into the torn root, and these can be either a simple suture or a luggage tack suture, which I prefer. Then there comes the step of drilling a transtibial tunnel that extends down to the anteromedial portion of the tibia. You make sure that you keep your zig exactly where you have curated the cartilage, and then you pass your pin and over drill it with a 4 mm drill bit, and then you retrieve the luggage tack suture ends through the tunnel. So once you retrieve those sutures, and as you pull them down, you're going to see that the root sits very nicely on its desired location. So once this is sitting well, then you go ahead and tie the sutures over a surgical button on the anteroproximal portion of the tibia with the knee flexed to 90 degrees. So this is how you're going to have your tunnel there, which you are going to tie, and you can use various devices to tie these sutures there. The one that I commonly use is from Ceronics. It's called T-button R. So there's a small video demonstration of T-button R here. So the advantage of this is a peak implant, and you can see that it has a thread-in-thread configuration which helps to pass on sliding knots as well once you put the button in its place. The plug sits nicely and you can get a good robust fixation. So doing a transtibial root repair is not as difficult as it may seem at the first go. But once you get a hang of it, I think root repairs are extremely easy to perform, especially the transtibial one. In my talk later, I'm going to talk about the other techniques of repairing the root, like using posterior suture anchors as well. But this is a standard technique which is commonly used. The rehabilitation involves 3 phases. The phase 1 is 0 to 6 weeks, where you keep the patient non-weight bearing and put the patient on a hinge knee brace locked in extension. You schedule passive range of movement exercises with the range of motion restricted to 0 to 90 degree of flexion to avoid deflection. Phase 2 begins at the end of 6 weeks and continues to about 12 weeks, where passive ROM slowly is increased beyond 90 degrees and active ROM is began. And weight bearing is initially with the walker, and you gradually progress to full weight bearing at the end of 8 to 12 weeks. And phase 3 is where the patient does deflection exercises and sports activities with strengthening exercises as well. I'm going to talk, as I said, about details of all of this in my talk later. And this is just a surgical demonstration. We would be also using this T-button R in the workshop later in the evening. And I'm sure all of you will get a good hands-on experience with that as well. Thank you.
Thank you, Dr. Amit. Now, may I request Dr. John sir, Dr. Vikas Kapoor sir, Dr. Ritesh Renu, Dr. Manish sir, Dr. Rajiv Gupta sir, and Dr. Khurshid Alam sir on the stage for lamp lighting, please. And Dr. Janki.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
चढ़ायो अच्छा गजमुख को धूंधिल लाल बिराजे सुत गौरी हर को हाथ लिए गुड़ दंडू साई सुरवर को महिमा कहे न जाए लागत हूँ पद को जय देव जय देव।
May I request Dr. John sir for welcome message?
Good morning, everybody, and welcome to the 9th Bihar Arthroscopy course. This course started many years ago. Initially, it was a much smaller affair, was being held in Paris Hospital itself, and it's been run every year, except for a couple of years because of COVID. I think Arvind has been the lead the person who's been really behind the course and is involved in the organization mostly. And you can see that over the years, it's grown from strength to strength. And now you have a whole lot of faculty. Unfortunately, a few of them couldn't come in the last minute due to medical reasons, which included my good friend, Dr. Anand Joshi from Mumbai, Dr. Debashish Chatterjee from Kolkata. Of course, we have Dr. Vikash Kapoor here, who's an old friend of mine, so that's great. And all of you, all the faculty who've come from various places around the country, welcome all of you here, and I'm sure the delegates are going to really benefit from this course. So with those few words, I would welcome all of you to this 9th Bihar Arthroscopy course. Thank you. This time we're going to cover, today, we're going to cover the knee and tomorrow the shoulder. Thanks.
May I please call Dr. Ritesh Runu sir, Dr. Khurshid Alam sir, Dr. Bhushan Sabni sir, Dr. Kaushlinder sir, and Dr. Rakesh sir for chairing this session. And may I call Dr. Ravi Kumar to give his, Dr. Shiv Choksi to give his talk on meniscal flap tear, repair or resect.
So a very good morning to everyone. Thank you, Dr. John sir, and thank you, Dr. Arvind sir, for having me here. It's my extreme privilege that out of the 9 courses, I think I've been here for about 4 to 5 times, and I've seen it, as sir mentioned, I've seen it grow since the beginning. So I'll be quickly taking you through the flap test. There are other topics of the other types of meniscal repair which will be also discussed, but this is sorry. So this is a subset variety where I'm going to speak about the meniscal pathology, wherein there is a partially detached meniscal fragment where there is a remaining tethered base which is connected to the base, and that usually causes an unstable flap. And that unstable flap causes, which displaces into the joint and causes mechanical symptoms like locking and acute pain. These flaps are also prone to incarceration between the condyles, and that leads to very deteriorated quality of the remaining meniscus. So these flap also present with acute pain, acute onset of pain when the flap is once developed. So looking at the subtype, there could be a parrot-shaped type. There could be a flap which is going upwards, turning upwards into the femoral condyle, like you see in this video. And it is very essential that, once you once you probe the meniscus, you try to probe out the superior surface as well as the inferior surface, as well as we can see it in this one. There's a big flap which has turned inside into the tibial recess, and that is very essential that we pull it out, because on the prima facie of it might look like appear as a normal meniscus with in continuation, but it is very essential that we try to probe it out and bring it out of the meniscus, which is adhered flap. This is a horizontal cleavage flap, also most commonly seen in degenerated meniscal tears. And there is a horizontal cleavage flap of the meniscus. Stability is very essential to assess because that decides the treatment plan. if it's a stable flap, it could be left, it could be repaired, it could be balanced little bit. But if it's an unstable flap, most of it usually has to be removed, and you are left with repairing or trying to preserve, when you're trying to preserve the meniscus, a very small bit of it. Incarcerated meniscus most likely have to be removed because they have been crushed between the condyles, and the meniscal and the vascularity has really been compromised. They present with pain and the other presentations of the meniscal tears, but definitely the pain is much, much more. And if you have a good joint line tenderness, and also a lot of times you can feel the meniscal flap. If you try to palpate the joint line, you can at times feel the meniscal flap underlying the meniscus and in the joint area. MRI mostly is very conclusive, and you need to have a sharp look at the meniscus and the morphology of the meniscus. There are also a couple of it's if there's a downward turning, it's called the comma sign on the MRI, and if there is an upward turning of the meniscal flap, it is also called the apostrophe sign of the meniscus. They are usually most likely and most oftenly picked up on the MRI if the MRI is done recently. If there's an old MRI, because patients have presented with an MRI which was done a few months back, which just had a radial tear, there are chances that if you don't have a recent MRI, it could be missed, and that radial flap could have upturned into a flap, or a flap tear could have been proceeded after a horizontal tear of the meniscus. So it is important that you pay attention to the MRI, and the MRI is recent. You can often find the flipped fragments. Coming to the management, as I mentioned, management is also based upon the area of the meniscal tear and how much of the portion is torn. In this case, as we see, the tear is only in the white zone, and the flap is there, more like a parrot beak kind of a tear. And this meniscus had to be balanced out. You can see the base of the parrot beak is going into the tibia. And after we see the configuration, we find that we have a substantial amount of meniscus that is still remaining. We could go ahead and remove this portion, because a white zone meniscal tear extending into the red-white zone with a fair amount of meniscal left behind, I think we can definitely balance it out and give a patient a pain-free joint. Coming to the next type of the next case, this is also a flap tear. Yeah. So now here the flap, as we can see, there is a flap, but the extension into the posterior horn is going nearly up to the root. So the unstable flap has to be excised, the avascular part, and the remaining part is then repaired. And especially the part going up to the horizontal segment, which is going up to the root, is repaired. So definitely all keen and all efforts should be made to preserve the meniscus wherever we can. But when we know there's a flap meniscus, the patient should be prognosticated that we are going to be removing quite a lot of it, because you cannot be repairing unstable flap, which is avascular. So this portion needs some repair, and which the repairing was done after the flap was removed. So you have a substantial amount of meniscus still left after the repair. This is also an interesting case where we had a young boy, and at the outset you find that the meniscus is pretty okay, but you have a big chunk of the flap which is interned into the tibia. And it actually was a discoid meniscus, where the entire discoid fragment had downturned into the tibia. And so in this case, we have removed the discoid fragment, and the extension of the parrot beak, which is going into the red zone, was then partially repaired. So this is the removal, and now the remaining part which is left is then repaired. Important part is that when we repair a parrot beak kind of a configuration, because now the flap tear has been converted into a parrot beak, we start repairing from the red zone. We get a vertical mattress here with the inside out device, so that we get the reduction in place. And once the reduction is done, and once we have the vertical configuration where we have held the meniscus in place, then we can go and, so this is the vertical. We are getting the reduction of the meniscus. Once that is done, then we can apply side to side sutures to the remaining flap or the parrot beak. So at the end of it, we have a substantial, healthy looking meniscus which has been repaired. That is the trephination and the biology induction. So the rehabilitation, if you're doing a meniscectomy, it's very fast, accelerated. But if you are doing certain amount of repair, we need to be slow on the weight bearing, because there's a lot of time there is vascularity has been compromised. So all my flap cases, I would go slow with my rehabilitation, especially the weight bearing. The movement ROM can still be allowed, but the weight bearing I delay to about 4 to 6 weeks, depending on the quality of the meniscus and the vascularity. And of course, the key home messages, whatever can be preserved, should be preserved. But definitely, if you see a flap, you have to prognosticate the patient that we are going to resect. We cannot promise them complete repair, but we have to see whatever we can repair. And minimal resection is paramount. And definitely, MRI plays a very important role, because on MRI, you are able to pick up flaps very nicely. Thank you so much.
Nice presentation, Dr. Shiv.
Thank you.
Any questions?
Absolutely, sir. So what happens is we should not be very aggressive on repairing the flap tears, as I mentioned. Unstable flaps should be resected. Definitely, there is no point in saving the unstable fragment or the fragments which have been compressed, encapsulated between the condyles. Once after resection, we should see how we can get the anatomical reduction. So like in the last case that I showed, so the first bite was taken vertically onto the parrot beak with the flap, so that we get the complete reduction. And that is also in the vascular part. Once we get the reduction, then we can take the side to side sutures, or depending on the configuration. But definitely stability is very important. And there is no harm in going in for resection if there is a very unstable and a compressed flap. Absolutely. In flap, there is definitely, you should not be, again, not very aggressive for repairing. We are definitely now very keen to repair meniscus, because we want to save that meniscus. But no, there is no point in repairing a avascular or a compressed or a compromised meniscus, because that is going to remain there unstable and certainly continue to give pain to the patient. So definitely there is no harm if we resect. And this is very important to prognosticate the patient about the resection that you might be doing on the OT table. Thank you so much, sir.
Dr. Shiv, one question I have. So in which age group do you find these type of injuries?
As I mentioned, so in the horizontal flap is very common in degenerated tears, because it progresses with a horizontal tear, which is very commonly seen in degenerative knees. But the vertical flaps, the parrot beak, is most commonly in traumatic young age group, very oftenly seen. And especially after a good sport or a activity where the meniscus is forced to turn upwards or into the inferior recess.
Yeah, because in some of the patients, we have seen that they don't come with the locking, unlocking phenomena, only with knee pain. And when we get the MRI done, we see these type of features.
So mostly what happens is also that once the flap has it is turned into the recess, it stops locking but continues to give pain. And if there is an unstable flap, so that continues to give locking and also the extension of the tears into the joint.
Thank you.
May I please call Dr. Kaushalinder Kumar to please chair this session? And may I please call Dr. Rohit Kulkarni to give his talk?
Good morning, everyone. So this talk is going to be about bucket handle medial meniscus tears. Again, thank you, sir, and thank you, the organizing committee, for this wonderful opportunity. So I'm not going to go into the details of that because we already saw this in the morning. So if you look at the types of meniscal tears and their progression, the longitudinal tears are the ones which can progress to bucket handle tears, and essentially they are a subtype of the longitudinal tears. The frequency has been reported to be around 9 to 26%, more commonly in young and middle-aged adults. A high male predominance and more predilection for the less mobile medial meniscus. And there is a strong association between an associated ACL injury. So signs and symptoms, noteworthy point would be a locked knee or inability to completely extend the knee because of the flipped meniscal fragment in the intercondylar notch. A classification which has been described, and we can read this paper, which is called as Dandy's classification, and there are 4 types. So type A is a complete tear, type 2 is an incomplete tear, and type C and D are called as broken bucket handle tears with an intact posterior or anterior root attachment respectively. I think this is very important because most of the bucket handle injuries can be diagnosed with the MRI scan. So the absent bow tie sign is something which is commonly seen. So on successive, consecutive or successive sagittal images, you will see a nice disc-like structure resembling a bow tie. And in cases of a bucket handle tear of the meniscus, the body portion will be absent, and that is called as an absent bow tie appearance. Double PCL sign is something that we all are aware of. And the second PCL is the flipped meniscal fragment. The flipped meniscus sign wherein the posterior horn appears to be shortened because a part of the meniscus has flipped anteriorly. There is a fragment in the intercondylar notch. It is called as the fragment in the intercondylar notch sign, and there is a band-like area of low signal intensity which can be seen in the intercondylar notch, but not in the same section as that of the PCL. A double anterior sign is quite commonly seen, wherein the red arrow here is the intact anterior horn, whereas the dashed arrow is the one in which the bucket handle fragment has flipped anteriorly. And then the disproportional posterior horn sign, wherein the posterior horn appears to be shortened. So it's important to know at least 2 or 3 of these signs because MRI is a proven accurate method to non-invasively diagnose the bucket handle tears, and we should always look out for the MRI scan before venturing in. So MRI assessment of repairability criteria have been established. Probably this article is important in terms of that. So a peripheral rim segment less than 4 millimeters wide, a tear length of 1 centimeter or greater, and minimal damage to the meniscal fragments. So in these cases, you can actually go ahead and do the repair. So repair techniques, we talked about that. So anterior horn, again, just to tell in brief, is the outside in repair, inside out for the body and all inside for the posterior horn. This is a good arthroscopy technique paper. It has been published recently in August 2025. And it tells you about 10 pearls of bucket handle medial meniscus repair. And these are easily reproducible in your day-to-day kind of practice. So right from patient positioning, which we can normally, I think most of us do it this way. I just keep a NS bottle instead of the bolster. A portal placement, which is mostly a standard portal placement. You can take a transpatellar portal if you want to do a bit of suture management. Evaluate the tear properly, and a preliminary reduction with the help of either a probe or an obturator. MCL pie crusting, again, like I said in the last talk, is very important because you have to visualize it properly and then only go ahead with your repair. Inadequate visualization might lead to iatrogenic cartilage injury. So this is how you can do it. A good, you can rasp it and shave off the perimeniscal tissue. Repair technique, choose your repair techniques wisely. And tying of the knots, you can take a small safety incision for retrieval of your threads and then tying the knots to avoid any kind of neurovascular injury. Safety incision, again, on the medial side as described. So a small 3 to 4 centimeter incision on the posterior medial aspect of the knee, just posterior to the MCL, and try to find a plane between the posterior medial capsule and the medial head of the gastroc tendon. So coming to the cases, a 33-year-old gentleman with history of twisting injury of the left knee. So he presented to us almost 1 month. So he had a concomitant ACL tear and a bucket handle tear of the medial meniscus. And his range of motion was terminally restricted because this is quite often the case in bucket handle medial meniscal tears. These were his MRI images, and you can see in the sagittal MRI a classical double PCL sign. And you can also see the flipped anterior horn, a double anterior horn sign, wherein the flipped portion of the meniscus. So the third Is there a pointer here? So the third image on the upper row, you can see that the meniscus fragment has flipped anteriorly. In the coronal images, again, you can see that a part of the meniscus has fallen inside the intercondylar notch and it is lying in the intercondylar notch. So I think Dr. Tapish described, but in the morning, but again, reduction of the meniscus is important. You can do that with the help of an obturator or with the help of a probe. After doing this, what is important is doing a bit of pie crusting of the MCL so that you get a good visualization. Many times these tend to pop out. Do a bit of, rasping and then go ahead with your repair. So my first stitch is always going to be the one at the junction of the body and the posterior horn. We call this as the reduction stitch or the holding stitch. And once you take that stitch, your meniscus is more or less stabilized. So once you take the stitch, make sure that when you're tightening, you're always giving some kind of a counter with the help of a probe so that it sits nicely in place. So the tightening should be a gentle process. It should not be, otherwise many a times your anchor might just, come out. There is an upturning of the meniscus here, but I'm going to show how we can tackle it in the subsequent part of the video. And after cutting this knot, you can then turn your attention to the body of the meniscus. And you can use multiple sort of vertical mattress kind of a configuration for the body, wherein you can use meniscal needles. These are flexible kind of meniscal needles. I normally take, if you're taking a medial safety incision, I normally take an autoclavable spoon, which is easily available. A Henning's retractor was what is recommended, but not always available. Take a spoon to withdraw your flexible meniscal needles from the medial side. Then again, you can take multiple stitches in the body of the meniscus. A vertical mattress configuration is more biomechanically superior than a horizontal mattress configuration. So I'll just run this ahead a bit. So after that, you can retrieve these threads on the medial side. Then I've addressed the upturned part of the meniscus. And this is what you can do to address the upturned part of the posterior horn of the meniscus. What you can do is you can do an undersurface kind of a stitch and in a horizontal mattress fashion so that the upturned part, it sits nicely. So this is how you can do it. So evaluate your area, put your cannula where you want to put your stitch. Take a good chunk of the meniscus on the undersurface. Then take it on either sides in a horizontal mattress kind of a fashion. Once you take that stitch, make sure that you're using your probe to good use and holding it into place so that the meniscus sits nicely into place. So this is how you can do it. Make sure that whenever you're tensioning, you do it gently so that, now you can see that the upturned meniscus is now sitting nicely on the tibial surface. After that, what I've done is to make it a bit more robust, I've used another all-inside device for the body as well. So the first bite through the capsule and the next bite should be through the intact part of the meniscal tissue. And then you can, sort of give a gentle counter with the help of your probe and then tighten your stitch so that it gets nicely seated in place with the help of your probe. You can do it. And then you can complete your rest of the repair by putting in another couple of stitches in a vertical mattress fashion, in an inside out kind of a fashion, and then it gets nicely secured. So literature shows that only 24% of the surgically treated bucket handle tears were treated using repair. So a lot of them are going in for a partial meniscectomy, but because a lot of factors come into play, meniscus devices are required, needles are required. So if you're doing an outside and inside out kind of a repair, then you can use a reusable meniscal needle and a fiber wire, and that will cut down the cost significantly. It can be technically challenging. However, we should always remember that preservation of the meniscus should be considered as the first line of treatment because of inferior clinical and radiological long-term outcomes and association with early OA with a partial meniscectomy as compared to a meniscus repair. So I think just run out of time, a couple of more cases again, but if you allow, I can show, but if... how much time? No, just 1.5. Here I have not much of a difference, but again, you can see a classical bucket handle kind of a tear. This guy presented to us late, so he was almost 1 year down the line if you look at him. So if you look at the history, and this is what we found in the MRI picture, an ACL tear and a bucket handle meniscus tear, again a classical double PCL sign. And then in the coronal images, you can see a displaced fragment. And this is how you can sort of reduce it. And then in this case, the only difference probably is I have taken a horizontal mattress kind of a configuration to span a larger part of the meniscus and, you know, try to cut down on the cost of the, try to cut down on the implant cost. And then the posterior kind, this also I have taken in a sort of a horizontal mattress kind of a suture configuration, and then you can gently tight it so that it holds, give a good counter so that the meniscus is held in place. And this is how it looks like after the final repair. And then I did a concomitant ACL reconstruction, and then have a look at your repair again after doing your ACL reconstruction and see if the meniscus is seating well. And it seems to be quite stable. All right, thank you. I think for the
Thank you.
time, I won't be able
One
to...
question I want to ask, as I am seeing that because of the lots of the nodes, meniscus become bulky. Is it creating some painful movement while there is rehabilitation while moving the knee because of the bulky position of that meniscus?
Not really. I mean, if it is upturning, you're saying, if it becomes bulky, or...
No, he is asking about the knot, not about the meniscus.
After tying the knot,
After tying the knot,
it was looking bulky because of the over tightening. So
Yeah.
usually meniscus should be flat.
flat,
And
yes.
if you are biting and
Yeah,
it
yeah,
is
yeah.
becoming some bulky,
I
will
think-
it create some
Not
differences?
really. I mean, while tightening the knots, it is important to not give too much of over tensioning. The thing that I would be worried about is causing a bit of extrusion of the meniscus. But rehab, I really haven't observed any kind of a, because 4 to 6 weeks, I keep them non-weight bearing. And if the anterior horn is not involved, I delay the knee range of motion as well. So week 1, I put them to 30 degrees, week 2, 60, week 3, 90. I do a gradual graded ROM, no knee ROM beyond 90 for the first 4 weeks. And after that, I start gradually increasing the knee range of motion. But I really haven't observed any kind of significant pain factors which are associated or any other
And
difference.
one final question. If I am resecting this white and red zone, because whatever the tear is in between the white and red,
Right.
if I am resecting the white zone, so what is the better outcome, whether to resect it or to repair it?
Repair would always be the first choice. Many of these tests, sir, they are in the red zone. Many of these bucket handle tests, the meniscus, if it is flipping inside the notch, most of it is because of that red zone, a continuous, longitudinal kind of a tear. But even if they are in the red-white zone, I would still attempt a repair. Rarely you can see a flipped fragment which is arising only from the white zone, in which case you might probably just resect it. But most of these fragments, they arise from the red zone or the red-white zone, in which case I would definitely attempt a repair.
Thank you very much.
One last question. So many a time this bucket handle, particularly the locked one,
Yes,
the
sir.
chronic bucket handle,
Yes.
become very difficult to reduce.
Reduce.
Even if it get reduced, very high chances to again
Come back inside.
displace into the notch.
Yes.
So what are your tips to keep in reduced position while you repairing the meniscus?
So a couple of tips probably. What you can do is so 2 things I would say. One is take an additional portal, and through that additional portal, keep something like a probe or a device. Tell your assistant to hold it in place. Otherwise, the second would be to take a traction stitch.
Yeah.
So you can take a
inside.
traction stitch, hold it in place, and then you can take your holding stitch and then continue with your repair.
Yeah, thank you.
Thank you.
Yeah, Sarthak wants to.
The lateral bucket handle meniscus sometimes becomes very difficult. So sometimes, you have to understand the chronicity of the tear, how old that tear is, and it's still not reducible. Sometimes we have to do a resection because even if you reduce it back, it comes back again. It might.
Yeah, it's happened many a time in chronic bucket handle. Yeah, definitely. When it is not reducible, it's not in anatomically reduced position even after the repair. So better to have resect it rather than to keep in position, and later on this will lead to pain.
Try for a repair, but if it is not getting reduced, if it is a chronic tear, the meniscus substance is not looking good, then you can consider a kind of a partial meniscectomy.
Yeah, thank you.
Thank you, sir.
Now, may I call Dr. Arun Jia for his talk on ramp lesion? Dr. Arun Jia.
Good morning. I thank the organizers for inviting me today here. So today I'll be talking on ramp lesion. As you know, ramp lesion is a hidden lesion in the posterior compartment. So it was initially coined by Michael Strobel in 1988. He termed it as a ramp-like structure in the posterior part of the posterior horn of medial meniscus along with the capsule. So this was the discovery made, and then in 2019 ESCA consensus, they were debating between whether it's a meniscus or it's a capsule. So they concluded that ramp lesion is not a meniscus tear because it doesn't contain any meniscal tissue. So it's more of a peel-off kind of injury in the posterior medial compartment of the capsule and the meniscotibial ligament rather than actually a meniscal tear. And both the mechanism of injury is totally different between a meniscal tear and the ramp lesion. So they came to a conclusion that it can't be called as a meniscus tear. So what is the mechanism? Mechanism is due to the pull of the semimembranous muscle, which pulls a posteroblique ligament and meniscotibial ligament. So it causes a peel-off kind of injury. And one more theory is the crushing of the posterior horn medial meniscus between the femoral condyle and the tibial plateau. So which was coined by Sims and Jacobson. So these are the mechanism of injury, and Kim et al. Showed some risk factor where you can expect a ramp lesion, just like varus alignment when it is more than 3 degrees, the steep medial tibial slope, deep posterior lateral femoral condyle, and steep medial meniscus slope. So increased lateral femoral condyle ratio will also have an impact on the ramp lesion because it creates a more excursion along the condyle in the rotations and causes peel-off injury in the posterior medial meniscus. Why it is important? So you have to diagnose and repair to avoid more of anterior tibial translation or external rotation in the after the repair. So to get a better outcome. So how do you diagnose? Where do you expect that the ramp lesion might be there? When there is a high-grade pivot or a grade 3 anterior drawer test or multiple episodes of instability ranging from 3 years to 5 years duration. If the patient is having ACL tear, you can expect a ramp lesion there. So MRI most likely it's a hidden lesion in MRI because patient will be in complete extension. The ramp will collapse and there won't be any tear in the MRI. So they have suggested to do a flexion, knee flexion MRI to diagnose ramp lesions. So along with that, you can also have a bone edema in the posteromedial tibia. So these things will help you in diagnosing preoperatively the ramp lesions. Otherwise, you can do a direct arthroscopy, visualize and use a needle to palpate the posteromedial meniscus and then probe it. You can directly diagnose. MRI wise, it's almost 43%. Arthroscopy wise, it's more than 58% you can diagnose. So these are the signs in MRI where you can see the lesion preoperatively and plan for the repair. So one is visualization of the fluid in the posterior horn of the medial meniscus, and there will be bruise in the posterior tibial condyle. EU et al. Has classified some of the features where you can diagnose ramp lesion in a preoperative MRI, like slightly avulsion of the part of the meniscus, or meniscotibial ligament avulsion, or the capsule fluid in between the capsule and the poststernal medial meniscus, or a North sign. So as they came to a conclusion that flexion MRI will have a better diagnosis. How do you visualize orthoscopically? You can do a recip maneuver by doing knee at 30-degree and valgus stress with slight internal rotation, or increase the fluid pressure so that the space will open up, or you can do a routine Gilchrist maneuver. So visualizing through the posteromedial portal will have a highest percentage of diagnostic condition, and Kim et al. Has showed that either in the posteromedial portal, or you can use a 70-degree orthoscope to diagnose these lesions accurately intraoperatively. So how do you classify? So the Thornett et al. Has classified into 5 types. One is meniscocapsular lesion. The other one is partially superior lesion, partial inferior, complete in the red zone, or the double tear. So while probing, you will have from anterior, you will have a stable lesion. From posterior, when you examine, you will have this partial superior or partial inferior, or a complete tear in the red zone. So this is a complete tear, and this is a double tear, both in the posterior horn and the capsular junction. Grief had further classified this based on the stability pattern and the methods of repair. So what is my preference of fixation? I generally do it from the posterior. You can also do it from anterior. Just make 2 posteromedial portals, shuttle the sutures, take a scorpion. Anybody who's comfortable with bank cuts will be easily doing this. Take the suture along the capsule, and then part of the meniscal tissue, shuttle your fiber wire, and place the knot over that. Approximately 2 to 3 stitches should be placed within a space of 10 millimeter and secure the knots. You can also do it from anteriorly when you have enough tissue. Just keep the tissue elevated, take the first pass, and take the sutures on either side. So we have our own Dr. Sheetal Gupta's technique, where he has done a shoelace technique. You can take the sutures just like a shoelace, both from the capsule and the meniscal part on either side, and placing the sutures exactly at the bulk of the tissue, and make sure that you don't entangle the sutures. And one by one, after that, finally tighten it so that it will close. The entire lesion will be closed. So you can use only one fiber wire for this and secure the whole repair. There are many studies which shows that stable ramp lesion can be left out after trephination, and unstable ramp should be repaired. The outcome is same. So this is a study where they showed that 92% of ramp repaired and 7.9% updated and refined both had an equal result. And in the follow-up, this is one of our follow-up where showed the isolated ramp. We had it was managed conservatively. The patient is doing good. So this is 2 years follow-up, pre and post. You can see the ramp is very well healed. And few studies where they have checked for the return to sports, and people who have done a good ramp repair and compared with the only needling, this repaired patient had approximately 85% return to sports, and the laxity was relatively less compared to the conservative managed group. So to conclude, posteromedial portal and probing for ramp lesion should be done as a routine in all ACLR. Failure to diagnose may lead to failed reconstruction. 2 portal will ease your repair, and place at least 2 to 3 knots for a better stability. Thank you.
Any question from audience?
Hi, sir. I said, just visualize, but I don't make a separate portal and probe it. Use the needle and probe it. Okay. As I told, you have to either have a pre-operatively and intraoperatively have a double vision to to diagnose that there is a ramp. So either if you have any doubt in the pre-op, you can go directly and visualize, or you can make a posterior portal and directly go in. Okay. Lift it up. Okay. There is a lamp region. Nice.
Just an extension to this question.
Okay.
So when you will be very suspicious that this may be a case of ramp, because many a time it's become very obvious that along with the ACL, this may be one of the condition that we should look intraoperatively. That should be in your mind before going to your surgery.
When the duration of the ACL is very old, as I told, till after 3 months to 5 years, you can suspect. Or the Lachman is very loose, means anterior drawer and Lachman is very loose, means you can suspect a ramp lesion.
And grade 3 pivot,
Grade 3 pivot
that is
fibrosis.
one of the condition where you should always search for either ramp
Yeah,
or
ramp
root along with ACL.
Yes.
Yeah, thank you.
I think we can, in your diagnostic also, only you add to see that you should always see for the ramp. Just you go to the medial side, give an anterior drawer and your scopes go easily inside. And you can have change the scope. So instead of suspecting, it should make a habit to see ramp lesion in all of your
In all
cases.
the
Sometimes, one thing what I've realized for bucket handle, it gets associated with the ramp. At that time, you have to be very careful in operating.
Can a ramp lesion be clinically diagnosed?
you can't. There is no test to diagnose clinically. So
There will be tenderness on the posteromedial side of the tibia, and grade 3 pivot will have. That is one of the suspicious for ramp.
suspicion.
Well, just one point if I can add, fantastic presentation. If you want to get to the posteromedial side and it's becoming difficult for you to reach your scope, what you can do is you can use the messenger rod and then pass it in between the
PCL and
medial quadrant. And then over the messenger rod, you can pass your sheet and then the scope. So it's slightly easier and you don't have to clear out.
Yeah, agreed.
And if you don't want to go onto the posteromedial portal, you can hook it around the posterior horn or middle meniscus and give it a pull with a probe. If you're getting a gross translation of the posterior horn, you should suspect there is a ramp. And it is said that if you don't repair a frank ramp, then the chances of your ACL reconstruction, that is failure chances more, because with repeated translation, the ramp increases and the graft fails. So if you're getting a frank ramp, you need to repair it.
Thank you.
Now, may I call Dr. Kapil Devgar for his talk on lateral meniscus tear with Okay, sorry. No. May I call Dr. Amit Mahajan for his talk on root avulsion? ये बंद करो।
Good morning. So here I am again to talk about the meniscus root tears. But here I'm going to talk about the current treatment options and delve more into the anatomy and the types of the root tears that we encounter in our practice. I'm so sorry for the orientation. Could you just change the orientation because my slide is not completely visible here. Yeah. Oh. The upper part is not visible. If you could just get that down. No, it's not helping. I think these are perennial problems when you connect a MacBook anywhere. Anyways, yeah, I think this is better. So if you delve into the anatomy of the meniscus root, we all know that there are two meniscal roots, the medial posterior and the lateral posterior, which are commonly torn. And the medial posterior root attachment is around 9.6 millimeter posterior and 0.7 millimeter lateral to the medial tibial eminence. The medial tibial eminence is one of the most reproducible osseous landmarks there. If you also have to look at the medial root in relation with the PCL attachment, it is found around 8.2 millimeter directly anterior to the most proximal aspect of the PCL tibial attachment. Similarly, the lateral posterior root attachment is around 1.5 millimeter posterior and around 4.2 millimeter medial to the lateral tibial eminence. And it is around 12.7 millimeter directly anterior to the most proximal aspect of the PCL tibial attachment. These landmarks are important because you need to attach the root directly to its most anatomical attachment so that you get the best of results. Again, coming to the classification has been proposed by none other than Dr. Rob Leprard. And as I discussed it in my previous talk, the root tears are classified into 5 major types. The first one is a partial tear. The second type is a complete radial tear in the root, which is again subdivided into 2A, 2B, and 2C, depending upon the distance from the root attachment. Type 3 is one which is associated with a bucket handle medial meniscus tear. The type 4 is an oblique tear which extends into the root. And type 5 is a root avulsion fracture. Again, the further subclassification has been proposed by our very own Dr. Sheetal Gupta from Bhopal. He is fondly also called as Meniscus Gupta. He has extended the classification into type 6, 7, and 8. Type 6 is one which is associated with a horizontal cleavage type of a tear, more commonly seen on the lateral side. Type 7 is associated with a meniscocapsular separation. So type 7A is one which is seen on the medial side with a ramp tear. Type 7B is one which is seen on the lateral side with a zip lesion. And type 8 is where there is a loss of substance of the root, and you just see a complete void there when you go ahead and do your scopy. Now, meniscus root, as we all know, aids in meniscal function by securing the meniscus in place. It also provides for optimal shock absorbing function of the knee. In a landmark study, Allaire et al. Reported that posterior root tear of the medial meniscus resulted in 25% increase in the medial compartment. Now, mind you, this is similar to a loading profile of a total meniscectomized knee. So when you have a root tear, you are actually dealing with a complete loss of meniscus. So the forces that are being transmitted are similar to that of a completely meniscectomized knee. That obviously leads to a lot of compromise in the hoop stresses, leading to decreased tibiofemoral contact area and increased contact pressures on the other hand. These changes are detrimental to the articular cartilage. We all know that, and ultimately leads to a development of early osteoarthritis. Hence, surgical repair is the treatment of choice in patients without significant osteoarthritis. So you need to do your outer bridge classification or Kelgan-Lawrence, and only type 1 and type 2 are amenable for a surgical repair. The diagnosis clinically is extremely challenging. Lee and co-authors in a review of 21 patients mentioned that only 14.3% of their patients and 9.5% of their patients complained of knee locking or giving way. So there will be no specific complaint that the patient will come to you with. It will be a very vague type of a history. To add to it, meniscal root injury is not typically associated with any inciting traumatic event. On physical examination, the most commonly encountered signs are posterior knee pain in deflection. So always whenever your patient tells you that on squatting he has pain, you may be dealing with a root tear, and there would be some medial joint line tenderness as well. Lee et al. Noted in their paper that around 66.7% and 61.9% of their patients respectively had presented with these findings. And McMurray test is again positive in only 57% of the patients, and effusion is noted only in 14%. So it's very vague. You have to depend more on the MRI. However, there is one test which has been described in literature called the SEAL test. Again, very, very subjective. The authors performed the test with patient fully relaxed and knee in full extension. During varus stress testing, the anteromedial joint line is palpated. And if the meniscus is torn, the root is torn and the meniscus is extruded, you can actually palpate the meniscus there. The extrusion disappears when the knee is returned to normal alignment. Again, as I said, it is subjective, can be evaluated only in very thin individuals where you can actually see the extrusion with your naked eye. MRI thus forms the gold standard for diagnosing these tears. In sagittal cut views, the posterior medial meniscus root is seen as a band of fibrocartilage which is attached or anchored to the posterior horn of the tibial plateau. T2 weighted images are more specific. Any meniscal extrusion which is more than 3 millimeters on your coronal planes is almost surely suggestive of a root tear. Ghost sign is absence of identifiable meniscus in the sagittal plane or high signal replacing the normal dark meniscal signal. Then you have other signs for meniscal roots, which include a radial linear defect at the posterior bony insertion on axial imaging and a vertical linear defect on coronal imaging. Coming to the treatment part, very, very clearly defined treatment. There's a simple algorithm for it. You need to find out whether your patient is a surgical candidate or not. If the patient is a surgical candidate, you need to understand whether your tears are acute or chronic. Those acute tears have to be repaired, and the chronic tears, again, you'll have to look at the joint space narrowing. If there is significant joint space narrowing, you rather conserve that patient and probably later go ahead and do a TKR in these patients. But if there is no significant joint space narrowing, you can go ahead and do a meniscal root repair. The principle remains, the technique of meniscus root repairs involves isolating the root, placing a minimum of 2 sutures and trying to reposition it back to a more anatomical position. The meniscus posterior horn in some instances may need to be released from the scar tissue. What are the treatment options that are available? Currently, the treatment options fall into 2 broad categories: transosseous sutures and suture anchors. Current preferred technique is the transosseous suture repair. Issues with loosening, hardware problems, and concomitant ligament reconstructions are there, however. Suture anchor repair has a theoretical advantage of no need to drill a tibial bone tunnel, which could later interfere with your ligament reconstructions, and they avoid the need for distal fixation as well. The suture anchor repair was described by Engelson et al. Using an accessory anteromedial portal. The danger here lies in taking a high posteromedial portal, which is approximately 4 centimeter proximal to the joint line and can lead to interference with the neurovascular structures there. Knotless anchor repair has been described by Dr. Tapasvi sir in his wonderful paper, where he uses a high posteromedial portal, takes bites through the root, and then passes these through the high posteromedial portal using a knotless anchor. However, the gold standard that we commonly use is transtibial transosseous repair. I'll just take a minute more. Transtibial repair of meniscus root tears offers several advantages, including improved anatomical placement of the meniscus, the ability to avoid the posterior joint capsule and the neurovascular structures, and potentially a simpler surgical technique. Potential risks are tunnel coalescence. When you do your ligament reconstruction, there is a risk of suture abrasion within the tunnel and the possibility of creep coming in when into the sutures, reducing the strength. The steps, again, I have already discussed in my previous talk. I'm just going to go through one simple case. I have 3 cases, but I'm going to just show one case here of a 53-year-old male who came with a complaints of pain and difficulty in squatting. That's all that he came up with. The common diagnosis here would be osteoarthritis. You would go ahead and just treat him accordingly because there was no history of trauma. But then on examination, the McMurray's was positive in his case. So we decided to go ahead and do an MRI, which was suggestive of a type 2 complete root tear with a ghost sign and a tear in the root. So this is how we repair this. So first step is to identify the root tear, and then you need to release it from the there is a liberal opening on the medial side that you need to do with your pie crusting so that you get a good vision. And the root is adhered with the scar tissue there. Don't mistake it to the root being a normal root. It is a scar which is just keeping the root attached there, but you need to remove the scar, make the root free, and then you take your luggage tack sutures. These luggage tack sutures are better off than taking simple sutures because they would not cheese wire into the meniscus. Once you've taken these luggage tack sutures, you drill a tunnel at the anatomical position after having debrided the cartilage there with a curette. And then you just pull these sutures down anteriorly, and as you pull the sutures down, you can see that the meniscus nicely sits back into its place and you get a good robust fixation. As I pull the sutures, you can see that the meniscus is coming back into place and sitting down nicely. So then you can fix this with any sort of a fixation device. You can use buttons, or you can use the T button, which I showed in my earlier presentation. I'm not going to go through the remaining cases for the dearth of time. I will just come directly to the rehab protocol. Again, that I have discussed earlier. It is divided into 3 phases. Phase 1 is where you keep the patient non-weight bearing for 6 weeks with a hinge knee brace locked in extension. You can start passive range of movement up to 90° and avoid deflection in phase 2, which is from 6 to 12 weeks. You actively increase the active range of movement from 0 to 60 to 90 gradually. Weight bearing is started at the end of 8 weeks. And phase 3 involves initiation of deflection and sports activities with strengthening exercises. Thank you.
So Amit,
yeah,
usually root is having 2 type of, one is associated with the ligament, that is
Yes.
most of the time associated with the major trauma.
Correct.
Another is age group in
Degenerative.
between 40 to 60s.
Yes.
And there is isolated root tear. Like in your first case.
Correct.
In the video, it was showing there is degeneration of the medial condyle as well as
Correct.
the tibial condyle. There is cartilage loss is there. So when you add this, any type of osteotomy in such type of cases, whether it's necessary or not, at the same time, when you are doing the osteotomy, so in that case, it is needed to do root or not.
Yeah, of course. Now, with the advent of newer techniques and simplification of techniques of HTO, I think alignment is very important, especially when it comes to that age group where you are seeing a degenerative type of a root tear. So I would recommend getting a scanogram for all of these patients and measure your angles. And if there is a varus alignment, it is worthwhile doing a medial opening wedge high tibial osteotomy along with your root tears so that you get equal distribution of the weight bearing, and then you protect your root as well. Now, the question that is commonly asked is, what is your highest age group where you would do a root repair? So there's no higher limit as such. If the patient is active, if the cartilage is pretty okay, as I said, if the arthritis is grade 1 or grade 2, you can still go ahead and do a root repair. But as you rightly mentioned, if there is an alignment issue, it is worthwhile doing a high tibial osteotomy to protect your root repair as well.
Yeah, thank you.
Thank you.
Now I would like to call Dr. Kapil Dev Garg for his talk on lateral meniscus tear with parameniscal cyst.
Good morning. So I'm going to speak on the lateral parameniscal cyst. So as you all know, lateral parameniscal cyst is the internal dearrangement of the knee at the parameniscal region. It usually associated with the complex degenerated meniscus tears like flap tear or degenerated horizontal cleavage tear. It's a benign lesion. It's more common over the lateral side, although the tear is more common on the medial side. The lateral parameniscal cyst is always smaller and very painful because of the presence of the IT band over the lateral side. It's more common in the woman in compared to men, and peak incidence is in the 4th to 5th decade of the life. So anatomy is usually arise from the parameniscal tissue, which are rich in the blood vessels as now. The etiology is unknown, but the trauma, degenerative, and inflammatory condition are the things which which form the parameniscal cyst. So trauma cause the tear happen in the meniscus, which may lead to the hemorrhage formation. There will be the increased mucopolysaccharide secretion, and the necrosis happen locally, plus degeneration of the mucoid form a cyst. So thus trauma cause the synovial fluid gateway to the meniscus and the periarticular soft tissue. The clinical presentation is always same: pain, swelling, limited mobility. There may or may not be mechanical symptom like locking or catching, and it may lead to the quadriceps weakness and instability in the future. The diagnosis is based on the combination of the clinical evaluation, imaging study, and your arthroscopic finding on the examination. So the imaging modality of the choice is the MRI, which provides the cyst location, size, and relation to the surrounding structure. Ultrasound and CT may be useful to confirm the diagnosis. So here you can see the sagittal view. Here is the meniscal tear in the meniscus cyst associated with the meniscus tear as the anterior horn of the lateral meniscus. In my axial view, there is the meniscal cyst located towards the infrapatellar fat pad. The surgical technique is the evacuation is the repair. There are the some step. The patient positioning is always same supine position. You need to flex the knee, make the standard AL, anterolateral, anteromedial, and posterolateral portal, followed by the formation of the lateral and medial infrapatellar portal. If your cyst is very large and associated with the lateral infrapatellar fat pad, you may require lateral parapatellar or higher portal to look over to diagnose your cyst. So viewing from the lateral parapatellar, you can make the medial infrapatellar portal, transfer your scope from lateral higher portal to the medial infrapatellar portal and look over the medial side of the lateral cyst. And you can make the lateral infrapatellar using the spinal needle. So if you find some fibrillation or degeneration over the inner edge of the meniscus, so you need to debride it and do the partial meniscectomy. But if there is some leakage of the fluid at the meniscal site, meniscus tear, then there is another technique to treat it. So if you find a puff up bulging of the meniscus along with the puff synovial lesion, including cyst, then it means there is a subsynovial cyst is present. You need to debride it. You need to shift your scope into the medial infrapatellar portal, pass your radio frequency probe in the infrapatellar medial lateral infrapatellar portal, and do the subsynovial shrinkage to expose the undersurface of the cyst and to find out the relation between the lateral meniscus and the cyst. Then next step is the decompression and the find out the meniscal cyst. So same viewing from the medial infrapatellar instrument to the lateral infrapatellar portal, you need to debride it, you need to probe it, penetrate and fenestrate using the basket forceps along with the lateral, just near meniscocapsular junction at the lateral wall of the meniscus to form the intrameniscal capsular window to reveal your future cyst. So here you can see this is the major cyst just near to the peripheral attachment of the lateral meniscus. As you uncover the synovium, you may find, you debride it, you may find out the major cyst. So now the next step is the cyst decompression. You need to do the meniscectomy just near to the peripheral attachment and do the compression and the outflow of content of the major cyst following the decompression. So in case of the multilocular satellite cyst, one should usually go more deeper inside of the meniscus and more satellite cyst should be found. So satellite cyst is always deeper than the decompressed major cyst. So you need to debride and decompress the thoroughly and find out the satellite cyst also. So next step is the closing the meniscosynovial window and meniscus repair. You can transplant the exogenous fibrous clot to fill the intrameniscal cavity by the grasper or forceps before closure. And then the next step is the closure of the lateral meniscus tear using either outside in or inside device. So here you can see there is that degenerated tear at the inner edge of the avascular edge of meniscus. You need to do debridement, do the partial meniscectomy. If you find some fluid is leakage out there at the site of the meniscus here, it means there is some cyst is there. So you need to go peripheral at the meniscocapsular junction, do the synovial shrinkage using the radio frequency probe from the lateral portal. Once you do the synovial shrinkage, you can find out some degenerated tissue underneath it. Then you need to probe it at the meniscocapsular junction. They'll do the multiple pinning, multiple probing, and fenestration using the basket forceps horizontally and make the intrameniscal window. So as you uncover all the superficial tissue, synovium, and the peripheral attachment of the meniscus, you may find out the lateral parameniscal cyst underneath it. Here you can see these are the lateral parameniscal cyst. You need to decompress it, debride it, and outflow of the all the content. It's usually present on the outer surface of the lateral meniscus, anterior horn, or the mid body of the lateral meniscus. It's very rarely present on the posterior horn because of the presence of the tight IT band. Once you debride it, you may find out some satellite cyst inside, just deeper to the major cyst. So as you find out some satellite cyst, you need to debride it also, decompress it. And then if you go more and more deeper, you may find out there is a big gap at the peripheral side. So you need to do exogenous fibrous clot and do the meniscus repair. If your cyst wall is very defined in adhere to surrounding structure, you need to debride it also the cyst wall, so that there is no remaining residual tissue remain. Otherwise, there is a chance of the recurrence. So there are some biological factor to increase the vascularity after the meniscus repair. Some are the trephination, synovial abrasion, fibrin clot application, or PRP also. So PRP is it provides a higher level of the growth factor, which may increase the angiogenesis and the soft tissue healing. There is some paper in favor of the autologous platelet-rich fibrin matrix combined with the meniscus repair in treatment of parameniscal cyst. So rehabilitation is always same. Immediate posture, you need to focus over the pain management, swelling reduction, and the range of motion exercise. You need to shift to standing exercise of the quadriceps, hamstring, and the core muscles. Then you can incorporate the functional phase, incorporate some special exercise like agitated drilling and the plyometric. So that's all for the lateral parameniscal cyst.
One question, Dr. Kapil.
Yes, sir.
While you're doing the decompression, do you always do it intra-articularly, or sometimes you need to go extra-articular also from outside?
So while doing the decompression, you need to go from the outside in, from the lateral infrapatellar portal.
Okay.
And do thorough debridement using either shaver. First, you can do the subsynovial shrinkage over the radiofrequency probe, then do the meniscectomy along with the cyst decompression using the basket forceps.
Yeah, I got that. Means you always do the decompression from inside by scope or shaver, or you do give an incision outside extra-articularly?
You want to say some incision from the outside. If the cyst is very visible from the arthroscopy, there is no need to go from the outside.
Sure. So it can be managed intra.
Yeah, you can.
What is your take for a cyst which is just anterolaterally?
Anterolateral or the, so if that is usually present on the anterolaterally, because at the portal placement, so you need to shift your scope from the anterolateral to the medial infrapatellar portal, and then take the lateral infrapatellar portal for your passing your instrument also, so that you can use to avoid that lateral patellar. Otherwise, if you make the portal, there is a fluid will seepage out. Thank you so much.
Now I would like to call Dr. B.N. Chaturvedi for his talk on all inside lateral meniscus repair.
Good morning, everyone, and good morning, respected teachers. Today, I'm going to present a little bit correction in brochure. It's inside out, not all inside. It's inside out meniscus repair.
ये वाला थोड़ा नीचे
Be aware
करना।
of CPN injury.
हाँ। सीधा। Knife.
My case history, a 20-year-old boy came to routine OPD with a right knee pain, and after proper test, he was positive for lateral meniscus tear, and after the MRI, it's a discoid lateral meniscus tear. And I planned for socialization and inside-out technique for repair of the tear. Discoid meniscus is shaped like a half moon or complete circle rather than a crescent moon. It's most often occur on the lateral side of the knee and can sometimes be found in both knees. Socialization technique, patient was in supine position, usually in a figure 4 leg position to allow better access to the lateral compartment. A standard anterolateral viewing and anteromedial working portals were used to assess the meniscus for peripheral instability or tear. Using a 45-degree angled arthroscopic punch, the central portion of the disc was removed, starting from anterior horn and moving posteriorly. The meniscus was sculpted into a normal looking crescent, creating a 6 to 8 mm wide peripheral rim, typically with 1 centimeter width from the hiatus. But peripheral instability exists, so the remaining rim was repaired to the capsule by using an inside out technique, and in that case, it's my fault. This is the LFC, lateral femoral condyle, and this is the discoid lateral meniscus, and this is ACL. Technique of inside out repair of lateral meniscus. The knee was placed in 10 to 20 degree of the flexion for suture passes. A lateral incision was made behind the lateral collateral ligament to expose the joint capsule. A cannula was inserted by the portal and placed against the meniscus tear. A long flexible needle carrying a high strength suture was passed through the cannula, through the meniscus and capsule, and retrieved through the posterolateral incision. Vertical matrix suture were performed, placed 3 to 4 mm apart. The first stage was crucial for anatomic reduction. Sutures were tied down over the fascia on the lateral side of the capsule, away from the neurovascular structure. But during post-op assessment, peroneal nerve injury was found and diagnosed with foot drop. The hallmark feature was foot drop, where the patient was unable to lift the front part of the foot of the ground. Possible cause of common peroneal nerve injury during inside-out repair of lateral meniscus in my case was iatrogenic nerve entrapment, either where suture needle or trocar penetrates or compress the nerve, but commonly occurring during the capsule piercing. Risks include improper retraction, excessive traction, hematoma, or navigating behind the lateral meniscus. But in my case, after proper physiotherapy and rehabilitation, patient was recovered, and after 9 months, he has full recovery. Take-home message of my today's case presentation is the lateral meniscus repair with inside-out technique is not a routine surgery, and if necessary, then use all inside. For lateral meniscus repair, both all inside and inside out techniques yield similar clinical success rates, but all inside is often preferred for posterior horn tear due to the speed and reduced neurovascular risk, while inside out is superior for complex, large or radial tears. All inside is generally faster, requires no extra incision, and has less risk of nerve injury. Thank you.
May I call
आप स्पीकर पे लगाओ. हेलो.
talk on decision making in meniscus surgery and repair technique?
So, exactly 30 years back, Dr. Anand Joshi in a Calcutta meeting, when the population of the country was about 100 crore, and he said, there's no need to worry. There were very few of us who were in arthroscopy at that time. So there's no need to worry. There's enough work. There are 200 crore meniscus. There are 200 crore ACLs. And look at what's happening to meniscus today. We've got meniscal repairs, post-meniscectomy patients. And now we've got a new breed of surgeon coming up asking meniscal replacement, I don't know. So meniscus has been a favorite topic, and here I am summarizing what has been happening throughout the morning. So meniscal tears, as we have seen, there's not much to be said after so many of lectures. I'll just give you an overview of all the things which have been shown. So, and indication is a tear between 1 to 4 centimeters, although nowadays it's a very low threshold to repair everything and anything. Vertical tears, red tears, meniscal root tears, and the younger patients. But now, as it is, the young youth is in 60s also. So why to repair the meniscus? Because of these reasons, because of the fact that the hoop stresses need to be properly taken care of. And symptoms affects everybody. So when to repair? So, well, if you have a very high threshold of kind of resisting the meniscal repair, you must only do it when you think it is in red or red-white zone. But nowadays, with the kind of instability issues which are coming up, the threshold is really very low. The types of tears we have just seen, indications you've just seen, principles of repair. Of course, you've seen extensive amount of MRIs just now. Arthroscopic evaluation is important. Freshen up the tear, stimulate healing, repair the meniscus, check stability. So outside in repair, I'll just show you a small video which would kind of clear the concept. Now the concept is to pass these two needles. It's a simple, very simple and easy repair. You just have to pass two needles, two loops, withdraw one loop from the other loop, and then pass both the threads from inside to out. So becomes outside in because you've basically put in two needles. As you can see, the second needle going in. It's a very nice, simple, cost-effective way of doing a repair. And it would really help you in anterior horn up to almost the mid-third of meniscus, almost to the later half of the mid-third of meniscus, and absolutely no cost attached at all. So a lot of cost saving in this technique. You can easily do it. Anybody can do it. This is a simple representation, animation, so that you can actually understand the principle. This has not been discussed in all these talks. And it is so important to understand this is how we started meniscal repairs. This is how we started meniscal repairs. See. Inside out technique, of course, we have just shown, and I'll straight away go to the case. It's I get a lot of soccer players, obviously, because of the kind of places we work in. And you can see all the signs which have been shown, including the double PCL sign. And I usually use a single cannula repair because of the type of system which you want to use. It doesn't matter whether you use a double cannula or a single cannula. And you can see you try to do as much as possible, take a part of meniscocapsular area at the back so that you have some thicker tissue, because if you pass the needle and if it goes through only the fragile part of the capsule, you tend to sometimes break the capsule and your meniscal repair fails. So you try to take something which is more thicker at the back, and then you try to repair it. And the trick is to, while you are tying the knot outside, to do a varus, decrease the space between the femoral and the medial condyle, and then tie that, because that would actually make your valgus stress, your meniscus will not kind of, meniscocapsular separation will not happen if you tie it in varus. Now, if you do that, you will tend to have a much tighter and a better repair. All inside suture fixation, as you just said, this has been properly and extensively shown. I will show a few cases. And the tears with the rim of more than 2 millimeter width, vertical and longitudinal tears in the radial tears. The advantage is you can do a reasonable visualization with pie crusting. It is quick and simple. And in the posterior horn and the posterior 1/3, it is much safer, because most of our studies have shown that even if you have 18 millimeter extrusion outside the capsule in flex position, you are not going to hurt the popliteal vessels. So therefore, it is a safe zone in which you can repair blindly. Again, this is a case which It's just a representative cases because this talk is about everything and anything and summarizing everything which has happened so far. As you can see, you just use one of the suture devices, and all three of them here have been used extensively by all of us, including myself. You tend to rasp and clean at the back. You go and see the posteromedial aspect for any ramp lesion, try to find out whether you have to repair the ramp also. But most of the times, if you have a tear in red white zone, you will not get a ramp. It is more likely when you have a tear in the red zone, or in a sometimes you have a chronic tear which is being pulled inside the joint several multiple time, you may have a reason to have a ramp lesion. So it's a matter of how you have experienced your meniscus, and this is a standard technique. As you can see, there is a flounce, and this flounce, as one of the speakers had shown, you can do a under surface horizontal cleavage mattress tears. You can actually do two vertical sutures, and if you get a flounce, you can then do a simple horizontal over the meniscus also. So instead of going under the meniscus, you can do a horizontal mattress, a horizontal stitch above the meniscus. It works the same ways. So this one also is an all inside technique. As you can see. So this is the other suture anchor which is being used. These are all now all suture anchors. So most of the companies are transitioning from bioabsorbable anchors to the all suture anchors, and for the sake of foreign body reactions and other things which have been reported. And sometimes I'll show some failures also, because I've had failures with all the devices. So when you're talking about good things, you have to talk about the difficult things also, and I will come to it. Now we come to the ramp region. At least 5 of the speakers have shown this slide. And basically, it is fiber stitch or short stitch or whatever you want to use. This is a classical ramp lesion near the posterior horn, and you've palpated it. I usually have a high threshold going posteromedial. I kind of a lazy guy who would do it from the same side. And most of the times I'm able to address with all inside suture devices. The failure happens when the posterior capsule is very, very fragile. And you have to take a part of the capsule and the meniscal tissue, which is at the back, or make sure, because if the capsule is very fragile, all the sutures, they tend to come out. So that is a situation where you might have to go ahead and use an anchor at the back and do it. As you can see, it's a simple way of doing a standard ramp procedure talk in which I just wanted to give you an overview. Another one, I think this is, yes, so root tears. Now, this technique, which I was discussing yesterday evening over the dinner, is a very unique thing which is happening nowadays. A lot of these lateral meniscus root tears are coming. This is a type 2 tear, which is, there's a lot of tissue of original lateral meniscus at the back. And this tissue is a part of the lateral meniscus, which is a part of the root. That is the natural area where the root has to go in. Now, when you are doing an ACL reconstruction, the premise earlier was to go as close to the posterior root. That used to be your target point, posterior horn of lateral meniscus, if you remember. So if you take out your pin somewhere close to posterior horn of lateral meniscus, your meniscus actually is very close to the 8 mm or 9 mm drill hole which you are doing for the ACL. It is almost coming at the anterior edge of the root of the lateral meniscus. Now, when you do that, as you can see, first of all, I take both the meniscal tissues and tie them together. So these two meniscal tissues are tied together. Sorry. So the first 2 or 3 bites were taken from the meniscus. The second 2 bites are taken from the residual tissue. If you have large enough tissue, take it from the residual tissue and then tie them together. So that becomes a concomitant lateral meniscus. You have repaired root to the meniscus. And then from there, it is the same tunnel through which you are doing your ACL that you draw this thread down of the meniscus and tie it down into the same suture button which you are using for the ACL at the tibial junction, at the tibial cortex. Now, this works in a way, and it is now being described as a technique. I've been doing this for 5 years because I thought my tunnel coalition would happen. But now this has become an accepted technique of doing some difficult posterior root repairs on the lateral meniscus along with ACL reconstruction. And you can see that the repair is absolutely solid. The opening has gone, and your ACL reconstruction tunnel, which is good posterior tunnel, because you need a posterior tunnel to avoid an anterior impingement. And then you take the same tunnel for passing the threads for the root repair, and it goes through the same button on the tibial cortex which you use. So using fiber stitch, this is for the horizontal cleavage tear, as you can see. Sorry, I am taking a bit more privilege here. You can use the stitch to close the fish mouth tears and then go ahead and do the this thing. This is one which we have done. So now avoiding failures in device assisted all inside meniscal repair. The most important thing, I have used all these devices, including the latest Sure Stitch, everything. And everything, if you don't use it properly, it will fail. And there are failure rates even if you use it properly. So be careful. It's not a panacea for everything. You must know that if you pass the device into a fragile capsule or meniscocapsular junction at the back, they will pull out. And that's how the evolution of all suture anchors have come. Also, the fact that the devices, if they are more than 1.5 millimeter piercing needle thick, they also lead to a larger hole in the posterior capsule, which can cause the pullout of the sutures. As you can see, everything fails. I'm just putting the names here because it's an impartial discussion. All three devices, all four devices which we have used has failed. You just have to be sure that whatever you are using, you use. The other thing which you should be doing is not only you can use what do you call a probe, you can also use a knot pusher. You can use a knot pusher so that you can pin down the meniscus and the thread together. And then when you pull the thread, the knot pusher really helps you to bring the meniscus down and pull the capsule up. Now that is one of the things which you can use instead of using a probe. So healing of meniscus, I think this is the last slide. It takes 8 to maybe 12 weeks to heal. And you may not see every time in MRI that the whole sign has disappeared after 2 years, but the patients are asymptomatic. Most of them do well if you conserve well. Don't be in a hurry to make them walk around. Also, the fact that patients should be listening to you is a part of your meniscal rehabilitation program. And thank you very much for this invitation, Arvind and Dr. John. It has been always a pleasure to be with you. Thank you very much.
Thank you, Vikas. Was couple of questions from you because you have a lot of experiences of this meniscus repair. Nowadays, there is a lot of push toward the repair of meniscus all the time. When you see, first thing comes into your mind, it should be repair.
It comes to the mind of the patient, actually. They ask for it.
So, and that might be because of the doctor has pushes a lot. So there is a lot of condition. You have did meniscectomy in the past, and maybe after 10, 15 year patient is coming to you. And so, and now most of the time meniscus is getting repaired.
Till 2015, it was meniscectomy all the way. I was just discussing with Dr. John, 3 national football captains played after partial meniscectomies, represented country, went on to do everything. I won't name them, done by us only. So and they are coaches, they are doing all kinds of activities running. So meniscectomy is not such a procedure where you kind of should be. Yesterday only I did a girl, she had an irreparable meniscus. I had to do a meniscectomy. She was a black belt in karate. But where do you rate what happens at the age of 60, 70 is something which we are discussing today. Why? Because we are into a knee preservation zone from a knee replacement zone. Now, being a surgeon who has been addressing knee in every way, in every which way, I don't find meniscectomy such an untouchable procedure. I do have my reservations of doing a red zone or very red and maybe white zone. I can't, maybe there will be a subclassification. But doing a red-white or a white-white meniscectomy is absolutely not a problem. Absolutely not a problem. Also, the fact what I have seen now is that the meniscal pull-in, whatever remnant of meniscectomy meniscus you have, if you put in a suture and pull in that remnant into the joint, that works as good as. So if you have 1/3 of meniscus left and you can put a suture at the posterior edge and pull in the meniscus into the joint, it works very well. Patients don't have any residual pain. So I think a combination of meniscectomy with a pull-in technique of taking a bit of meniscal tissue back inside the joint is a very good combination and a middle path of irreparable meniscus where you do a meniscectomy and instead of doing a complete meniscal repair, do a pull-in procedure so that you can put the meniscocapsular junction inside that joint and it actually works.
Very important message, boss, because in nowadays it's always meniscus repair. So whenever we feel it's in the white zone or it's difficult repair or even after repair it's not looking good, we can do the partial meniscectomy and we don't feel regret for that.
Yes.
Thank you, boss. Thank you
Sir,
very much.
one question, sir. You said about that root repair and passing the thread through the same tibial tunnel during ACL reconstruction. That's a very good method, sir. But while you're creating the tibial tunnel, it is slightly anterior. So what do? You push the tunnel posterior.
The needle is coming anterior. If your tunnel is 9 millimeters, if you remember, we used to always advocate what is the landmark of your ACL jig. The landmark of putting the ACL jig was the anterior edge of the posterior horn of lateral meniscus.
Right, sir.
Right? So if you're putting it at the anterior edge of the posterior horn of lateral meniscus, it will come out about 4 millimeters. The pin would come out about 3 to 4 millimeters anterior to it. When you drill 8 millimeters, 4 millimeter will go behind. So you are at the lateral edge, at the anterior edge of posterior horn of lateral meniscus. When you are at that place where you want your root to get attached, so that is exactly the place where you want to put in. And now you put in another tunnel, which is actually non-anatomical. You're putting it at the back of the edge of the tibia. And that is actually a meniscal pull-in procedure. It's not a root repair position. Root repair position, you're already getting in a proper ACL tunnel. Then why in lateral meniscus, not in the medial side? And why would you go anywhere else? So this used to make sense to me 5 years back. Now it is getting reported all over the world that surgeons are doing it this way.
This you're advocating for the lateral meniscus.
Only for lateral meniscal root tears. Yeah. In case you are very close to the ACL tunnel.
Thank you, sir.
Thank you very much, sir. Thank you very much. Now session is closed for the medial meniscus. Thank you very much to the audience and the speakers.
Thank you, Chairperson, for chairing this session. And now I would like to call Dr. Sudeep Kumar, Dr. Manish sir, and Dr. Pankaj Kumar for moderating this live surgery session.
तो हमारा ही दिख रहा है ऑन कर दो कोगलेट कोगलेट बस लाइव
Hello, Siv.
Hello.
Sir.
Siv, you are
Yes,
live
sir.
now. Dr. Sudeep sir, Dr. Pankaj and Dr. Manish sir will be moderating this live surgery.
Hi, Shiv. Can you hear
Hi.
us?
Yes, sir. Am I audible, sir?
Yeah, you're quite audible and your arthroscopic view is also on the screen.
Right, great. So thank you so much for having me over, Dr. Arvind. And this is a 42-year-old female with a 2-month-old injury. And she has a ACL complete tear, which we've just removed some of the remaining parts from here to have a clear view for the audience. And so the patient is having a complete ACL tear along with some meniscal injury that we saw on the MRI. Now, the MRI shows a vertical ramp lesion right at the back. But when you start the scopy and you try to probe, not much comes in. But because we have an MRI which suggests a ramp, there we should have a good view. And so I have done a pie crusting before we go in. So as the audience can visualize, right now I'm scoping, and it often happens with the beginners when you try to probe in. There's not much of meniscus tissue coming into the joint, but that doesn't really mean that the meniscus is fine. And especially if we have a backup of the MRI which suggests so, I've gone in, done a pie crusting, and now you can visualize that there is a long vertical ramp tear at the back. Can everybody appreciate this?
Yeah.
So this
quite
often is missed, and a lot of times about 68 to 70% of the ACLs are have a ramp tear along with it, and it is important that we don't miss this. And this is quite oftenly missed. So this is a message for the beginners as well. When you're out there, keep a good eye on the MRI, and even with little suspicion, if you find that the meniscus is not coming in, do a little bit of pry crusting, get a good view of the undersurface, try to lift up the meniscus with your probe, and there you can find a lesion. So once you've seen that, you know that we cannot leave this cannot be left alone, even though it looks like a stable one, but this is going to progress and going to cause issues later on, as we've discussed in the meniscal session. So the
If-
cartilage is pretty okay. Yes, sir?
Can you show us the MRI, this lesion on MRI?
Yes, definitely. Can you turn the view?
Cameraman,
Dr.
focus on the
Sajir is
MRI.
here. He will help us with the MRI view on the coronal and the SAG. SAG will show us better. If we can focus on the PDFS SAG view, you will be able to appreciate on the medial aspect there is a vertical split. Is it visualized, sir?
Yeah.
Yes, yes.
Yes. So Dr. Sajir is there pointing out where the split is there, and this should not be missed. And there's also a bony contusion right there. And that is also a indirect sign which signifies and tells us that there is something, and we need to look deeper into this area and not just leave it, because very commonly ramp lesions are the most oftenly missed lesions. So this is a very important message here, that how not to miss. And in case of any doubt, there is no harm to do a little bit of pie crusting onto the tibial side, because we're looking at the undersurface and have a better view, as you can appreciate here. Quickly running through the lateral side also there is some meniscal disturbance, but it doesn't bother me because it is a partial tear which has already started to heal or will heal, because it is in the red zone. I wouldn't bother about it much. When I've tried to probe in, it doesn't come in and it doesn't communicate inferiorly. So again, this is also a message that any disturbance here can be left and need not be bothered about here. So this seems to be stable. That is the hiatus there. We can definitely leave this partial healed meniscal tear here. Quickly coming to the ACL, I have done the tibial tunnel, and tibial tunnel as standard probe. So we follow the anterior root of the lateral meniscus that comes here, and this is where my tunnel comes in for the tibial side. Can I have the bead pin, please? Can I have a trimmer? Retract. So that's where my bead pin comes in, the drill pin comes in onto the tibial side. I'm very much in the center of the footprint of the ACL. Keep it like this. Yes. Yes. Yes, please. So we have harvested a hamstring graft, and we have We have taken Semity and the Gracialis. We have tripled it. We have a good diameter. Excellent, Pakro. Let me do it. Okay. So we have done the tibial side. Now we'll go on to the femur side. Can I have the offset? Five. Jig for the femur. अभी जो दिखाया था बेटा क्या हो गया सामने लगाना है ना So I always prefer to use a femoral offset guide, which gives me a good hold on the, sit down, flex the knee. So my offset is abutting right at the posterior cortex. I'm using a 5 mm offset, which will give me a 2 mm. सीधा करो थोड़ा.
Hi, Dr. Shiv.
Hi, sir. Yes, sir. Any question? I'm not able to hear. Yeah. Please go ahead. Drill.
Entry point. Entry point of the femoral. But where will you put it the exact?
पीछे जाओ. ले ले यार. Can we have the normal drill, please? Not this. Can we have the normal drill? चलो. पीछे पीछे पीछे. हाँ. आप निकाल लो एक बार. निकाल लो. We'll do it again. Never mind. निकालो बाहर. Yeah. सीधा. Okay. Can I have the offset again? चलो. Flex it slightly, about 90 degree. Yes. Yes. ये निकाल लो. आप करो.
Shiv,
हाँ.
if you are comfortable, there is a question from the house. Why did you make the tibia tunnel first? Did you drill the tibia tunnel all the way?
No, I've made it with the so while we were waiting to go live, we had made the entry point with the drill pin.
Okay. So you haven't drilled it yet?
We haven't drilled it yet. We have drilled it only till 4.5.
So do you routinely make the do it this way, or you
So
make?
I routinely, what I'll do is I will just make the tibial tunnel and और आगे. So I would make my tibial tunnel and I would put the drill pin and then ream it with the required reamer. I did a 4.5 just to demonstrate here, and then now I'll be doing it with the 8.
So you do the tibia once you are done with the femoral tunnel.
Yes, first I do the tibia and then I do the tibia, femur side. So this is 4.5. Okay, ठीक है. So we've got a length of 35. एक बार देखना length. Hold this. Do we have markings here?
So, Shiv, this
Yes,
patient
sir.
is having meniscus as well as ACL.
Right. Can we have the?
So you do meniscus after completion of this tunnel part, Always, or it's
Always I'll make the tunnels first, and then I'll then come to the ACL. So once the tunnels are drilled, then I'll come to the ACL part, the meniscal repair
meniscus
part.
Yeah.
कौन सा है?
The reason behind this, Sib?
Reason is that then when I'm flexing, I'm not, and when I'm flexing the knee for the femoral tunnel, I'm not flexing it too much, and there is not much of movement after I've done the repair. So any advent movement or drilling, I don't want to disturb the meniscus while I'm making the tunnels. Go
Yeah,
deeper.
absolutely right. Lot of people does this meniscus repair once femoral tunnel
Good.
completed.
थोड़ा सा और.
Because many a time you have to do,
बस.
particularly for the lateral meniscus, you
Can I
have
have the
to do
ethibond or the fiber wire?
for the repair.
Now, after making the femoral tunnel, I would quickly take you to the meniscus and then do the tibia later, because we have to demonstrate the meniscus, and so that we don't run out of time. यार इसमें wire डालने का है. Okay. Can you pull out the wire, please? Yeah, thank you. So now the tunnel on the femur side is done, and the tibial side partially it's done. I will trim it with the 8 later on, because that will also do a lot of oozing of the fluid, extravasation of the fluid, which might disturb the arthroscopic view for the audience. So now I'm going to come back. So again, to take it quickly, my femoral tunnel is done. My tibial tunnel is done with 4.5. I'm not doing it with 8, so that there is no extravasation of the fluid, which might disturb the view. Now I'm coming to the meniscal part to show the ramp repair. Ramp repair, there are various ways of doing it. How I prefer to do it is with an all-inside configuration, all-inside devices, and I will just show you how. So this is the meniscal tear right at the back. I'm rasping it. Getting the biology is very important. Very important is the ABC of the for meniscal repair, that is getting the anatomical reduction, inducing the biology, and having a good compression. So that's where I am getting my golden rasp, which comes in nice and clean inside. I make sure I'm not damaging anything which comes my way. I go in at the back, rasp it nicely, get a good, remove all the fibrous tissue which would have developed for the past 2 months. And now I'll bring in my devices. So what I'm doing here is I'm using a ConMed AIM device. This is also something new which has come in. And the good part is that you don't need a sleeve. You don't need a separate sleeve here. It comes with an inbuilt sleeve, which can then, once you are inside the joint, छोड़ दो उसे, valgus दो बस. So once I'm inside the joint, I'm going to the undersurface. My sleeve is there to protect the needle. I pull back the sleeve. I rotate the device and take it how I want to. Pierce it. And then shoot it. So important point here is I'm doing everything on the undersurface. I've taken my first bite through the meniscus, and the second bite goes through the capsule. Can you appreciate that? So I'm going right into the capsule. So it's like a vertical configuration
at this point,
which is going to pull out the meniscus. And then that is my first stitch in place. Can I have the knot pusher cutter? Can you hold this? छोड़ दो. Can I have the knot pusher cutter, please? Knot pusher cutter. Sorry. We are just trying to find the knot pusher cutter. They wanted me to cut it without the knot pusher cutter. Smith and Nephew का कहाँ है? Can I have the Smith and Nephew knot pusher cutter, please? Okay. So here we have. So what I typically do is I use the knot pusher cutter to pull in my shreds. I'm happy with the construct. I'm happy with the pull and the tension. I don't want to tension it too much because, hold it, because the capsule here and the capsule button could be a weak link because we don't know how the capsule quality might be. I don't want to pull it on it too hard. So I'm there, just a slight bit of tug, getting a good compression and trying to cut. It doesn't cut. Sorry, I'll just change the knot pusher cutter. It's not something that I routinely use.
So, Siv, any tips to prevent the injury to the neurovascular structure in the back while you are putting the stitch in the capsule?
So typically I don't go too deep. I wouldn't go too deep. And also on the medial side, we are still safer. If we are looking at too posterior and the central side, there might be a little risk. It's not cutting. Naya diya hai? Okay, sorry. So yes, not going in too deep, just getting adequate amount of tissue, not being too greedy. One more onto the getting a good go. So now one meniscus, one stitch is done. One stitch is done. And if you can appreciate, there is a vertical mattress. I don't want to pull it on it right now. I'll have another stitch coming in here. Get in the second device. Turn it up. So when you are using sutures on the undersurface, the good part is that the meniscus comes in down and sits onto the place very nicely, which is very important because there is no upturning of the meniscus when you're using sutures on the undersurface, and also you get a good vertical compression. So if I had done it on the superior side, we could have had seen the meniscus tissue getting upturned. So that doesn't happen when you do it like this. So first bite is gone into the tissue.
So you're okay. This does not look very close to the.
No, actually that is not close. That is the extra thread that has been cut.
Okay,
I'll just show you. So
Yeah, no,
that appeared. So that stitch is here. This
Yeah.
is just a part of the extra thread that has been cut. So I am about definitely about 4 mm away from the last stitch. I'll just try to show you. So again, I had also that doubt, but then I just saw that it is just the extra bit of the meniscal, the device thread that was cut earlier. So and again, we'll confirm it again once this is cut. So I come in, give a nice tug, not pull it too hard, and I see the tissue coming down. Right. So now can I have the meniscus, please? The probe, please, sorry. So if I try to lift it up, that was the extra tissue, the wire that seemed like it is coming close, but we have one stitch here, one stitch there. Can you appreciate that? And now if I'm trying to pull, I'm not able to pull out on any tissue. It is
Yeah,
a
that's
stable,
quite clear.
it is a stable repair, and the meniscus is sitting onto its place. And there's no upturning and quite an anatomical repair, right? We'll quickly move to the ACL. Can I have the, sir.
You continue with this. We'll
Right.
back to you once you are passing the graft. Meanwhile,
Absolutely, sir. Absolutely.
Meanwhile,
I hope I've done justice to the ramp repair and everybody was able to.
absolutely fantastic job.
And we have a big round of applause for
Yeah.
the demonstration, please. Thank you so much.
Thank you,
Nice
sir.
meeting
Thank you
you.
so much. Thank you so much. Beat pin. Can I have the beat pin, please?
So, may I request now Dr. Ramakant for this panel discussion on meniscus tear. And panelist for this session is Dr. Bhushan Sabni sir, and Dr. Ajam sir, Dr. Shivam Sinha, Dr. Siddharth Agarwal, and Dr. Samudit Datta. Please join on the stage.
Good morning, all. First, thanks, John sir, Dr. Arvind sir, and Janaki for this opportunity. So from morning we have seen various techniques of meniscal repairs, and the principles were all discussed. Yeah, good morning, all. So I request the panelists to keep the discussion crisp so that we can have more cases to be shown for the short of time. So let's go to the first case. This was left knee pain and instability for I think it's 5 months and not 5 years, and aggravated since 1 month. Instability and locking episode was there, and the knee range of movement was 130-degree, and drawer was positive, so it was at ACL, and McMurray test was positive. X-rays were normal, and this was the MRI coronal and sagittal images. So there was a subtle small undisplaced medial meniscal tear, and that was a preoperative MRI, which was not very conclusive. And this was the intraop picture. So Bhushan sir.
What's the age of the patient?
Age was about, I think, 40 years.
Okay, so what's the question?
Yeah, so how often you see this, and what would be your plan? And
A bucket of a lateral side is not very uncommon. This seems to be a fairly white on white part. You're right, it's a double bucket. And
not exactly does this fit into that classification, red, white? Because we see there are not only double bucket, but it seems to be there is a horizontal degenerative tear, and there is a peripheral rim tear also.
So I'll cut the chase. I think the free end, which is displaceable, the one you're showing, needs to come off. The peripheral portion, which is attaching to the capsule, needs to be repaired. It's a red zone. You can, of course, try and salvage the situation by repairing all of them together, but you will hamper the biology of the local area by putting too many sutures inside. I think I would take out the bucket handle of it and save
the superior flap, you
superior
take it,
flap,
the inferior flap, and then the peripheral portion you would
I'll try
repair
and
it.
save that, because the blood supply will be good in that region,
Okay.
posterolaterally.
Okay, any difference of opinion regarding that, sir, or just needs a partial meniscectomy?
No, we will try to preserve the peripheral and the posterior part. The flap needs to be removed.
I need to see the root part also, the extension of the tail.
The root was intact. The root was intact. So sometimes we do, as a surprise, we go inside and then we see this kind of, bucket handle tears where double or triple fragment would be there. But then the ultimate goal would be to retain as much as collagen as possible, and then try to, preserve, restore the hoop stresses of the meniscus. So any difference of opinion?
No, just I will remove the white zone and put a 1 or 2 all inside to stabilize the meniscus with the capsule.
Yeah, so this was not exactly like a white zone, this thing, because as we can see, it is a horizontal tear, and then the superior flap has come as a bucket handle, and the inferior flap was also a bucket handle. So it is a peripheral rim of tissue is there, where the original is the red, and then there is a horizontal component dividing the meniscus into upper half and the lower half, and then it has it's created this kind of triple bucket handle. So what I did was I tried to retain all the collagen tissue and restore the meniscus. And here there are various techniques to be employed in treating this complex tears. where I just passed first the suture lasso underneath it, got the threads across, and took bites in all the 3 layers. So it kind of compresses the meniscus. And once the posterior horn was stabilized, then we had to go and repair the bucket handle, which is beyond the popliteus fossa with inside multiple inside outs. It's a quite challenging because this fragment is little flimsy, and this was a red tear with the upper flap and the lower flap. So that's why I've tried to stabilize all the fragments, all the 3 components of the bucket handle. And it took a lot of time to do that, but then needs a lot of multiple sutures. So here again, once the sides are done, and then the central part again pass the suture lasso and shuttle the wires. Now there are upper fiber and the lower fiber. The lower fiber first took the bite into the lower fragment and then into the upper fragment, and then the upper fiber into the posterior peripheral zone. So this gives the compression for the horizontal component as well as fixation to the peripheral portion of the meniscus. And then we can see that it's still opening up, and then just to close the the meniscus, you can stabilize it with the all inside device. So this was the repair configuration. It needs multiple stitches, and the biology of course would come from the ACL tunnels. So this would, once the meniscus are, all the fragments are stabilized, then it will go on to heal. So this is the final picture of the complex meniscal repair. Siddharth, any comment or anything to add upon?
You have used a lot of techniques. I think all the instruments in the battery have been used. Somehow I'm not very comfortable having so many bites in the meniscus, number one. Secondly, the superior flap that you have fixed, at the end of the day, it doesn't look to be very healthy to me. So I won't be very happy preserving the superior flap. My approach would still be the same as what Bhushan sir said. Remove the superior flap that was seemingly flimsy and thin on the outside.
Yes, that's very true. Actually, this fragments are little flimsy. It is like we can try only one shot. If we do multiple shots, then it will become very friable, and then we have to end up in doing the
Ramakant, how much time did it take?
Yeah, probably 40 minutes.
That's still good. So
40
you
minutes
have
in your hands.
Yeah, your
That's the
hands. So
point.
and we know you are a gifted surgeon, but for normal people, it might take an hour and a half to do all these many sutures. So if it heals, fantastic. There's no harm done. But I think the bill will be too high with so many sutures and instrumentation you're used.
No, actually, only the fiber threads. All were
inside out. Okay.
Inside out with a loop wire.
Yeah,
so
that's
it's only the fiber wire, and only one all inside device I've used.
So you have done definitely a good surgery, there's no question about it. But the point of discussion is how much meniscus you need for the loop stress to work. You don't need more than 50%, number one. Second, the healing rate. Yes, we can tie everything, but the healing rate in white and white zones is very actually poor. And after 5 months or after almost 6 months.
Yes, sir. Definitely, I agree upon that. This was not exactly a white tear. As I told, there is a red tear, and then the inner portion is divided into upper half and the lower half. So it is actually a red tear. So I'm just putting back the red zone back. And then there is a horizontal component which divides the upper half and the lower half. I've just did the compression. So the inner portion definitely may not heal, but then the bleeding has to come from inside, and then it has to heal. Of course, this is little technically demanding, but we need to have a combination of techniques to salvage the meniscus. So at the beginning, even I have gone and
What
done
you
many
need to
partial
so the
meniscectomies.
take home is don't just go for a meniscal surgery with all inside devices. You should have a lasso, you should have a scorpion or first pass mini or whatever instrument you use, and inside out ready in your armamentarium. You cannot just take a single fast fix or something like that and say that I'll do any kind of meniscal repair using this.
Yes.
So all of them are essential to be known to the surgeon as well as to be there during surgery for such a complex case. But
Yes, sir.
good case otherwise.
Yes, sir. Thank you. And this is the 31-year-old male with pain and instability for 2 weeks and twisting injury. And of course, there was a ACL tear and then there was a meniscal tear. And the meniscal coronal MRI showed that there was a radial tear and there was a horizontal tear again in the lateral meniscus. Lateral meniscus, it's little flimsy tear because of the popliteus hiatus coming in. So this was the 3 fragments. We can see that there was a medial fragment, there was an intermediate fragment, and there was a lateral fragment. So what would be plan and the configuration of repair, if at all? This is just 2 weeks old. We can see that there is a good looking meniscus, the healthy meniscus, and there are some bleeding points in the peripheral zone we can see. And what techniques can be employed in this, Siddharth?
This definitely looks very much healthy and fresh. So I would like to preserve as much tissue as possible. So we divide in 3 parts: the anterior, the middle, and the posterior part. So the posterior gets repaired with the middle and middle gets repaired with the anterior. I would repair the middle and the posterior part side to side and put a tunnel through the tibia and deliver the suture pull out, just like we do in a root repair. So it will be sutured together plus delivering through a tunnel in the tibia for the posterior bites. And the anterior and the middle I'll fix with each other and then try to fix them with popliteus.
Bhushan sir, anything to add upon?
So luckily you got a good joint opening there, so sufficient space. I would use a scorpion or first pass mini to repair the posterior and middle fragments with each other. And I might even be able to do the whole thing with scorpion only and get multiple bites in the meniscus to repair it using all inside device such as scorpion. Of course, you can add a all inside device whichever way you want. This is too posterior to use a inside out device in my opinion. So we'll try and stay with.
The message is clear. We need to have a combination of technique to do this repair. Actually, in this case, I was little lucky. The fragment was little flimsy, but the meniscus quality was good. And I was not sure about the middle fragment, but now this was done about 4 years back. I would have done initially, fixing the middle fragment to the medial and again the medial fragment, the innermost fragment to the posterior fragment. So that would be my plan of action as of now. But what I did 3-4 years back was I tried to do the side-to-side repair between the medial and the lateral fragment, and the intermediate fragment I had just kept it across there. I didn't excise that in this case, and just put it in between the repair. So I did the side to side repair, and then there was an overlap, and of course this is not going to heal because this overlap. So the overlap portion I had to go and excise carefully, make it like a simple side to side. So this was the overlap portion, but then it was curling up inside. So I had to fix it with the all inside device and trying to see that the needle pierces through the middle fragment as well, and then finally achieve this kind of repair configuration where the meniscus has beautifully formed the C-shape kind of repair. But this was little the repair was approximation was good in this case. So what we have started and then what we had ended up was this
So basically the intermediate fragment was excised or short.
Yeah, inside that I've just pushed it inside the fragment. I didn't excise it, but then I made sure that when I took the inside all inside device, I made sure that I passed through the inside the intermediate fragment as well.
What's your take on passing through a tunnel in the tibia in this case? The side-to-side bites that you have taken.
Yeah, that could definitely add to the value because it reduces the stress on the repair. So definitely that is a good point. But I didn't have that thought process at that time.
Lateral meniscus needs to have some mobility. So fixing with the tibial tunnel makes it more rigid actually.
It will give us more about a fixation point, more like a root repair. In
Agreed.
this case, we are really skeptical that these two fragments will heal. So they will have one more point to heal if and plus they provide exact biology at the point of repair. So that helps in such cases in which we have a very hashtag.
I agree with that for medial meniscus. For lateral meniscus, I think I will not put the.
Yeah, it's a collagen tissue. So we want to preserve the tissue and then fix it to the, posterior capsule. If you excise it, there will be a gap. Yeah, that the meniscus was little tight actually.
So
when we did the repair.
that's why it crumbled out and he have to shave it a little.
Yeah.
The basic philosophy is working in last two cases I see is that they are trying to preserve lateral meniscus as much as possible.
This is 3 years back. Did it heal? That's the most important question.
And how you assessed
Yeah,
it?
there was no symptoms for the patient as such, and he didn't come with any mechanical system, so that we had to go back and do MRI and then
Perfect.
do it.
That's good then.
So. No, if you overlap it, the peripheral portion, there is a possibility that they will unite. But then the inner zone, which is white zone, we doesn't have any, blood supply. And all these meniscus healing has to, the glue has to come from the ACL tunnels. So whatever it comes, all that, the biology has to, kind of fix it.
But he trimmed that. It's not the trim that.
Yeah. So we'll go.
Then he trimmed the thing.
He wants to move on.
Yeah, so we'll go to the third case. This is a very interesting case. It's a 45-year-old female with 5 months pain. She was given 2 trial of conservative management. There was a lot of medial joint pain and the McMurray test was positive. X-ray was looking fairly normal. The alignment was looking fairly normal in this case. And there was again a radial tear and there was some cartilage changes in the MRI grade 2 to grade 3. And it was not exactly the radial tear. It was kind of radial oblique tear. So that means that there was a radial tear with the oblique component to the meniscus was there. And this
Ramakant, they are ready at OT for final closure.
Yeah, sure.
Just have a look on that.
Yeah, sure,
Then
sure.
So we are ready with the final picture. Just to close it all, we've had a good ACL reconstruction done. We've used our adjustable loop. We have a nice tight hamstring graft sitting right anatomically. And the PCL, which was a little lax, is also in place. The meniscus is also sitting well. And there is no displacement or any stability issue there. So thank you all. Thank you. I hope it was a good demonstration and we have been able to show what we wanted to show. We've had excellent meniscal session today morning and this was in continuation with the same. Thank you, Dr. Arvind. Thank you, the anesthetist team here at Paras. Thank you, my assistants here, Dr. Piyush and Dr. Prasanjit and also Niloy. Thank you very much. Signing out from Paras Hospital. Thank you.
Thank you, dear. Thank you.
Yes. Now we'll proceed. Dr. Bhushan sir, this was 45-year-old, 5 months pain. There was a lot of tenderness was there, and she was given a trial of conservative management twice, but then she came back repeatedly, and then we found that intra-articular it was a radial oblique tear. So not exactly 2 radial tear, but it was a oblique tear. That is a combination of radial tear with the parrot beak tear. So what you would want to do that? And there was some cartilage changes. We can see it's for 45 years.
I think posterior horn medial meniscus in a 45-year-old without a ACL is a bad combination, and an ideal solution to get her back in action fast will be to excise the tear. But the problem here is the periphery of the tear. So the extension into the capsule junction is a tricky thing. So what you can do is you can take out the white portion of the tear and just repair the peripheral part using whatever device repair technique you want. So what I'm saying is you can repair it here and here and excise this much part if it's coming in your way. Of course, you can repair the whole thing without
Okay.
any issues. Even if it doesn't heal, as long as the periphery is stable, that meniscus might still survive. 2 degrees varus is too less for a osteotomy, I agree. But you can think of that if there's significant more than 3-4 degrees varus.
So offload,
So that-
yeah. Siddharth, you would want again, transtibial.
Add a tunnel to this. Same thing, add a tunnel.
Okay. So here, this is a radial oblique tear. It was little degenerative and flimsy. It was little old tear was there, and it was an oblique tear. So I did, try to do the side to side, and then it gets cut through that fragment. So this was my first attempt. As you can see that I tried to do the side to side, probably in the mid zone. Because I could not reach the peripheral zone. And then I did try second time till form the knot, but then again with the knot, when I tried to approximate it got cut through. So twice attempted, flimsy fragment, and it gets cut through, and then cuts the meniscus into posterior half and the anterior half. So what was the salvage? Just excise it, come out, or anything else? Actually, this was my first case.
You can do the good old hashtag technique to repair it. So
Hashtag, can we do it for oblique tear? I've never tried
difficult.
it.
It's
because
difficult.
for a true radial
Yeah.
tear, it would be
So,
nice hashtag.
So, but you will need maybe 2 or 3 all-inside devices for hashtags. So go slightly further away and then try and repair it along with the inside out.
Still, after the second cutout, you would want to do it?
If I've cut out twice, I will stop there. I will excise that part of the meniscus and just put one all-inside device or inside out extremely in the periphery. That will be my plan.
So Rama, there was a gap in between the two fragments.
Yes.
As you closing this gap, there was cut through.
Cut through.
So that was the reason behind cut through.
No,
Even though it was
also-
bad
also
tissue
you can
also.
see the status of the joint, sir. It was like
It's degenerated and
degenerated.
quality is not very good.
Meniscal quality is also not that great. So I did end up in excising it. Anything else to do here?
You
anything-
stabilize it with the
Inside-
capsule also. You use the inside out, all inside also. Stabilize the remaining with the capsule.
Okay.
As sir was saying.
Okay, that could be the option. So this was my first case here. I did, read about it, the root reconstruction, but I've never done it. This was my first case, which I did about 2 years back. So here we can see that to begin with, there was an oblique, there was a flimsy fragment, and there was a gap as well. So first attempt, there was a cut through, and then I did try to do a second attempt. I was able to get the knot, but then as I was tightening the knot, I had my second cutout. So I'll just move a little forward. Okay. So as I was tightening it, I had my second cutout, and once 2 cutouts, already flimsy fragment, it's not going to hold any more sutures into that flimsy fragment. Intraop, I did have the idea of, doing a root reconstruction. So I did a regular like a transtibial tunnel, just 4.5 mm tunnel. And then I took a gracilis graft. I shuttled the wires across the medial fragment, and then I shuttled the gracilis graft into the, the medial fragment, and then took both the threads into the tunnel. There's a shuttle suture going through the tunnel, and then railroaded, and then got the graft into the tibial tunnel. So here you can see that we need just a connecting collagen tissue, and then I try to pull it, and then here the root reconstruction was attempted, and then it was successful in this case. And then outside, I had to go and fix it with the 6 mm screw there. So this was a root reconstruction as a salvage technique was done, and this is the final picture. So we need a connecting collagen, just to restore the meniscal root to its original position. And I did follow up this patient. There was full movements, and I did a 6 months MRI. just to see that was there any healing in that root region, and there was a healed root which could be identified. So this was a 6-month follow-up MRI. Any comments, sir?
Novel technique. I haven't gotten my head around this, but yeah, if it's working, why not?
Yeah, just to buy some time till they go for TKR.
So can
He's
you
just 45 years.
without doing this gracilis graft, can you not be able to do the root repair?
Yeah, in situ you can
root
fix
repair,
that,
you can-
but then it's going to be a non-anatomical repair. I mean, it's going to be away from the footprint. So you want to get it to the footprint, the gap is 10 to 12 mm. So that much of, meniscus getting it
Or
into
you
the
can do the Laprat technique, release the posterior
Peripheral-
meniscal capsule, release completely and pull it inside. The main thing is the meniscal extrusion is not corrected yet on the 6 months MRI. So that is
Yes.
the main issue here. So you have got a continuity of the meniscus now, which will allow some hook force transmission. But whether it will actually give you time for offloading that joint for more than a couple of years, we don't know yet. But yeah, if it works, that is a very good way.
Yeah,
of
now
doing it.
it's 2.5 years. The patient is okay. There are some pains are there because of the cartilage issues, and we have to wait. She's just 45, so we have to wait for long-term
Good
follow-up.
technique, yeah.
Yeah, Bhushan sir, you are doing a lot of osteotomy. So do you think adding HTO in this case will help this meniscus to heal better or preservation of the joint?
I'm going to say something very controversial, and John or all of the senior guys might be upset with me. But I feel if you have a bad meniscal tear with a failing medial compartment, any varus is bad. So even if it's a 5 millimeter correction,
5
also,
degree of
I would do
correction.
it.
Yeah.
So osteotomy is a very powerful surgery. You don't need to get her to 70 degrees like a very bad knocked in
absolutely.
position. But I would do a 5 to 6 millimeter H2 at the same time, and that would actually help in healing this meniscus. Even if you hadn't done anything, it would have healed in about 6 months' time. That's what
Same
my
I have started
my
doing
experience.
for last.
You won't be, in case it is, as he's saying, that is she's wearing the meniscus each time. If you would have done the osteotomy and left the meniscus like that, it would have healed.
So if you offload a meniscus, it heals. That's the theory.
There were signs of medial compartment overload also. There are a lot of subchondral bony edema.
On the MRI as well as on the arthroscopy, there's a lot of cartilage damage.
That time I was wondering what
So
exactly.
this is a failing medial compartment. So
This
you
is
need to
failing,
do
so
something about it.
offloading would definitely help.
Yeah. Did you do a lot of pie crusting for the MCL?
Yeah, I did
That helps in offloading the medial compartment.
Yes.
So that's
that's why the gap was little good. Thanks, Arvind sir. I would conclude here. The repair depends on the tear morphology, and we need to know all the different techniques. And sometimes for the complex tears, you have to use a combination of techniques. And for poor tissue quality, root reconstruction with Grizzly's graft may be the salvage temporary option. Thank you very much. And I take this opportunity to invite you all for Ganga Arthroscopy course. So we have already planned around 29 live surgeries and panel discussion and live audience poll and debate. Thank you very much.
Thank you, Rama, for wonderful cases. And thank you, Chairperson, for great comment and thought. Thank you. Sajir, Dr. Sajir.
Yeah, can you hear me?
Yeah, Dr. Sajir.
Hello.
Yeah. So
Where is the camera? Where is the camera?
So,
yeah,
Chair,
hi.
so Dr. Sajir, moderator is Vikas Kapoor, sir.
Hello, Dr. Vikas.
Dr. Manish Kumar, sir. Okay.
Dr. Manish. Let me thank Bihar Arthroscopy and the Arthroscopic Society combined effort, the Paras Hospital involved, Dr. Arvind Gupta and Dr. John Mukhopadhyay to give us this opportunity to demonstrate our surgery. Today, Dr. Anand Juti was supposed to demonstrate this, but I am doing this on his behalf with his team. I have to give credit to two people who are here with me, which is Mr. Prakash Mahajan and Mr. Bhagwan Nirgude, who are the full-time assistants at our clinic in Mumbai, which is called SportsMed Mumbai. which is a facility for sports injury and arthroscopy where I work at. And I've been associated with Dr. Joshi since last 12 years. So I hope that I can live up to his expectations today here. The patient that we are having on table today is a 48-year-old gentleman who is a professor by occupation. He is a low demand individual. And he had a surgery in his knee 10 years back, which was an ACL reconstruction. No further details are available. For almost 10 years, he was doing very well when he had a twisting injury 3 weeks back, after which his knee got locked. So if you look at the clinical situation of the patient, he is in almost neutral alignment. If you can demonstrate the look of the leg from externally, you can see if not neutral, it is in slight valgus, and it is not in varus for sure. And clinically, now I have taken out the meniscus. This is a better time for me to examine. You can see that his knee is grossly lax. It's a big knee, so you know how much of graft you would need from some of the things like this. He has a very mild pivot glide, I would say, but it is definitely opening up both on the lateral side and very mild on the medial side. If you look at the radiology of this patient, you can see that there is extensive changes in the medial compartment. There is degeneration in the medial compartment. Shiv is showing the changes. You can see that there is some osteophytic lipping also anteriorly on the medial femoral condyle. The graft position which was there prior gives me an idea of how it will affect this surgery or how it is going to affect me during the reconstruction process. So here you can see that the graft is quite posterior on the tibia and slightly anterior and vertical on the femur. So it is not going to come in my way in any which way, even if I do a revision or if I do an IT band tenodesis, if I do a lemur, these things are not going to come in my way. And the size of the cavity of the previous tunnel is also important for me. So you can see it's very slender. There is hardly any remnant tissue. So you know that these tunnels are not going to come in our way at all. So here we have done a diagnostic arthroscopy, the recording of which was not there. He had a badly frayed medial meniscus, and it was a buccal tear. We excised the meniscus. You can show the excised fragment and some of the factors that Ramakant was discussing in his session. You can see here how these secondary tears, the presence of a radial tear, how the meniscus in itself is fully spliced. All these things are sometimes only one meniscus. So still there, I analyzed that his lateral side of the knee had a easy drive through. So I decided that we have to add a lateral sided procedure, which I'm thinking that I will do a lemur. I've made the incision to now incision, which is roughly around 2 inch. And the idea of this cord graft is that you should take the portion of the graft which is thickest. Now, if you can bring the video in to show where we are harvesting the graft from, the things that I look out for and is this muscle belly. Can you see it on your screens? Muscle belly of vastus medialis is what I look out for before I start my incision on the quad tendon. So this is, of course, a slightly smaller incision. Yeah, make it even more smaller, that roughly about 1 inch. And we typically use the Quad Pro to harvest the strip. But here, since I'm demonstrating, I would go ahead and make a slightly more bigger incision. But how I would go about if I was incising is, I would place the medial side of the strip, ensuring that there is a slight cuff of tissue for me to repair back. Here I know I need a graft of roughly around 9.5. Accordingly, I'm making my strip on the lateral border. And this strip we can now extend right up to the patella. And once you hit bone, you know that's where you have to stop. At this point, there are many discussions that one can have, whether to take a soft tissue only, whether to take a soft tissue with bone, whether to take a partial thickness, whether to take a full thickness. In my experience, I find that a partial thickness cord graft is sufficient for majority of the scenarios, and one doesn't need to really take the full thickness. And this was a point that I was even discussing with Shiv yesterday, that when we take a full thickness cord graft, often we are finding nowadays that the graft becomes even more thicker. A year and a half down the line, we find that these graft, which we had put in at original size of maybe 9 or 10, a full thickness graft, becomes even more thicker. A simple Alice forceps is what I use at this point after elevating the cord strip of the patella. And one tip that anyone can use is using a blunt-ended steelis, not a sharp one, to get a partial thickness. You slide the steelis in all the way. So that way you have opened up the lamellae, and you know you are between the vastus intermedialis and the rectus, so that you can go ahead and harvest only a partial thickness of the cord. At this point, you can insert a Quad Pro. A Quad Pro is a device by Arthrex which allows one to cut and detach the cord tendon from its proximal attachment. Few of the things that I guide or advise everyone to do initially while harvesting is better to visualize fully, make a big incision, and ensure that you are in the right plane before you cut your proximal cord. So I'm keeping my finger and seeing that I have roughly around 7 centimeters of soft tissue, because half of my digit is an inch.
So, Sajid, Dr.
And-
Kapoor here.
Yes.
So you are already 7 centimeters of length.
Yes. Yes.
And my take is, if you don't have a Quad Pro in hand, what would you do to harvest this tendon?
No, if I do not have a Quad Pro, I have to just extend the incision and snip it on the top. You can
Correct.
even
So-
insert a blade and snip it on the top, but just for demonstration purpose,
Yes.
here I have made the incision slightly larger. I'll also demonstrate how you use the Quad Pro to take the proximal strip, how I do it, not how the industry tells me, but this is how I do the Quad Pro cutting component and how it helps you. Can you open the Quad Pro, please? So here my strip is already elevated. You can see it is a partial thickness. I have not gone deep. It is convincingly superficial thickness only. This helps in two ways. Number one, I have not taken the deeper layer, so ensuring that the fat between the superficial and layers is still there, and that doesn't go into the joint. And the Quad Pro comes in 3 sizes, 8, 9, and 10. I always use 10 in all my cases so that there is sufficient space for my graft to go in. So this is the length of my graft. It is roughly around 60. If you are not happy with that, you can go a little bit more and go up to probably 70. And once you reach 70, I'm quite happy with that. You insert the plug in and strip, and that's your cord partial thickness out. So the
Sajid,
preparation, yeah,
you have taken only the superficial part of the cords, that is mostly
correct,
rectus.
correct,
So
correct.
do you measure this on the MRI about the thickness of your cords? Because many
Initially-
times superficial cords give you very less diameter. Is the full thickness always confirmatory of your diameter what you want?
So
Because
that's
yeah, people-
rightly thought about, very rightly thought about, sir. So initially I used to think that taking a superficial cord only is going to give me a very thin graft, but I would suggest also look in the MRI at the thickness of the patellar tendon and what we used to put in the patellar tendon. The
Yeah.
thickness of the cord is double that of the patellar tendon. This is proven on research. And if you look at the history wise, we used to put patellar tendons of 7 and 8. The tendon itself, I'm not talking about the bone block, the tendon itself used to be 7 or 8, and they used to survive for a lifetime. So what I'm trying to tell here is this is an entire different collagen we are dealing with. We do not have to have a big bulky graft like the semi-T, and the diameter of the graft is no longer important. And what's more important is the kind of collagen you take.
Yeah,
You are
definitely. This graft is having the highest percentage of collagen. Yeah, but what I say, if you are taking superficial quadriceps only, and
it will
if you
come up to
think,
only 8.5, 9 max.
yeah,
You're right about it.
if you think the graft is thinner, then you can
Yes.
take the full length of this rectus femoris.
Yeah, so that is the original technique which was presented in France, publicized by Dr. Rajiv Raman,
Rajiv
where
Raman,
you'd
yeah.
strip the entire length of the rectus femoris. But I somehow have seen patients with a huge defect which is insinuating into the quad post surgery. Quad is not like the hamstring where you can take a strip and just leave it. It is an anterior stabilizing structure as well. You cannot take a strip of the quad expansion and expect no issues in an athlete. So the first time I got a problem was when I extended the incision into the proximal rectus muscle belly itself. I found a patient which had come back with a bulbous lesion in the thigh some 8 months post surgery. He said, "ये क्या है? मेरे thigh में ये क्या है?"
It was
I told,
herniating.
"Boss,
It was muscle
oh,
herniating through that lesion.
correct. So that was the rectus which was herniating out of the defect and causing a big bulky. For a basketballer, it's definitely a problem. So he obviously I couldn't do anything about it, but I would warn anyone against going into the muscle belly of the quad because it's a very vital structure when it comes to athletes. So here I've closed the superficial layer of the cord. I'm closing the superficial fat pad as well, while you can demonstrate how the cord is being prepared with the RTT fiber tag implant. Now, Prakash is an expert in preparation of this cord, and he has just made the graft slightly smoother. It's not going to be too big. It's going to be max 8.5 diameter. And I had checked his footprint, and I believe that that diameter is enough for me. And in this case, I am supplementing with an external IT band tenodesis. So for me, a 8.5 graft, which can be really sleeping inside, that is an obliquely placed a central cord graft, is enough for me and to give him good stability because he's a low demand individual. Any questions or?
No, you are absolutely right about the herniation. This is one of the complications of taking.
Yeah.
And if you don't
So
have any instrumentation to harvest the quadriceps, you can
Yes.
just maybe increase the incision by 1 centimeter more,
Correct,
shift the
correct.
window, harvest,
Correct.
harvest 7 or 8 centimeters. That's what we had
Yes.
20 years back to take
Yeah.
the quad tendon. So that's the standard
Yeah.
technique.
Yeah, but nowadays all my patients are sitting on social media. So some of the girls are really unhappy with the scar, which especially elongates post surgery. So I really like to give a cosmetic incision. So majority of my time, my incision is half this size, especially in the female. And I believe that this scar stretches too much. This area that we're dealing with, it stretches too much and leaves a very ugly scar. So I do not do the transverse incision, but vertical incision slightly smaller is what I go ahead with. Now, since we have discussed with the cord, do you want me to demonstrate the IT band tenodesis approach and then I'll go ahead with the revision, or shall I start with the revision?
I think we do the revision first, and then whatever time is left, we see the edit.
Okay. So this cord preparation will take some time. If you have some topics to discuss, you can go ahead and discuss that. Then I'll come back for the revision. It'll take another 10 minutes, or you want to
So
watch
for
me do the
revision,
IT band tenodesis
what is
exposure?
your plan for your tibial tunnel and for your femoral tunnel? This
Here
tunnel
it's
needs to be vertical.
here
So would you do an anteromedial accessory
stools.
portal and do
Can I
the
have
standard?
एक वीडियो इधर दिखा दो. Sorry, yeah. So this is a 10-year-old tunnel. I don't think that this tunnel is going to come in my way in any which. It's not going to hamper me.
So if in the X-ray you look, it's a very vertical tunnel. So it is probably transtibial surgery which has been done last time. And
Yeah, so it's quite
it
posterior,
is
and I believe that this old tunnel is not going to come in my way. So 3 scenarios of how you deal with a revision. Number 1, you are having a tunnel which is bang on position, well placed tunnel. Number 2, you have a tunnel which is way off. These two situations I am not at all bothered about. But if I have a situation which the tunnel has been placed almost there, that's the kind of tunnel which interferes with my revision surgery. Here I've just exposed the IT band and I'm taking a posteriorly blazed strip. I'm not detaching it. I'll tell you why. I don't detach my tendons, the IT band strip. The reason is because in case during my surgery, if I see that my socket of the femoral tunnel comes anterior and is going to coalesce, then I can convert this surgery into a modified Macintosh, which essentially means I'm going to do a soft tissue tenodesis of the IT band and not tenodesis into the femoral condyle itself. So here I've just made the strip, not detached it, and we are just completing the cord preparation. It's almost done. We can complete the surgery in another 2 minutes. We'll start off. The tibial side is also prepared. And you can see one tip that you can use to complete the suturing of the cord on both sides is these suture straight needles with battery low. Can you hear me in the crowd, or the battery of the camera is low? आवाज आ रहा है?
We can hear you.
Yeah, okay. So I'm just telling that you can use these straight needles, which works very easy in our hands for preparation of the cord. We have essentially placed two sutures on the tibial side, one suture onto the tag on the femoral side, fixing the button. So the adjustable loop on one side and 4 sutures on the tibial side. The whole construct is ready. You can see it. Could have been cleaner and neater, but I think I have to be satisfied with this today. But the size of the graft is 8.5. 8 is snug, so it has to be an 8.5 size graft. And the length is roughly around 70. So here I'm done with my quadriceps graft preparation. Now I proceed with the revision surgery. You can show the inside video, please. Outside video, bahar bata do. Khali inside video chalu kar do. Yeah. So to complete Dr. Anand Joshi's principle, we never harvest the graft without doing a diagnosticoscopy, which I did first. Can you switch on the light of the camera system, please? Camera system light, please. Light chalu karo. Camera system ka light chalu karo. Yes. Okay. So you have the picture on your screens. Do you have the picture in the inside video? Andar ka video screen pe laga do. Ja raha hai? Okay. So you can see I evaluated the patella, I evaluated the trochlea, checked for any chondral wear. I came in, I looked at the intercondylar notch. There were 3 loose bodies like particles over here, which I cleared out. And the meniscus bucket handle was stuck in the intercondylar notch. I did a very conservative notch plasty using a bar. And can I get a probe, please? Then after the meniscectomy, you can see that the intra-articular picture of the medial femoral condyle and the tibial plateau is not too bad to give up on this knee. You can see it is still smooth, rounded, and doesn't have any grade 4 changes. And he has a decent size remnant. And the important point at this stage is also to evaluate the ramp area. So you can see that majority of the meniscus is gone, and you are only seeing a subtotal meniscectomy, a peripheral rim of the ramp. This is not a lesion. This is just what the capsule left behind. But one important finding, which concludes what kind of reconstruction or extra-articular procedure I need to add in this case, is by visualizing the lateral side. So if you look at this, the lateral side is excellent. But wash. बाटले दबाओ, चालू कर दो. पानी चालू है क्या? You can see the lateral compartment is excellent. It's dry through. The tip of my probe is roughly 5 millimeter, and it's clearly 8 millimeter to 1 centimeter opening on the lateral side. And this is not with any pressure. This is just figure of 4 position. Hath sod, paiche, hath sod, pressure nako. This is without any pressure, you can see. So adding an extra-articular procedure in this is definitely necessary. So here again, the question is about the tibial tunnel and the femoral tunneling. The old tunnel doesn't come in my way. So here, the notchplasty has revealed the exact area where I need to go to, the footprint of the ACL. I have made a liberal notchplasty. You can see that's the anatomical position where I need to go. Now, this area is completely virgin and it's not going to come in my way of the previous tunnel is not going to come in my way, and that previous tunnel is nowhere to be even visualized. So this is a pretty straightforward primary ACL like drilling of the femoral tunnel. To a table height bada do, please. So this is a jig by Stryker, and this is the system that we use routinely. You can see that's the posterior lateral femoral condyle. You can drill in this situation with the knee 90-degree flexion, and you can place the jig at exactly where you want it to be anatomically. This visualization is anatomical, and you really don't need to hyperflex the knee to. तुम बाजू में आओ, कैमरा बाहर से दिखाओ, वो बाजू से आओ, शिव जिधर खड़ा है उधर कैमरा लाइए प्लीज. So this flexible wire has gone in the exact femoral footprint where I need it to be, and I've gone as far posteriorly as possible because I have a lot of space to play there with a size 8.5 graft. There is no harm or issue of a posterior blowout with a graft which is this much. I have sufficient condyle over there. Can you see that? Can you see on your screens? Yeah, one additional landmark that I take into consideration is the root of the posterior and lateral meniscus, where 35 is the size of the tunnel. So now I'll go ahead and drill around 20 to 25 of the femoral socket. One important thing when it comes to a central cord is all this preparation is based on sutures on adjustable loops. And there is some amount of slack that happens always. So you drill extra, don't drill cut to cut, as in don't keep it to just 20. Drill a little bit extra so that you ensure that slack doesn't bring the sutures intra-articular. So here I've drilled up to 25. Sort card 4.5. So once I'm done with my size of the socket that I intended to have, now I'll go ahead. Thoda or table height or head low denge. Can you give me some head low, please? Head low. Okay, that's completed my 4.5 drilling. My femoral socket is done. Sorry. क्या बोल रहे हैं? Sorry. Suction देख लीजिए. So I am nice and low and posterior. Does anyone have any comments on this, or do you want me to do any changes? Which I really can't do at this point, but I'm very satisfied with this. It's quite nice and low. You can see a thin shell of cortex at the back. And this is all, the entire process is being done in 90-degree flexion. And it might be slightly different from your view of a transportal jig, where you do the drilling in roughly 100 degrees of flexion. So that's my femoral tunnel done. Now I'm going ahead with my tibial tunnel. Just want to have a, 1 second. Can I have the probe, please? So here, the question that Dr. Vikas had asked, the original socket, the concern about the original socket. Here on MRI itself, I said, this is the original socket. Can you see that graph material there? Can you see the anterior horn? Am I audible in the crowd?
Yes, yes,
Am I
you are.
audible? So this is the anterior horn of the lateral meniscus. This is where we should be at. And this is the medial tibial spine. And you can see that this is where one should attempt to be at and not there when it comes to anatomical tibial tunneling. Here, I know that my graft is only 8.5, so I don't need to make a huge socket. I can go as far medial, hugging the medial tibial spine as well when I come in during the tibial tunneling. So here, if I target a site, I would keep my angled elbow aimer, flex curve, elbow aimer in such a position that I am way central probably, so that I can gradually take it more medial. Any which way is the old tunnel is far away anterior. You can see is anterior to my jig and doesn't come in my way at all. I'm feeling all left out. Any questions?
Don't you think this will cause an impingement? It's too anterior.
Yeah, you're absolutely right about it. But here, so since you said that, we have come anterior, and thanks. So what I'll try to do is I'll drill one more wire and bring it slightly more posterior and ensure that unkinnick wire drill color. So if you do make a mistake here, so now I made a mistake, I need to correct it. If I need to correct it, the way is keep that wire in and drill with one more so that it go slightly posterior. Or the alternate option is use a very small size drill like a 4.5. And with that drill, with the 4.5, and with that 4.5, then you can serially dilate and get to that area where you really want to come in. Okay, this has come even more anterior. छोड़ो 4.5 से करो. नहीं तो ये थोड़ी आगे गए. Just take this a little bit behind. Just give me a moment while I rectify this step of mine, so I do not want to make any mistakes here. Can you slightly full नाही भाऊ, थोडी मागे थोडी मागे perfect. आता अजून drill करा, दूसरी wire drill करा. Most often at this point is when you have a perfectly placed previous tunnel, it's an easy job. The same socket can be used. Only thing, you have to use a graft which is slightly bigger so that it obliterates the tunnel. If the cavity is too big and you end up drilling
I
with
feel,
a very...
if you go posterior, it will not
Yes.
matter whether you reach through the anterior part of the old tunnel. What would help you is
cut.
that you will
4.5
still
cut.
have, you can manage the tibial tunnel with a thicker screw.
Cut.
So, I think you should go more
It's kara
posterior.
4. Sorry, I didn't get you. What did you say?
If you go posterior, instead of worrying about the posterior tunnel which is there at the back,
Yes.
you would still not be hampered, because once you pull the
Correct.
graft, there'll be
Put it in.
enough space which you can measure and give a larger size screw. Or you
Correct.
can
Yeah.
use the,
You,
so
you're
don't
talking
worry
about...
about this
You
is
got,
becoming.
you're talking about stacking of screws intra tibial,
Yeah.
if in case you're having a coalition, right? Or
Yes.
the previous
Don't worry.
socket.
I think we should go posterior in the interest.
Yeah.
It'll save you a lot of trouble.
Okay. So if you look at it right now, it is anterior. It is along the anterior border of the posterior horn of lateral meniscus, anterior horn of the lateral meniscus. And it is closer to the medial tibial spine. So I am using a 4.5 and using a blunt hemostat. I'm giving a pressure posteriorly while my assistant is also giving a pressure posteriorly to slightly change that position and come intra-articular slowly. Halu Atmadaya. This is the problem with the 4.5. It just blows out interiorly. So here I have come quite decent. Now I will change and try to drill with a bigger size, which is size 7. And here I'm giving a pressure on the wire so that it comes more posteriorly. Any comments?
Sajir, can you
Yes.
show us the wire in extension, whether it's impinging or not?
Yeah.
This is one of the things that beginners should always watch for. After
Right.
putting the bead pin with the jig, they
Right.
should check for this in extension, whether this is not hitting the notch.
Correct. So I did do that initially, but now I've already created my socket with a size 7.
Then it's fine.
Sorry, I
No,
already
it's
have.
okay.
So now I'll proceed with, wait, wire taka and 8.5. Sarat.
So you drill with 4 mm or it's 8.5?
Initially, I drilled with a 4.5. Okay, still now I can show the step which Arvind sir is requesting. So here my wire is in the socket. And you can see how it is coming in. The medial tibial spine is there. That's where I've come through. And this is here. You can see my full extension. And this is my full extension. And the wire is still posterior.
Yeah. That's the thing. This all newcomer has to be watchful about this wire impingement in the extension. That should go into the notch rather than hitting the notch. Okay.
Yeah. Also use this simple step of using a hemostat intra-articular.
Yes.
It does leave a little bit of metal debris. You can see the metal debris intra-articular.
Yeah,
but it gets my socket perfectly where I want it. So I'm quite used to this step of using a hemostat.
So after with the a smaller rimmer, you can change the
Yes.
position of your bead pin according to
Correct.
where you want. If your initial
Correct.
bead pin is not in the exactly anatomical position.
Perfect. And that's the way I like to do the tibial tunnel always, because this step ensures that I get the tibial tunnel in an oblique fashion. Because here, when I give a pressure posteriorly, I'm not getting a circular socket. I'm getting a slightly oblong socket, because my graft is going to sit exactly how the shaver is going to sit.
Yeah, yeah,
And
yeah.
at this point, I also knock off some of this bone by just converting the shaver to one side rotation. I like to knock off this bone because this is one thing that you observe in your MRIs. If you see the good ligament surgeries that are done, you can see that the graft is sitting flush and straight right up to the posterior lateral femoral condyle.
Yeah, perfect. So Sajir, will back to you because
Yeah.
time is shooting. So
Okay.
we'll starting here ACL session. We'll back to you in between. Okay.
Okay, sure.
Okay,
Thank you,
Sajid.
sir. I'm done
Thank you.
actually. I'm just passing the graft right now. If you have 1 minute, we can then close it fully.
Yeah, definitely. We have 1 minute. You close in 1 minute.
Okay, we are done. The graft is prepared. Marking dal hai. Chala, yeah. I hope I have lived up to the expectation of the Bihar Arthroscopy Society.
Yeah,
Sorry,
absolutely,
Orthopedic Association.
absolutely. It's a wonderful demonstration, Sajir.
Please go ahead. Yes. So that's the button going in. Halu kara, demonstrate karaitse. So that's the button flipped exactly on the mark that indicates that's the exact measurement of 35 that I did. And now I am ready to railroad my graft inside. It should look okay. You can see that slack. That's the slack that I was talking about.
Yeah.
And you can see that's my finely placed anterior cruciate ligament using a cord graft revision. And this gentleman who is low demand, if you just add an IT band tenodesis to this whole setup, I think he will do excellently well.
Yeah, looks good. Yeah.
Some of this bone anteriorly, which is a part of his osteophyte, or maybe during my drilling, which has come up a bit, I just chamfer it, and then I'm done with my surgery.
Yeah. Thank you, Sajir. Thank you very much for very nice demonstration. We'll add the LET in this also. Okay.
Yes, I'm already made the strip. I'm adding my LET. I
Perfect,
just need
perfect.
to.
Thank you.
I can show you that later after your
Yeah,
session
later
is.
on we'll come to you. Okay, thank you.
Thank you,
Thank you
sir.
very much.
Thank you.
So moving on to the ACL session, Siraj.
Punch.
Good morning. Good morning, respected chairperson, distinguished faculty, and dear colleagues. Welcome to the ACL scientific session. Today we have a very interesting lineup of case-based presentation covering topics from ACL spine avulsion to joint preservation strategies. I, Mohammad Shiraz Ali, will be moderating this session. We are privileged to have our esteemed chairpersons, Dr. S.P. Gupta, sir, Dr. Sumant Nayak, Dr. Prabhat Prakash, Dr. Kapil Dev, each case will have 6 minutes presentation and 2 minutes discussion. So I request all speakers to adhere to the time. So moving on to case 1. Now I invite Dr. Ramakant Kumar to present case 1, topic ACL spine avulsion.
So good afternoon, everyone. Thank you, Dr. Arvind, for having me here. So I'm going to present a case, topic on tibial spine or ACL avulsion. This is the case history, 27-year-old male, RTA, pain and swelling, difficulty walking, local examination, painful and tender. These are the x-rays, AP and lateral views. These are the CT findings. Can see the ACL avulsion, tibial spine avulsion in the coronal and the sagittal sections. MRI images showing the avulsed ACL fragment, and also there is a undisplaced fracture in the posterior part of the tibia. Axial and sagittal cuts. So this is what I did. In this case, I used a combination of pull-through suture and tightrope, endovertebral tightrope. So first step is you have to debride the base, try to reduce the avulsed ACL fragment. Then I took a passing stitch. Can you switch up the lights? It's not visible on the screen. There's too much light. दिख रहा है? Okay. मुझे नहीं दिख रहा था इस पर. So first I took the bite with the help of a scorpion device in a luggage tag fashion. After taking the bite, I passed a guide wire and then over drilled it with 4 mm drill. Then I used a 2.6 mm endovertebral tight rope. Okay. So once I put the tight rope, I will use a drill to pull these sutures pass through the ACL fibers. So I drilled it just an anterior aspect of the footprint of the ACL. Loop the sutures. So this additional suture acts as a additional buttress that will help to stabilize the avulsed fragment. So this is the final construct, both the technique, the endovertebral tightrope, as well as pull-through suture. So it's a double fixation. So these are the post-op X-ray. This is a bedside X-ray, and this is the 3 weeks post-op X-ray. So technical pulse, first you have to debride the fracture bed, identify any intermeniscal ligament entrapment, confirm reduction with the probe, and avoid excessive tension so that you can avoid any arthroplasty or loss of extension. So there is Mayer's and McKeever classification we are all aware of, from type 1 to type 4. Treatment algorithm, normally type 1 is conservative, type 2 controversial, some operate, some does not operate, but type 3 and type 4 is usually operative. Fixation techniques, large fragment, normally you can use a screw fixation as well as suture pull-through technique, both. But in case of small fragments, comminuted fragment, and in a skeletally mature patients, suture pull-through technique is the best. So there are multiple ways you can bell a cat. Pull-through suture techniques, single tunnel, double tunnel, cross suture techniques, suture bridge techniques. Each of them has their own advantage and disadvantage. So just a comparative slide to show the advantages and disadvantages of each technique. Single tunnel is easy, but it has poor rotational stability. Best compression is achieved with the cross suture techniques, but suture management is a bit difficult. So this just so the evidence, suture versus screw, there are multiple studies. 2024 meta-analysis, they say that there's similar functional outcome. And 24, again, a pediatric meta-analysis with more than 1,000 patients, they have found that suture fixation has a fewer reoperation. While in another study, comparative study with 60 patients, Jan et al. Has found higher Lisch-Forman score with the suture technique. So the take-home message is fixation techniques depends on the size of the fragment. Both the techniques are effective. Suture fixation is associated with fewer complications. Thank you.
Hello. So have you used the single tibial tunnel for the both button and the thread?
Yes.
And then you fix it entirely?
Yes.
So what do you find advantage of double fixation over this only suture pull out technique?
I mean, just extra assurances. I mean, I'm sure that it's well fixed. Compression is good. And in this technique, I mean, the sutures that provides additional buttress to the tightrope fixation. So it's a good compression at the fracture site.
Yeah, mostly are doing this with this
double you can do
either
this
tape or suture
Yes.
in the two tunnel nowadays, because with the single tunnel many a time one side it's remain elevated. So that is the problem. In two tunnel you have better buttress of the fragment.
Yes.
So only thing I have seen the new thing that you have put it this button over that also with the suture. That is the additional you are providing to
So
them.
you do for all the AC levels button or because
just
of the big
this case I showed this.
Okay.
I use multiple techniques, single tunnel, double tunnel. So this technique is new to me. So just
So luggage tag is very important in any of the smaller fragment or the bigger fragment. It's very important when, what my experience I've seen, things work, things fails as well. The button also pulls out many a times. Smaller fragment, the button pulls out and you're left with nothing. Then again, because flimsy, sometimes the patient present late and it is multiple fragment and it just pulls out. The button you have flipped, but it pulls out. So it's very important to have a luggage tag as a standby and keep it ready.
So in this case, this patient also had a fracture.
Yeah, on the back.
posterior
That is
part.
yeah. What did you?
So how many will you fix it? I did not fix it. It's on
So
list.
Yeah,
for the cost saving, we could have done one or two screw because it was a bigger chunk. So you could have fixed with the CC screw going entirely in place of going, because it was a tibial condyle fracture also, posterior tibial condyle. So we could have fixed with the CC screw either one or two. It was bigger chunk over the tibial side.
No,
posterior
the fracture. Will you fix the fracture or you leave it?
I think we
The
can take the
distance,
audience opinion
fracture side,
also.
posterior one. Okay.
So how many of you would have waited for the fracture to heal and
yeah,
then
that's
addresses
the
the ACL? No one, I think. Everyone would have gone for ACL.
And how many will you fix it? Anybody? So on displaced fracture, so leave it. Okay.
See, anyway, you're going to immobilize the patient for some time. I think
that was the whole
undisplaced
point,
fragment,
in-
yeah, it won't make a much of a difference.
Ramakant, for your knitted fracture fragments, so if you do the same bridge technique or the other technique?
Yeah, I mean the suture pull through technique is the best for committed fragments. If a fragment is large, like in type 3B, you can use the screws. But other than that, suture pull through technique is best. There are multiple studies which says that suture versus screw, they have equal functional outcome.
So you have did the MRI and CT scan both.
Yes.
So if your patient was to escape one investigation, so what do you prefer? You go
Okay.
for CT or MRI?
I will prefer CT then.
Fragment could have been in center, or it can just be centrally, because in such a small fragment, getting its position in center is looks like little bit difficult.
See, you can use the ACL jig to position your guide wire. Wherever you want, it will come out.
That would be.
Yeah, absolutely. Center, yes.
I think we can have a discussion later.
Yeah. Thank you.
Thank you.
Thank you, everyone.
Thank you.
Thank you, Dr. Ramakant, for that excellent presentation. Moving on to next, I invite Dr. Pradeep Meena, all inside ACL. Dr. Pradeep Meena. All inside ACLR with amnion membrane augmentation.
Okay. Good morning, everyone. Thank you. I would like to thank Bihar Orthopedic Association for having me here. I'll be talking on amniotic membrane augmented all inside ACL reconstruction. So why are we talking about this amniotic membrane augmentation? It has been in use in fashion since last 10 years in cases of ACL reconstruction, and it has been proved in various literature over this 10 years of time that it has healing potential. It has various growth factors which helps in ligamentization, the bony integration, osseointegration of the graft, and significantly improvement in the clinical outcomes. And it has been proven to be safe in various studies. So when we are planning for amniotic membrane augmentation, we first need to harvest the amniotic membrane. The ideal patient for the harvest will be the patient who is undergoing sterile. For the donor, it needs to be a patient who has been undergoing elective cesarean section under sterile precautions. The patient needs to be screened. The donor patient needs to be screened for all these: HIV, hepatitis B, C, and syphilis. So after screening the patient, after selecting the donor, after the delivery, from the placenta, we separate the amniotic membrane under sterile precautions. We place it in the sterile container. The container contains gentamicin along with the normal saline in the 1:10 ratio. And it can be stored up to 24 to 48 hours under this 2 to 8 degrees Celsius of the temperature. So if the patient is undergoing ACL, the next day we can harvest the amniotic membrane previous day. So there's no issue regarding to this timing of this graft harvest and the donor because the cesarean sections have been in various volumes. So when we are planning for the patient for the amniotic membrane augmentation, the amniotic membrane needs to be taken out from the container. The membrane is washed with a normal saline. Antibiotic residues are removed, and the membrane is dehydrated using a gauze paste. It is very stretchable membrane. So there is also the care needs to take off that it should not get turned off. This is used in particular in the cases who have been selected for all inside ACL reconstruction only, because for the conventional ACL reconstruction, this amniotic membrane cannot be used because it gets rubbed off while passing the graft. So ideal candidate will be a patient who is planned for all inside ACL reconstruction. After the preparation of the graft for the all inside ACL, we wrap the amniotic membrane around the graft, and we run the baseball type stitch sutures in the fully tension position of the graft. So this steps needs to be carried first. The diagnostic arthroscopy is done first so as to confirm the integrity of the ACL, whether the patient is to be selected for all inside ACL reconstruction, for the conventional ACL reconstruction, for the remnant preserving ACL reconstruction. So if, after shortlisting the patient for all inside ACL reconstruction, we then proceed for that amniotic membrane part. So careful assessment of the ACL needs to be done. After planning for all inside ACL reconstruction, the initial steps of the all inside ACL reconstruction are the same only. Some people prefer femoral tunnel preparation using a retro reamer. I prefer it using a simple conventional technique by first passing the guide wire and by then reaming with the endo button reamer and followed by the reamer of the graft diameter. And the knee needs to be positioned, the tunnel needs to be ideally placed, that we all have been seeing through these live lectures. First, after doing the femoral preparation, we need to go for the tibial preparation. The footprint needs to be visualized and the jig is placed over it. Guide wire is passed, the reaming is done, and the retrograde reaming is being done using a flip cutter. The tibial sockets needs to be cleared thoroughly for the bone debris. After preparing the ideal bone tunnels, we need to place this 5 cc syringe. This is kind of hack so as to prevent the rubbing of the amniotic membrane while passing it through into the knee joint. So a 5 cc syringe with the front and fret tip cut off, it is inserted into the medial knee portal, and the sutures are shuttled and kind of internal cannula is formed. After the cannula is formed, the graft, the threads are passed from the femur and then through the tibia, and finally the graft has been pushed first into the femur and then it is subsequently docked into the tibia. The fixation is mostly used using the suspension fixation only. Some people prefer adjustable buttons on both the ends. I prefer fixed loop on the femoral end and adjustable loop on the tibial end. And final assessment after the fixation and final tensioning, the graft needs to be steadied and the tension needs to be confirmed and the amniotic membrane placement needs to be confirmed. This is a case example. I will go through it quickly. This is a patient, a 20-year-old male who had pain in the left knee along with instability after suffering RTA. The clinical examination showed the Lachman and ADT positive along with the pivot shift positive. The knee range of motion was adequate, 0 to 140 degrees. This is under anesthesia checkup of the patient showing a Lachman positive. ADT positive. And pivot shift positive. X-rays were done. X-rays were essentially normal. MRI was done. MRI showed that there was complete tear of the ACL. The menisci were normal. The collaterals were normal. The PCL was normal. So the plan was all inside ACL reconstruction using peroneus longus along with the amniotic. I prefer peroneus longus graft in my practice. This is arthroscopic video showing the steps that I used. The ACL was found to be torn. And initially, after confirming the ACL tear, I take the graft and handle it to the assistant to preparation of the graft. After I do my femoral tunnel, the footprint of the femoral surface is prepared. And I do for calculation of the length, so as to select the 15 mm or 20 mm fixed loop, I first do the femoral end. Passing the guide wire, passing the endo-button reamer and calculating the length of the femoral tunnel. After calculating the femoral tunnel, I do the diagnostic arthroscopy for the meniscal part. In this patient, both the menisci were normal. After going through the menisci, I prepare for the femoral tunnel, the tibial tunnel, sorry. For the anatomical footprint, care needs to be taken off so as to both the ends of the tibial entry and the femoral entry should be cleared off so that the graft doesn't go, the graft doesn't impede, because in this process, the graft is pulled from inside out only, not from the tibial end. So care needs to be taken. After this, the syringe is passed and the graft is passed through the syringe. So there is no rubbing off of the graft. Here we can see a well-placed graft along with the amniotic membrane floating around it. These are the post-op X-rays of this patient showing the endo-buttons well into the place. This is a 1-year follow-up video of this patient. He is satisfied with his outcomes. The lysome has improved from 58 to 94 and the IKDC has improved from 47 to 92. These are the DTI sequences of the patient we obtain at 1 year of follow-up so as to assess the ADC and the FA of the patient, so as to know the ligamentization of the graft, because of the main aim of this study is to know how the amniotic membrane is helping. So native ACL, FA and ADCs are given below, and we were able to achieve this near normal ADC and FA of the graft to the native ACL by means of this amniotic membrane augmentation. Thank you so much for your patience listening.
Thank you, Dr. Pradeep. No word to say. Anything, anybody from the audience?
This is FA is functional anisotropy and ADC diffusion coefficient. These are the markers that needs to be studied. They study the water coefficient into the native ACL. Yes.
What was the justification and how the second question is how would you avoid any
No, what is the selection criteria? I would say better word.
First selection criteria is we need to select the patient for all inside only, because it cannot be done for the normal conventional ACL patient.
So in that
Second, amniotic membrane, it helps only. There is no other side of this. After confirming the patient has undergone the various immunological tests, the markers only, we just go for the viral markers only, not the immunological testing, because the process itself removes this, and it has been into use for ophthalmological purposes.
Preserving it in a normal saline for 48 hours. Is that correct? In gentamicin 1:10, you're preserving it for 48 hours. and there is no antigen antibody reaction or any
We have done almost
no
30 to 50 cases
no,
right
that's
now.
fine. You
Yeah.
must have done hundreds. I'm just asking as a curiosity.
We have been not undergone.
No, but then as an adding a tissue which is not taken from the patient
Yes.
without, will it not incite an immunogenic reaction? Just as a medical student,
yes,
I'm
yes,
asking.
yes. This is a very good question, but the various studies have been done over the period of time. They have shown there is no such response.
So you're
No, I am not lucky. I have not invented this technique. Yes. There is a possibility, but yes, the literature says otherwise.
Literature says that it does not react. I think
Yes.
what was the advantage that you were looking for? So you must be doing this for many years.
Yes, we have
and-
compared actually the DTI sequences of the amniotic membrane patients along with the normal
No,
patients.
that's fine. The sequence I'm not looking about.
The people
functional
want to
outcome-
ask.
It shows that it has
I'm
better
not
healing
asking
compared to the
the-
normal.
That's fine. But the functional outcome, maybe 6 months, maybe 1 year, maybe 2 year follow-up. How does your patients where you have not done this amniotic membrane wrapping to the ones you have done, how do these things matter? Because at the end of the day,
What is the special advantage of using
Advantage of
amniotic
using
membrane in
amniotic
your cases? So people want to ask.
Patient, if we are aiming for early return to sports, early healing, better healing, then yes, it helps.
No,
But over a period of time, it will be similar only. After 2-3 years, let's say.
My question was, what was the purpose of adding?
Dr. Rajam, I think he want to say something.
Ligamentization.
Yes.
That is
Our
what
main
we
purpose
come
is our main purpose is ligamentization only. Yes. Our main purpose is that only.
Question of immunogenicity, the amniotic membrane. The amniotic membrane has got two parts. It has got a cellular part, it has got a acellular part. So there are very easily you can separate the cellular part from the acellular. The immunogenicity is caused by the cellular part. So I don't know about your textbook, but yes, it's being used even in protective cups. I've seen some papers.
Yes, it has been used.
That's cellular part.
So if you are using acellular part, then how it helps in early healing?
No,
If the person using acellular part, then how it helps?
an
in
acellular part
early
will act
healing?
as a plastic membrane. How will it? But anyway, it is working.
Our concern was this one. Before starting this, our main concern was this immunological reaction only.
No,
It
but
has
then
been
other
used
than
in
that-
ophthalmology.
doctor-
Ophthalmology is, I think it's more
So
morbid.
doctor,
It has
if you are using the membrane, you have a study its cells or what before doing
before going to the study, I showed the literature, and the literature is since 10 years.
बंद है चालू है
It has been proven actually.
Thanks, Dr. Pradeep, for wonderful presentation. Now we will shift to the OR, and I think he is ready with the tenor. Thanks, Dr. Pradeep.
Sajir,
Can you
Yes,
hear us?
sir.
Dr. Sajir, can you hear us?
Yes.
So
Yes.
Yeah,
So
it's
some
good.
closing comments I wanted to give before we sign off. I've done with my lemma and can see that the graft is as posterior on the field and as anterior medial on the tibia, hugging the medial tibial spine. This is some fibrous tissue over here. Don't ignore that, but you can see that the medial tibial spine is where we are at. And additionally, you can see that the lateral side is fully closed down now after a lemma right tenodesis. One difference in the steps that I would have done is I would have initially passed and fixed the lemma right tenodesis, then past my graft, because there is always the risk of coalition. I would check intra-articular whether the graft is coalescing, the femoral tunnel is coalescing with the lemmaris tunnel. And if you go through the video of my steps, I think someone else will be presenting it, but I don't need to present it. But I'll just say 2 or 3 things in the recording that is there. Can they show my recording, please, in fast forward? IT band वो जो बाहर से वीडियो निकाला ना उसको जो recording हुआ था उसको जरा दिखा दो fast forward में. Just 1 minute I'll take, okay? I'm done with my tibial side fixation also. I used a metal screw on both sides. So this is the video recording of the procedure that I did. Essentially, I had made the strip only and I did not detach it. And at the, when I went on with the procedure, I can decide at that stage whether I need to do a Lemaire or a Macintosh or a modified Ellison. I can decide where to detach the strip based on my coalition. Now you can see my suture on the lateral femoral condyle is way away. and that is not in the way of my Lemaire's tunnel. At this point, my strip is prepared and I whip stitch a small component of it, roughly around 2.5 to 3 centimeters, so that fast forward, fast. ये सब ठीक है एकदम fast or fast करो. Yes, very good. So one or two things here. Now you identify the lateral femoral condyle where you need to go. Come back, reverse, reverse, rewind, Just one more, please. One more step, rewind. Yeah, this is what I wanted to emphasize. Pause. Pause. Play. Fast play kar lo. So here, what I wanted to say is, often we see these lateral IT band tenodesis 7-8 months down the line where patients say they're feeling a bulgy sensation on the lateral side. To reduce it, what I do is I make a complete slit in the lateral capsule, not too deep, but only in the superficial layers, through which the strip goes, and then it goes under the LCL and posterior lateral to the lateral femoral condyle where it tenodesis it. That way, the entire capsule is closed on top of the strip, with the strip being a component of the capsule itself. And you can ensure that with this, there is no prominent portion which can cause a bursitis or an inflammation later. That stitches that I'm taking is in the rent in the capsule that I made for the strip to go through. Any more questions? We can sign off. Thank you so much for this opportunity.
Yeah, thank you, Sajir. Knee asymmetry is one of the, you can say, complication of doing this Lemire technique.
Yes.
If you are afraid about the collision of the tunnel, you can use the suture anchor, because your IT band will heal with the cortex only. It will not heal into the tunnel. So making tunnel is always not necessary. You can fix over the surface with suture anchor or cork screw or anything. Thank you, Sajid. It's a wonderful surgery. So we'll continue with the ACL session. Thank you.
Thank you.
Next, I'll invite Dr. Abhishek Kumar Das, present his topic, revision ACLR with BTB old.
Good afternoon, everybody. Thank you, Dr. Arvind and team, for this opportunity and bringing such a nice arthroscopy course to Patna. So I looked up at the AI in this age of artificial intelligence. What is the gold standard graft for an ACL, whether it is revision or primary ACL? And it still gives me the age-old answer that BTB is still the gold standard. And any other graft that we use, whether it is hamstring or peroneus or Ward's tendon, has to be compared in terms of functional outcome to the bone patellar tendon bone graft. Now, what are the reasons why the younger surgeons are moving away from it? So we'll look at all this. I looked up at some of the papers, why primary ACLs fail mainly. So primary ACLs fail because of mainly three factors, which is one patient related, which could be a poor compliance with the rehab, or injury, which is quite common in the sports players, athletes, or too early return to sports. But there are surgeon-related errors as well, which we can minimize. That is, one is graft harvest technique or tunnel positioning, which is femoral tunnel is one of the commonest surgical errors. And finally, the biology-related. One is infection, and other, what we'll talk about, is failure of graft incorporation. So in revision ACLR, we as surgeons need to address what is in our hand. That is, surgeon-related factors. Tunnel placement should be good. And if you need to do a proper planning when we are doing a revision ACL to look what is the size of the original tunnel, whether it is malpositioned or it's in the right position. And then you have to decide what graft you take, how you fix it. Then address the biology-related factors, that is graft incorporation. And here the bone patellar tendon bone graft is really a good choice because it gives you a good bone-to-bone healing in the tunnel. So let's look at the tensile strength of the grafts. And if you look at it, the native ACL has a tensile strength of around 2,200 newtons. And in this, if you quadruple the hamstring graft, then it's actually the tensile strength is more than the BTB graft, which is around 1,700 odd newtons for the BTB, and for the quadruple hamstring tendon, which we'll compare in this talk, is around 2,400 newtons. But then we look at some other studies where it shows that the tensile strength is not the only thing when it comes to choosing a graft and when the grafts fail. So there are studies which shows that no matter the tensile strength of the hamstring grafts are more, but it does fail. And that's why in Western countries where they have athletes with heavy contact, like American footballers or rugby players, they still go for BTB grafts. So this is a good read on biomechanical considerations for the graft choice in the ACL reconstruction. Now, why the bone patellar tendon bone graft has gone out of vogue? One, because, and it has been overtaken by the hamstring tendon harvest, is BTB is not difficult, but it is more technically precise and it is more technically demanding, because if the bone rips off from the patellar tendon, which can happen, then pretty much you are stuffed. Then you are looking at a bailout option, or you're looking at another graft. Then there's a risk of patellar fracture, which can happen. And especially in small ladies or girls who have a smaller patella, and if you're harvesting a 10 mm graft, then there is a real risk of patellar fracture. And obviously anterior knee pain. This is somehow more common in females as compared to males. Could be due to a thinner bursa on top, could be due to other factors. So my case, this is a 48-year-old male, 110 kgs with a knee injury, fall from scooty 3 months ago. He has type 2 diabetes and previous ACL reconstruction done 12 years ago. On examination, grade 3 instability of his ACL. These are his MR scans. It shows pretty much the tunnel was in the proper position. And so a decision was taken to revise his ACL because he was having problems with it. So mainly in this video, I'll go through my technique of harvesting the tendon, which is yeah. This one. Yeah.
Precision device.
So in the femur, which implant it is? Raise your hand, please.
Yeah. So
Do it routinely, Dr. Mehta. That was the device that was
I used
at
it 12 years ago.
Yeah, 20
So
years
12 years ago,
ago,
this was the implant
Yeah,
available
yeah.
for this.
And it actually gave very good fixation in the femur, isn't
I
it?
don't know. That I'm not sure whether it was giving. It used to give.
It used to, but you
Yeah.
can misfire this device.
Yeah, misfire.
You can
but-
misfire
but
this
there was
device.
seen a misfire, but then it absolutely gone up.
Yeah, it absolutely went out of vogue. So I saw it after a long time here. Actually, first time in India. So this is the arthroscopic video where
So
you can see
it was
totally threaded
transfix
ACL.
device for the femur.
Sorry. क्या हो रहा है यार? हाँ, यार, कुछ करो भाई. Come on. What's happening? चल रहा था. हाँ. ठीक. So you can see the totally shredded ACL. So I like to do arthroscopy, diagnostic arthroscopy first, then harvest the graft. You can do it whichever way you like. And then it is a central midline incision. And then this is what I want to show. Just preserve the peritoneum. Be very, very careful with the peritoneum. Just make a slit in that. And then sort of undermine it so that you have got a very nice peritoneum to close it, because it has a good role in the blood supply to the remaining tendon and the patella as well. Then you do your markings. I normally take 10 millimeter thickness patella tendon, as well as 10 millimeter on the patella side, as well as the tibial side. If the patella is too small, then you can go up to 8 millimeters. And this, again, on that day, I did not have a TPS saw with me. So I normally like to use a TPS saw, which my department, the neurosurgeons have it. So I have to actually beg them for it when I'm doing the revision ACLs. On this occasion, I did not have the luxury of the TPS. So this saw can actually cause a fracture. So this is not a very good one. And another thing is, do not use a osteotome and hammer it. You can use an osteotome to pry open your graft in the end, but hammering your, trying to take the whole graft with only an osteotome is not a very good idea. So in the end, you can see the osteotome, you gently pry open where you have scored your graft. So gently score the graft on the bone, on the tibial and the patella side. And on the tibial side, I make my hole, one tunnel in the graft before harvesting. On the patella side, I am slightly nervous making a hole beforehand because it can actually cause a fracture of the graft. So once I have harvested it, then I make my tunnel. Sorry, I'll just take a couple of minutes more. So remove all the fat and stuff from it. And then on the patella side, I drill my tunnel again. Then when you're putting the suture, that is your ethibond suture, just a small tip is that you pass it through the tunnel and then through the graft again, so that you are not only pulling the bone through the tunnel, because that is the place where it can fracture. If I'm able to explain myself, you pass it through the tunnel in there and then take it through the junction of the tendon and the bone as well, so that you have got a good hold on the graft when you're pulling it. And then sew up the peritoneum, and then you go drill your tunnels. This is your tunnel. And I like to fix it with the screw on both the sides when I'm doing bone patellar tendon bone graft. I don't like to use the endo buttons. But you can actually use it if you like, or you can do a double fixation. You can use an endo button as well as a screw, whatever whatever you feel is good for you. But have a robust fixation. This is a post-op X-ray. You cannot pretty much see anything because there are bioabsorbable screws on both the sides. This is a rugby player. This is another player, actually, not the same person. This is another player because in the athletes, male athletes, I actually like to do a bone patellar tendon bone graft. So he has gone back to playing rugby. I have done both his ACLs. One is a hamstring, other is a bone patellar tendon bone, because first I did bone patellar tendon bone, which was about 3 years ago, and the other side I've done 1 year ago. So finally, you can look at the registry data. There are ligament registry data where patellar tendons have been compared with the hamstring tendon in the revision ACLs, and it has shown that the bone patellar tendon bone actually has a better outcome, especially in the revision scenarios, as compared to the hamstring grafts. So give it a thought. Ultimately, you have to make a choice. I feel there are a lot of factors which go into a successful revision ACL reconstruction, apart from just the graft selection. But graft selection is the key to the success. Thank you.
Dr. Das, one question with. So if you have blowout at the femoral side while making the femoral tunnel,
oh,
so is there any bailout option? If
sorry,
you are making the femoral tunnel like we do in the hamstring
yeah,
for the bone patellar tendon, and if there is a posterior wall blowout, so you are using the screw at the femoral side. So what is the bailout option?
So in that, I haven't encountered this, but I feel if there's a blowout, you can use the previous interface. You can actually drill a screw, or you can use a button on button technique for this one as well. I'm not entirely sure what bailout there would be.
We should have used the button on the femoral side also, na? So it's like
here I did not use a button because my tunnel was good, and I was quite confident that the screw will hold. And normally, I might have done, pretty much around more than 50 cases at least where I have always used a screw, never encountered a blowout of the
Good.
femoral tunnel. So I cannot share my experience on this, but I guess that would be a good thing to
I
do.
have encountered one case 10 days ago. I was doing revision ACL, there was a blowout, but unfortunately I was using Arthrex button, that thing, for the
Okay,
bone patellar tendon.
All right. I have had cases where the bone has fractured from the tunnel. There was a bone rip-off as well, where we actually did just the tendon on the femoral side. We sewed it up like a hamstring. That was in England, not here. We sewed up the patellar tendon and used the endo button and just use it because the healing actually takes place on the mouth. But I don't know what the follow-up of that patient was. Yes.
You have a triangular section of graft at the patellar side and a triangular section at the tendon.
It's a trapezoidal section. You should aim for a trapezoidal section. So there are jigs which
Fix that quadrangular section inside the inside the femur without getting the flow and avoiding the anterior impingement.
So first is you have to ensure your tunnel, you have to, once you have drilled your tunnel, you have to be.
The femoral tunnel is built the same way what you do for hamstring, or there is some change?
I think it should be some anterior one if you are
Sure.
using bone
I
patellar.
have tried posterior tunnels. I have gone anteriorly as well sometimes, but now I look at the footprint and go
It's a better
bang
idea.
in the center. And then you normally have a play of around 7 millimeters behind and around 5 to 6 millimeters anteriorly. So if you are on the center or slightly posterior to that, chances of blowout are very, very less. I never hammer the graft inside. I just pull it off, pull the graft like you pull the hamstring, and then keep hold of that and then screw it. Sorry? That's a good question. That depends on where your tunnel is and where you want the graft to be. If your tunnel is too low, then you put the screw anteriorly. If it is too high, then you go posteriorly.
So a bone in the femoral tunnel, instead of 2 mm, you should have 4 mm. A screw size should be smaller than the tunnel. This will prevent your
So
blowout.
I normally use the screw same size.
So you are lucky that even using the same size, you don't have the blowout of the posterior surface. You are very lucky.
If you're using a metallic screw, you go one size small. If you're using a wire screw, you can probably go the same
Okay.
size.
My question is little bit different from this. Revision scenario, young patient, one side this BPTP alone, or you will add this Lemire or extra-articular? So in this case, have you
also I have added.
Okay, that's perfect. So this is the message, young patient, athlete one, once already torn ACL, you are going for the revision one. And if the pivot shift is high grade or any high risk things in that patient, so you should be adding this extra articular tenodesis in this to prevent the re-rupture of your ACL second time.
We need to sleep well at night, isn't
Yeah,
it? Not worry
absolutely.
about them, what happening. So I think the Lemire's technique adds only 10-15 minutes extra time if you're using suture anchor.
Thank you,
isn't it?
Abhishek. Thank you.
Thank you very much.
Thanks, Dr. Bas.
Thank you, Dr. Abhishek. Next, I invite Dr. Kamar Azam for his topic, ACL reconstruction with HTO and slope reduction osteotomy.
Dr. Kamar Azam sir is professor at AIMS Rishikesh. He has started this sports injury center at Rishikesh AIMS. He belongs to this place only from Darbhanga. And he is very happy to come here. Last year also he tried, and this time he make it.
Thank you for generous introduction, Dr. Arvind. So it was already there. I had given my presentation. So okay, thank you very much for the invitation, Dr. Arvind. It is pleasure to be here, though I am coming for the first time. I belong to Darbhanga, which is around 125 kilometers from here. So the topic which is given to me is quite important, and we must be doing day in, day out, or at least once in a while. Whenever there is a coronal malalignment and the mechanical axis passes medial to the joint, it causes an adduction force in the ACL, which increases the stress on the ACL and risks its injury. So whenever there is a varus more than 6 degrees, particularly in a revision scenarios, I prefer to do the high tibial osteotomy together. In a primary setting, if the patient has instability and more than 6 degree varus, particularly with pain and young demanding patients, I will again go for that. It is very important to know where exactly is the deformity. It can be in the proximal tibia, in the joint line, or even in the distal femur. We have to consider that so that we do correction either in one place or even bipolar. To know the deformity, where exactly it is, we need to measure certain angles, and the common angles are 3: the joint congruency angle, which denotes the cartilage and the ligament laxity; the proximal medial tibial angle, if it is less than 87, it represents primary tibia vara, and if the lateral distal femoral angle, if it is more than 87, it represents the distal femur issues. Once we know the exact place of deformity, we need to calculate the angle of the deformity. For that, we use the Miniasi method, in which the first line goes from the center of the femoral head to the center of the talus. The second line goes from the center of the femoral head to the Fujisiwa point, which is usually 62.5, though it can vary, and we project it to the new projected ankle placement. This line should be equal to the first line. The third line we draw from the distal part to the hinge point, which is usually at the proximal level of the fibula. And the fourth line will be from the hinge point to the native center of talus. This angle is also known as alpha angle, and that is the angle for varus correction. It is important to know that the varus can be contributed, particularly in a chronic cases, because of the ligament laxity or even the cartilage damage. So to adjust the joint line congruency, anything which is more than 2 is abnormal, and that we need to subtract. So we need to subtract, suppose the joint line congruency angle is 6, we need to subtract 2, then it comes to 4, and then we divide it further 2, so that we don't do any overcorrection. Now, suppose in a case scenario, the tibia vara is 9 degree, joint congruency angle is 6, and the desired recommended valgus angle is 3 degree. So the calculation will be like 9 minus 2 plus 3. That is the 10 degree correction is required. Now we know that the proximal tibia is actually a trapezoid joint bone. So 1 degree doesn't necessarily equal to 1 millimeter. So this table is very helpful. For example, if you need 14 degree correction in the angle and the width of the tibia is 50, then you need 12 degree correction, 12 millimeter of the wedge. And if suppose the width of the proximal tibia is 80, for the same degree of correction, it has to be 19 millimeter of the wedge. So we need to take care of that. Finally, whenever we do medial wedge osteotomy, it is precise. With the same incision, you can harvest the hamstring graft also, but then it has a tendency to increase the slope of the posterior tibial slope, which is actually you have to take care. Otherwise, one can go for lateral closed wedge osteotomy also, which is not my preference because of the nerve issues. And if you need more correction, you have to do osteotomy of the fibula. So I'm presenting one case scenario. We had a 23-year-old male. He was having pain in the medial joint line. His varus was 14 degree. So I'll pass a bit quickly. So the first thing that we do is we have to do arthroscopic assessment. If there is any cartilage issue, we have to take care of the cartilage. Usually meniscal issues will be there. We will do that. And then we will make the femoral tunnel. After doing the femoral tunnel, we will come to the incision. Usually I use the longitudinal incision, slightly posteriorly based incision. Slightly posteriorly based incision, and then we harvest the graft. That is the first thing that we do. After harvesting the graft, I identify the superior medial superior and superficial MCL with the pen, and we do controlled release of the superficial MCL. This is important because otherwise the joint pressure on the medial side will always be there, and the pain will not go to the patients. And also the correction becomes easier. After that, under the C-arm, we pass the 3 guide wires. I do double osteotomy. Then under the C-arm, I try to increase the wedge. I keep this instrument far posteriorly so that we don't open anything anteriorly. I don't hesitate in putting the lateral hinge wire, which prevents any extension of the fracture, particularly if you are doing more than 10 millimeter wedge. Meanwhile, I harvest the graft from the iliac crest. I put it inside. I put the screws. The screws are put, posterior screws are put first. We rather keep the anterior screw hole free. And you can dial it because these plates has got variable angles, so you can change the direction of the screw. Finally, we take the tibial jig. We try to manage the tibial jigs in such a way that our tunnel comes in the anterior side. So these are the different stages which we use per op to confirm our position. These are the 3 months, 6 month, and 1 year follow-up. I will not play the videos so that I can cover the other topic. So the take-home message is that accurate degree of deformity calculation and its placement is very important. We start with the arthroscopy to manage the cartilage and meniscus and do the femoral tunnel first. Then controlled superficial MCL release is important. Protect the lateral hinge by putting a wire and subsequently a screw. That is very important, I think. And then we do the tibial grafting. Coming to the posterior slope reduction osteotomy, we know that whenever there is a increased posterior tibial slope, the tibia has got a tendency to translate anteriorly. And when it translates anteriorly, it causes stress to the ACL ligament, and your native ligament failure chance is very high. As you can see here in this diagram, I will not explain that. Now, so much so that if the posterior tibial slope, which is normally up to 6 to 7 degrees, if the posterior tibial slope is more than 12 degrees, the chances of failure of the graft independently increases to 4 times, and some of the literature says that even up to 10 times. Just 1 minute, please. Then the hinge in this situation will be at the attachment of the PCL insertion point. Again, proper weight-bearing lateral X-ray is very important, and measurement of the central axis of the tibia is important. Now, in my indications is in a primary case, if the posterior tibial slope is more than 14 degree, you should do rather, and particularly if the patient is demanding. In a revision setting, even if the posterior tibial slope is more than 11 degree, I think you should go for the slope reduction osteotomy. Slope reduction osteotomies are different types. My preference is the transtibial, which has its own advantages, but there are certain disadvantages also. So we had a case, actually, we operated 4 years back. We did that time we used hamstring graft, but after 4 years, he was a football player. Then he presented after 4 years with the failure. So when we did the X-rays and the CT scans and the MRI, we could see that the tunnel placements are perfectly all right. So the options were 3, either just to change with the other type of graft or do with the slope reduction osteotomy, graft reconstruction, as well as LET. There were the 3 possibilities, and I went for the second. The slope was 14 or 15 degree. So because I used the transtibial with the same incision, we can harvest the patellar tendon. So patellar tendon is harvested, it is prepared. Then again started with the arthroscopy, cartilage management. I was thinking of doing OATS, but that time I was not prepared for it. So I did some subcondylar drilling alone. Then meniscal management and femoral tunnel preparation. It is just 30 seconds. Then we pass the tendon fixed with the metallic screw, and the metallic screw that we use is two size less than the tunnel. That makes life easier. Otherwise, it is very difficult. Under image, we put the 2 sets of guide wires. Then we remove the wedge, calculated wedge actually. You have to protect the neurovascular by putting some instrumentations like Homens from both the sides, and then we correct it. So these are different stages of CM techniques, and this is the follow-up after 6 months. And so the take-home message is that start with arthroscopy, manage the cartilage, manage the meniscus, do the femoral tunnel. I prefer transtibial. The target correction should be 5 to 6 degrees. There are some literature which suggests that you can go up to 0 degree, but that has a chance of patella alta and genu recurvatum. Thank you very much.
So Azam sir, if you have to do one osteotomy and you have to correct the varus and also correct the do the slope reduction, how you can achieve this?
So actually varus and slope is a quite common combinations. And for that we do the actually medial wedge osteotomy. We try to correct more posteriorly and less correction on the anteriorly. That is one way. Otherwise you can go for the lateral closed wedge osteotomy.
Rajam, in your case of the revision ACL with slope correction osteotomy along using the bone patella tendon bone graft. So
Yes.
you passed the bone graft first and then did the osteotomy later.
Yes, yes.
So is there any chance of damaging the graft or collision of the bone?
No. I didn't pass the graft first actually, though in the video it may look. So we prepare the tunnel. We prepare the tunnel in the femoral side.
Then you always pass the graft later on.
Later on. And that is very important question because I have suffered it. Because if you tight the graft beforehand, because your slope is now changing, the graft becomes loose.
So you will make femoral tunnel first,
Femoral tunnel first,
then prepare the osteotomy and then the tibial tunnel.
Fix the osteotomy, and finally pass the graft and do the
Then
tightening on the tibial side. That is the last thing to be done.
Thank you.
Thank you very much.
Thank you, doctor.
Complete lease, sir. Complete lease from anterior. It is not complete lease actually. From the anterior I mark, yes. You control release that we do like in total knee replacements. You don't completely remove it from the posterior side, but you release it actually. If you don't release, then the correction is not very good. And as well as it causes overcompression in the medial joint. So it is recommended actually. Thank you very much.
Thank you, sir.
Thank you, Professor. Next, I invite Dr. Manish Kumar to present his topic, joint preservation after ligament surgery of knee.
Okay. See, when you are managing ligament injuries in elderly persons, it's always a challenge and a dilemma what to do, whether you are going to manage it or you're going to go for a plasty. So I like to present one or two cases if time permits. Let's see the things. Okay. So this is case one, a 64 years old male with a BMI of 24. He had a history of a fall after being hit by a tractor, and he presented to us with the symptoms of instability. Weight bearing was difficult and the terminal range of motion was affected. It was restricted. If you see the X-ray of the patient, the X-ray which was taken on 3rd of Feb, you can see the joint is not appropriate, it's not anatomical, it's dislocated. But when he presented to us on 20th of Feb, you see the joint is aligned, so it has reduced by itself. 2 days later, we performed a stress view and we found there was a gross opening of the medial joint line. So that was suggestive of a MCL tear. The MRI suggested a ACL as well as a PCL tear. So seeing this case in a 64 years old male, we thought what to do. So the house, what would they like to do? 64 years old, multi-ligament injury. Would you like to go for a reconstruction of the ligaments, or would you like to?
So basically, what is the physiological age of this patient, how active it was, and also the clinically how unstable knee is.
Right.
If it is complete unstable, like grade 3 opening on the medial side, grade 3 Latchman, grade 3 posterior door is there. Cartilage looks reasonably good. It's not arthritic.
Right.
Then it should be reconstructed.
Okay, very good. That's the thing. So this you can see the knee is almost the patient is able to have a complete extension of the knee. There's a valgus opening, as you can see. The range of motion only terminal restriction. And this is your amount of laxity. And this is the gait of the patient before surgery. You can see he's having a hesitant gait. But when he has his braces on, he can walk with some confidence. So we performed a single sitting reconstruction of all the ligaments, and you can see the stability of the knee. It was good enough. And this is the 1 month follow-up of the patient with a range of motion. And this is the 8 months follow-up. This is the amount of squat which he can perform and the range of motion. The stability of the knee was good enough. The valgus stability, that was also there. The amount of squat which he could perform. And at 4 years, this is the gait of the patient. And this is the result. He is able to squat almost fully at 4 years. So this is one case where the age should not be taken into the only consideration. You should try to see what can be done for the patient. Another case, a 17 years male, BMI 18.36, hit by a car about 6 months back when he presented to us, and he had instability of his knee. ROM was 130 degrees, 0 to 130 degrees, both sides. 70 years male, what to do? Would you like to go for reconstruction? This is his knee. Looks good. The only structure damaged is your cruciates, the anterocruciate ligament. 6 months of injury. Instability, gross instability. No. Yes. Right. So we gave him instructions regarding different exercises to strengthen his group of muscles of the thigh, but still the patient was having instability. And this is the gait of the patient. He's able to walk, but he's hesitant. He's having a hesitant to walk. And this is his examination anesthesia. There is a stability problem. So we performed an ACL reconstruction for this patient.
70-year male, 6-month-old age. Little bit of varus.
Yes.
So did you ask for long leg film?
Yeah. There was a varus deformity to a certain extent, but he was not ready for that. We did a ACL reconstruction only.
So this is the message elderly
So
people.
if you have an alignment defect,
Yeah, with
that's so
chronic
ACL
ACL tear coming to you,
with an alignment
MRI
defect.
is not only enough investigation. You should always ask for long leg film at the same
Right.
time, because it's the chronic one and patient is older. So there is chances of varus deformity is there. And in varus knee, if you are doing isolated ACL reconstruction, the chances of failure of your graft is very much high.
The patient hasn't changed much. He came to me about 1.5 years back, and in the OPD, we asked him. he could
Super
have-
job, boss.
Yeah, and this is the video of the person. He can run nicely. So the message is, it's never too late. Try to preserve the joint. That would be helpful. Thank you.
Thank you so much.
Yeah.
We have the factory but that is there. And at times it is hypothesized that once you have the inflammatory process are observed, hasn't said anything now. But once you have intervened, it might.
It accentuate yet. Of course, the inflammatory cascade begins and it starts degrading the joint. Thank you.
So this is an add-on topic before the lunch. I'd like to thank Arvind sir and Paras Hospital for giving me the opportunity. So I'll be talking on how to avoid tunnel coalition in a multi-ligament reconstruction. दूसरा वाला है? Okay. So this was in JBGS 1971, which is, it is unlikely that any single physician personally cares for more than a few knee dislocation in a lifetime. Because of the increasing accidents, so this is not true anymore. But what are the surgical challenges? It's an multi-ligament surgeries are itself harder surgeries. Let us not make it harder. So what are the surgical challenges in this? So we have a complex anatomy of the knee. It is like knees are dense. You have a dense ligament all around, and you have a limited real estates in and around the knee. So complexity of the surgery and anatomical restoration. As we know that each ligament around the knee has its own function. So anatomically reconstructing the ligament is at utmost important. So what are the reasons of the failures in case of a multi-ligament reconstruction? That is, first and foremost, and takes the highest on the table, is a tunnel malposition or collision. Let's not talk about other things. So what is the importance of precise tunnel placement? So we have structural integrity, which graft failures, and when it comes to alignment. So talking about structural integrity. So when a tunnel is tunnel convergence, there is a structural integrity is lost due to bone bridge might get fractured, or it is too thin to incorporate either the screws in these conditions, which in turn leading to graft failure or graft loosening. So second, coming to one of the most commonly encountered would be, once your tunnel convergence, there normally you have this sequence. So when your tunnel convergence, your sequence, however the PCL first ACL, once your tunnel convergence has happened, this doesn't matter. So it affects the tensioning sequence, in turn causing non-physiological graft stress on the graft and disrupts your joint alignment. So lastly, what happens is your graft and graft, there is an contact which increases the abrasions, impingement basically, and then the abrasions, and in turn causing increased graft ruptures. So coming to the topic of tunnel convergence. So most commonly in the femur and the tibia. So in the femur, you on the medial side, when you're doing the PCL and the MCL. When you're doing on the lateral side, it is ACL and the PLC. I'll not be talking about ACL and LET. And when it comes to a tibia, it is ACL and PCL, and on the medial side, it is PCL and MCL. So we have a lot of tracks coming on the way on the medial, lateral, and on the tibial side. So let's talk on the femur, that is on the medial side, that is your PCL and your MCL. So normally you go dead on straight, bang on, and there is definitely you have a higher chance of tunnel convergence. So in these cases, what do you do is, so basically first you always have to do your, I'll be talking later as well, but you have to do your cruciates first tunnel on the femur side. I'll be talking on that as well. But before I talk about the tunnel placements, your femoral cruciate tunnel has to be placed first, because you have a play with your collaterals, but you don't have a much play with your cruciates. So when you do this, when you slightly change your orientation to 40 degrees, in case of your MCL, so superficial MCL, 40 degrees axial and 40 degrees coronal. And when it comes to your POL, it is 20-20, T20s, where 20 axial and 20 coronal. So coming to the lateral side, you have PCA when you're doing ACL and the PLC. Again, a bang on, it goes, there's high chance of tunnel convergence. So in these cases, what you do is you go, and when it comes, you go 35 degrees anteriorly and 0 degrees proximally. So in this cases where when you're doing ACL, you have a highest chance with the FCL, and when you're doing a popliteus tendon, it can highest chance of going into the intercondylar notch. So that is with the femoral side. Now you coming to your tibial side, where normally you go is a straight bang on of your POL. There is a high chance with your PCL tunnel. But in these cases, we need to understand that this causes convergence with your PCL. So when you direct it a little with the exit coming medial to 15 mm medial to your Gerdy's tubercle, then you definitely miss your PCL tunnel. And you have to go almost 30 degrees distally as well. And your superficial MCL, when you go deep, where you come 6 centimeters distal. And in this case, also you have a high chance of going convergence with your PCL. So in this case as well, the same thing what you're doing for POL. You angle it 30 degrees distally and escaping anterior to your fibular shaft. So this is, and most of the multi-ligament, you do come across these root tears. You can't ignore this meniscus root. So in case of medial meniscus, always try your transtibial repairs. And in this case, the ACL and the PCL has to be, the pin has to be placed first. And if there is any chance of convergence, you can go as slightly as medial as possible. And if at all you are converging, and you can always think about all suture anchor. But mind you, in an acute condition, your bone also would have a lot of swelling. So there is high chance of this suture pull out in these cases. So just 2 minutes, 1 minute, sir. So lateral meniscus, again, a transtibial repair. In this case, you have two options. Either you can go distal to your ACL, or you can actually think about going laterally to your tibial tuberosity. So how to overcome? Like I spoke, approach, always an approach first. Because if you do an approach later, there is high chance of fluid exavation and then causes anatomy distortion. So, and as I told, it's a ream femoral cruciates first. And collateral pin placement can be done under visualization, seeing through the scope, putting through the cruciate tunnel, whether it is coming in between. And always change the trajectory if there is any chance of convergence. So in these cases, an ACL and FCL, there was a chance. So in these cases, you under visualization direct it anterior, directed 35 degrees anteriorly. So again, more point would be arthroscopic visualization under the guided and the reaming during the collateral, which you had seen just now. And all inside, if you are well versed with all inside technique, that also the socket technique also can be used. And please, if required, please use the C-arm. And then sequential drilling tunnel also can be done. under C-arm also can be done, and approach would be first. To summarize, attention to anatomical principles, angle, which I already mentioned for the tunnel, viewing arthroscopic image while drilling and trimming, using a C-arm judiciously if you require, and getting it right the first time. You don't want, already this is a hard surgery, you don't want it coming back with the revision. Thank you. And I kindly invite all of you for the Tejaswini's Arthroscopic Surgical Conclave, which is happening in Mangalore. Thank you.
Thanks, Dr. Suman. Any question from audience?
I think it was
Thanks.
good, I think.
Yeah, wonderful presentation.
Thank you, sir. Thank you.
What next, Dr.?
Thank you, Chairperson. So now it's live surgery by Dr. Vikas Kapoor and Dr. Siddharth Agrawal. He will be doing ACL reconstruction and lateral extraarticular
Stab
tenodesis.
knife जो होता है इधर.
And moderator for this surgery will be Dr. Kapil Shukla, Dr. Sanavas
पानी है वो vancomycin dip.
and Dr. Aswini Gaurav.
Vancomycin dip.
Tapis,
Vancomycin dip पानी saline beta.
Dr. Shivam Sinha, boss, please.
Yeah. Hello, Arvind.
Good afternoon, boss.
कैसे हो?
Dr. Shivam Sinha and Dr. Sanavas will be moderating this surgery.
Okay. So, Arvind, Dr. Second, good afternoon.
Good afternoon.
So, we have taken the semitendinosus along with the sleeve of periosteum. We used an open-end tendon stripper, and this is around 2 centimeters of the periosteal sleeve that we have got. So, our graft is good 32-33 centimeters. So, we plan to make it 4 strand. धागा डालो single धागा. Single धागा डालो इसके अंदर. Yes. And वो दो alleys. So we plan to. So this is single looped semi-T, which is around 18 centimeters as of now. So we can further reduce the length of this. We have cleared it of all the soft tissue. Thoda beta. So now I have a length of around 16.5 centimeters. I'm happy with it. So we'll stitch it. Baseball
What
type
is the minimum length you will accept, Siddharth?
I take 8 centimeters final prepared length for all my cases in a male patient, and a female around 7 to 7.5 centimeters final prepared length of the graft. So this length should be around 15 to 16 centimeters. If it is longer, I normally cut in my cases because I want it precisely 8. Chhod do beta. I want my graft not to be hanging from the tibial tunnel. I use additional fixation at a tibial end, in my cases at the surface via suture disc, to provide a double fixation. So that is why I want my graft to be finishing flush at the tibial end.
So as said, we just don't want to waste the graft.
Yes, I want all the graft inside the joint. So we have taken around 2 centimeters of periosteum along with the base of the graft to have a good graft. So I have around 4 to 5 stitches with a suture wire number 2. So 5 throws here, then I rotate it, and then I take it back.
In routine, we are using Ethibond.
Yeah, frankly, in routine, I'm using number 5 Ethibond, or sometimes I use number 2 suture wire, especially in case of thin individuals or in case of females. As I told you, I put a suture disc, so I have to put knots at the end. So I'm happier putting it with the number 2 suture wire than with Ethibond.
In order to avoid any cutout of the threads, right?
So
yes.
you said the length is 8 centimeter, right?
Yeah, it is 16 right now. So when we will further loop it around the adjust.
In this case, it's 16. So when it's, suppose it's become 14 or 13.
So what I do, I do not bring the end right till here. I loop and finish it till here and suture here. Suture the graft end here so that the total length is 15 or 16. So I do not make it complete 4 times and make it 3.5 times.
So let make me question
it.
easy. So what is the minimum length from the house? It's 7. Can you raise your hand?
Minimum 7 I need, minimum.
So recent literature, recently published with very good number, it says even with the 6.5.
Oh no, Arvind, I'll tell you the
6.5 is good
reason.
enough.
I'll tell you the reason what I'm saying. We
No,
have
no.
normally a tunnel
You
of
are
around
doing,
36.
Siddharth, you are doing very good. Just we are discussing because many a time on doing quadruple, the semity, even with taking the periosteum. Because
Yeah.
I do in all my cases, quadruple semity as well as gracilis also same time. And it's many a time it's come 6.5 only.
Yeah. So see,
And I don't have any problem. I'm doing it for last 5
Yeah.
years. So even less 6.5 and you are using this suture disc on the tibia, then this length is good enough. But I'll respect your decision. 7.5 and 8 length is good length.
Why don't you add gracilis to it?
Because I want my diameter more than 8.5 most of the time.
We checked the dia before harvesting the graft. On table had a rough idea. It was coming around 8.5 and 9. So we were happy with the semity and we did not go ahead with the gracilis.
Absolutely right.
And frankly speaking, right now we checked the dia. Looks to be somewhere 8.5 to me.
Yeah, looks.
And if I go, it is precisely 8 on the femoral side and 8.5 on the tibial side.
Perfect.
So right now we have a graft which is precisely 8 centimeters long, quadruple semitendinosus, sutured at one end, 8 mm on the femoral side and 8.5 mm on the tibial end. But I said vancomycin dip mein dalna hai. So I think all of us are using vancomycin dips as of now.
No.
No.
How many of you are using vancomycin for ACL reconstruction? Raise your hand, please.
Saline to le lo. Simple saline le lo. Beta
Yeah,
dry
so
ho jayega.
50-50. Siddharth, it's 50-50.
50-50. Wo, I'm surprised.
Yeah,
I thought it would be 110 versus -10.
Yeah, still a lot of people are don't using the
What prevent
vancomycin.
you from using vancomycin?
Why do you want to use vancomycin?
To prevent.
So to eliminate that that 0.8% of the risk, 50 ml कितना है? 500 है 50 ml saline आधी कटोरी भरो.
So
उसके अंदर ही डालो.
Shibam was not using vancomycin because he has not believing that this will prevent the infection. But in my mind,
Antibiotics, infection, if at all, will be there. It will be through the systemic circulation. Local infection control, you are using using adequate irrigation there. You are completing your surgery right in the time. You are using new sutures. I haven't encountered. I don't say it's very.
Dr. Sinha, the question is, we all don't know whether the graft gets vascularized pretty late. It takes around 3 months for early vascularization to happen. So we are essentially putting a non-vascular structure. So having a higher concentration of a bactericidal drug around it, I think it is more of a mental security and studies do
It
support
will
it.
be washed off by the time you will be closing your surgery.
so Siddharth, I am using this antibiotic for my all graft. But only thing in my mind, what is this vancomycin doing to my cartilage? That I don't know. So this comes in the
Arvind,
literature once. This comes in the literature once that vancomycin is preventing the infection. But at the same time, none of the literature is saying what vancomycin is doing to my young cartilage or chondrocytes. That is the only concern for me. Although I'm using in my all cases this antibiotic.
Arvind, I think let's go to the live surgery. Sir is already inside the joint.
Yeah.
Please. Sir, over to you, sir.
Lao bhai. So we have a large bucket handle tear, as you can see. I'm adjusting.
Cameraman,
I'm adjusting the. I've done MCL ply casting a little bit, and I'm adjusting the loop to 18. The device, and here I go. So I take the first bite.
Bus.
So it's large bucket handle tear.
थोड़ा सलाइन और चाहिए, सलाइन काटा था ना, बोतल डालो, दूसरे डाल डाल चला, डाल दे डाल दे डाल डालते रहे।
Can I have knot pusher? Knot
Because
pusher, please.
What is your place for pie crusting in MCL?
Wait.
Not pusher.
So Arvind, can you see this is the first bite I have taken,
Yes, sir.
and I have taken it here. Now I'll take the second suture in the meniscal repair. Can I have? अरे कुछ तो दो मेरे को, knot pusher दो. Idiots. पकड़ इसको. पुल कर थोड़ा सा. पुल कर. Okay, leave it. Knot cutter दो. So basically, I have double breasted it because there was a loss of meniscal tissue in between.
Correct.
So I had anticipated this tear on the MRI in the morning, and I went in looking for it, and it was a large bucket handle. Again, this thing usually doesn't work with any company, and these people are no exceptions. So now it has worked. Okay. Very, very lousy. Okay. So now, yeah, so MCL pie crusting I did exactly at the joint level and slightly above that along the course of MCL. Can I have the second implant, please?
So that is the magic point of Banja, where we have to do the MCL pie crusting.
Magic point for
And,
pie crusting.
and then I will need two inside out sutures. Quickly, there is less time. You people take more time to give implant than I need to put it in.
Do you believe in cleaning the edges of the meniscus for a better healing? Because?
Sorry?
Do you believe in cleaning the edges of the meniscus before?
Yes, I did that, but I was doing it while the graft was being prepared. So I did it at the backside.
Still the
So I'll
inner
give-
edges feeling a little bit rolled in.
Yeah, I'll give one more at the back because that's the posterior edge of the bucket handle here. So, and then I think I should give one here first.
So would you be using all the
इसको पकड़ो,
techniques
इसको
that-
पकड़ो. छोड़ दो, निकाल लो इसको. So can you give me the knot pusher now? Scope पकड़ो बेटा. Hold the scope. Yeah. So now with the knot pusher, the intent is to hold it. Pani do. And this is the time it fails. You see,
one of the implant will
this
pop.
is the time most of it fails. So you have to be very, very careful. Don't worry about this small upturning which is happening, because we are giving a very good pull into the capsule with the meniscus. See, even if your meniscus is not so broad, the intent is to have a tight cushion and tightening of the capsule with the meniscus so that you are able to give it a very, very good and tight capsular meniscal junction, which will help to mitigate the pain response. Okay, so this is what we have done. Now we have, I'll be putting probably two sutures inside out here. maybe 3 or 2, whatever time permits, and maybe one small suture somewhere later on this side or at the back if I get some place, Okay. So, yeah, knot cutter. So the MCL pie crusting I did at the joint level and slightly above that. Along the course of the MCL, I used 18 gauge needle and continuous valgus stress, and it gradually opened up with a pop sound. Just a minute. Oh, तुमको यार क्या है? हटाओ. ये क्या दिया?
Sir, if I'm allowed to ask a question.
Yeah, definitely.
In bucket handle tears, do you take any reduction stitch before doing the repairs? And if so, where do you take?
What step?
That before doing your meniscus repair in bucket handle, do you do any reduction stitch? Do you take any reduction sutures?
Yeah. No. In this case, I did not need to do it. That in chronic bucket handle tear, sometimes when it is stuck in the joint for a long time, then it gets flipped over all the time. Every time it comes back to the joint. So that's why we do that maneuver. That is usually not required all the time. Now inside out. Yeah, can I have something to abrade the meniscal tissue there? Rasp.
Would you like to put some sutures more posterior there also, or is the tear extending there?
I will. Let me finish off the inside out part and then let me inspect at the back whether we need to go there or not.
Right.
Can I have the rasp, please? So the rasp is not around, so I think it will be there somewhere in the other OT, I don't know. So I've changed the portals. And you can see here, so there is a rasp in my hand. I'll go from the other portal. Oops. And do a bit of cleaning, whether it works, whatever it is worth. But I believe that this area is quite bleeding once the tourniquet is off. It is a good area for the healing. Can you see this?
Yeah.
I'm doing it just below the meniscus. And I don't need to do beyond the point. There's too aggression I don't find it of much use because it usually heals well here. Can I get the cannula? So in this case, I have a double-loaded cannula, but I use a single cannula, single bent cannula here. Whatever I have, it's okay. I'm sure So the problem is that it is slightly very rigid. तो इसमें क्या है ना कि ये ऐसे करके घूम नहीं रहा है. पानी दो भाई. So, no, wait. Okay, so first go the lower one. Now here, I don't like this because it dictates terms. You have put in one, now you have to put in other one in a certain way only. So, हाँ, आप पहले निकाल लो इसको पूरा निकाल लो, रुको, I will do it differently. बस, ये क्या किया तुमने यार? Why did you take the thread out, idiot? हटाओ इसको, दूसरा नीडल दो, काटो यहाँ से. Take out. You don't use your brains here. These company guys. Give me one more needle. So the trick is you don't take the thread out of that area, because if you take the thread out, you will end up cutting it when you cut the skin for. So as soon as your needle is piercing the skin, you make the cut. A liberal cut so that you can retract and then you can actually take the full needle out. Can somebody show outside what is happening also?
Outside camera, please. Cameraman
outside और inside दोनों दिखाओ, तो समझ में आएगा अच्छे से.
It's a
wait, Siddhant.
थोड़ा
से
सा
डालो,
बड़ा
चल।
करो कैमरामैन आउटसाइड पिक्चर.
Go, go, good. Wait,
Yeah.
wait, now wait. So,
Vicky.
knife, please. Knife, wait, number 15. ये नहीं, दूसरा वाला दो.
And see the needle
Light on
exit.
करो.
Needle exit, please.
Yeah, it's good.
Light on करो. इधर का OT light on करो. So I'll make an incision here now.
We are not able to see that part.
थोड़ा सा लाइट कम करो, ग्लेयर थोड़ा ज्यादा हो रहा है कैमरामैन. Outside picture.
Outside picture.
In the
back of
middle.
the knee. Middle side of the knee. Yeah.
So I have brought this out and it is coming out from the incision now. Now that I have one out, I will take the second one. Now second one you can take now from the other hole. Yes. Please take it. Yeah, go. Go please. Wait. Just a minute. So you have come out again from the incision only. Let me see. Yes, you have come out from the incision. So here you can see now. Okay, so can you just pull it slowly? Pull both the sides slowly. अरे यार इसको निकालो ना. हाँ निकाल लीजिए. हाँ. So now we have one suture in. Can you see this?
Yes.
We appreciate
So
that.
we have taken both the one more please. One needle more. So at this stage, what I would do is, I would first close this, and I can see at this, as soon as you do this, you will see that there is a lot of gap here. So please hold it like this. अब इसको काट दो. चलो. Can you hold the scope for a minute, Siddhant? Siddhant, hold the scope. Cut.
Just for the audience, the viewing portal here is the medial portal and the working portal is
So
the
can you see I'm closing this at this stage? So you make it slightly neutral varus, and I do my first suture and I don't leave it like that. I close it now itself. You see, now I'm closing it and you can see it is closure. So now when I will do valgus, you will see there will be not much opening anyway. And in varus, it tends to open. So this is the time you need to understand how much, because after surgery, sometimes you find if you keep in valgus and keep doing the surgery, at the end, you will see you are never happy with the closure when you do the varus or correction of the limb straightening happens at that time. So I have taken one suture and I have already created an ecosystem where I know exactly how much will be the opening. Now you see. See this?
Yes.
Arvind, am I,
Yes, sir, yes,
It's very clearly visible and it's looking very good.
the whole trick is that this technique needs to be understood that when you are putting in the first suture, at that time only you bring the capsule together, and the laxity happens when you put it in varus. So, and we are doing the repair in valgus. So at the time of tying up the suture, you must do it in varus, because that will help you to mitigate any kind of laxity between the capsular tissue and the meniscus, which you can see in front of your eyes. So now if you do varus also, you can see there is no gap. Can you see this, audience?
Yes, yes.
There is no gap, very little gap. So one more suture will actually do the trick. Okay.
So whether you are planning inside out or outside in for this one?
Inside out, inside out. So now here we are. It is slightly rigid. Okay. चलो बेटा इसको थोड़ा सा ऐसे करो. हाँ. थोड़ा सा मुश्किल हो रही है। हाँ, बस बस, बहुत अच्छा, फर्स्ट क्लास। चलो, हाँ जी, जाइए जाइए,
The cannula you are using is a straight or a curved one?
किसी में भी जाइए। Whatever cannula they have given me, I'm using. Arvind, please tell कौन सा cannula दिया यार? It's, I think,
Very
curved,
correct.
So it's
slightly
very,
curved.
Dual lumen
It's
cannula.
yeah,
Yes,
it's
with
double
the-
slightly,
lumen. It's very,
slightly curved.
yeah, it's
I
very
have,
commonly available. Yeah,
I
it's
don't use this cannula. I usually use a single cannula with separate attachment for curved and separate for which can be interchanged. So I think it is Arthrex. I think, I don't know the company.
Yeah, Arthrex, Striker, everything has got that.
Sometimes I don't even bother. Whatever is the best, I want to use in my hands. So that is the second one. So it comes out.
The problem with the dual lumen cannula is that if you're taking the bite very close, sometimes
Correct. You are committed. You are committed.
Yeah.
You are
The thing is
committed.
that you can keep the cannula a little bit away from the
Can you
meniscus
hold
tissue
Siddhant? Siddhant.
and put the needle a little bit inside and pierce through the exact point where you want to pierce. So you can
Again.
get a good bite. Yeah.
वायरस करना है थोड़ा सा। ओके, जस्ट ऐसे रखो। हाँ, दिखाना भी तो है। ऐसे पकड़ो। हाँ, ऐसे पकड़ो। So now you see, again, we have done a little bit of varus, and in varus, I am going to tie. See?
Yes, yes.
Cut here. काट दिया ना? बेटा इसको यहाँ पे हाथ करो, यहाँ हाथ करो। हाँ।
Varus and extension.
A slight extension, yes. It's not complete extension because you can't see otherwise. Siddhant is also struggling because it's too much of extension. It's difficult to see. So for the sake of demonstration, yes, we'll see it from here. Okay. Yeah. Varus kiya? So, yeah, so this is the problem. It has come out from here. Artery दो, artery दो. देखा नहीं तुम लोगों ने कहाँ से निकल रहा है ये? अरे रुको यार। नहीं हो गया. So last time it came out from the skin. This time I have brought it out subcutaneous again, and now I have retrieved my suture. I have been able to salvage the stitch. Now I am putting it back on the capsule. वारस कर दो final एक बार अच्छे से. Yeah. Yeah, see now it looks, with even 2 sutures, it looks such a big tear. It looks very secure. Now you can always put 1 or 2 extra sutures to make sure that you are rightfully tying it. Okay. Now let's see what has happened. The suture broke there. Yeah, it has held well. I gave about 5 or 6 of them. So 1 more suture maybe will be needed here. And then we will have 1 back suture if you want. Can I have the probe? ये वाला टूट गया. That is a problem also. Can I have 1 more inside out? One more inside out quickly. Then we have to go to. So this is a slightly. इसको हटाओ. उसको काट, रुक जाओ, काट दो उसको, थोड़ा बड़ा रख के काट दो। आओ थोड़ा बेटा इसको, एक मिनट ऐसे रखो, कैनुला बड़ा बेकार सा है। आप लाए हो क्या? अच्छा चल ये अच्छा लग गया, ये अच्छा लग गया, चल ये बढ़िया लगा है। हाँ दोनों में डाल दो, ऊपर नीचे करके। कौन सा डाला? ऊपर डाला? चलो ठीक है, रुक जाओ। हाँ ये सही निकला है, चलो इसके, एक मिनट, नीचे वाला डालो। ये ऊपर वाला डाल रहे हो क्या? एक मिनट, श्योर? नहीं ऊपर जा रहा है, इसको वापस निकालो, देखें। एक मिनट, हाँ ये गया, सही गया, ये नीचे वाला गया, ऊपर वाला डालो। सो हियर यू आर कमिटेड टू द, हाँ गुड, गो। घाव में से निकला है कि उसमें से? थोड़ा बैक करो, थोड़ा बैक करो, हाँ जो, हाँ परफेक्ट, चलो दोनों निकाल लो। So now, Shivam, Arvind, all of you sitting there. So see, these two are going very nicely. हाँ चलो, what a fantastic colleague here.
That is the best bite.
ये देखो, ये नोट पड़ी हुई थी, ठीक। So now again, I use this, इसको ऐसे ही पकड़ के रखो, इसको दबा के रखो मेनिस्कस को, और अब वायरस थोड़ा सा कर दो, कोई बात नहीं, पीपल देख, अब लोग समझ चुके हैं प्रिंसिपल। इसको काटो, इसको काटो। We are using it as a reduction device, and because of time constraint, पकड़ो इसको धीरे से, थोड़ा सा और वायरस करो, हाँ ठीक। I've given 5 throws or 6 throws. I think that is enough. Now you see. अब निकाल लो, चलो। See, I think we have done a decent job on the inside out part. That suture became loose eventually because it broke. So we gave the other one, and it worked out better this way. So can I have this thing? इसको निकाल दें उस suture को। हाँ वो निकाल दो उसको। So I will go back to my lateral portal now and see from here. एक मिनट छोड़ दो, छोड़ो। Yeah. So that is our final. हाँ उसको बाद में निकाल देंगे. Let me finish the ACL part. So I think we are okay. Can we go to the ACL? We'll take out that thread later on.
Yeah.
Arvind?
Yeah.
Shivam?
Yeah, it's all well. We are just removing that suture, which was intra-articular.
Yeah, this we will remove with a shaver at some point of time.
You can always.
Okay, so I'll go now to the ACL part. We'll just do a bit of inspection. We'll put one more anchor suture at the back here. And this is the ACL, sorry, the lateral side. It's not opening too much at all. We are figure of 4, it's quite tight. So this actually doesn't require an LET. It actually required a meniscal repair and an ACL. What do you say?
What
So,
was the examination?
can you see, we are doing a severe valgus and we are not opening. Very nice lateral meniscus, no drive-through sign. And this is a lot of valgus done. I can't even put my full, so it doesn't require LET in my opinion. What is the opinion of the house? Hello?
What is the examination under anesthesia evaluation? What is the findings? Because LET is a pre-op decision, I think, rather than.
grade 1 pivot. It was a grade 1 pivot.
Grade 1 pivot only.
Yeah.
Then there is no need for an LET, I think.
Yeah. So I think per-op I have taken that decision because I didn't see the pre-op. So, okay. So here we are. I'll try to preserve this remnant of ACL, whatever we have, and try to do the surgery. ये काम कैसे करेगा?
Sir, foot pedal. This is the foot pedal, sir.
Okay.
कौन सा है बेटा? ये वाला दूसरा foot pedal दो.
कितना ना?
Quantum का foot pedal दीजिए please.
छोड़ो यार, हटाओ.
वो
चलो मेरे को एक माइक्रो फ्रैक्चर ऑल दो. माइक्रो फ्रैक्चर ऑल.
So,
This is,
for making the femoral tunnel, you will be using zig or something like an offset, or you'll be doing
I'll
freehand?
doing freehand. I'll show you how. I'll do freehand. So that is the edge of the posterior edge of the femur. If you can see very well. Now I must show you something very clearly. These are the anterior fiber attachment of ACL, and this is the posterior part of the. So this whole shaggy area which you see is the original ACL attachment.
Yes.
Now I will take a point which is around 10 o'clock or 10:30. So if this is 12 o'clock, can you see?
Yes.
This is 11 o'clock. This is 10 o'clock. Okay. This is 10 o'clock, and this is the backside of this thing. I come, make a straight line from here to here, and from there I take a midpoint.
Right.
This is where I am going to go at 10 o'clock position. Wait. Hammer. This is my point of ACL attachment.
So
Go.
at this time your knee is at 90 degrees.
नीचे वो चला जाएगा अपने आप. The knee is at around 70-80 degrees or something, hanging out of this thing. Maro. Perfect. छोड़ दो. ठीक. So this is where it's quite posterior also. Now I bend the knee completely. Okay. Wait. Don't be in a hurry. Knife though. Relax. So I will do a bit of cleaning here. This is a visible tunnel, good posterior, reasonably inferior, right in the midpoint of the ACL attachment. Can you see this?
Yes, very nicely seen.
Okay. Now give me थोड़ा सा इसको ऐसे बंद करके रखो. भैया काटने के लिए थोड़ा ना चाहिए.
11 नंबर चाहिए 11
यार
11 चाहिए बेटा 11.
चलो ठीक है यार क्या बोला. Make an accessory anteromedial portal. दो.
आर्टरी दो
ये क्या दे दिया. ठीक है. Now you see I'm going directly and hitting there. मेरे को एक बीच पिन दो.
Yes.
बीच पिन दो बेटा पहले बीच पिन उसके बाद 4.5 के ड्रिल बिट.
पानी दो.
थोड़ा प्रेशर देंगे प्लीज somebody. ये बंद कर देंगे. बंद कर दीजिए प्लीज. थैंक यू.
क्या यार तुम खड़ा होके यहाँ पे.
पहले 2.4 2.7
पता नहीं है 20 साल से आ रहा है उधर से. ये तो चलता ही नहीं है यार.
पैर पकड़ना सर.
इतना बड़ा कर दिया अभी स्पिन
उठा
को.
दो बेटा.
सुअर कहीं का.
उठा करके दो.
क्या करने आता है. लात खाएगा ओटी में आकर के खाली.
बस.
इडियट. इसीलिए मैं कह रहा था लेके आता हूँ स्टाफ को. यस. अब खोलो इधर से. नाइफ दो. Sorry. So here we have got an exit of our bead pin. Now I will use a 4.5 reamer to go on this side. चलो दो. अभी इसमें thread डालना होगा थोड़ी देर बाद. इसके बाद ऊपर.
अगला depth gauge.
So I'm going with the 4.5 and I'll drive completely, and at the point at which it exits, I will count. It has still not exited. 35. It is now hitting the cortex. I exit at 45.
Right.
चलो एक मिनट रुक जाओ. अभी मेरे को वो दो. 8 ग्राफ्ट कितना है?
Graph 8 है sir, femoral 8.
चलो femoral 8 मिलीमीटर का दो रीमर.
8.5.
हाँ ठीक. थोड़ा आराम से जाएगा ना 8.
8 tight है. 8
Your tunnel is 45 mm. How
8.5
much
करो.
you intend to do the femoral socket?
Sorry, I can't hear you.
How much femoral socket you intend to get?
Length. I will give. What is the length of the graph?
45 is we have 8 centimeters.
8 centimeter. I'll give 2.5 centimeters. Femoral socket. कितना गया?
Maybe 15, 20, 25.
So we have gone 25. अब मेरे को बीच पिन पे थ्रेड लगा के दो. इसमें थ्रेड डालो. चलो. So this you can see I've got a good posterior wall. पानी दो. I've got a good posterior wall.
पकड़े रखना बेटा.
And I have put in my thread. And now I am secure on my femoral side. I will go right on the tibial side. चलो दिखाओ. So this is where, can you see the attachment of ACL now?
Yes.
Yes, the posterior wall is very nicely seen.
And how do you think is the attachment of ACL vis-a-vis when you use the marking device?
It's very anatomical.
So this is what we need. So my calculation is to look at the edges of the original ACL, take a diameter from the posterior edge of the whole femoral condyle at the halfway at 10 o'clock on the right knee, and at halfway at 2 o'clock on the left knee, I would do my ACL tunnel. Give me the my jig, tibial jig quickly. ये tibial jig है. मतलब क्या इसको बोलेंगे यार.
So when would you prefer to do or look for the notch and widen the notch or do a notch plasty?
अरे वो I think I am not a great advocate of notch plasty because I put my ACL reasonably posterior.
Correct.
I was telling Sarthak just now, he was in the car, that so many, almost 2.5, 3 decades of ACL, and all of them are behind the Blumenstadt's line. So the whole trick is that the patient with ACL reconstruction should be able to hyperextend the knee. If they are not able to hyperextend the knee, your graft will fail, and most of my athletes and gymnasts will always be very unhappy. They cannot pursue a career. So now look, wait. See, I am putting this pin where? This is the edge of the posterior horn of lateral meniscus. This is the place I am going to put my pin. My pin will come out at the anterior side of this hole, towards the anterior side of the knee. And 4 millimeters from that pin will be the drill hole, and that should be quite anterior. Can you see that? So I will show you how the pin comes out. Come, put in the pin. And it will come out right in the, it will be very interesting to see the end of the ACL, because this ACL will be absolutely like inside the graft. Yes, if this device works properly. Okay, Karan, come on. Drill karo.
So you're referencing with respect to the posterior horn of the lateral meniscus and PCL.
Yes, yes. Just now you see this, Shivam. Actually, Shivam, we have worked together once.
Yes, yes.
ACL, PCL together, 25 years, 20 years back. चलो
हो गया शुरू।
जाओ, थोड़ा सा जाओ, दिखाना होगा ना पब्लिक
चला
को।
गया
चलो बस वापस निकालो, थोड़ा वापस निकालो, बस 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 बस। आई एम गुड, डोंट वरी, आई विल शो यू हाउ। दिस इज वेरी सिक्योर।
खोलो बेटा, खोलो।
निकालो, करण खोलो,
ये खोलो बेटा,
टेक
ये।
दिस आउट। This is a different jig, usually we don't use this. चलो अब मेरे को वो दो, ड्रिल दो, ड्रिल 8.5 का ड्रिल। So I had filled the pin. अच्छा 9 का देना, 9 का बोल रहे हैं डॉक्टर साहब, डॉक्टर सिद्धांत साहब।
8.5 टाइट है सर।
आउट 9 का देने बोल रहे हैं, 9 का दो। नॉट सीन द ग्राफ ना। Once you see the graft in this case, you will realize what I am saying. डालो, पकड़ो, ऊपर हाथ लगा के रखो। So here it comes reasonably posterior. It is through the old ACL. So I am not really struggling here. Okay. Can I have the shaver now? Can I have the shaver? Okay. Move all this. See, this is where I will come out.
Yes. ACL is as a hood. The remnant is like a hood over your tunnel. We're just clearing it.
I would like to get the thread out now through the tibia. इसको इधर करो बेटा। अभी रुक जाओ, अभी रुक जाओ। इसको घुसने के लिए जगह तो दो। किधर है? घुसाओ इसको। So, हटाओ, हाथ हटाओ। So now this is where I have reached. Can you see this? Can you see?
Yes.
And I want to थोड़ा सा इसको पकड़ो, इसको पकड़ो, इसको पकड़ो, एक आर्टरी दो या कुछ दो, एक प्रोब दो। So what you are seeing is slightly different from what you saw in the first case. So एक मिनट करण, चलो बंद करो, खींचो। So that is it. And now you see where my ACL will go from, and it will be behind the original ACL stump, which is starting at the anterior edge.
Yes.
So this is how it will be. Can I get the ACL graph, please? Can
Is it
you hold the
invisible
scope?
ACL? Will it
I will show
invisible
you. I will show you everything. Just a minute. ये पकड़ लो बेटा, इसको पकड़ो, वहां दिखाते रहो। हाँ, चलो दो। Ready? Graft. So our ACL will go like this, and इसको पकड़ो, कस के खींच के रखो. And if I make it straight, it will be well within the notch. It will be well within the notch. Can you see this?
Yes.
This will be my ACL's trajectory. And when it is filled up, 9 millimeter, when it gets filled up, you will see it coming slightly anteriorly already. So it will get filled up. You must see that last visual. Hold it. क्या दिखा रहे हो? ACL की तेमा दिखाओ ना। हाँ, अभी बाकी है क्या ग्राफ्ट का? छोड़ो। मेनिस्कस का भी हो ही गया है। एक सूचर एंकर और मार देंगे उधर पीछे की तरफ। Just 2 minutes more for the graft to come. बास्केट है क्या? थोड़ा सा।
Won't that flap which is sitting as a hood on your tunnel will be acting as a cyclope later?
नहीं बनेगा नहीं, मैं वही दिखाना चाह रहा हूँ ना. Let the graft come.
Yeah.
I don't want to use the RF here because it will burn the tissue. I want biology to be okay. Almost over. I had to do the meniscal repair also. हाँ duckbill ठीक है. It's okay. Just that I am waiting for the graft. That's all. हाँ ready हो गया. चलो. I'll do the cleaning later on. पकड़ लो. आओ तुम पकड़ो फिर. Scope पकड़ो. बाहर का अंदर का दोनों का दिखाइएगा. ठीक है. So we have this device from Seronix. It's a variable, the thread, and we can actually mark it. लाओ दो, scale दो. Scale दो, 45 पे mark करो. So the flipping point will be 45. So we will mark it. Pen दो. Although I don't bother to see so much, but since it is सामने से हटो. Since it is a workshop, we need to do the right things. So we have 45 marked here. At this level, the button will be out. Okay, chalo, let's do it. कैसा thread? मेरे को कुछ नहीं चाहिए, सब तो है तो. वो कब कर लिया बॉस? अब तक तो खत्म करके घर चले जाते हो. हाँ, छोड़ो बेटा, छोड़ो. So I hold the button in my hand when I withdraw, so that we inadvertently. So I have taken it out, and now the first thing you do is you take the tiger wire part first. You take the tiger wire part first. Why? I'll tell you. Because you will then make the button straight. And it is the strongest wire. बेटा कुछ मत करना, बहुत ही खतरनाक काम है ये. So you can see the button is now going in a longitudinal fashion.
Inside picture, yes.
Yes, it goes up, and inside you can see that it has gone up. Okay. Now let us see whether our blue thing mark has come or not. It has not come. So can you just keep withdrawing? No, leave all this. Just take this one out. Slowly. Yeah, slowly. Take it out. Take it out. No, it's okay. Take it out slowly. Yeah, take it out. Take it out. Take it out. Take it out. पानी दो भाई, क्या कर रहे हो? Take it out. Take it out. Yeah, take it out. Take it out. Perfect. Very nice. ये आ गया. अब आप black वाला खींचो. So our graft has almost reached the mouth, and it has. No, अभी हो गया flip. Now that he has flipped the button, now we take this out. Both इसको दोनों को निकाल देना बाहर. हाँ, इसको निकाल दो, नहीं तो ये बेकार में तुम्हारा टाइम वेस्ट करेगा. हाँ, अब दोनों को करो. So while Dr. Siddhant doing this, I am assisting him to show you the intra-articular part. चलो खींचो आहिस्ता आहिस्ता. Pull. See, that has come. Now pull. See, the graft is going up beautifully. Can you see, Shivam?
The graft is trotting inside, and the mark is about to come along
It
the
is like a baby in the mother's womb. It has come out from the ACL attachment in that way. पूरा खींचो. हाँ, टाइट करो, खींचो. कोई बात नहीं, खींचो ना यार, जाएगा ही नहीं उसके आगे.
Yes.
25 के आगे जाएगा ही नहीं. समझे ना? हाँ, बस हो गया. Now you see what I was trying to say.
Correct.
My friends, just see, look at this ACL. Would you like to have this ACL, or would you like to anteriorize it further? Can you see? I am pulling this whole leg with these threads of ACL. ACL is not moving at all. Can you see? I'm moving the whole tibia with the graft. And if you straighten the knee, Karan, straighten the knee. Cyclops की बात हो रही थी ना? Look at this. Do hyperextension. Do hyperextension. We are doing hyperextension of 5 to 7 degrees. Look at this. There is
No
nothing.
impingement, nothing, right?
Nothing. But still I will take out that loose piece and look at ACL. There is no pistoning of ACL. Can you see this? There is no pistoning of ACL. So the champion athletes would require an ACL where you can do hyperextension.
Very
Thank you.
perfectly demonstrated.
I think we have finished the job. Whatever little is left, we'll do. LET is not required, as I said. Instead, we have seen the meniscal
We
repair.
would still like to see the final picture after a few minutes, and we know you will be completing it. And we are switching over here for the PCL session.
Yeah.
दिखा लेने दीजिए, okay. Yes, yes.
Vikas boss,
हाँ, ठीक है.
have you done or you want to show anything else?
No,
It's
we have
very
done.
quick.
We are over. We are over. We
Yeah,
are
thank
done.
you, boss. Thank you.
Thank you. A
very
good
much.
round of applause for
Yeah,
you,
thank
Vikas
you.
sir, from here.
Yeah.
Nice demonstration. Difficult case.
Thank you.
Thank you, Arvind.
Thank you, Siddhant. Thank you.
Thank you, Siddharth. Thank you very much.
इसका नीचे फिक्सेशन करो. कोई भी स्क्रू डाल दो यार. साइज क्या है? 9 है ना? 10 का.
एक हमारा भी.
Good afternoon. Good afternoon, delegates and faculty. I'm Dr. Zishan Ali Khan. I'm honored to serve as the moderator of this sessions. We had a very wonderful and insightful sessions on ACL and meniscal injury. Now we will commence on these sessions with PCL injury. I call upon Dr. N.K. Singh sir, Dr. Rajiv Anand sir, Dr. Rajiv, and Dr. Vikram Veer sir as the chairperson on a dais. The first case will be presented by Dr. Abhijit Jaiswal sir, and the topic will be the arthroscopic PCL tibial spine avulsion fixations with recent advances with Dr. Abhijit Jaiswal sir is here.
Good afternoon, everyone. I'm Dr. Abhijit Jaiswal from Popular Orthopedic Hospital, Patna. My talk is on arthroscopic PCL avulsion fracture fixation techniques and literature. So post-lunch session, I'd like to make this a bit more interactive. So my question to the audience is, how many of us are doing tibial PCL fixations by the open method till now? So any hands in the audience? Yes, okay. So are you happy with the functional results and rate of recovery and return to sports compared to the arthroscopic methods? Or yes, sir, please.
So if it's an avulsion and it's a big chunk, then I like to do mini open posterior approach, which results are extremely good. I have no issues at all. But yeah, I do appreciate it's a good technique, arthroscopic, and I use it about 80 to 90% of the times is the arthroscopic technique. But it depends mainly on the chunk. If it's a big chunk, I like to do mini open. If it's a fragmented chunk, then obviously arthroscopic technique works better for me.
So thank you so much, sir. So that's where I'm going to highlight how is arthroscopy a better option. So TAPCLs, tibial avulsions of the posterior cruciate ligaments, they constitute about 3 to 20% of all the knee injuries. And mostly they are associated with dashboard injuries during four-wheeler, but in an Indian subcontinent, we have motorbike related RTAs. And when we talk about sports, knee hyperextension is most frequent mechanism. Till now, Mears and McKeever's classification is the most widely adopted system, which divides into three distinct types based on degree and pattern. So this is type 1, which is undisplaced. Type 2 is minimally displaced. Type 3 is completely displaced. And there has been a modification where type 4 and type 5 has been added. Type 4 is a comminuted fragment, and type 5 is displaced with associated tibial plateau fracture. When you talk about imaging, X-rays, AP and lateral is the most valuable, I feel. And since the PCL inserts about 10 millimeter distal to the joint line, fragments with less than 10 mm displacement may not be appreciated on radiographs. So that's in where you go and get an MRI done. CT is always beneficial, giving you correct information regarding the size and comminution of the fracture fragments, and they can help you in utilization for pre-operative planning. So these are some cases, my own cases. On the left is a type 3 avulsion. Type 5, very frequently seen in our Indian subcontinent, PCL avulsion fracture with a lateral condyle split fracture. MRI type 1 SAG, where you see clearly the PCL fragment along with the fracture fragment. Type 4 comminuted CT in the 3T CT scans. So how does the patient present to you? They will present to you with a history of RTA or a sports injury with pain and swelling. Hemarthrosis is very common. Instability, limited mobility, bruising, sag sign, tibia sags backward relative to the femur when the knee is flexed at 90 degrees. Posterior draw test is positive, confirming PCL laxity. So how do you manage these cases? That's the dilemma. So for non-operative cases, undisplaced where you have a firm endpoint, you go with a cylindrical cast with a posterior sag pad, or you can keep in 15 degrees of knee flexion. Surgical. So for decades, ORIF, open reduction, internal fixation has been preferred by many of us, trauma surgeons. And so what is the approach that we use here is the Box and Schaffer approach, where we use of screws and sutures. And I'm going to talk about the arthroscopic fixation methods, which is a less invasive option with reduced risk to neurovascular structures. Methods you can use suture, bridge, pull-out, suspensory fixation. So just to highlight how the Box-Schaffer approach with the posterior approach, where you make the patient in prone position and the incision is in an inverted L. You take while after giving the incision, you retract from the medial side of the gastroc and pull all the important neurovascular structures to the lateral side. And this was adopted by many of us, still being adopted. I don't say it is a very good method, but I'm going to talk about what I do. So this is my first case. This is a CT, and this is the video. So how does it play? Can you play this? Yes. In the panel, somebody can play this video. It was playing in that PowerPoint. Yes, sir. So, yes, but the video was there, sir. It was playing there in the PowerPoint. This is another video. So, until the video plays, probably the laptop configuration. So these are my two. Yes, sir. Yes, sir. So this one video is playing. So we can see in the diagnostic scopy the lax ACL and PCL. So I utilized the interval of Gilquist to make the posteromedial portal, which was there in the previous video. And I use fiber tape and fiber wire. method with a first pass mini. Make the tibia tunnel posterior, like around 15 mm. I want to go below the joint line. And I retrieve those threads by using a 4.5 mm drill bit from the anterior side. And after fixing them, yeah, so this is my final result. So you can see how well the tout ACL PCL. This is a suture disc method. I wanted actually this video to play, but somehow it is not playing. So how do you manage the post-op rehab? So first phase is protection and activation, where you keep the patient in a long knee brace and do ROM as tolerated. From after week 6 to 12, you start with controlled motion like stationary cycling, and phase 3 is focused more on strengthening and return. So my comparison highlights clinical outcomes. Both methods achieve excellent bony union and functional scores, but arthroscopy patients have higher return to activity rates. Arthroscopy offers smaller incisions, faster recovery, less post-operative pain. It is more safer, more flexible in the way that you can address intra-articular pathologies as well. Arthropfibrosis is a listed complication. Some recent journals that I've got. Thank you. If I was able to play this video, I could have showed more, but so it is not playing.
Thank you very much. Any questions from the audience? So I think in PCL avulsion, the protocol is we should consider it as a fracture. So the protocol, rehab protocol is slightly different from the other ACL and all. So till it glues and unites, then until then you should keep it in the brace.
Yes.
Not to walk. I think you have given 6 weeks.
Yes, sir. 0 to 6 weeks. I keep them locked in brace.
Yeah, right.
Yes.
Very nice video. I have one question. So do you use a single tunnel or do you use two
No,
tunnels?
sir. I use a single tunnel, 4.5 mm drill bit, and I use a fiber tape and a fiber wire and tie them over a suture disc.
All right. And the bites that you take, do you take multiple or just single bite and cinch it over?
So I use a fiber tape, try to go intra-substance, like more posterior, and just tie them with a loop and bring them down, and use simple knotting methods to tie them. Thank you.
Thank you.
So may I call upon Dr. Saji Rusman? He will be talking on remnant preservation PCL construction. Right. Oh, Dr. Steve Choksey, double bundle PCL reconstruction, please.
Thank you. Thank you so much, sir. Today, I will be speaking on double bundle PCL reconstruction. So when we say double bundle PCL, why do we really need double bundle PCL reconstruction? Not only because it's anatomical, of course, that's one of the main reasons, but let's dive deeper into it and figure out. So it's been an age-old concept wherein we started studying. The studies came out since early as 1994, where there were mechanical studies, and there were again comparisons between double bundle and single bundle anatomical reconstruction. So the concept is basically that the AL or a single bundle PCL is tight in full flexion, but it is lax in 190 to 130 degree flexion. And also when we do a isometric single bundle PCL reconstruction, it is lax in greater flexion. And that is also one of the reasons why if you do a single bundle PCL reconstruction, a lot of times in post-operated patients, in cases which we have operated earlier, when we do a posterior drawer, you find a step 1 or 2 degrees laxity. And when we see at a double bundle reconstruction, there is a normal laxity or the tightness is throughout the full range of movement. So we are looking at anatomy, which is greater and which is more important than isometry. When we do a single bundle reconstruction, we are only concentrating on isometry and not on the anatomical reconstruction. And when we're doing a reconstruction, the basic principle is that we have to be as anatomical as possible. Coming to a study done in AGSM in 2000, it was a biomechanical study in cadaveric, which also proved the same and state that the double bundle reconstruction is much more superior. 2009, we had a study wherein there were 8 patients of single bundle inlay, 11 of transtibial, and 10 of double bundle inlay technique. And there was lesser posterior sag when we compared a double bundle to single bundle. So there have been various studies, and Laprade has also studied a lot into this, and in fact has done a robotic study wherein they saw that there was a double bundle was closer to the natural anatomy as compared to a single bundle ACL reconstructions. So better AP stability in deep flexion, yes, it does reduce the posterior translation in knee angles more than 90 degrees. So that is very, very important. And especially when you're looking at athletes and high demand patient, that plays a very vital role. Quickly taking you through the anatomical video, a very good anatomical demonstration done by Rob Laprade, and which actually shows us the anatomy properly into it, wherein we see how the PCL is really attached. So there's a basic concept of the roof and the wall. So starting from the top, the roof, the trochlear groove or the trochlear point, that's where it starts, the PCL starts, the AL bundle, and it is attached right on top. And as we come down to the medial arch point, that is where the wall starts. And that is where the posterior medial bundle is attached onto the femur. So this wide fan-shaped insertion of the PCL onto the femur is very important to replicate. And this actually shows us why double bundle reconstruction is important. Also, there are the anterior meniscofemoral ligament, which is also attached, which also gives the stability and adds to the stability of the PCL. Looking posteriorly, as you can see, the roof, there's a tight, strong band onto the roof where we can see posteriorly. And as we come to the tibia, you find a linear fashion, compact insertion, which is only about 8 mm. So as we look on top, it's about 13 to 14 mm, and we look at the tibia, it's only about 8 mm. So that explains us how we should really reconstruct the PCL when you're looking at a double bundle reconstruction. If you do a section, we see the posterior medial bundle is tight in full extension and also in deep flexion. And whereas the PL bundle is tight in all through the flexion, during the flexion. So this is what we have to replicate and get closer to anatomy as possible. These are the various points that I already explained. Again, there are various studies which show the same. And again, which has proven that, extension, there is lax, and the AL bundle, which is taut in 90-degree flexion and lax in extension, whereas the AM is the PL bundle, the posterior medial bundle, is extension, fully taut, and also in deep flexion it is taut. So taking you through the surgical video, this is a patient wherein we can see there's the ACL is lax, there's a floppy ACL sign, which confirms the PCL tear diagnosis. And this is where we are looking at the PCL. And this is where the fan-shaped insertion you can appreciate right from the roof here going to the wall. So there we mark a point onto the roof close to the cartilage, because AL bundle is very close to the cartilage. And as we go to the wall, it is slightly posterior, about 7 to 8 mm posterior from the articular cartilage. And that's where I'll have my tunnels drilled. I do an outside-in technique, a full socket, not a closed socket technique, and I put interferential screws on the femur as well as the tibia. So that's where the AL bundle comes in, very close to the cartilage, right onto the top at the roof. And this is where I'm going to be placing my PM bundle, which is slightly posterior from the cartilage, and that's covering the wall of the femoral attachment. The PM bundle, which is slightly thinner, about 5 mm if you're doing the hamstring, and the AL bundle, we get about 7 mm if you're using the semi-T. So these are the two tunnels. And you can appreciate that the roof and the wall, which has been covered, and the full PCL insertion on the femur has been covered. Now we're coming to the posterior part. It is very important and vital that you make the posterior medial portal. The posterior medial portal is slightly higher to get a good visualization and good access when you're trying to clear out the posterior structures. That is the meniscus, which you need to visualize properly, and also the shiny structures, shiny white fibers of the medial meniscus posterior root, which is very important because that should not be violated at any cost, because that causes root detachment of the meniscus, leading to progressing to OA. And there is also this point, that is the bundle ridge, behind which is the AM bundle and the PM bundle inserted onto the tibia. So this is where I'm going to be centering my tibial tunnel. So there is one single tunnel for the tibia and two tunnels for the femur. And that's where I'm going to come out with my drill. This is below the shiny fibers, but just above the champagne drop off. So if we are able to visualize, I wouldn't take a C-arm shot. But if things are not visualized properly, I would use a C-arm shot to just be sure. Closely using the jig, I have a controlled drilling there. And that's where I have about 8 mm drill coming onto the tibia. A fiber stick wire is passed to railroad the ligaments, and both are then fixed onto the femur side and onto the tibial side, fixed onto the tibial side, and on the femur side, I do a sequential tightening and fixation, and the AL bundle is tightened in 90 degrees of flexion, whereas the PM is tightened in full extension. Sequentially, you have to pass the graft. This is also a very crucial part because there can be intertwining of the ligaments. So that is where the PM comes in. And then I'll be passing the AL bundle. And then they are tightened and fixed according to the flexion. So this is the final picture where we are able to appreciate that we have a good 7 mm and a 5 mm graft covering almost the entire femoral footprint onto the femur, and we have a nice tight ACL there. There have been meta-analysis, again, signifying the same, but definitely take-home message is that if we are able to replicate anatomy and get as close as possible to the anatomy, we are able to get a good success in PCL surgery. So thank you so much.
Any question to Shiv?
Thank you,
From the
Shiv, for
audience?
this double bundle PCL. Definitely, this double bundle PCL having edge over the single bundle. We have recently published that double bundle advantage over the single. Just I want to know that the tunnel in the tibia or single tunnel in the tibia, does it make any difference?
No.
Or the result is
So
same?
that is why I showed the anatomical. It is a very condensed and a very condensed and a compact insertion on the tibia. It's only about 8 mm when the cadaveric studies were done and deeply studied by Lob Laprade. And he also follows only single tunnel in the tibia, and which comes about 8 mm. So we are covering the entire footprint. Very essential to have 2 tunnels on the femur, which covers the entire femoral
Yeah,
footprint.
absolutely right. So like double bundle ACL, not necessary to 2 tunnel in the tibia. It can be deal with the single tunnel in the tibia and 2 tunnel in the femur.
Absolutely.
And this technique definitely having advantage over the single bundle PCL reconstruction. So do you do this double bundle PCL reconstruction in multi-leg also, or is there in a specific selection criteria for your double bundle PCL reconstruction?
Multi-leg, I would do a single bundle PCL. ACL PCL, I would do a double bundle PCL and a single bundle ACL. Again, these are high demand patients, and definitely male with good size of the knee has to be big enough. Female patient with small knees, it could be a little tricky, but yes, definitely for a multi-leg with only ACL PCL, I would go in for a double bundle PCL with a single bundle ACL.
Perfect. Last question. What is your angle of fixation of the graft over the femur?
So the AL bundle is fixed in 90-degree flexion and the PM is fixed in full extension.
Perfect. Thank you.
Thank you, sir.
Thank you.
Any other question?
So just wanted to ask you, what is your sequence of passage of graft in this double bundle PCL?
So as I showed in the video, I passed both the grafts from the tibia because I have an open socket in the tibia and the femur. And I would pass both the graft from the tibia, bring it to the femoral side, not fix it on the femoral side, fix a common screw fixation for the tibia, and then do my sequential tightening with varied angle of flexion.
Okay, thank you, Dr.
Thank you. Thank you so much, sir.
Now may I call upon Dr. Shivam Sinha?
No,
for
not
his-
you. Sajeev Usman.
Sajeev Usman.
Yeah, hi. Sir, Sarjil Rasid, Dr. Sarjil Rasid आ गए हैं. इनके बाद Dr. शिवम सिन्हा का.
अरे ऑफिस शिवाना के लिए बोल रहे हैं मेरा. They want you to speak on the single bundle again. तो मेरा presentation भी नहीं चल रहा. So the idea of single bundle PCL reconstruction is because the majority of our practice, we see that the PCL remnant is intact. And we do find that in quite often as in 80% of our cases, we do find a viable PCL remnant which we can save in our surgery. I wouldn't recommend to do this initially as a beginner to preserve the PCL. But if at all you are doing a reconstruction, a PCL reconstruction, and if you attempt to do it in a remnant preserving manner, the end result or the final picture of the surgery is beautiful. So that's what I would like to convince here. And I would not like to dispute a double bundle. A double bundle is an excellent surgery. If 2 bundles on the femoral side, 1 bundle on the tibial side. But this surgery is in only 2 tunnels, which is 1 on the femur, 1 on the tibia to complete the PCL reconstruction. But the way we do it is slightly different. The meaning is we do not take down tissues, we do not burn tissues, we do not ablate tissues as much as we do in a double bundle or a remnant takeoff surgery. So the first thing in a PCL reconstruction is to always look at the characteristic features of a PCL deficient knee, which is patellofemoral and medial femoral cartilage wear. So you must record these 2 findings and at the beginning of the surgery itself, because these are important findings before you prognosticate the case. Before you proceed for a remnant preserving PCL, you should understand there are 3 windows that you can use. One is between the anterior cruciate ligament and the posterior cruciate ligament. 2 is between the posterior cruciate ligament remnant tissue and the femoral condyle. And 3 is the posterior medial axis. If you have made these 3 windows, then you can proceed with the surgery beautifully. So the first window is by using a small shaver directed between the anterior cruciate and the posterior cruciate ligament. And you start creating this opening through which you start visualizing posteriorly. Ensure that you keep switching off the suction intermittently and you can slowly open up the posterior capsule. What you're seeing in between is the interseptum, is the septum, and now you are seeing the posterior medial portal being created. So once you visualize the posterior aspect and you created the window between the ACL, PCL, and you have put the posterior medial cannula, you can proceed to continue your debridement posteriorly. At this point, we do use a little bit of RF, and then the jig is inserted to the anterior portal, placing it posteriorly on the tibial footprint. The tibial footprint to identify and drill at this point, like Shiva shown, some of the shiny white fibers is often seen. It is roughly around 18 to 20 millimeter distal. But the most important landmark that one can look out for is these dark fibers of the popliteus. One doesn't need to necessarily elevate the fibers of the PCL to see them. You can see them in the muscle belly itself. And that's as far distal that you need to go up to. On both medial and lateral side, you often see the small mammillary bodies between which, if you can place the jig, you will ensure that the tibial tunnel is as central as possible. Mic बीच में ना cut off हो जाता है. नहीं इसलिए point ओके चले. Mic ना बीच में connection चला जा रहा. So इसके if he can find this tibial footprint and place the jig at least around 18 to 20 millimeter distal, you can be sure that you are as distal as possible. Now, how do you do this process entirely remnant preserving? You make sure that you use the wire catcher jig And after the wire catcher jig, the final steps of drilling should be always done by hand. If you look at the Strobel's textbook on the description of the PCL from which the animation is taken, you can see that he has made a slot in the distal tibia in which the PCL is completely seated into. So you can even make a slot in the tibia proximal to the tunnel so that the PCL graft can sit into that defect. That way you will ensure that the graft and the remnant combines as one. So now you have retrieved the suture from the posterior aspect into the anterior aspect of the knee, and you can drill the femoral tunnel. How do you identify and drill the femoral tunnel? Again, trace the remnant. And if you point more towards the roof, that is the more functional bundle which you want to reconstruct. And if you do look at that point and use an outside-in jig, the same way of the terminal drilling, if one does by hand only, you ensure that the most minimum amount of fibers are taken off. So essentially, we are making a slot, a defect in the femoral aspect of the PCL more towards the roof so that you reconstruct the functional bundle of the PCL, and then comes the passage of the graft. If you want to avoid the killer turn, you take two sutures, one from the femoral tunnel, two through the tibial tunnel, and you retrieve the graft into the tibial tunnel through the portal and then retrieve the graft into the femoral tunnel from the portal itself. That way your graft passage is through the portal and not through the tibia. That way there is no killer turn. And this is the all inside technique of PCL reconstruction, which we use in our surgeries now. So here, two suture loops. The green one is coming from the femur. The black one coming from the tibia has pulled the graft into position, and then the graft is reloaded into the femoral socket. Fixing it with screws is what we do usually, and you can see the screw at the aperture before taking the retinol wire out. But at the end of the surgery, you have preserved the entire PCL remnant which is under it and reconstructed the whole structure. Thank you very much.
Just one pause. There is live surgery going on in the OT2. It's the plain ACL. Nowadays, there is lot of augmentation of the ACL. It's biological augmentation, non-biological, from the tissue itself, or it's the product that's coming. This is the BioBrace augmentation of the ACL. Dr. Sarthak Patnaik from Bhubaneswar, he is doing this surgery. Just will spend for a couple of minutes here. Sarthak, are you? Hello, Sarthak, can you hear us? Sarthak?
मशीन ऑन नहीं तुम लेके चले गए थे मुकुट हेलो
हाँ सार्थक
हाँ कैन यू हियर मी
Yeah, you are very clear and loud.
Okay, good afternoon and good evening, everyone. I'm Dr. Sarthak from Bhubaneswar. So here we are seeing a patient who has a 35-year-old male who's a corporate player. He plays cricket and has sustained an alleged of injury of around 1 month back. Came to with instability. Clinical examination shows Lachman grade 2, pivot shift grade 1. So the McMurrays were negative because I saw him before he was given anesthesia. On a diagnostic, we could see the cartilage are well in shape, the gutters are good, the meniscus, as you can see, I'll show you here. This is how I do, I just keep it on my side, and you can see the posterior meniscus over here, portion of the medial meniscus. So I just push my hand, please, water, please. And I just like to show you the ramp. There is no specific ramp lesion over here. थोड़ा enter draw दीजिए. Slightly bulge ho gaya hai. So the meniscus is normal. There's no tear of the medial meniscus, which I have probed already. I won't waste your time. And then the lateral meniscus is also normal on doing a figure of 4. So after seeing the meniscus is there, we have done the tunnels in which the femur tunnel is here. As you can see, is quite inferior and posterior. So my probe is very close. So we have done a 8 mm drill and the tibial tunnel, which is again the anterior horn of the lateral meniscus. And so it's quite, as you can see, in an anatomical position, it's going inside. We have taken Can you show the camera here? Graft. So we went for a graft harvesting. We could manage to take the Semiti and gracilis. Where the graft was not so thick in the diameter, but luckily we had a chance to do with the BioBrace from ConMed. So BioBrace is basically a biological type of implant, which just add, it's around a thin, it's slightly polysynthetic, and in due course of time, it when you wrap it around, like if you can see camera closer, please give me a closer of this camera. So if you can see the graft here, this is the semity, the shining part, and this is the brace. So the brace is well wrapped around the graft, just like a jacket. So we wrap it around the graft which we take, and then it's something like an augmentation, and slowly in due course of time it gets mixed. We dip it, I generally dip it with the venous blood and soak it for around 2 to 3 minutes, and I take around 1 to 2 ml of blood, and once it is soaked, it is ready now. So we are going.
What
Sorry?
are the groups of patient where this you will use, Sarthak? Which
I
type
have
of
used
patient
it.
you will use?
My first case was on a obese female. She was 120 kilo from Gurgaon, and she came to me, and so my first patient I used is a obese female, and the second I used mostly patients were affable,
So
because
basically,
you
it's
know this the
all high
brace,
risk
the
group.
only.
So it's basically
Yes,
all
I have
high risk
also.
group.
Yes, in my youngest age group, which I have used a BioBrace is 15 years of age, in a football player, and is also quite doing. I've been using it in April. I will be doing nearly more than 40 plus in more 1 year of BioBrace surgery. So I find this is good, but the only demerit is the cost, because it costs around 4 lakh Indian rupees. Though it is well covered in the insurance, company do cover it.
Thank you,
So
Sarthak. We'll back to you.
yeah.
We are continuing with the lectures. We'll back to you. Okay.
I'll just pass the grafts. क्या करें?
Okay.
Pass.
Take your. How much time you will take, Sarthak?
I will finish in 2 minutes. I'm
Okay.
ready.
Okay,
2
take your
minutes.
time. Perfect.
Yeah. Please just show this. So now we are trying to pass the graft. क्या हुआ? क्यों क्या हुआ? One second, just. So the femur tunnels and the tibial tunnels are, as per me, is quite in the anatomical position. So I'm not doing in the normal all inside technique which I do. पकड़ो. So, ये ना.
There was baby sister. In
Yes,
spite of she is doing
I am very
something, she is
thankful, Arvind, to ask baby sister to come and assist me. And your
for us. And most
and
of
SR,
ligament surgery is assisted by her only for
yes.
me.
So Aman is also there SR ship. So now you can see we are passing. We are trying to pass the graft. So this is what to the femur tunnel. खींच. खींचो. खींचो और खींचो. वो बीट पिन निकाल दिया था क्या? वो वाला खाया कहाँ गया? यस, धीरे धीरे, या आराम से तो निकालो उसको. जल्दी जल्दी लो. So as you can see, button तो नहीं गया ना. So there are 3 ways in which you can understand, like your button is well set. One, you can go through, you can follow the button through this tunnel. So one, and the other is the marking. As you can see, I have marked my femur side thread. All खींचो. Button कहाँ आया? So you can see the button has already gone. It is not there. It is outside. We will do
Sarthak, are you using the internal brace as well?
no internal brace.
Okay.
No internal brace. So now I am trying to.
Tendinosus, gracilis, both.
Yeah, because that was not thicker. Even after taking this, the graft diameter was around 7.5. So I had to take both. So I was lucky the brace was there. Others I would have gone for the peroneus longus. But luckily, we had the bio brace.
Of
So it
diameter
was-
now after using the brace.
Now it's 8.5. So we have drilled a tunnel of 8 mm. Kincho.
So what is your, long-term experience with this? Does that give you a very nice MRI picture 1 year or 2 year down the line?
Yeah, I have to take my follow-up of my follow-up of my MRIs. So it's quite good. The most important is the graft integration is quite good there.
And have you encountered any sort of infection after it?
No, Bhagwan, there, not yet till now. Thank you. But my infection ratio with BioBrace is 0 till date.
Do you soak this in vancomycin?
We soak it with, yes, vancomycin, and also once the my gentamicin is also on in my IV. This and the normal saline is mixed with gentamicin, so which I do regularly.
So there was question from Sunit Boss. Do you find anything advantage in post-op period? So we are doing a study, one with the BioBrace, another with the LET, and the initial diameter at the time of reconstruction, and after the end of 6 months and 1 year MRI analysis of that. So one of the thesis topic of my DNB candidate, that LET part, and this with the help of BioBrace, whether really it's increasing the diameter of this graft or not with the time. So with the MRI, we are doing this study.
Sunit Bose, the benefit is this, since it's a biological brace, as you go to the concept which Conrad has said, it nicely integrates. Unlike the internal brace, that doesn't integrate, it still lies. But this graft, what they have claimed, it integrates into the thing. So you can see now, this is my BioBrace, this is my BioBrace, this is my graft, and there's one more behind. So it's like a extra jacket, and this is already taut. So I just need to put a screw now. And as you can see, when I'm trying to extend my knee, it is well inside the anatomical portion. So the good thing is, if you have this, you don't need to do what I have in my practice. No LETs and all we have never do, and I'm doing with BioBrace because they tend to be good. And post-op pain is lesser. The ROM is, we can start the ROM within 48 hours. And then the load bearing is also quite faster when you do an IO-base.
Okay, thank you, Sarthak. Thank you for wonderful demonstration. We are going back to this lecture part. Thank you, Sarthak.
इतना टाइट मेरा स्पीकर बंद करो इतना टाइट क्यों था?
Now we'll proceed to the next case. I will call upon Dr. Shivam Sinha to present a case titling Management of Neglected PCL Avulsion Fracture.
Thank you for helping me participate in this conclave. And with my case, I would like to have attention of chairpersons and my previous speakers. Very often in our trauma practice, we get femur fractures with a tibial avulsion. So the things change that it goes through the fixation of femur, but when do you encounter your PCL problem with those cases? Immediately or after some time? Can I have a show of hands? People who would immediately attend the PCL injury at the time of initial fixation. And a late reconstruction or something like that, or you will just wait. Can I show of hands for people who will attend it later? Yeah, there are two schools of thought.
You're talking about the PCL avulsion or the PCL injury?
PCL injury, and avulsion, even
Avulsion.
avulsion, even avulsion. Would you like to fix it at the same time? Everyone would like to wait.
Yeah.
Right. So here's some atypical presentation I had, and I would like to share with your inputs. This is not moving. So this is an 18-year female. She had a history of trauma to the right knee only and had a fall from scooty some 7 months back, being managed conservatively elsewhere. And can see there was an avulsion, but presented to us after a re-trauma 3 weeks back. So when we examined, there was a positive posterior drawer. The dial test was negative. The varus valgus stress was negative, was having a full knee range of movement. But the problem was there was difficulty in walking and the muscle wasting at thigh. So if we draw the line, we can absolutely see a separation of the avulsion, but it's not appears to be fresh. And there is a translation of tibia. And then we got the CT or MRI as per requirement. So this is the CT scan. That is the avulse fragment visible and displaced at 7 months of time. What the learned panel or the previous speakers would like to do.
So how much posterior instability was it? Grade 2, grade 3, grade 1?
It was grade 2, was posteriorly unstable.
And CT size, CT measurement of the size of the fragment.
The fragment was not much larger, but though it appears larger,
This looks
it
like a
was about-
sizable fragment, isn't
Huh?
it? This looks like a sizable fragment.
a sizable fragment. You can still think of getting a
Some
screw in,
resorption of the bone underneath, but it looks
Right.
like a sizable.
and it is displaced.
It is displaced.
Displaced, the crater is there. We didn't measure the size of the fragment, but it appears amenable to be fixation by a screw.
So what is our approach? Most of the time it's chronic one. If it is chronic one, then always we look for the size of the fragment with the help of CT. So here two thought is there. One is repair of that fragment by the fixation. Another thing is the reconstruction.
So
So many a time it's very a small fragment and the chronic one. Most of the time reconstruction of the PCL, but it's looking very good size.
The size is good.
And
Right.
we have, though literature says more than 2.5 months you should be reconstructing, but we have very good experience of fixation of this bigger size of PCL as well as ACL also. Even 1 year old, we have fixed this with very good result. Only thing is the freshening of the crater, that has to be very important. And the fixation implant has to be very good hold.
So I'm coming to it. I'm coming
Yeah,
to it. I'm
because,
coming to it.
yeah.
Arvind, are you
So-
talking about arthroscopic fixation or mini open?
So that is on decision making, and that we mutually will decide. So any addition of MRI, yes, confirms there is an avulsion of a PCL injury. It's a
Plus you look at
flush, plus there is no other
ligament
meniscal or
itself.
contralateral. And we see the ligament itself. Okay. So now what goes to the plan is, we're talking about fixation device. The devices can be many. We can have a suture disc. We can have a screw. We can have a spike washer. We can have techniques. So are you still going to consider for a PCL reconstruction or avulsion fixation, which can be either open and arthroscopic? If open or arthroscopic, whether you're going to use a screw and a single portal or a double portal. So that was the dilemma. And the best fixation we are talking since morning is about the suture bridge. And getting this in an older scenario is something difficult to deal with. So I kept my fingers crossed, and keeping this fracture having 7-month-old, even that small fragment can be little osteoporotic. That even if I try to compress it with a spike washer or a screw, this might even fracture off, and it may warrant to go to an open procedure. So with this, we started with having an arthroscopic look into it. And before that, we reviewed the literature about fixation techniques, about avulsion fracture of posterior tibia. They were describing about the implants, they were describing about the techniques, but unfortunately, no one was describing about the chronicity and porosity or the fragmentation of the fragment. So what we did was an arthroscopic two-portal technique. Debrided the crater, was difficult to find. I kept my portals both posteromedially, high up and high low, and the compression of the fracture was achieved through the avulsion by going quite low using a PCL jig and getting my point right at the crater, getting it reduced temporarily by a K-wire, but was not complete reduction was there, but I could get a suture disc over it and could compress it from both the sides. And this was 6 weeks follow-up. This is at 3 months, no alignment issues. Yes, there is some loosening seen on the suture disc at the tibial side, but the fracture is uniting, the functions are improved, This young girl is walking, could maintain the balance. And if you see, this is stable enough in the post-op. And so in my conclusion, the two-portal technique is preferred. Debridement of crater is important. The usage of cautery was handy and quite effective. The open avulsion fixation is effective, but the hospital stay is prolonged, may require a larger posterior incision. Adjustable suture disc is effective in achieving the compression at the avulsion site. Thank you.
Any questions?
So that is why we kept the scope inside. We checked the reducibility. Had it not been a reducible one,
Yeah, you
had
would
it
have
not,
converted.
had it been too much of retracted, I would have converted it into an open procedure. I would have converted it into an open.
So just one question. Once you're doing scope, it's in supine position. You convert to open. So
Yeah, that
you
is the
flip-
problem. That is something which is an unexplored arena, but you have to keep plan B ready always.
Yeah. So my thought is most of the times, even if the thing is osteoporotic, it's more like a chip avulsion. You will get some bone over it. Once you freshen the crater, most of the times it is reducible.
Right.
So chronic cases, I go mini open, not a full open.
Chronic cases, sir. Arvind sir, what's your take? Arvind sir is there? No.
So basically, again, I'll say it's depend upon the size of the fragment. If it is a smaller size, very small, I always go for the reconstruction. If it is bigger size like this, I try to fix it most of the time. Instead of that suture disc, I use the Indo button. That is the thinner one, and take the bite through that. And I put two stitches. One is like one is like how you say this is
Like a noose around the PCL.
Yeah, most of the times PCL avulsions are neglected only. In our practice, they come late at a very
That
late
is that
stage.
prologue I was talking
that's what
of with the femoral nail system. That was the prologue.
So one thread is like sliding knot. So sliding knot give you the maximum compression over the fragment through that Indo button. That is as much as you pull the thread, this will compress your fragment. It's not the simple knot through which you will give the maximum compression. So it's the sliding knot that will give you the maximum compression over the fragment. So one is sliding. You compress as much as possible. As much as you will pull that thread, this will compress the fragment. And the chances of cut through will be less because there is Indo button over that fragment. And another knot is simple knot. You just applied another thread with that simple knot. So two thread passing through that Indo button. One is for maximum compression, then followed by the.
Though the end result was same, but I think my patient achieved, so it's one anecdotal case. My patient achieved a rehabilitation and independence a little earlier than I would have got it from an open procedure.
I think my take is that in a neglected scenario, an arthroscopic approach is always better because in a neglected case with PCL insufficiency, you are likely to have chondral injuries, you are likely to have meniscal injuries. So an arthroscopic approach gives you the advantage of dealing with these injuries. And at the same time, if it is not reducible, you can always move on for a reconstruction. But once you have gone for an open this thing, you will not be able to handle the intra-articular pathology. And if you want to go for an reconstruction, then again, it will be a problem. So in a fresh case, maybe a mini open is a good scenario, but in a old injury, I think arthroscopic is better for me.
Yeah, Ramakant, you published the level 1 study in the CASTA about the comparing the arthroscopic with open, where you said that the arthroscopic procedure in fresh case has more dreaded complication compared to the open procedure, isn't it? Isn't it true?
So
the arthroscopic has a more it's in the from the Ganga.
Are they talking of
Saying
neglected cases?
In initial injury, an open is better, but for a neglected injury, an arthroscopic approach.
I feel chances of missing the chondral injuries and other injuries are more in this case.
similar. Only thing is arthroscopy has a little bit longer learning curve and the potential of, the vascular complication is there. So in our paper also we have put that, there was a case of vascular injury and things like that. But, it is not for the beginners, like, those who have done like lot of PCL reconstruction, then arthroscopic, our patient becomes better option.
Thank you. Thank you. Thank you, Shivam boss. Thank you, Chairperson. We are moving
you.
to the next session, that is multi-ligaments with collaterals. And Dr. Jisan will be moderating this. Dr. Jisan and Ujjwal.
Good afternoon, everyone. Myself, Dr. Ujjwal Verma. I am here to moderate the session on multi-ligaments and collaterals. I would like to invite Chairperson, Dr. Sarjit Rashid sir, Dr. Rajiv Bhatt sir, Dr. J. Chaudhary sir, Dr. Bipin Gopi sir, and Dr. Pawan Kumar sir. Please come on the dais. Our first case will be delivered by Dr. Ramakant sir on MCL injury repair, reconstruction, the evidence-based approach.
Good morning, good afternoon. After a heavy lunch, hopefully I don't bore. I just show some cases and thanks Dr. Arvind for giving me opportunity to share our experience. So my talk will be on MCL repair and the reconstruction. So ACL and MCL is the most common kind of multiligamentous, around 38%, and 90% of grade 3 MCL has an associated injury. And this happens because of the knee hawk position, that is valgus flexion and the external rotation that causes both ACL along with PCL or with the MCL. And MCL has a good anatomy. It is a flat, long structure, unlike LCL, which is more cord-like structure. And it has a two parts, superficial and deep, and it has an excellent healing potential. So acute management of ACL for MCL would be either conservative or operative management. And the systemic review, which has non-operative management of 21 studies, which are published in literature. And there are only 16 studies for the repair for the MCL. However, these are all level 2, level 3, and level 4 studies. And there are newer techniques like internal bracing. However, there are only 2 studies for level 1 randomized controlled trial. So the management is still controversial. So that is where we have done our study in our hospital, 3-arm randomized controlled trial for repair, reconstruction versus conservative management of equal number of patients of around 32 patients. And we have found that it has a similar results, but the repair fared better, whereas the internal brace had a little bit of stiffness. So from the EFORTS guidelines, all the repairs are done for less than 3 weeks, and for chronic tests more than 3 weeks. So there are only 2 randomized controlled trials in the literature, and from RCT from our institute forms the third study for this thing, and it is based on the level of MCL injury. That is femoral. There could be a femoral side tear, mid substance tear, or a tibial side tear. So let me share a case example, a unique case where the patient had an injury while lifting heavy weights, and he had a pain and instability for 4 days. It was acute injury. The range of movement was 120. Valgus stress was positive at grade 0 and 3. the X-rays were normal. But this is a unique case of MCL tear where there was both femoral side tear and the tibial side tear, and then the part of deep MCL was also torn. There was also a lateral meniscus complex tear was there. There was a radial tear of the lateral meniscus was there, and standard diagnostic arthroscopy revealed ACL tear, and then MCL tear. We can see that the femoral side tear, it just pops into the joint. And there was a lateral meniscus complex tear was there, so for which hashtag repair was done for a radial and the peripheral tear of the meniscus in the same patient. And when we saw the medial side opening was more than 15 to 16 opening was there. So for a combined injury, first we do standard ACL reconstruction. Once we do the intra-articular work, that is meniscal repair in ACL, and then we opened up with the medial side. It showed there was the femoral side tear was there, and then the tibial side tear was there. So here we can see in this video, that is the femoral side tear, and that was the portion of deep MCL, and this was a superficial MCL was also torn. The mid substance was intact in this particular case. So we need a suture anchor both at the femoral side and the tibial side. So this was acute injury, 4 days old injury, and the femoral side tear and the tibial side tear along with the deep MCL was sutured. And this is the video showing the MCL repair for both femoral side and the tibial side tear. It's a rare scenario. And then the robust tight repair was completed with the medial retinacular imbrication as well, and bit of sartorius fascia also. Pestplasty was done to give a medial and posteromedial support for the repair. And that is the completion of the tear, completion of the repair after the ACL reconstruction. So this is the amount of opening before ACL reconstruction and after ACL reconstruction to provide a good medial side stability. So the second case, the road traffic accident with pain and deformity. And in this case, there was a lot of tenderness and then tibial tuberosity as well. And there was a valgus stress was positive. Here, the X-ray showed that a kind bony avulsion of the tibial tuberosity along with ACL and MCL. So this was ACL tear, and the patient had the femoral side MCL tear and the bony avulsion of the patella tendon as well. So there was a ACL tear. So first we can see the medial opening more than 15, and first to do the intra-articular work, ACL reconstruction was done. And this is a video after ACL reconstruction, it was opened. We can identify the femoral side tear and tibial tuberosity bony avulsion was there. So for femoral side tear, a suture anchor was inserted, and then the MCL was repaired, and then the patella tendon, which was there was a bony avulsion. So for which what I've done is I put a suture anchor into the bed and then tied it around it, and then the same threads were taken it, and then the proximal tibia, the tunnel was drilled, and then the kind of double fixation was done for the patella tendon. So here we can see the suture anchor, and then the same threads were taken into transverse tunnel just below the tibial tuberosity and then tightened it. So this is the fixation. And this was final follow-up of 6 months when he came. He had a good extension of the knee. The third case, quickly, this patient had a pain instability, and following a road traffic accident, there was a grade 3 opening was there, and this was a mid-substance tear was there. So this is another scenario where mid-substance tear was there, and it was a shredded tear, and then there was a ACL tear as well. So the ACL tear, and you can see the amount of opening due to mid-substance, it's again more than 15 mm of opening is there. The standard ACL reconstruction was done, and here we can see the shredded tendons of the mid-substance. There was a complete tear at the mid-substance was there. And the ligament was too much shredded to do any side-to-side repair, and then healing in this mid substance are a little poor. So in this case, we knew that we planned for a retaining of the semi-T. Distal attachment was retained, and then with open tendon stripper, the semi-T was harvested and tied it. The stitches was done, and then in the femoral it was inserted. So this would act like a anterior band of the front portion would act like anterior band, and the posterior band will act like a POL ligament. So this is the post-femoral fixation of the superficial MCL, and then the inferior band would act like a POL. So the POL the tunnel was made in the posterior aspect of the tibia, and then with the knee extension, the POL was fixed. So this is the post-reconstruction of MCL and POL tendon, and then the retinaculum and the remnant mid-substance tear were imbricated into the repair. So the take-home message is, in acute cases, repair would do. For femoral side and tibial side, suture anchor alone would suffice. For mid-substance tear, we can do a repair if the quality of ligament is good, or else we need to augment it with the reconstruction. And definitely for chronic tear, semi-T along with POL reconstruction would yield good results. And again, I take this opportunity to invite you all for this Ganga Arthroscopy course, which is about to happen in next 2 weeks. Thank you. Thank you. Thank you for the opportunity.
Thank you, sir. Our next case 2 is posterolateral corner injury of knee, my approach by Dr. Tapi Sukla, sir.
Good afternoon, everyone. I'm Dr. Tapesh. I'm going to be speaking on my approach to the posterolateral corner, which is the dark side of the knee. So now, why is it called the dark side? We know the convex lateral femoral condyle is going to articulate with a convex lateral tibial plateau. That makes this side an inherently unstable side, and these ligaments, they don't heal on its own, unlike the medial counterparts, which have remarkable healing potential. So starting off with the anatomy, there are 3 components in the posterolateral corner. First is your fibular collateral ligament, starting from the lateral epicondyle, going down towards the head of fibula. This is the primary varus restraint to your knee joint. Second up is your popliteus tendon. Mind you, the origin of the popliteus is distal and anterior to your lateral epicondyle. Popliteus is your primary restraint to the external rotation of the knee joint. Third is a small strip of band from the popliteus tendon, which is called the popliteofibular ligament. Again, popliteofibular is a secondary restraint to your external rotation of the knee joint. So let's start with the case presentation. We've got a 35 male with an RTA injury to the knee. It was a 10-day-old injury. Primary management was done elsewhere. On examination, on presentation, his Latchman was positive. Decent range of motion, 0 to 100. Still, the varus valgus stress test was too painful to perform. There was a foot drop when he presented in the OPD. He came with the MRI done. MRI showed a complete ACL femoral avulsion tear. But also the report mentions grade 2 LCL tear and grade 2 popliteus tear. So now when such patient comes, it becomes a dilemma, because when you look at these MRI images, you can clearly see the fibular collateral ligament is not actually torn. It is seen as a wavy structure. The popliteus tendon also shows, it appears that it has been torn from the femoral side. However, the report mentioned as grade 2 and grade 2 injury. Now, these patients become challenging cases because our decision making is now not sure whether we should go ahead with the PLC reconstruction or not. So the question that needs to be answered is whether this PLC needs surgery. If yes, then what type of surgery? Either we repair it or we reconstruct it. Should we do it acutely or in a staged manner? If we are doing it, what technique should be used? And now the patient also has a foot drop, so what to do about CPN? Now let's take this one by one. Now, how to decide whether this PLC needs surgery? In such cases, stress X-rays, they are of enormous value. You give varus stress to both the knee joints, measure the lateral opening, and then see your side-to-side difference. Now, how to interpret this? If the difference if the side-to-side difference is between 2.7 to 4 mm, it tells us that it is an isolated complete FCL tear. If the difference is more than 4 mm, that means it's a combined FCL and popliteal tendon injury or a combined PLC injury. Examination under anesthesia also plays a role. So once you're taking in the patient for an ACL surgery, check for the varus stress and also check for your dial test to see for the rotation. The dial test should be checked in 0, 30 and 90 degrees of flexion. Now, once we have done the stress x-rays and we have done our examination under anesthesia, we know that we are going to go ahead with some sort of surgery for this PLC. Now, what do we do? Should we repair it or reconstruct it? So multiple studies have shown that repair of PLC structures have got a very high failure rate, 40% failure rate for repair and 6% failure rate for reconstruction. So always reconstruction is much, much better than repair. However, there are certain scenarios in posterolateral corner where we can actually attempt repair. What are those? One is your anterolateral capsular tear. Pure capsular tear can be repaired. It doesn't need reconstruction. Your avulsions of the fibular collateral ligament, either from the fibular side or from the femoral side, if it is purely avulsed, if the tissue quality is good, you can actually take your whip stitch and repair it with the help of pull-through sutures. Third is your arcuate fractures with the fractures of the head of the fibula. These can be easily repaired with good results. Now, early or delayed or stage surgery. Now, there are again multiple systematic reviews and RCTs showing us that the better outcomes, better lysome scores with early surgery, which is should be done at less than 3 weeks. Mind you, make sure your skin condition is good because most of these patients may have blisters because they are a very high velocity injury. If the skin condition permits, try to go in as early as possible. Now, CPN injury. So in order to go ahead with CPN injury, we need to know what is the prognosis of the injury we are dealing with. So first of all, always make sure you divide your injury into two types. Either it is a complete injury and incomplete injury. For a complete injury, you need to make sure that there is 0/5 power in your tibialis anterior and your EHL and complete sensory loss in the distribution of CPN. Incomplete injury has got a very good recovery rate of about 83%. However, a complete injury, the recovery rate varies from 0 to 38%. If it is a stretch injury, you might get at times 50% recovery. But for a complete cut injury, spontaneous recovery, the chances are 0%. Now, if it's an acute CPN palsy, we have decided to go in, as we have known that early surgery is better. You explore and do neuralysis of the nerve. After exploration and neuralysis, if you find that the nerve is in continuity, you wait and watch. Do your progressive examination and wait for recovery. If the nerve does not recover in 6 to 9 months, you go ahead with tendon transfer. If the time of surgery nerve is not in continuity, then you have to measure the defect. If the defect is less than 6 centimeter or more than 6 centimeter. If the defect is less than 6 centimeter, you try to graft it. If it is more than 6 centimeter, then you do a nerve graft plus transfer. Now, what technique you should use? So techniques, they are broadly divided into a tibia-based and a fibula-based technique. Tibia-based is Laparat technique, anatomic, reconstructs all three structures. Fibula-based technique, it's Larson's, modified Larson's. You can safely go ahead when there is low rotational laxity. It is easier to do. Last two animation videos for the technique. We are doing a Laparat type of technique here. Make a generous incision, make a big posterior flap. You try to identify your common peroneal nerve just behind the biceps femoris tendon. Now you go ahead with making your tibial tunnel, fibular tunnel. For making the fibular tunnel, get hold of the fibular collateral ligament, tug on it so that you could know what is the insertion point. Make a tunnel from anterolateral to posteromedial and then pass a suture here. This completes your fibular tunnel. Now you have to make one more tunnel in the tibia, which is going to be medial and superior to your exit point of the fibular tunnel. Use a jig, drill a hole from anterior to posterior. This is going to be the place where your popliteal tendon graft is going to go. Now make two tunnels in your femur. One will be at the lateral epicondyle, which is going to be your insertion point for your fibular collateral ligament. Another one will be just distal and anterior to your previous tunnel and over ream it. After you are done with the reaming, you pass sutures in every tunnel, and now it is the time to pass in the grafts. The first graft that you are going to pass is in the fibular tunnel. You pass a autologous autograft of semi-T and fix it with a screw. Make sure this graft goes from anterior to posterior in the fibular graft. Once it is gone, give a generous valgus stress and fix the graft with an interference screw in 20 degrees of flexion. Another time, you fix the graft in the popliteus tunnel. Both these grafts will now go from posterior to anterior and about 60 degree of knee flexion, fix it in the tibia. Next technique is going to be your modified Larsen or RCRO technique. You have drilled your tunnels, fix it in the femur, pass the graft, fix it with a screw. The graft goes from anterolateral to posteromedial. Now you give a valgus stress, make sure the knee is bent at 20 degrees of flexion and fix this with a screw. The same graft goes beneath this FCL, goes into the popliteal tendon, popliteal tunnel, and then at about 60 degrees of flexion, you fix it. This is a standard RCRO's technique, which is very good, provided the rotational laxity is less. So we ended up doing a complete ACL tear. So we ended up doing an ACL reconstruction with a modified Larsen's technique. The patient is doing fine. The exploration was done. Nerve was found in continuity. Nothing was done. At 6 months, the CPN recovered. So the take-home messages would be, do your stress egress and examination under anesthesia. It helps in decision-making. Early surgery is better than delayed. Always try to go for reconstruction, which is better than repair. CPN injury needs appropriate management, and RCRO technique is safe in low rotational laxity. Thank you.
Thank you. That was an excellent presentation. Here.
Yeah.
Hi. So I'd like to ask one question. If you're doing an ACL with a PLC reconstruction, so what will be your sequence of doing, whether you'll be doing the PLC or the ACL first?
So a tourniquet time is actually quite important here. So what I do is I don't inflate the tourniquet first, make sure I'm done with my dissections of the CPN. I make all the tunnels laterally, pass in the sutures. Then I inflate my tourniquet, go ahead and do my intra-articular work, pass the graft, and then I come back and pass the graft for PLC and fix it.
So first you'll do the PLC tunnel, then ACL tunnel.
Yeah.
First you will be tightening the ACL and then the PLC.
Correct.
Okay. So to avoid tunnel correlation of your femoral ACL tunnel and the PLC tunnel femoral, so any tips to avoid?
It is important that if we mark while drilling the bead pin, if we just keep it proximal and anteriorly, more often than not, you'll be fine. You won't hit the femoral tunnel of the ACL. Just keep your bead pin proximal and anterior.
Okay, thank you.
Excuse me, I would like to ask, do you always go for a stress X-ray?
So
in all the cases?
importance of stress X-rays comes when it's an ambiguous case, just like I showed, that the fibula FCL was not actually torn. It was wavy in the MRIs. The report is not also helping us. So we need to make sure that whether to go in for a reconstruction or not. So stress X-rays are very important, not always. If it is a completely torn, then of course we are going to go ahead with the surgery. But if it is an ambiguous case, then it helps in decision-making.
A little curious from my side, with respect to this case, how you deal with the CPN injury?
So like I told you, I explored the nerve, did a neurolysis from top to bottom thoroughly, and the nerve was found in continuity. And then I just waited. I didn't do anything extra. Progressive examination showed improvement, and at 6 months it spontaneously recovered. Okay.
Thank you.
Thank you.
Any more questions? Very thank.
Thank you, sir. I would like to invite Dr. Siddharth Agarwal for third case, that is KD3M knee injury.
Dr. Siddharth is on the way after completion of life surgery is coming. So thank you, Chairperson. We are moving to another session, that is the panel discussion on multi-ligament injury.
Thank you. Thank you, everyone.
From the Dr. Pradeep Meena, kindly come on this.
है ना उसको नहीं लगा बस आया कि नहीं So I think we already had nice lectures on various types of injuries, multi-ligament injuries. So I think we'll just have sort of recapitulation, maybe a little odd type of cases maybe. है क्या? पूरा तो नहीं आ रहा है बस. Okay. Okay. So I think can we take this? Are you comfortable taking this, or we should only stick to the multi-ligament injury? Also, would you call it a ligament knee dislocation or MLKI? Does this X-ray qualifies that? Yeah. Purely. So we don't. Okay. Anyone who is comfortable with Ramakant? Are you comfortable? Yeah. So I will keep.
Not that we are uncomfortable.
No, yeah, maybe your practice is purely on the ligamentous part, so you will skip
Nothing,
this. Huh?
nothing like that.
Okay.
This is a pure osteosynthesis case.
Yeah. 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 So the issue is, would you like to, do the ligament reconstruction at this stage as well, or after fixation, you will re-examine this case, and depending upon your finding perioperative, you will choose the ligament reconstruction. I think your mic is not working.
So there could be a CPN palsy as well. Does this patient has a CPN
no,
palsy?
CPN palsy is not there.
Okay. So first is bone needs the priority in this combined injuries. Bone needs a priority, and it all depends on how much is the sag. So what I would do is first I would fix the bone and then see how much is the sag. If too much of sag is not there or this thing, then second stage I would go and do the ligament reconstruction.
Yeah, on the medial side, I think if I give you a perioperative finding after fixing the bone, so medial side was little lax. So would you like to do at this stage, or you want to conserve that medial side currently, repair the MCL or not? That's my main question.
Yeah, see, we are going to do a open this thing. So first, once bone fixation is done, so in these cases, I would take like kind of a midline incision, go on either side, and then acutely, if it is possible, we can definitely put some suture anchor and then fix it.
Yeah.
So the extra-articular, when bone is involved in the multiligamentous, the extra-articular portion forms the first priority for us.
Okay. So Amrish, any difference of opinion or same?
Yeah, same. After fixing the bony part, if medial side is lax and it's already open, so better to do with medial side at the same setting.
Okay. Yeah. I think the only problem I had was actually the CT scan was not there in same hospital, so we had to refer that patient. So this patient admitted at the evening. So I thought I'll go ahead with without that CT scan. I think CT scan. This was the medial side incision where the after fixing. This was the lateral side after fixation. This is the Siam picture after fixation, APL lateral view, and the medial side was opening a little more. So I did open on the medial side. And it was tibial side avulsion mainly, so we repaired it with the anchor. I think this was, this patient, we did not do CT because the CT scan was not there inside the CT and the dislocation was also there. So I thought the priority should be to reduce the dislocation, and if the patient is undergone an anesthesia, and we fixed at that time only without the CT scan or any other investigations. And this is the after post-operative, and we didn't do any CT or MRI because there was no additional ligamentous injury like the PCL or LCL all were intact. And this is the 4 months down the line. This is how the patient is. I think this patient had a full range of motion after that. So would you have done anything different? Any opinion?
It looks okay, but small sag is there, but that is okay.
This part, yeah, I think, but maybe grade 1 sag will be there, but the patient is usually asymptomatic at this stage. So would you like to intervene at this stage, even if grade 1 sag is there, suppose? But the form endpoint is there, and the grade 1 sag you may or may not be. I think this, as you can see, the fracture was there. So the entire PCL facet was actually with the part of the condyle which was not dislocated.
Do you have any stress X-ray at this stage?
Sorry?
Stress X-ray, kneeling stress X-ray at this stage to look for the.
I don't have that stress X-ray, but I am giving you my clinical finding, what I examined this patient 4 months down the line. Just maybe one grade 1 laxity you can say, but I think otherwise the patient is rock solid on the, compared to both collaterals as well as PCL.
What was done for the MCL in this case?
MCL was repair on the tibial side with the suture anchor.
All suture anchor.
Yeah. So I think this was another case. I think this is a dislocation posterior subluxation, and this is a large chunk is there. So how do you like to investigate this case further?
So definitely you have to go for a CT evaluation and MRI.
Both.
Both.
Sajid, you want to get the both? And
I
do you
think it will be
where from
difficult
this-
to get an MRI, and this looks like an sorry.
Okay, so how will you reduce this? So what do you think? What? Sorry. Okay. So
I think this is a classical anteromedial tibia, which Ramakant has spoken about very often. And this anteromedial fragment is very important to be fixed. Understanding this fragment better can be done with a CT scan. With a reduction, you cannot achieve stability because this is a highly unstable injury.
Exactly. So I think
And
it was reducible also.
Even with a thin flake, we have seen these kind of knees going into a fixed posterior subluxation. So it is essential and crucial to fix this. How to fix this should be the ideology.
Yeah.
And the ligament injuries, if can be addressed simultaneously, we can understand the ligament injury better on an MR, but it's difficult to do an MRI.
Yeah.
So
Amrish, Ramakant, I think is same. Yeah, but.
This is a posterior lateral dislocation. And any posterior lateral dislocation is very difficult to reduce. Even if you reduce, this will not stay into reduced position. This will again subluxate or dislocate. Many a time, if you want to keep in reduced position, you have to keep this
external
dislocation over the fixator. So this dislocation has to be kept in mind. And this type of dislocation is very difficult to keep in reduced position.
Yeah. Amrish,
we have seen different sizes of that fragment. I think Ramakant had presented it.
No, actually, the problem is, I think this is the most commonly, this is the anteromedial fragments are there, but this is a rare sort of variety where it was not actually the anteromedial fragment actually. So you will be, I think it will be better visualized on your CT scan. I'll show you. I think if you can see, this is the in subluxated position MRI was done. And if you can make out, this is a PCL.
That's a flipped posterior cruciate.
Yeah, exactly. Yeah, exactly. So that's not very common, which you tend to find. It's a large fragment where you had that. I mean, you can see from the CT scan.
Again, the flake is there.
Flake is there anteriorly.
Anteromedially also there is a separate.
No, I think this was intact. I mean, I have not put the your entire. I think I have a detailed subtracted version. See, this part anteromedial. This was a pristine. This entire fragment was from there.
So, Sajid, most of the time, posterior side you have vestibular tip avulsion, but
Yeah, this is there. I mean, this is biceps avulsion, biceps femoris avulsion, not the collateral, because the collateral attaches the anterolateral part, not purely. So, how would you like to manage this case?
This definitely needs a open reduction because the closed reduction will keep subluxating, and also we have to put back that fragment into the crater.
Exactly.
So unless we put back the fragment, the joint will never become a congruent. So this is a day one open reduction. We just have to do like a TKR approach, just open, see the fragment and just give the traction and put a Homans and then push that fragment. It will go nicely, get seated there.
Yeah. So any different, any Amrish?
No, if you reduce by anterior approach, then fixation, what about fixation?
Fixation would be, no,
From
but
anterior-
once you reduced it, it will get nicely seated it, and then you can just immobilize it, and once it is seated, snugly seated well, then you don't need a maybe
Immobilization also not required.
no, immobilization is needed.
I mean, the fixation. What is your choice of fixation here?
See, if I'm going anterior approach, I would kind of push that fragment in and then do my tunnels from the anterior, get it across to the fragment, completely subluxating the tibia. and then maybe it kind of put a button there and then kind of suture pull out I would do, because I've already approached anterior. Otherwise, what I have to do, this is the day one anterior opening it. So if you open anteriorly, then put back the fragment, then you have to turn the patient and then put a screw fixation.
But isn't this fragment too big for a suspensory? Yes.
Yeah, but then it will nicely get seated in, the crater. So that would give a stable reduction.
Reduced and the knee is also reduced, it will give some sort of inherent stability also.
stability,
So
because-
in addition to that, if you can put some pull-out suture, that might work. I think. What is your take?
Yeah,
You have
retrograde also you can
special
catch the
suggestion for this?
fragment.
Yeah.
Maybe retrograde screw also you can try
Retrograde
to.
retrograde screw will be, I mean, very flimsy purchase, I think.
Quite difficult from anterior, I think. I will approach it from workshop or posterior.
So how will you reduce then?
Yes, yes. Yes,
Yeah.
anterior.
What did you do?
Yeah, also definitely.
Fragment is anterior. Have to approach anteriorly only.
Yeah.
Maybe you can joystick it anteriorly and then open posteriorly, do a formal screw fix.
Yeah, that always you can do. I think what Ramakant said, I did that. No, because the PCL and entire fragment was there. When you're pulling it, the fragment and PCL goes anteriorly, and when you're just leaving it, it goes posteriorly again. Yeah, so it's a sort of TKR anteromedial arthrotomy complete. I think that what I thought was if a little bit of ACL might remain attached, but there was a separate flex of the ACL fragment was there. That helped me in subluxating the tibia anteriorly, and this entire fragment along with the lateral meniscus and medial meniscus root was there. So I flipped it and then fixed it with the screw, and then used the ACL flex of the bones from the tibia to pull it out and repair the ACL. So that's what I did. I think this was how I fixed it. So put it vertical screws from up to the up or down. Happy? Yeah, exactly. The ACL tier was helping me in subluxing the tibia a little anterior.
Do you think that the screw heads are prominent more?
Sorry? No, screw was not prominent. I mean, it was inside the ligaments only, PCL and ACL. Yeah, exactly. The cartilage वगैरह है ना बस. Yeah. So only thing which I regret is probably removal of this implant is really difficult. Once the entire knee gets stabilized, then the subluxation will be a little problem. So I think after that this will be a removal is a challenge. So I think that was
Anything you have done for that biceps avulsion?
so no, I did not do anything for the triceps avulsion. That was because the PLC was intact. So that's why I didn't want to venture to do anything on that. So this is 6 months down the line. I think you can see that the triceps is still floating down there, but the instability was not there. And this is the patient's range of motion. I think this is patient is doing well. I mean, 6 months, and now I think it's more than 1 year. So patient is doing well. This is, I think, more of a the case which we were discussing. So, what is your take? I mean, how would you like to interpret this X-ray? Yeah. So let other also give some opinion, boss.
Yes, CT scan and MRI will help.
Yeah. So which one is you want to do? Both CT and MRI or CT only?
Now, going by the X-ray only, there is fibula head fracture,
Yeah.
definitely, and there is something on the medial side also.
Yeah.
So maybe posterior medial, I don't know. So CT and MRI.
Yeah, but overall it looks quite, I mean, simple sort of X-ray, isn't it? But I think these sort of patients are really a big problem. You can see the anteromedial fragment is there, and the fibular avulsion is. How do you interpret this? This is I mean, the PLC avulsion completely, or you think this is only just a? Sorry.
This is called the type of diagonal injury only, na? Anteromedial fragment along with the PLC.
I think what else you think could be also be there? This combination, the anteromedial and the I mean the PLC avulsion.
Meniscus. Part of the
yeah. PCL is always there. I mean, these are hyperextension sort of injury. PCL will always be there. I think if you miss the PCL here, I think you miss the bus, the posterior subluxation, fixed posterior, and then probably the patients might land up in disaster. So this is the another problem which I think X-ray, there was the indentation was there on the anteromedial part, this large indentation on anteromedial fragment. So I think this was the PCL peel-off lesion in the MRI segment. So we repaired the PCL and the anteromedial fragment. This is the PCL which was peeled off from the femoral attachment, And then this is how it looks like. And the PLC was also, I mean, with the fixed with the screw as well as the suture augmentation were also done. And the PCL was repaired with the pull-out tunnels. I think this is more of a common scenario that we tend to land up in some sort of stiffness. So this is 2 months down the line. This is the 80-degree range of motion, maybe 10 degree of fixed flexion deformity also. So how would you like to tackle this now?
All this bone fixation with the ligament, even I have faced a lot of stiffness. So, so what I do is at the 6 weeks, I generally tell them that we'll do a gentle manipulation. Once we do that little bit of manipulation, just gentle at 6 weeks, whether they have movement or not, invariably they have 30 to 40 only at 6 weeks. But then exactly at 6 weeks, we do a gentle manipulation and they all gain movement of 120 by 8 weeks.
Yeah. So any difference of opinion? Everybody wants to do a manipulation at this stage.
Routinely, we will do a small manipulation. Ask the patient to lie prone in the OPD. Just we'll have a push and do a manipulation.
I mean, under anesthesia or without anesthesia?
If the patient can tolerate pain, we will generally do it without anesthesia, or else we'll take to OT under a short J, we'll manipulate.
So I have little bit difference.
Yeah.
I wait for 2 months.
No, ये 8 weeks ही है बस.
And this, most of the time I do arthroscopy. Because many a time, even if you do gentle manipulation, it will remain till 90 degrees in such type of facility.
Okay.
And arthroscopic ortholysis is one of the best tools in all these multi-ligament. If you see the multi-ligament in single stage, almost 30 to 40% will have some kind of restriction.
Yeah.
If you want to get rid of that, that's arthroscopic ortholysis is one of the best ways.
Yeah,
We will just manipulate and accelerate the physio and rehab.
Yeah.
That is what we do, but
Yeah.
not much stiffness routinely. In arthroscopic arthrolysis, by 6 weeks, what all things you will do? 2 months, what all things you will do, sir? You will additions.
That prevents getting this range of movement in the multi-ligament. So you just release that and this will like.
So what we will do after multi-ligament surgery, you will immobilize the patient?
No, immediate
mobilization.
Yeah. So the CPM machine will work for this patient for initial 3 weeks, then followed by the passive range of motion, then followed by active one. At the end of 6 weeks, most of the patients are doing active one. Wait for 2 to 3 weeks further. At the end of 2.5 months, 2.5 months is the maximum limit. If this kind of movement, that is the 30-degree range of motion, if any patient with extension lag you cannot correct most of the time.
Yeah.
Yeah.
So this there was extension lag.
Yeah.
So any patient with extension lag always arthroscopy work.
Yeah.
That the result is very low for being.
Yeah. So what we did actually, we did an manipulation under anesthesia only. So the extension and flexion both were achieved. So yeah. Yeah, I mean, I can understand. I mean, the arthroscopic arthrolysis will give you a better correction on the. Yeah. Yeah. Cut the capsule. Yeah. Yeah. No. I mean, the tibial attachment. Yeah. Yeah, but I think this was corrected. I think this you can see the at the
Nicely corrected with manipulations.
Yeah. Yeah. No. I think it's not acceptable. I think I mean, if the manipulation fails, then I will do definitely arthroscopic arthrolysis. There is no doubt about it. You can't accept that young patients to land up with 10 to 20 degree of fixed flexion deformity. So I think this is after the rehabilitation, after that manipulation, and now that you can see the patient entire range of motion is regained. I think this is a patient 1 year down the line. I think the posterolateral corner has also healed, and this part is also healed. And I think the fixed flexion, yeah, sag is still there. Yes, grade 1, grade 2. I told him that probably you might require the PCL reconstruction. But he has accepted that. So he said that I will not go any further surgery. I'm happy with it. I'm painless. My knee is stable. So you can't argue with that, boss, if the patient denies surgery.
So I would add a point here. The same thing I would have done, but then when I opened it, I have also done few cases, around 5 to 6 cases of open PCL reconstruction.
Yeah, yeah.
So when you're plating it, all your screws will be in the anterior portion of the tibia. So definitely the screws will not come into the
Right,
tunnel
that's
portion. So I would have added
Open
the PCL reconstruction.
yeah, I
open
mean, that's what, so we believe had a hypothesis that if the femoral avulsion is there, PCL tear tends to heal well. That's what we know. If the PCL tear, intersubstance tear can heal well, why not the PCL femoral avulsion? So we published this also after repair. I mean, 13 cases were there. So I think the PCL peel-off lesion heals well with the open repair as well. So that's what the message I want to give you. And if the patients fail, I mean, maybe 3 or 4 cases have failed, so we offered them the PCL reconstruction only. And out of the 3, I mean, 2 agreed for the PCL reconstruction. But I think by and large, majority we can, I mean, avoid the PCL reconstruction at the primary setting. That's what the message I want to give.
If you want, you can add an internal brace to the peel off.
Yeah, maybe. Yeah, that's a
That will
good
give,
idea. I think internal brace can
give
also be added. So this is, I mean, another similar sort of cases. So any opinion? How would you like to, I mean, they interpret this X-ray? Very small flakes of bone. And it's a knee dislocation, of course. I think the fibular side also there was some injury, but I think the biggest problem is this innocuous looking X-ray. You will end up with, I mean, the vessel injury. So how would you like to proceed with this, Ramakan?
Yeah, so first saving the limb is more important.
Yeah.
So we have to reduce it and then put a X-fix and then hand over the patient to the vascular repair.
Yeah, I mean, yeah, the problem with this patient came quite late, I think, maybe 7 days down the line. I mean, but the limb was viable. I mean, it was, I mean, viable. How do you tackle that? I mean, the CTVS says it's an reconstruction, vascular reconstruction is no more possible.
Yeah, so it is like already the collaterals are started opening up.
Exactly.
Only thing is this joint has to be reduced. So we have to do a open reduction, maintain the reduction, and then post reduction, we have to do one more CT scan just for sake of documentation. And if limb has already survived for 7 days, so it is going to survive. So we have to open reduce and then wait for 3 to 4 weeks, till full opening up of the vascular channels.
Yeah, I think that's the biggest dilemma. I mean, the limb is surviving for 7 days and you are planning for open reduction. The problem with
possibility is that
yeah,
we
the
may
collateral,
injure
you
it.
might injure the collateral. So, I mean, the post surgery patient might have some sort of problem. I mean, that's the biggest problem. So, I think we waited for another 2 weeks. So, we waited for 3 to 4 weeks for the collateral to well develop. And then we went ahead and did this PCL, open PCL repair and the collateral repairs. I think once the repair is done, this is, I think you can do it on an external fixator, but I prefer to do it, I mean, the K-wire immobilization. This works good for me. And this is the patient, I think 2 months down the line, and this is 6 months down the line, the range of motion has regained. And that's the patient. I think this is, I mean, maybe a little bit of stiffness you might expect, but this is patient is doing well. So if he is happy, you can't complain. This is another case, completely dislocated. So, and this is interesting. So,
why vascular repair could have not be done? If the thrombus is there, they can always, excise that and then do
the consultant, the CTV said that the window has gone. They said that they won't do it. I don't know. But I mean, I didn't ask them what exactly is the reason why the vascular reconstruction is not possible. I didn't ask him. Yeah, I mean, can you do it after 7 days also? I mean, 3 to 4 days after the patient. This is the, I mean, the golden period is 6 to 12 hours.
No, the vessel injury means it is completely thrombosed.
Yeah.
So you have to excise the
thrombotic part.
excise the part, and then they have to do the introp. In cath lab they do that to see the distal circulation, how good it is.
Okay.
In the CT, whatever you have showed,
that
if the collaterals are well developed, then we'll see the branches all over.
Okay.
So this is a kind of dicey situation that we don't know whether there is a one segment block or multiple segment blocks in the.
Okay. So that I didn't have idea.
That
I was
patient
just
doesn't have
believing them
any-
blindly.
It doesn't have any compartment syndrome too.
Sorry?
Any compartments?
The compartment was not there. I mean, you can always do a prophylactic compartment release at that time, but the 5 days down the line, I think doesn't make sense to do the compartment release as well if the symptoms are not there. So I think this patient after reduction, you can say that the patellar tendon avulsion was also there. Collaterals were also damaged. I think we are running short of time. So I think this is what we can call it a KD5. So we did the CT scan as well. So we did, this is what we did, repair the patellar tendon with angle. This was part of it was avulsed, part of what it was torn. So repaired as well as fixation was also done. Collaterals were also fixed. And this is the 6 weeks down the line. The problem is this patient started developing this sort of sort of HO on the medial collateral ligament. So I think might have stabilized that patient also. But do you have any solution? This patient landed up in 90-degree flexion. This is the range of motion the patient had, I think. But the knee was quite stable at this time. So can we do anything to this, Ramakant? Any Sajid?
Yes. These are one of the worst disasters that can happen.
Yeah.
Especially the MCL heterotrophic ossification. There's very minimal intra-articular procedure that you can. So adding to that point of arthroscopic arthrolysis, even the stiffness is extra-articular. And if you have a healing MCL or a HO, there is no much role for arthroscopy, even at early post-multi-leg repair or conserved cases. So here, an arthroscopic excision cannot really, or arthrolysis or MUGA cannot help. And these are cases which we have followed up for even 15 years with persisting stiffness. I don't know if anyone has experience of excising it.
That's what I also thinking. I don't have any experience. This patient was a 90-degree range of motion was there. He was doing his daily activity well, so he didn't want any further investigation. I mean, even I didn't offer any operations as well. So I think 90-degree range of motion was good enough for him.
Good result.
So you can see the PCL was very stable, and the collaterals were also quite stable. So, see, the MCL was quite stable. So I think thank my panelists for their nice inputs. I think would like to invite you for the ISCON 2026 as well, which is in 8 to 10th October at Calcutta. So all of you please register for the ISCON as well. Thank you.
Thank you, Sunit boss, and thank you all the chairperson. So we are moving on to the next session, and that is osteotomy and the cartilage, and the moderator is Dr. Tasneem and Dr. Vivek Singh. And before that, one case left for presentation by Dr. Siddharth. So he was on the way after surgery, so he'll completing his case.
Good afternoon. Good afternoon, all of you. I request, please, our chairpersons, Dr. Pawan Kumar sir, Dr. Wasim Ahmed sir, Dr. Indrajit Kumar sir, Dr. Prabhat Kumar sir, and Dr. Sunit Hajra sir. I request Dr. Bhushan sir to give a lecture on STO planning and technique.
That's fine.
So, good afternoon, everybody. So after this intense discussion about the knee dislocations, I'll just give a small discussion of a case, KD3M injury. So it's a group of 2-3 cases that I have got together. It's generally high energy trauma, and there is a high risk of neurovascular injuries along with KD3, KD4. We all know the Schenk's classification of knee dislocation. So KD3M in our case is ACL plus PCL plus MCL disruption. That is the medial structures along with the anterior and the posterior cruciate ligaments. So we have 3 cases which I have grouped together. They have all are males. They have the ages 32, 51 and 63 years. Mechanism of injury was RTA in all the cases, and all of them presented acute to me. So clinical examination, if you see, very commonly you have the dimple sign. If you see the knee from the side and the front, on the medial aspect, you see a big depression, which you call the dimple sign. There's a swelling, the test of instability are generally positive, and you can have the neurovascular examination. वीडियोस नहीं चला, वीडियो नहीं चला, चलाना बेटा नीचे और. So if you see, कोई बात रहने दो. So this is basically a dimple sign which I wanted to point out. You see a big dimple on the medial aspect, and believe me, this is irreducible. When you see this, you should know it. The next is the radiographs. So one of them had a near total dislocation of the knee. The other one had a subluxation of the knee. And all of three had MCL, which was stuck inside the joint with medial femoral condyle buttonholing. The MRI findings were ACL tear, PCL tear, MCL tear and invaginated in the medial compartment, along with the buttonholing of the medial femoral condyle, as you can see on these MRIs. Few more MRI images from the other patients. You can see complete tear of the ligaments along with the MCL stuck inside the joint. So what the treatment plan would be, whether you'd like to do a staged surgery or a single stage reconstruction. So we did a single stage in 2 of these cases and staged in 1 of them. The surgical procedure was ACL reconstruction oblique repair, PCL reconstruction oblique repair, same for MCL, and we used arthroscopic and combined approach. So first thing was to manage the MCL as it was stuck inside the joint. We released the medial retinaculum, delivered the MCL out of the joint, and reduced the medial femoral condyle. Then we repaired the MCL if it was possible and augmented the superficial MCL and the POL with the semitendinosus from the same side. Again, the video would not be working, but this can show the buttonholed medial femoral condyle and the MCL which has gone within the joint. So after repairing and releasing and reducing, this is the augmented picture, the final of the MCL. The anterior is the superficial MCL, the posterior band is the posterior oblique ligament. If you see the condition of the skin, it is not healthy. On the anterior aspect, you can see some abrasions. This happens when the injury is delayed by 3 to 4 days before you intervene. The skin that is under the dimpled part gets starts getting ischemic. This is another second one of the MCL. You can see the medial femoral condyle is very well clearly visible on the first image. Second, you can see the invaginated MCL inside. Third, we have taken out the MCL and held with the forceps. Fourth and fifth images showing the part of the MCL which further could have been repaired. The third case, we have taken out the MCL just before repair, and the other is the semitendinosus going just before fixation of the superficial MCL reconstruction. So this is after the reconstruction superficial MCL and the POL. We basically repaired the MCL as much as was possible and did an augmentation over it. What we did with the PCL is and the ACL is the important part. We thought that reconstruction of the PCL and the ACL in acute setting would be too much, especially within such an open surgery. So what I decided, with the cases in which I had a femoral injury, I just sutured the femoral end of the PCL and the ACL and repaired it to the footprint area with just a free endobutton on the outer cortex. In 2 of the cases, I repaired it, and in 1, I did an open reconstruction of the PCL at the same sitting. So this is the PCL that we have repaired. We just put a bites with a antegrade suture passer and tied them over a free endobutton on the medial cortex. And similarly, the thing is that we did with the ACL. Second part, in cases in which we are not happy about the posterior stabilization, we have to understand that posterior stabilization is a must in these injuries. After the MCL, you have to stabilize. You can't leave it, otherwise it will subluxate. So either you do a PCL repair and give stability in case it's possible. In tibial end avulsion, it's difficult to have a repair. Then you do an open PCL reconstruction. If this also is not a good option for you, you have to go ahead and apply external fixator. But at the end, you have to prevent posterior subluxation anyway after you've taken care of the MCL. So this is what the final repair on the medial aspect looked like, along with the repaired ACL and the PCL. The medial retinaculum has been closed. So again, this was a video it showed how stable the knee was after ACL and PCL and MCL repair, all three repaired with an MCL augmentation. And knee was pretty stable on table, and I had a range of 0 to 90 degree comfortable range of motion. नहीं चलेगा, कोई चांस नहीं है. So what I want to just tell you that just by the repair of the ACL and PCL by free endo button and simple stitches, you can have a reasonably stable knee on table in these injuries also. These are the post-op X-rays in which I have done the repairs of the ACL and PCL and MCL augmentations. And this is the case in which we did the MCL in the first stage, did an external fixator, and a second stage reconstruction of the ACL and the PCL arthroscopically. So this was at the end of 3 months in the patient, in which only the 3 ligaments were repaired with MCL reconstruction. The knee had a good range of motion of 0 to 90, and it was hardly grade 1 anterior-posterior laxity was there in this patient, and the patient was walking hardly using the walker at the end of 3 months. He was walking independently. This is the 63-year-old gentleman out of the 3 patients. So the timeline, day 0 of injury is when the accident occurs. Emergency department, we have radiographs, MRI, preoperatively immobilized, surgery, in which you do the repairs and the reconstruction. And 6 weeks, you have good follow-ups. You start gradual weight bearing. 3 months, you have normal weight bearing and good range of motion. 6 months, you say it's nearly completely recovered. So outcome, we have to assess on the range of motion, stability, and the follow-up results. These are the few studies which supported the augmentation and repair of MCL with stabilization of the posterior laxity by either of the 3 means. And the conclusions are, these are complex multi-ligament injuries. MRI is daily essential for diagnosis. You have to take care to see whether there is any neurovascular injury. Early surgical repairs is a must and improves the outcomes. MCL repair plus augmentation is definitely the key, and posterior stabilization has to be done. Otherwise, you are in for a trouble at a later stage. And it's up to you whether you want to go in for a single or a 2-stage surgery. Thank you.
We are continuing with osteotomy and cartilage, and I would like to call Dr. Bhushan Samnish sir for topic STO planning and technique.
Master taking up the master lecture.
देख लो भाई. So let's change the gears. We'll talk of alignment and osteotomies now. And hopefully you'll start seeing something in a second. So yeah, so my name is Bhushan Sabnis. I'm a big passionate person for osteotomies, and let's talk a bit about osteotomy planning. I'll try and stick to the time. I don't think we'll have time enough to discuss the steps in osteotomy because Dr. John Mukhopadhyay will be showing the steps in a HTO. Me and Dr. Sandeep are going to show a double osteotomy in a few minutes anyway, so you can see all the steps while we are doing the surgery as well. So the key part of this procedure is to plan it properly. I've specifically called it Desi to Videsi. So even a paper pen technique also equally works well. Most important thing to understand is to get a good looking or a good, well-performed X-ray, the so-called scanograms or long leg alignment views. That will allow you to plan your surgery. And after that, execution is a fairly straightforward thing. All of us are surgeons. All of us know how to use a saw and put screws in the bone and plate in the bone. It works really well. So everyone who gets an osteotomy will need a standardized scanogram done. There are a few important things. The patellae have to be facing forward. The pelvis has to be squared, and the limb length discrepancy has to be corrected. These are essential. Otherwise, you'll get false reading and you will not get the correct planning, And if your planning is wrong, the execution will always be wrong. So some of the scanograms which I see and have outright rejected them for planning is something like this. You can see that different images stitched onto each other and they are not matching. So you can't plan your surgery in something like that. Number two, can anyone tell me why I won't accept this? It's a supine one. So the patient is not standing, it's a supine scanogram. You can't plan your surgery on a supine scanogram. You want a scanogram where something like this is there, where the patella are fairly in the center. You have your pelvis which is level and your alignment can be then assessed by drawing various lines. So that's the standard scanogram that you want to plan your osteotomy on. There are various levels of correction one can do. So you can do the frontal plane, sagittal plane, transverse plane, or even rotational plane as such. What's important to understand is that the deformity analysis plays a major role in achieving the desired result. And indeed, this was one of the plans for the Leaning Tower of Pisa. Putting a big wedge on the base of the stilt didn't work. Okay, so the key part in your planning is drawing these lines on your scanogram. So you want to assess the mechanical axis of the lower limb. You want to have the weight-bearing axis going from the center of the femoral head all the way to the center of the ankle. Then you want to measure the area where it bisects or transects the tibial plateau. That point is called as Mikulicz point. You then want to draw two separate lines for the mechanical axis of the femur and the tibia and measure the angles subtended by the joint lines to this. Based on that, you are going to have your MPTA and your LDFA. These two are the crucial angles that you want to talk on, and they all are around 87 degrees to make it easy for us. So any MPTA reduction less than 87 indicates varus deformity, and similar on the lateral side. I'm going to stick to HTO in this talk. So this is a typical way in which the deformity analysis decides what you want to do. MAD is mechanical axis deviation. We are going to stick to the medial side for a high tibial osteotomy, and you decide whether the deformity lies in the tibia alone, femur as well, or both at the same time. And quite often than not, you will realize the deformity lies both in femur and tibia, and your correction is only decided based on the deformity. I do not advise correcting a femoral deformity less than 2 or 3 degrees, but at the same time, do not create a tibial valgus to compensate for a femoral deformity. That will lead to a significant joint line obliquity and the joint will fail early on. Now, if you do all these steps properly, you can easily say that the osteotomy will last for 10-15 years or longer also. Now, where do you want the target point to be? That is not a set point as such, but generally speaking, it depends on the grade of arthritis. Severe grades of arthritis, you want to correct around 60%. Lower grades of arthritis, around 55%. We rarely go about 65% because the problems of joint and obliquity and subsequent difficulties with knee replacement are always there. The various ways of planning your osteotomy is fairly straightforward. What we normally follow is the Miniachi technique if you're using a paper pen pencil, but nowadays most of us have started using software planning. It works really well. This is a so-called Miniachi technique. What we're doing is we're drawing the weight-bearing axis from the center of the femur to center of the ankle. We see where it subtends or where it transects the tibial plateau. That's your Mikulicz point. Then you draw another line where you want this line to be in future. Now, that will give you the new center of ankle where you want the correction to be. Then you mark your hinge point where the hinge should be, which is about 5 millimeters medial to the fibular head or the lateral tibial cortex, about 1.5 centimeters from the lateral joint line. Now, from there, you draw this angle alpha or angle theta, whatever you to call, and then subtend that angle on the tibial metaphysis medially, and that's your correction. That's a fairly straightforward technique. If you have a calibration way of exactly measuring the width, you can measure the width. I'll show everything in a second. So this is the so-called paper pen technique, which all of us can do. All you need to invest is maybe a good sketch pen, a long scale, and a good printer to have a print something like this. So this is the video. I'll try and make it fast. So as you can see, it's a significant varus deformity. I'm drawing the center of the hip to center of the knee, rather the area between the two condyles to measure the femoral angle. And a similar way, I'm measuring the, sorry, let me go back. I went a bit too far. Okay, so now we are drawing where we want the Mikulicz point to be. That's the point where I want my new osteotomy, sorry, my new leg alignment to be. This is the same old miniature technique. So this is where I want my leg to be. So I want the leg to turn like that so that my alignment will be perfect. That's my hinge point now. So I'm drawing a line from the hinge point to the new ankle center. And that's the angle of my correction, the angle theta or angle alpha, whatever you want to call it. I'm measuring it as theta. And I'm going to just use a standard protractor to measure the angle. So let's say that angle comes to whatever degrees. Now we are going to subtend the same angle where the osteotomy is to be, and that much opening is required in terms of angle to find the correction that we want to do. Now angles do not mean millimeters. So what I'm doing is measuring the width of the tibial osteotomy on that line that I drew to the new ankle, and I'm going to measure the width of the triangle that I've so far created, and that is the actual correction that I'm going to do in terms of millimeters. So you don't need to worry too much about this. One caveat is the JLCA. So we'll talk about that when we're doing the live surgery. So that's the kind of correction we do. Now, this is a A4 size picture. So what we are going to do now is find the magnification. So we're now going to find the magnification point for this. Now, if we measure these are called grids. These are 5 centimeter grids. So I'm going to measure the width of the grid on the paper, which comes to 12 millimeters. So 50 millimeters corresponds to 12 millimeters. That means it's 4 times magnified in a normal setting. So I need to correct by 4 times more whatever my angle, whatever my measurements are. And it roughly comes to, let me see. So based on some basic mathematics, now it comes to 16 millimeter correction. I'm going to subtract the excess of joint line convergence angle. So in this case, it's 8 millimeters. So I'll subtract 2 from that, which is the normal JLCF, and divide that by 2. That's 3 millimeters. So my final correction will be 13 millimeters. So that's how one can actually plan osteotomy using a paper and pen. I won't go to DFO planning just now. There are a lot of softwares now which make life easy for all of us. The one that I normally use is called as Bone Ninja, and I'll show you how it looks. So that's the Bone Ninja software. So here you can measure the angles far easily. You just need to draw the lines from the mechanical points, sort of from the center of the head of the femur to the center of the ankle. Then you can measure the various angles that you want to measure to see where the deformity lies. And you can actually plan the osteotomy beforehand. So now then you can plan the osteotomy to see exactly where you want to go. So that goes to the hinge point, and now that's my opening and closing of the osteotomy. And then this can be done with a simple mouse pad. And now you can see the correction you are achieving. And since you are using a calibrated scanogram, you are able to then find out exactly how much correction you are going to achieve by doing this. So this is called as a calibration. So that scale that you're seeing is 30 centimeter scale. Of course, you can use whatever you want in terms of calibration. As long as you know the dimensions of the thing that you have on the scanogram, it can be easy to do that. So most important thing to remember, the cliche statement that we always talk about, that failing to plan is planning to fail, holds true for osteotomies. So every patient you do, always plan your osteotomies properly and make sure that you execute the plan exactly to the T. If you are relying on a good, well-done scanogram, it's very rare to have a major fallacy or major discrepancy in your correction when you're checking it on table. I think I won't bore you too much. That's all. Thank you very much.
Just a very basic question, because you want to keep it for basics. While getting the scanogram correct and drawing those lines manually, how would you identify the center of movement?
So if you have done a scanogram properly, center of hip should be fairly easy to assess. If you are a Puritan, you want to be perfect, you have something called as Moses circles. So you get small circles, things which you can actually superimpose on top of the head of the femur to find the perfect center. That's the easiest way. And for the ankle, you find the center of the talus. So if you have a properly done X-ray, you can easily find the talus. And the best way is to physically measure the length of the width of the talus and put a half of that. That usually works. Okay. Sorry,
Next, I would like to call Dr. Sandeep Birari, sir, on the talk complication of osteotomy around the knee.
Yeah. Thank you very much, Dr. John Mukhopadhyay, Dr. Arvind, Dr. Vikas, and Dr. Janki Sharan for this warm invitation. Happy to be the part of BAC. Presentation.
You are welcome, birthday boy. Many, many happy returns of the day.
So we saw a very nice presentation by Dr. Bhushan about the planning, and planning is very important in a HTO because not all virus needs osteotomy in tibia, and like different scenarios are there. So there are enormous complications associated with high tibial osteotomy. So there is a classification for these complications as well. So like it is based on what treatment is required for that complication if it occurs. So class 1 is being no additional treatment is required, just willful neglect is enough. Class 2, patients need some short non-operative management like non-weight bearing or something like that. And class 3 means it needs additional surgery and may have a long-term non-operative management for these patients. So complications can be patient or procedure related. It can happen intraoperatively or postoperatively. So let us see preoperatively, all these factors are responsible for complications for the high tibial osteotomy surgery. I'm not going to go detail into those. Mainly we'll be focusing onto the technical pulse. So like the commonest complications like cortical hinge fracture, then alterations of the tibial slopes, changes in patella, like patella baja or alta. So the first one, cortical hinge fracture, almost 20 to 25% patients, you do get these cortical hinge fractures, and very well classified by Takeuchi type 1, 2, and 3. One is where the osteotomy goes on the lateral plateau. Type 2 is when it goes distally, and type 3 when it goes into the intra-articularly. So that is the different breakage of the hinge. So this particular case, you can see this was noticed there, but as it was stable, just left as it is, not much correction was there, and the patient was already bone grafted. That was my initial days of the surgery. Then same patient, they tend to unite. Patient was just kept little non-weight bearing for 3 weeks or so, and then I mobilized. So whenever you get these intraoperatively, there are various treatments. If it has broken, then put with the staples or coventry pins on the lateral side, or even if it is very much unstable, then you can supplement with the plate. So how do you prevent this type of cortical hinge fractures? So this particular osteotomy, whenever you are planning, the end point is tip of the fibular head. And whenever you cut, make sure you are cutting, because proximal tibia is a triangular bone. You are cutting anteriorly and posteriorly with the chisels. And this zone being the most preferable zone where your osteotomy or hinge should be there. So that is a very much forgiving zone. So if your osteotomy is in that zone, or hinge is at the zone, chances of breakage are very much less. If it is less than 11 millimeter, chances of breakage, opening less than 11 millimeter, chances of breakage are less. And these newer implants like locking compression plates, they are very much helpful for giving a stable construct. So whenever when I pass these parallel wires, I usually make sure I cut my osteotomy below these wires, so that in case there is going to be cortical hinge fracture, it is not going into the tibial plateau, or that is intra-articular. So concept of golden screw by Tomofix, where you fix proximally and then you put this cortical screw, so that it is they say that it gives additional compression onto the cortical hinge, and that prevents the breakage. So this, during the osteotomy, you may prevent that cortical hinge breakage by passing a hinge wire, also called as a golden pin. Make sure it is exactly at the lateral border of the proximal tibia. And once it is done, then go ahead and complete your osteotomies. So this one particular case, you can see that's a patient of mine, already osteotomy done with the saw. And then I was putting now sequential chisels, that was done. And then I started opening, and then you can see there is a type 3 Takeuchi. It is opening here. So that was like because of bones being soft, and maybe I did not pay much attention towards chiseling out the lateral aspect. And then when I found out, immediately I passed the screw from lateral to, then again completed my high tibial osteotomy procedure. And that's patient's intra-op picture, and that's immediate follow-up. Later on, patient went for the opposite side fixation osteotomy as well. The proximal tibial osteotomy is very much forgiving, but distal femur is not, because if the cortical hinge of the distal femur breaks, then it can lead to n number of complications. It causes deformity occurrence, or it can become unstable as well. So you need to pay very much good attention towards, and preferably, that's why I prefer lateral closing on the femur and opening on the, I prefer closing wedge osteotomy on the femur, because it needs good bone contact for the healing, while tibia is better with the opening osteotomy. So how do you prevent this fracture? There should be longer plate is preferred for patients. Then if I invariably take now biplane osteotomy for all my patients. So like it's one more osteotomy. So you cut it in 2 planes. And then once it is depending upon how bad is that fracture, cortical hinge fracture, you plan your rehabilitation of the patient. Second complications or commonest mistake is the tibial slope alterations. So what happens if you do closing wedge osteotomy? It tends to cause the increase in the slope. But if you cause opening wedge, it leads to increase in the slope. So that's the reason when you do that, you need to put your lamina spreader onto the posterior aspect, so that slope alterations are prevented. Then if there is a lot of correction, then it may lead to changes in the patellar height. Opening wedge osteotomy can cause patella baja, and closing wedge can cause patella alta. Sometimes very much large angulations, you may have to go distal tubercle osteotomy. That means osteotomy, biplane osteotomy goes on the distal aspect. There are other complications like vascular injury, pseudoaneurysm or arterial occlusions. Almost 20-25% cases, the chance of this complication is there. The trick is when you do your dissection on medial side, keep the knees in 70 to 90 degrees of flexion to do the blunt dissection. Then once done, I make sure that my finger, I'm able to palpate the fibular head and there is no muscle or soft tissue underneath. And then I usually prefer this type of radiolucent. It is not completely radiolucent, but it tells me where exactly my Hohmann retractor is when I'm using the saw. And then complete osteotomy with the chisels. Preferable to use the saw with lex excursion, like a precision saw. Then there are other complications, which I'm not going to go into the detail. Complications of the surgery being infection and all. We do get all these sort of complications. DVT risk is around 2 to 5% cases. Then compartment syndrome is seen if you are doing any intra-articular procedure along with high tibial osteotomy. These are just for the academic purpose: hardware failure, hardware irritation, delayed union and non-unions, and number of complications. So I think the main complications being the technical ones being cortical hinge, slope alterations. These are the ones which you should be able to know and you should be able to tackle. So I'll just quickly run through it because of the lack of time. And if any further reading, this is very good. Now I have stopped using bone graft at all. Earlier I used to use, I don't use bone graft, no bone substitute, almost for 12 degrees or so. I'm okay. I just leave it as it is and I wait bear the patient next day of the surgery, provided I have not done any meniscus repairs or something like that. But just for osteotomies, I just make them wait bear. So for any further knowledge on this, please refer this article by Alan Gategood about failures of realignment osteotomy. Thank you very much.
Excuse me, sir. Yeah, from this
Yes.
side. One question I would like to ask in respect to the closing wedge and the open wedge osteotomy, and there is alteration of the slope. Where is the placement of the lamina?
So, lamina spreader comes in a picture when you are doing opening wedge osteotomy. So when you do open wedge osteotomy for proximal tibia, it leads to increased slope. So that's why you need to keep the lamina spreader on the posterior aspect.
And for the decrease in the slope, is there any method how to prevent the decrease in the closing wedge osteotomy?
Closing wedge osteotomy. So closing wedge osteotomy, you mean decrease? I don't do closing wedge osteotomy. So there is no question of, but then you can manually, when you are taking your cut, you can manually press it in a extension.
Okay. Thank you. Any more question from the
Thank
audience
you,
side?
Sandeep boss. There is little bit change. Dr. John sir is ready with HTO case. So we'll finish the live surgery, then followed by remaining lecture will be done. Chairperson, please remain seated. And the moderator for this live surgery is Dr. Beliappa, Dr. Kapil Dev, and Dr. Manish Kumar. Dr. Kapil Dev. Dr. Beliappa, please. Yeah, please.
Hi, can you hear me there?
Yes, sir. You are visible, clear, and very loud.
Okay, so we've done the basic incision. If you look at the X-rays, can you focus on the X-rays? You can see that he's got medial compartment osteoarthritis and varus in the right knee. Also has some in the left, but not so bad. Okay. We've done the Bovie cord thing in the OT. I think Dr. Bhushan has already gone through the steps of calculating the angle, so I'm not going to go through all that again. If you see the image here, can you see the images?
Yes, sir.
Yes, sir.
So that's the line through the center of the head to the center of the ankle. And you can see where it passes the center of the knee. Okay, so it's way off the center where it would
Right,
normally
sir.
would go center or up to 4 to 8 millimeters medial to the center of the knee joint. Okay, so it's way off. We've done the initial incision here. So if you look at the original description by Lobenhofer and Stobley in their book, they go actually almost along the posteromedial border of the tibia, just above the pes. We made an incision which can be converted to a TKR incision very easily. So it's the same incision that we use. What we do is we tend not to dissect out the pes. We leave it intact. I mean, we dissect it out, but we don't divide the pes. Answeriness, chota wala retractor. Okay, so if you can see here, that's where the pes is. Okay.
Right, sir.
Yeah.
And we go to the back, and the superficial ligament is superficial medial collateral ligament is raised off the tibia completely. If you look at the original description, they actually divide the medial collateral superficial bands of the medial collateral ligament. We just stretch it out with the diathermy, and we don't actually divide it per se, but we just release it enough to get a good look at the posterior part of the tibia. Okay, so can you hold that?
We are using the MCL up to the posteromedial crest.
Yeah, right up to the posteromedial crest. And you can see that. Oops, sorry. And this is a radiolucent Homans. Okay. We can use a regular Homans. That's not a problem. Can you see that here?
Right, sir.
KVAS, please. So is that part of the thing quite clear?
Right, sir.
Okay. So diathermy. So the osteotomy is a biplanar osteotomy. Okay. So what we do is we go
this is the vertical limb of the osteotomy, and this is the transverse limb which goes up at an angle of about 110 degrees to the vertical limb and goes up towards the top of the tibial tubercle. Okay.
So what is your level of osteotomy? Where from the, how far below the joint level you start the osteotomy?
So we go, so that's what the pes decides it. Okay. So we try to go above the pes as far distally as possible. Okay.
Okay.
So, and that should give you enough room for your first three and the fourth screw on the plate that you use. Okay.
And
That's
putting
the idea.
implant a little anterior, does it make a little difficult to put the human posteriorly completely throughout up to the fibula?
Not really. I mean, you can see that it's not that difficult. You just need to release the ligament. The deep part of the medial collateral ligament you leave intact. Okay, you can see that there.
Yeah.
Okay, can you see that up there?
Yes, sir, we can see that.
Okay, and then is that Sumit?
Yes, sir.
Ah, sounds like you. Yeah. When did you come?
I just came today.
Okay. So we put in these two wires. We start with the posterior wire. So that's the amount we are going below the thing. We make the osteotomy just below the wire. Okay.
Okay.
So the wires are directed. So you put the posterior wire first and you go towards the lateral cortex, just about a centimeter and a bit. So 1.2 centimeters below the joint line. Okay.
Okay.
So, or the top of the fibular head, whichever way you like to do it. Okay.
Yeah. So I think fibular head is a less consistent mark because a lot of people have a high fibula.
That's what I'm saying. So that's why we go for about a centimeter and a bit above the joint, below the joint line.
Yes.
Okay. And you take it almost up to the lateral cortex. You don't cross the lateral cortex. People put a screw there to prevent the lateral cortex being divided, but we don't tend to do that normally. Sorry?
I mean, the picture in picture can focus on the Siam view. That will be good, I think.
Yeah,
sir.
can you just see the K-wire there?
Yeah, we can't see the Siam, sir, right now. Siam pictures.
Please show
Yeah.
the Siam picture.
Yes, sir.
Yeah.
Yes, sir. Yes, sir.
Sorry. Okay, and that's.
So for
Show
the
me.
benefit of the viewers, sir, how do we know it's exactly a true AP view?
So you tell me.
So actually the 1/3 of the
Since you know it, you can tell us.
Yes, sir. The 1/3 of
So
the
what you want is just slightly, no? So you want a fourth of the fibula to be overlapped by the tibia.
right,
Okay?
sir. Yes, sir.
That's what we take it as.
Right, sir.
Okay, show it now. So a bit more internally, that would be perfect, yeah? Okay?
Yes, sir.
And then you put the second wire again parallel to the first. Okay?
Yeah. So do you prefer to use the parallel jig or you can do it freehand only, sir?
I just do it freehand. I'm sorry, I don't use any jigs or anything. I mean, you can use a jig. There's no rule that you can't use it, but we don't seem to cut the wires, please.
So these are a little thicker wire. Is this a 2.5 K wire?
Yeah, we use the 2.5 wires because the thinner wires tend to bend when you're putting them.
Yeah.
Okay, so this is a little harder to cut. So we sometimes need the big cutter to cut the wires. And here you can see Rajiv Ranjan struggling to cut the wire. He's a Calcutta trained person, so you know he has to struggle to cut a wire. So Rajiv is the one who's done the initial exposure, so we have to give him credit for that.
Yeah.
Okay, so now that's our preparation for the osteotomy, okay? So we begin the osteotomy with a saw. So once we cut the wires, it doesn't get in the way of the saw. We keep the knee flexed, retract the, can you pull on the pes here? So you've got room between the pes and the wires to do the initial part of. Yeah.
Hello.
Any question?
Camera, please. Can we have the Siam image as well parallelly?
Okay. एक आदमी सियाम को दिखाओ. Can you see that?
No, actually, sir, we can only see the in the operating field only.
सियाम को दिखाओ ना. क्या हुआ? नहीं, दोनों दिखाना है ना, एक खाली नहीं दिखा. So hang on a minute while they get their things, camera sorted out.
Yeah, yeah, okay, sir.
The wire has come off. तुम इधर ही रहो ना, उसको करने दो. Is that okay?
Not
But
really.
careful.
You can continue, sir. I think we'll.
Yeah, okay. So they are struggling with that. So what we have to make sure is that you cut the posterior part of the cortex, yeah?
Okay. Any tips to, prevent, you have to keep your homens exactly below the saw, isn't it, sir?
Exactly. So you can see that.
Yeah.
Yeah, and
Dr.
okay,
John?
so we just take it and then we take the thinner blade.
Okay.
Dr. John, before starting
Yeah.
the osteotomy, do you believe in putting a lateral wire as well at the hinge?
So I've never put it. Having said that, today I'll probably crack the lateral cortex, but I'm not worried about that too much. Yes, if you want to put the lateral wire, certainly you should put that wire to prevent you going through
So there are
breaking the
now
lateral
the paper
cortex.
coming out which says the highlights the hind side of it as well, sir. It says that you can prevent the type 1 and type 2 fracture, but the most dangerous type 3
One is
fracture.
that goes into the joint.
Yeah, exactly.
And
So,
that doesn't get
hind side of
prevented by that. Yeah. So what we do is, if we've had a couple of occasions where we've seen the beginning of the propagation into the joint. So then what we do is we put a wire across from the medial to the lateral side. So that prevents that from happening. Okay. So here, when you're cutting this oblique thing, start with your saw a bit vertical, because otherwise it will tend to skive off.
Yeah. So do
Okay,
you
and then-
like to lift off the ligamenta patella, sir? Or you don't want that?
Sorry?
Ligamenta patella, you want to dissect put a homen in between the bone and the ligamenta patella?
I don't ever do that. Yeah.
Okay.
So we've got it separated here. Can you see
Yes,
that?
sir. Yes, sir.
But we don't actually, and this is a complete cut.
Okay.
So we go across to the. So,
Sir, do you?
so that's a
prefer
complete
to
cut,
take
yeah?
the-
Yes.
Sir, do
So
you prefer the
there's
vertical
some of these things which I think when you're starting to do your osteotomies, you should certainly do it, like putting the lateral wire, etc.
Yeah.
So we've done, I think, I don't know how many, well over 100 of them. We've probably damaged the lateral cortex 2 or 3 times in the whole. Can we have the osteotomies? So put them here. So the Tomofix set has this. ये क्या है? साफ करो. So has this set of chisels, starting from the most broad one to the narrow ones, and we put them one after the other, starting with the broad one, and we go till about a centimeter from the edge of the cortex. Okay?
Okay.
इसको ऐसे करो ना. Okay, so that's it. So you have to make sure that the posterior cortex is cut.
Yeah. How do you ensure that the posterior cortex is cut? Any way you can assess that, sir? Or
Yeah, we look at it.
Yeah. Okay.
That tells you. See, I can take out this thing and show you. If you can see there, can you see right there?
Yes, sir. We can actually. The retractor is coming in the way in the posterior cortex. Yeah.
So you
Yes.
have to make sure
Yeah.
that this goes right all the way there. Huh?
Okay. Now we can see that.
Okay.
Second thing is, if you are able to
So
create
and you run the chisel. At the grazing the posterior cortex. Is it, sir?
Yeah. So we are going right up to the because this Homan is there. You're safe. It will not cross that. Okay.
Okay.
Okay. Just see that. Okay. You can see the wire is going parallel to the wires.
Perfect.
Sure. Okay. Yeah. Okay. So yeah. Bit more.
Yes.
Yeah. So we'll stop there, okay?
Yes, sir.
So we tend to keep the osteotomes in this direction so that you reduce the amount of, and also cut in the same direction. Okay.
Yes, sir.
So then the third one, which will go in between the two, just make sure that the level stays the same, doesn't go off too anteriorly or posteriorly. Okay.
Yeah.
Okay. Look up. Okay. And then we have a fourth one if you want. Initially we had only 3, now they have given us 4, so we use all 4. Again, you have to be careful with the last one, it tends to skive off one way or the other, so adjust the direction. So this is what you have to avoid. I thought you were holding it. Okay, don't worry. Hey, yaar. Push mat karo mere ko. Okay, just keep it there, na? Yeah. Okay. Okay. Still going on. Wait, na? You have to keep it there. Okay. That's it. That's okay. That's okay. Okay.
Yes,
See the
sir.
image? Image? Okay, that's okay. Now you take them off, you hammer on either side, they come off gradually.
So if it is too tight, does that mean that your release of the MCL is not complete?
I don't know. Does that mean that?
Yeah, I thought if the MCL distal part is attached, then
I think it just means that the quality of bone is good, huh?
Okay.
No, sir, even the wall, whether it has been completely cut or not, that is also to be checked out.
Yeah, obviously, but that will check that. Okay, so that when you do the next step, that you will check if the posterior cortex has been cut or not. You can always check it at this stage also by checking with your artery forceps. And if you have any doubt, you just cut that part, yeah? Osteotome dena to. We'll just check that it is cut. It is cut, but we'll just, maybe it's not cut full. That should be. Okay. So then we put in this distraction device, which is a very useful device. So the advantage of this is that it actually gives you the angle. You don't need to actually measure like we do in the Miculix exactly how much your wedge should be. Okay. And we had calculated that we need to correct about 14 degrees, if 13 degrees, if we take the joint line congruence angle as 4. Kya kar rahe ho?
Yeah. So that is after adjustment of the JLCS, sir?
Yeah, JLCL. Yeah. Which is about 4 degrees, huh?
Okay.
Okay, hammer. Okay, so then we just hammer this in.
So how far medially you need to push it, sir? Exactly.
As
at
far
the-
as your osteotomy, huh?
Okay.
So about a centimeter from the lateral cortex. Dekha?
Okay.
So even if you just crack the lateral cortex, it's okay. It's when it displaces that it's a problem.
Exactly.
And the first screw you put in as a cortical screw tensions your lateral side, yeah?
Exactly.
Dekha? Dekha? Okay, so we're going to take it about a bit more. Okay, so
you keep it as near to the posterior cortex as possible, isn't it, sir?
yeah, you can see that. So then we start distracting it gradually.
Okay.
Go slowly in this because that's when you crack the thing. If you go too fast, give it some time, wait after every 2 or 3 degrees, wait for some time. Dikha. Okay, keep going.
So one question, sir.
Yeah, sure.
The pre-operative assessment of the angle to be corrected and the intraoperative finding which you get intraoperative correction, do you ever find any discrepancy?
So you have a standing view in the preoperative X-ray. Here you have a lateral position, you have a patient supine.
Yes, sir.
Okay, so there will be a minor difference. So I think what you correct preoperatively is important, but what you can do is basically check how much correction you got. I think that's the one advantage of the external fixator is that you can adjust your correction. Okay.
This will be more accurate, sir. Intraoperative.
Yeah, if you want to do it to 1 degree or 2 degrees, then the external fixator has that advantage that you can correct it post-operatively as well.
Right, sir.
While here, what you do at surgery is what you get. Okay. Now, the advantage of this biplanar osteotomy, if you watch this very carefully, is that you can see that here it's separating, but at this level, there's no separation. Yeah.
Yes, sir. Yes, sir.
It's almost in contact with the bone. Yeah. Keep going. How much have we done? Okay, we've done 11 degrees. We'll do at least 3 more degrees, I think.
So, I mean, this high degree of correction, do you think that the chances of, I mean, the delayed healing might be there, sir? Heals slowly?
Of what?
I mean, this high degree.
So we have done up to 18, 19 degrees of correction, and in more than 100 and I don't know how many exactly, I think it's probably around 140, 150 cases by now. We've not used bone graft in a single one. And we've not had a non-union problem. We've had other complications like low-grade infection, etc. We've had patients who probably we were not supposed to do, and we did, and they did not get the result that we wanted. But we've not had a non-union in any of them.
Okay.
And we've never used a bone graft till now. Okay. So and we start them walking the next day.
So do you
Okay,
keep them non-smoking? I mean, how important is stopping the smoking, sir?
So it depends on how often you look at the literature. We have never even bothered about smoking, to be honest. But yes, obviously the literature says that if you have a smoker, it's a problem. But we honestly don't even ask our patients if they smoke or not most of the time. I think in a non-union, maybe we do, but for these osteotomies, we haven't even bothered to ask. Okay, now can we check the bovies? So we'll check this with the bovie. That's the best we've got of. Let's go keep it a bit up, keep it a bit above, because it gets kinked, huh? Idhar bhi. Dikhao, hip joint dikhao. Little, thoda sa hai na. Dikhao. Gone too far. Just go back a bit. Yeah. Ah, that's good. Okay, now did the ankle. Just turn this in a bit, huh? And the other thing is we don't always go for the Mikulic's point exactly, thoda sa lateral. Okay. We just make sure that we are just a bit lateral to the spine, huh?
Slightly, slightly medial, sir.
No, medial is okay, but we try
He
to
said
go
slightly
just.
medial to the Mikulic's, sir.
Yeah, so this is what we are aiming for, huh?
This is good,
We
sir.
don't try to overcorrect it because here the hinge is very close to the cora, huh?
Yes, sir.
Okay, so that's it. Now the next step is putting in this wedge. You got a wedge. Yeah, isko na dimag. So we put in this wedge. Okay, we just hammer this in. इसको ढीला करो और लामिना स्प्रेडर दो. So this prevents the osteotomy from falling back. Now you can see the back, okay?
Yeah.
So we also
Because-
have these sets, but now I am understanding what is the use of all these instruments.
Yes, you must know what to use when. Okay, so this is the laminar spreader.
Okay.
So now we correct it again. Again, you should measure the angle once you've done this. Okay. Okay. Then you just take this off. Again, you can see that anteriorly it's very close.
Yes.
Okay. Yeah. You see that? And now the correction looks good.
Yeah.
If you want, you can go 1 more degree with that. Okay. We take out the wires, at
Sir,
least the anterior one, because that gets in the way of the plate.
Okay. So any opinion regarding the position of the plate? Do you want to put the plate more posteriorly or more anteriorly or just in the middle?
In the center of the shaft.
Okay.
Okay. And and the level should be around there. Okay.
Okay.
So if
Put
you
it,
need to,
over the pace, sir, over the pace, under the pace.
yeah, it's over the pest because we use these spacers.
Yeah.
Yes, sir. Spaces.
So that, okay, can we see the image, please? Because we want to make sure that your direction is right
One
and the
question.
level is right.
So when
You
you're
can go a bit higher.
it's over the pest.
Artery forceps. So it doesn't matter. The pest is here.
Yes,
When you
yes.
put the screw, these two spacers stop it from pressing the press. Okay.
Okay.
sir.
Okay.
So can we have any difficulties if we want to harvest the hamstring graft with the plates on?
With the plates on.
Yes, sir.
Well, you would take out the plates if you want to harvest the hamstring, no? I don't, there's something here which is getting in. Knife, please.
Rarely
No, there's
patients
no-
of arthritis will require an ACL reconstruction.
Yeah. So you just need some more room on top here for the plate.
Okay.
Okay. Okay, let's see it again. So here in the bottom, you should be in the center of the shaft. Huh?
Okay.
On top, you can be a little. So you want to be not posterior, but in the center all the time. Huh?
Okay.
Okay, let's see. Can go a bit higher.
Slightly higher, sir, because the fourth
Yeah.
screw
Can we have this thing?
just
Yeah.
proximate to the
Yeah. Okay, now let's see.
Sir, any reason why you keep the K wire till now? You just
I've kept one, the posterior one is not getting in our way.
okay.
Okay, but yes, otherwise, and what the K-wire does is if your bone is soft, it's protecting your spreader from going
Okay.
into the bone. Yeah.
Okay.
Okay, so let's see so what we do is at this stage, we'll drill and check that we are going in the right direction. Because we're still too low. I think we need to go higher. Yeah, okay? So knife, please. We'll just go up with the incision a little bit and release this tissue here. Okay. अब देखो. I think that's better. Just push it up now. Push it up. Push the plate up. Oh, that's good. Keep pushing it up now. देखो. Still coming too low, yeah. Nee, but why are you? एक सेकंड इसको डालने दो ना छोड़ दो ना प्लेट so to get there's a actually jig for this also
yes
which the Tomofix has where you can but वो jig है इधर नहीं छोड़ दो we don't usually use it so
what would be your sequence of placing the screws? Is slot A, B, or C?
so we put our top screw first, put 2 of those, then put the tensioning screw, yeah? दिखाओ एक बार ना दिखाओ हाँ ठीक है that's better. So you don't want it to go into the joint, so you're going very close to the joint.
Yeah.
It's subchondral, yeah?
Yeah.
Chalo. Kitna measure? 95, 90, 80, 80 देना. ठीक है छोड़ दो
So don't you prefer to put 1 or 2 K wires in the screw slots before drilling for the first screw?
Don't I prefer? No, I don't bother, but yes, you can do that.
There's always a chance that the plate moves here and there while you're drilling for it.
Absolutely right. I have, but we've not done.
You have done more than 100. That's not the case.
Yeah, I mean, so that's what I'm saying. So you are definitely justified in doing that.
Right, sir.
I don't see anything wrong in it. Just keep it like that. Dekha? Yeah, that's good. 80 though. 75 though. And we don't lock it till we put the second one. So because otherwise you get the helicopter effect, huh?
Right, sir.
So we don't do the final locking. We just, come on here, retract this. Don't go to sleep, na? देखा? नहीं वो ठीक है देखा. चलो. Keep this here. नहीं इसको नीचे पकड़ो. एक सेकंड पहले मेरे को इसको थोड़ा वापस करने दो. क्या तुम रिट्रैक्ट करके रखो ना. बीच में सो क्यों जाते हो? Just keep that centered. ठीक है? You sure? Okay, so just no, keep it a bit lower down. Huh. Okay. Okay.
So
we
you
get
use
this.
Spacer screws or you
Yeah.
remove them?
Sorry?
The spacer screws, you leave them or you want to use remove them at the
No,
end?
we take them out later.
Okay.
Then it can be
Because we have to put screws into those holes, na?
Yeah.
But till we put that compression screw, we keep it on, huh?
Okay.
Okay. So because you don't want the plate to press. So this one which we put now, you
Yes.
still have the spacer which will keep the
Okay.
plate off.
ordinary. Okay. And the other thing we do is, see, if you look at it, if you go distally, you're going to end up compressing the osteotomy a bit, huh? So we
Okay.
tend to make this hole a little more on the lower side of that hole or the upper side of that hole.
Okay.
So if anything, it will not compress it, huh?
Okay.
It won't distract, but it won't compress it. Measure. $44. 44 though. Machine.
So this screw is going to compress the hinge point.
Yeah, this will lock the hinge. Screwdriver. So as you tighten this, you take it.
So do you change it into a locking screw at the end of the surgery, or you'll keep it as such?
I leave it to my assistant to decide. If they feel like changing it, they do. If they don't feel like changing it, they don't. Okay. Yeah, I think it's the fact is that you're not. एक काम देता है उसको भी नहीं करेगा ठीक से. Okay, then we put the locking screw. We are a little anterior, but I think it's enough. It's okay. They're going too cortical, huh? So I'm not entirely happy with that. So I'm going to change that a little bit because we are a little more anterior than we want. Oh, sorry, this is the. I have to take this one out now. Machine though. Plate rock. I think the hey, रिवर्स का नहीं काम कर रहा है हाँ उल्टा किया हुआ उधर में रीमिंग में डाला हुआ होगा तो क्या है हाँ डाला हुआ रीमिंग में टिपिकल ना हाँ की हाँ तो एक टू खानी रीमे so this is the thing whenever you put the thing check because if that was a locking screw that might have been the end that we might not have been able to take out the plate at all huh luckily it was a compression screw and not the locking screw दोनों को कर देते ना चलो इसको ये करो keep it there are you sure just show me yeah okay just make sure you leave it there huh okay
Yeah.
so always make sure your plate is centered and this is one of the problems that can occur if you're not careful keep it they're not ordinary drill okay so there 44 44 though ये screwdriver ordinary screwdriver where's it okay. machine though keep holding it ना ठीक है चलो दिखाओ okay torque limiting though just check the torque limiting on these okay now let's put the last one that is okay drill locking so initially I was going through the cortex with that screw
Okay.
now so now you can see it's gone through one cortex and then the other so it was too anterior earlier
Yeah.
थर्टी दे दो 28 दे दो so at this stage you always want to check the lateral view huh once you've done this we can take out everything huh
Okay.
एक बार दिखा दो ठीक है so you can see the hinge is not disturbed
Yeah.
okay
So how many
you can-
screws do you prefer on the proximal fragment, sir?
sorry
On the proximal fragment, how many screws you prefer?
no I put all the screws but I just
All
check
4.
at this
Okay.
तो check करो इसको छोड़ दो now you can remove lateral दिखाओ AP lateral दिखाओ ना so sometimes the screw might look very close to the joint but when you see the lateral you'll find that it's okay I hope
The screw in slot A appears to be slightly longer.
so it's well below the joint yeah
Yes.
okay so if you want you can change that first screw
Yes, a slot A screw can be changed.
pardon
The screw in the
you put in all the screws before you do any change sleeve তুমি বলবে না নেক্সট দুটো থাকা উচিত না সেকেন্ড কোথায় দুটো ওখানে তুমি রাখবে না হ্যাঁ চলো Next one on top. दिखाओ. Okay. कितना दिए थे? 75 दे दो. ये 75 है. Sure. चेक करो. चेक. पहले भी 75 दिया है. दिखाओ. Okay. Top limiting. Still locking. So take out, now you can take out the spacers. So you can see the two spacers we've got. And this hole very often looks very close to the osteotomy, but almost always it's well above, yeah?
Yes.
I don't know why it makes it look very close. In this case, it isn't that close, but sometimes it looks so close that you're worried. But when you check it, it's actually well above.
Yeah,
See
but
that?
few companies are come up with the variable angle as well for this, I think. So
Yeah, I mean, there are lots of things you can do which make life easier. You don't always need them. Yeah. 75 दे दो. So change that screw, huh? First one. Okay. दिखाओ. No. Top limiting. Lateral दिखा ना. Lateral में just एक बार lateral दिखाओ. So the other thing you look at the lateral is to make sure that you haven't changed the slope too much, huh? I forgot to
we
point
saw
that
that.
out. Yeah, we saw that it looks fine, but I just wanted to show it to you again for people who are not aware of it. That's the other sign that you know that your, see, you can see the slope is fine, huh? That means your posterior opening is okay, huh?
Yes, sir.
Okay, fine. That's, I think we can stop there. Just putting the rest of this couple of screws. That's, thanks a lot.
Thank you, sir. Thank you,
Okay.
sir.
Yeah.
Thank you
demonstration.
for a wonderful
Thank you,
demonstration,
sir.
sir.
Yeah. Thanks very much.
Thank you, sir.
Yeah.
Sir, for nice live surgery. Now we continue with osteotomy and cartilage session. I would like to call Dr. Amit Kumar sir, Jha sir, for osteotomy in malunited proximal tibia. Dr. Amit Kumar Jha.
Thank you, Bihar Arthroscopic Association and Dr. Arvind, sir, for giving me this opportunity. So you have seen the planning, the complication, and very well done execution also. But little bit from osteotomy. So these are few regular cases which comes on this part of our practices, where there is malunited proximal tibia is not that uncommon. So when I see this patient, there are two thoughts which comes in our mind. What we are going to do with this? So osteotomy alone is going to work, or whether we have to do some kind of osteotomy along with ligamentous work. If osteotomy, what kind of osteotomy? Whether extra-articular, intra-articular, or combined. So here, so this is the case one. 25-year male who had a fracture 8 months back, and this was the fixation done. So when he came, he came with the walking with pain and instability. That was his chief complaint. On examination, there was full-blown posterior drawer test positive, dial test positive. If you see the knee, it is going back. And this is the alignment. So how to go in, whether osteotomy alone or some kind of ligamentous surgery he need. So on MRI, there was a PCL tear also, along with the medial condyle slope was changed, which was adding on the instability of the posterior instability. This is examination under anesthesia, and this is the kind of laxity he was having, posterior as well as posterolateral instability. So I did a PCL reconstruction, STO to align this thing along with simultaneously changing the slope. In spite that, there was some rotatory and subluxating instability. So add-on modified Arcerio. This was post procedure stability, and this is 18-month follow-up. Patient is walking well.
So Amit.
Yes.
So your case was started with this was a case of medial condyle fracture.
No. If
that was fixed with T plate on the medial side.
No, if that is the when you see a malunited fracture.
No, I'm telling you, case presented to with this. So whenever you see picture like this is the posterior lateral corner must involve in that.
Yeah.
So that ligament should come in. This is message just for the
Yes.
beginner.
So
But
if
isolated medial condyle fracture is always a subluxation or dislocation kind of thing. And it's always associated with some kind of ligamentous laxity. Most of the time it's posterior lateral corner and sometime PCL also. So as you said, you did the PCL, then you find there was some rotatory instability. That's why I said, whenever there is medial condyle fracture, your mind should look for posterolateral side. It's
True.
always there. It's either subluxation or dislocation.
And
kind
in this case, there were telltale sign also. If you look carefully on the lateral aspect, you will see there is the bony avulsion which was present.
Absolutely right.
So initial, if you get the immediate post-op X-ray or the immediate trauma X-ray, that gives us a hint that is, it is not only a full simple malunion. There is something else also. So this is the case 2, similar malunited proximal tibia. And here what we find, this is post 18 month of the injury. And there is, you see the slope is reversed. But this case is not having that kind of laxity, what the initial case was having. But posterior subluxation due to the reversal of the slope. So here there was 2 issues. One, there is the change in the amphitheater due to the medial condyle fracture. And second, there is varus knee problem is also there, which was adding the laxity. So in this case, to correct the slope, I did a TCVO along with to correct the varus alignment STO. So TCVO with STO was done, and this is post fixation. Patient at 9 months, he sent me this video. This was the gait. He is able to bend fully, and this is at 15 month, the same patient walking well. So this kind of laxity which patient is having for a longer period of time, to ligament to get stabilized, you have to wait sometimes. So even after 9 months, I was worried why he is not getting that kind of gait, what he should get. But I waited, and at 15 month, he got a good range of motion and stability also. So this is the case 3. And this was the malunited proximal tibia fracture. So here there is a, this is kind of complex intra-articular fracture. So there is 2 thought process. Either we have to go intra-articular osteotomy, but deciding the plane through which I should go, I decided to do the extra-articular osteotomy, and simple extra-articular alignment correction was done, just doing the osteotomy and filling the bone graft. This is the post fixation alignment. I corrected the slope and alignment. This is post 18 month. The fracture has healed well with the normal walking and full range of motion and no postal instability. This is childhood trauma leading to the isolated posterior slope reversal. So here the problem was he was not having any pain, but on walking his knee getting back, that was an issue. And if you see, this is the uniplanar instability, only the knee is getting subluxed, and that was the solid kind of subluxation. So here, slope correction osteotomy was done, supratubercle and with a pin fixation and bone grafting. Intraop, if you see, this is the this is the 2-year follow-up. Is walking well with no instability. The last one, medial condyle malunion. The problem with pain and instability. Usually the medial condyle malunion, they walk with the valgus kind of gait. And this is a simple intra-articular kind of fracture. So I decided to go with the intra-articular osteotomy through the fracture plane and post fixation, and at 2-year, he's having the full range of motion and walking well. So whenever we see these kind of patient, the alignment is the main issue. So we should see the coronal and sagittal balance first, then the ligament work, then this knee going to last long. Thank you.
Nice cases, Amit.
Next, I would like to call Dr. Biliappa, sir. His topic is STO with medial meniscus root repair.
Good evening, everybody. Big thank you to Dr. Arvind and his team at Bihar Arthroscopic course for having me here. So I'm just going to talk about the need of a high tibial osteotomy in the setting of a meniscal root repair. As we know, just go back to that. Yeah, sorry. So as we know, meniscal root tears are a silent epidemic, and they account for about 10 to 21% of most meniscal tears. Meniscal root tears have gained recent attention for the diagnostic difficulty, inconsistent clinical presentation, and often rapid progression to osteoarthritis. Patients who are in varus malalignment are more at risk of experiencing medial root tear compared to the lateral, which is more common in a trauma setting. Going back to the basics, a root tear is defined as a tear 1 centimeter from the attachment of the root, a bony avulsion or a soft tissue avulsion of the root. Studies have shown that meniscal root tears lead to a biomechanical state that is equivalent to that of a meniscectomized patient. Extrusion of the meniscus out of the joint space, along with the altered biomechanics, are often the cause. Non-anatomical repair of a torn meniscal root has been shown to be biomechanically equivalent to a meniscectomy. And these findings underscore the importance of preserving the menisci, ensuring that all surgical repairs, especially those of the menisci, return the menisci to their native orientation. This is the classification of root tears given by Laprade, and there are extensions to this as well. What follows a meniscal root tear is this cascade. Following a meniscal root tear, you have the loss of hoop stress, which leads to meniscal extrusion. There is altered knee loading profile and leading to the loss of chondroprotective functions. There is reduced contact area of the joint and increased contact pressure. This leads to something called as point pressure changes, leading to damage of the cartilage. What are the treatment options available for an isolated root repair? Non-operative for patients who are unwilling or not fit for surgery. That would include a offloading brace followed by rehabilitation. Operative meniscectomy, which was followed for a very long time, but now isolated only for irreparable roots and patients whose arthritis has progressed to just give them some symptomatic relief. Meniscal root repair is the new trend. Single tunnel, double tunnel, transtibial pull-out, and that is the gold standard. HTO surgeries were also advised at one point of time, and I'll come to that. The indications for a meniscal root repair are very clear. They are meant for younger patients, especially those who are very active and who have not developed ipsilateral compartment chondromalacia grade 3 and 4 by the outer bridge classification. Contraindications, patients of advanced age, patients with progressive arthritis, increased BMI, and one which is very common is varus alignment, which is greater than 3 degrees. But what happens in the setting of a varus aligned knees? One has noticed that the medial compartment overload is worsened in tears in varus aligned knees, leading to meniscal extrusion and 25 to 40% rise in medial compartment osteoarthritis. The transtibial pullout technique can restore 70 to 80% of the native contact pressures and reduce the extrusion by 50 to 60%. However, healing remains incomplete. Isolated repairs hence do not address the biomechanical overload in varus knees, resulting in persistent medial meniscus extrusion and osteoarthritis progression. Opening wedge high tibial osteotomy is widely accepted treatment for patients with osteoarthritis and varus alignment, aiming to offload the medial compartment. Given the frequent existence of both the root tear and varus malalignment, combining root tear repair with osteotomy may enhance the joint preservation. So as we know what a high tibial osteotomy is all about, it helps in treating varus alignment. The purpose is to shift the mechanical axis of the lower limb from the medial to the lateral compartment, thereby reducing the load and reducing the contact area over the medial compartment. So there is no obvious consensus whether the addition of high tibial osteotomy is required in the setting of root repair in varus knees. But there are multiple studies show that root repair tear patients had more significant varus. And Jing and all had a study where he considered high tibial osteotomy in any patient undergoing root repair with a varus setting more than 4 degrees. This paper by the team at Ganga Hospital has simplified our search. The one on the superior most is very important, which mentions that anyone with 5-degree varus requires only a root repair. Anyone with 5 to 10 degrees of varus, you can add a HTO depending on the demands of the patient and the age of a patient. And any malalignment more than 10 degrees, there is an advice for a root repair with a high tibial osteotomy. The pre-investigations that is required, which I think Dr. Bhushan has already spoken upon, a good AP and lateral x-rays, long leg x-rays or scanograms, measure the amount of varus that is available and the amount that has to be corrected. MRI to see the root tear. Quickly coming to the surgical steps for a root repair with a high tibial osteotomy. One would first start with a diagnostic arthroscopy using the anteromedial and anterolateral portals, isolate the tear, debride the root so that the edges are a little free and clear. The tibial tunnel has to be, the exit point for the tibial tunnel has to be prepared by denuding the cartilage so that you can expose the subchondral bone. That helps a good bed for the healing purpose. Following that, an aiming device is kept at the tibial footprint. And the entry point for this aiming device would be anterolateral rather than anteromedial so that it does not converge onto the metal hardware that comes for the high tibial osteotomy. Following that, a guide wire is drilled through. A 4.5 millimeter cannulated drill bit is reamed over this guide wire, and a PDS suture is shuttled through the eyelet. Sutures are then passed through the meniscal root using any suture devices. Different suture configurations can be used, but we prefer using a luggage tag or a cinch suture using 2 fiber tape or fiber wire sutures. These sutures are then shuttled through the tibial tunnel And to protect these sutures, they are railroaded through the 4.5 cannula, which is pushed back into the tunnel to protect these sutures during the osteotomy procedure. Coming to the osteotomy, as Dr. John demonstrated, we would rather start with marking the hinge so that we can mark the hinge and protect the hinge. The incision is made on the anteromedial aspect, about 7 centimeters. You go down to expose the sartorius and the pes. The pes, in our case, we tend to divide it. And the superficial MCL is released on the anterior aspect, anteroinferior aspect, to expose the posterior border. Using a Cobb's retractor or any elevator or protector, you protect the posterior neurovascular structures. Guide wires are then drilled through under CM this to reach the osteotomy hinge. An oscillating saw is used to create the osteotomy. The osteotomy is pried open initially with stacked osteotomes, followed by the osteotomy jack, which is used to open the osteotomy. These trial wedges are then put as Dr. John demonstrated, and the osteotomy is then fixed using any of the plates available. Following that, and that image on the left shows how a drill bit is used to protect the sutures during passing of the screws in the superior holes. Following fixation of the osteotomy, you can complete the repair using a button on the outer aspect, on the anterolateral aspect of the tibia. So take home message, HTO has to be added in any root repair with varus greater than 10 degrees. The starting point for the osteotomy can be a little inferior if you want to avoid any hardware collision. And the pull-through sutures need to be protected during osteotomy and during fixation as well. Okay. Thank you.
Thank you, Baliappa. I think it was a nice lecture. I think we need to move on to Mr. Dr. Abhishek Gol. He will be speaking all arthroscopy codes, is it?
Yes, yes.
Okay.
Good evening, everyone. Special thanks to Dr. Arvind Prasad Gupta and Bihar Arthroscopy Society for inviting me. So, myself, Dr. Abhishek Gol. I work as an arthroscopy and shoulder surgeon in Rajkot, Gujarat. Today, my topic is all arthroscopic odds. So, coming to basics, as we all know, there are 5 types of cartilage in human body, but articular surface cartilage are made up of hyaline cartilage, and hyaline cartilage is having 5 layers. So, this tide mark zone is very, very important. When the cartilage damage occurs up to tide mark zone, fibrocartilage formation occurs. So as we all know, there is high prevalence of cartilage injury that found during arthroscopy surgery, but barely 5% of them are ICRS grade 3 and 4 that require surgical intervention. So there are 3 major techniques for cartilage preservation. One of them is microfracture, another is odds, and third one is ACI or MACI. So microfracture works well in lesion less than 2 centimeters square, but the major disadvantage is formation of fibrocartilage after microfracture and formation of intracartilaginous osteophytes and subchondral cyst. So nowadays trend is shifted toward nanofractures. So nanofracture owls are readily available in the market, or one can use 1 mm K-wire and goes deep up to 1.5 centimeter only using single entry and different trajectories. So microfracture is single state procedure that works well in low demand and smaller lesion. But the results are very poor after 5 years. So after microfracture, consider metal as a second surgery. Second one is odds. Odds works well in small to medium sized lesion up to 2 to 3 centimeter squares. The major advantage is formation of hyaline cartilage after odds, and it is a single stage surgery that works well in active patient and small and medium sized lesion. One of the disadvantages is donor side morbidity. And third one is ACI or MACI, that is matrix assisted autologous chondrocyte implantation. that works well in larger lesion more than 4 centimeters square. The formation of cartilage is hyaline-like, but the disadvantage is it is two-stage surgery and high cost, but it works well in large, deep, and complex defects. So other procedures are means cartilage, osteochondral allografts, stem cells, BMAC, and PRPs. So oats are definitely a healthier option for human body, as we all know. So indication of oats are osteochondral defects, grade 3 and 4 ICRS classification that can be traumatic, degenerative, metabolic, genetic, or idiopathic. And OCD, osteochondritis dissecans, grade 3 and 4 lesions that is unstable. There are some prerequisites for oats. That is, alignment should be normal within 5 degrees of varus or valgus alignment. Any ligamentous instability should be corrected along with oats, and adequate meniscus tissue must be there. Some of the contraindications are global arthrosis, bipolar lesion, inflammatory arthritis, infection, biomechanically altered joint line, diffuse degenerative changes, and severe obesities. So some of the complications are graft failure, donor side morbidity, infection, stiffness, and progression to arthritis. Not going detail into that. So few of my cases. Case number 1 is 20-year-old male with chronic ACL tear along with medial meniscus complex tear and medial femoral condyle osteochondral lesion. So this is medial femoral condyle osteochondral lesion. Lesion was debrided. Then this kit is readily available in the market with 2 separate graft and recipient harvester, tunnel dilator, and blue color temp. So first recipient size, recipient plug was taken using recipient harvester and margin was cleared. Then using donor harvester, graft is taken from the non-weight bearing area like sulcus terminalis, and graft was put to donor area using graft delivery tube. This is graft delivery tube. And this is after graft was put at the recipient side, and final taping was done using blue color temp. So this is final picture. And donor side was filled back with autograft, or one can use allograft if it is available. Along with that, ACL reconstruction was done. Second case is 22-year female with osteochondritis dissecans, type 3 unstable lesion of the medial femoral condyle. So this is big lesion of the medial femoral condyle. This is intraoperative view. So lesion was attached to native cartilage, not completely detached. So that is type 3. So cartilage flap was removed. That was around 2.5 centimeter into 2 centimeter. So we can have basic idea of the cartilage lesion size by using reamer. So this is 10 mm reamer. So we need to plant 2 plugs. So 2 plugs were kept. We should aware that more than 80% cartilage should be covered using donor plugs. Rest of the area can be held by fibrocartilage. And we need to make ensure that both plugs are within 1 mm of the native cartilage. So third case is the 40-year-old male with acute ACL injury. Along with that, lateral meniscus complex tear and lateral femoral condyle osteochondral lesion. So this is the osteochondral lesion. Debridement was done and plug was kept. So this is the final picture. Along with that, ACL reconstruction was done. So we can see the nice uptake of the graft by the end of 3 months. So this is the beauty of OTS. The patient can do floor sitting, full squatting, everything, because the cartilage is same, hyaline cartilage, no fibrocartilage, not hyaline-like cartilage, completely hyaline cartilage. So I have to skip this technique video because of lack of time. So take-home message is arthroscopic OTS is less invasive, less blood loss, and relatively cheaper option, and less chances of injury to the ligamentous structure, reduced post-operative time, and donor side morbidity can be avoided by backfilling with allograft or autografts, and larger osteochondral defects more than up to 3 centimeters square can be handled with multiple plugs. But the some of the disadvantages, difficult visualization, proper portal placement is very important. So we should not shy away from making another portal, and it is more challenging to stay perpendicular arthroscopically. And donor and recipient both plug size mismatch would be disaster. So plug should not be more than 1 mm proud or countersunk by 1 mm. That may lead to graft necrosis and donor side morbidity. If the graft is not properly taken, donor side morbidity may occurs. So knees are pleading to say, save me please. So awareness regarding cartilage injury is very important to doctors and patients also. Because I work in a town where 8 out of 10 doctors don't advise anything for cartilage injury. So that need to be changed. Thank you for patience hearing.
Thank you, Abhishek. I think it was a nice lecture. I think without wasting time, we would like to call Dr. Santosh Kumar. Is not there, no? Okay, so I think we'll have the double level osteotomy by Dr. Sahnawaz KP.
Respected Chair, seniors and dear friends. Thank you, BSc and Arvind sir, for giving me the opportunity. And I am Dr. Shanavas from Kerala. So greeting from the two institution where I work. Straight away, we will go to the case. It's a case scenario, 48 years of female, housewife, complaints of pain right knee, of insidious onset, gradually progressing over 2 years with difficulty in walking and limping and activities of daily restriction. There are no comorbidities. And the clinical evaluation is there is a tender medial joint line with patellofemoral joint also. Bilateral genuvarum, right more than left, which is partially correctable, and a range of movement from 0 to 110 degree, and no distal neurovascular deficit, and her BMI is 25 degree, spine, hip, and knee within normal limits. So this is a scenario, a middle-aged female varus with MCOA, early PFOF right knee. So what are things you should look for? So this is an X-rays. You can see the medial joint space, MCOA, patellofemoral OA, and genuvarum. So in evaluation, what all things you should take care of? Everybody has been highlighting regarding the scanogram. So definitely we should have a scanogram, long limb X-rays. And what alert you or warn you while looking at these scanograms? So if you draw a line, that the Michaelis line, if it passes too much medial or out of the knee joint, then that's thing you should worry about. So at that time, you should have some plans in your mind other than your high tibial osteotomy. So anything more to do? We should go for an MRI to look for the status of the cartilage and the meniscus. So these are the MRIs. You can see that middle compartment OA with middle meniscus degeneration and some patellofemoral arthritis too. So looking at this X-ray, what will you plan? Whether to preserve or replace? Arvind sir, what will be your plan? 48-year-old, middle-aged.
Yeah, definitely. This patient need knee preservation surgery. And my threshold for doing, though I do TKR also, but my threshold for doing TKR is very high. It's more than, most of the time, more than 60 years. So this patient's knee should be preserved. And you very rightly said, any line outside the knee joint, always think this is not going to deal with only high tibial osteotomy.
I think you can think about doing a UKR as well.
UKR.
But I think UKR, not the TKR. I'm saying the UKR, but the problem is this significant varus and UKR will high chances of failure is very high. So if you want to do a UKR, probably you need to do some sort of osteotomy to keep it
alignment,
5 degree of alignment.
making alignment right.
So the severe varus is against UKA, and young age, you have to preserve the knee itself. So if you're planning to preserve, you should have a proper planning. So you should look for the medial tibio-femoral axis. The Bhushan sir already highlighted the importance of your access to your digital planning. If you have proper access to softwares and digital planning, then your planning will be perfect. So you can see there is a 16 degrees of varus, and the MPTI is 83 degree and LDFA is 95 degree with JLC of 6 degrees. And the correction required after adjusting for JLCA is 14 degrees of varus. So what will you do? Will you go for a correction in one bone itself? And what will happen if you correct it over one bone itself? Sunit sir, can you add up a point here?
No, I mean, yeah, I won't do it a single level osteotomy in at this 14 degree of correction. I think probably a dual level osteotomy will give you much better chance of correction, much accurate correction, and joint line
Yeah.
will not be that obliquely oriented after the correction.
Exactly. That is the point we want to highlight. If you have a more correction required, you have to always go for a double level osteotomy, because if you have a joint line obliquity more than 5 degree with a single bone osteotomy, or if you have an opening of more than 15 millimeter, or if your planned correction of isolated open wedge HTO result in MTA of more than 94 degree, in all these scenarios, you have to think about a double level osteotomy. So double level osteotomy is to be planned. So you have to equally divide it between the femur and tibia, and the distal femur osteotomy is 7 degrees, and opening wedge high tibial osteotomy is 7 degrees. So there comes the questions. 1 millimeter is not always 1 degrees. So you should be very meticulous. You should plan your osteotomy length. So where exactly you want to go for the osteotomy or closing wedge, you should plan for the osteotomy length from the femur and the tibia. And you should have this trigonometric chart, trigonometric chart along with you in your OT to look for how much degrees correspond to how much millimeters. And this will be your plan. So the correction required for the preoperative is 14 degrees. And for a double level osteotomy, with the osteotomy length 7 mm and 7 mm, that is the wedge and the opening. To have a targeted MPT of 90 degree and LD of 80 degrees and JLC 2 degrees. So what is your take on this, sir? Everybody do a preoperative or prior to osteotomy and arthroscopy?
90% of the cases I do arthroscopy in, until unless it's not very bone to bone disease in which I'm planning to do osteotomy. Rest in all my cases I do intra-op arthroscopy.
So, sir?
90% of cases I don't do arthroscopy.
Don't do arthroscopy. But we 100% do a pre-op arthroscopy. You just clear off the, you should have, look at the cartilage status of the joint, patellofemoral joint, the inferior osteophytes, and the anvil osteophytes, intercondylar notch osteophytes, all things we will get cleared off to have a good range of movements. And sometimes there will be mucodegeneration of the ACL too, that we will have some debulking too. And the distal femur osteotomy, supine with the bolster, lateral subbossus approach, always you should look for the hinge point. I think Bhushan sir is ready in the theater with, he will be highlighting what all things to be, we should look for while doing an distal femur lateral coastal merge osteotomy. Your hinge should be near 1 centimeter from the adductor tubercle, and your osteotomy cut should start from 2 centimeter above from the lateral femoral condyle flare. And you should mark the pins. And the osteotomy will be always biplanar. You should have 2 vertical cuts and 1 horizontal cut. Then it will give a stable osteotomy. So all these things points you should keep in mind while doing a lateral femoral osteotomy. And once you have taken that wedges, just to have a compression over the femur angle will close the osteotomy, and you can put and fix it with the plates. So the wedge has been removed. While compressing over the heel, you can close the osteotomy and you can fix it with the plates. And the high tibial osteotomy, John sir had already highlighted what all things you should be very careful while doing, what all things you should be planned. Whereas 7 mm opening wedge high tibial osteotomy has been done. And the precautions and plans, everything has been covered in the live surgery. So this is the post-op X-rays and the post-op rehab protocols, partial weight bearing with a range of movements, and by about 6 weeks we will put her on full weight bearing. And these are the follow-up X-rays. You can see by meticulous planning and exact replication of the plan on the theater, you can have the value you want. And the patient is symptom-free and working happily. Thank you.
Perfect. I think nice execution and nice demonstration as well. I think we now closing the
Yeah.
session and proceed for the live session.
Yeah, thank you, Sanabas and Chairperson. We are proceeding for the live surgery 7, that is double level osteotomy around the knee. And surgeon is Dr. Bhushan Sabnis and Dr. Sandeep Birase. And moderator is Dr. Sanavas KP, Dr. Ajam sir, please, and Dr. Anup Kumar sir, please.
So we'll open, close on त्रास दिला तर करूया जाड wire आहे ते.
Bhushan
Ready
sir?
आहे? Can you hear me?
Yeah, you are very
So-
clear and loud, boss.
So while you were listening to those interesting talks, I've just opened the lateral side of the femur. Can you see the patient is supine?
Yeah. It's very nicely
Okay,
seen.
so all
Already
I've
we have
done till
completed
now,
something.
so all I've done is made a lateral incision, cut the ITB in a straight line, and passed to guide wires. Can you look at the Siam picture, guys?
Yes. We can nicely see your hinge wires and your osteotomy
I've-
and
So
wires.
the hinge, if you look, I haven't passed the hinge wire beyond the osteotomy yet. It just plays there. So because if you put a thick hinge wire like that, it will not allow me to close the osteotomy. We're going to do a biplanar osteotomy and you'll see that in hopefully in next 5 minutes. So I'm just waiting for the saw blade to arrive, which is
So
here
what is
now.
your plan to bed, sir? What is your plan? What is the size?
So the plan is doing a 8 mm closing wedge femoral osteotomy and 9 wedge tibial osteotomy to correct the deformity the way I want. Now, what I'm going to do is I'm going to try and be perfectly parallel to these guide wires. Cut. Good idea. Cut. So Sandeep is very clever, and you need a real luck to have someone who knows exactly what you want to do during surgery. So if you can see, I'm just putting one wire. आपको सिर्फ ऐसा करना है, tilt करना है ऐसे. Straight down all the way. थोड़ा सा कर हल्दी. The femur is a so I should be parallel to the bone. Can to the wire? Can you see that? I'm
Yeah,
bang on
clearly.
parallel. That's very important.
Yes.
Show me. Again. Need another couple of millimeters. Okay.
Do you routinely mark your saw blade with your osteotomy length?
Yes. So no, I haven't. I'm just looking in the screen now. This is a smaller blade, so it will not go beyond certain levels. So it's okay. So now the second one, same exactly parallel to the. So we are not playing with the slope here. So don't worry about the slope.
I'm just stopping for a couple of seconds only. We have arranged this iftar party in the back of this hall. So kindly those who wish to join, please join there.
Please alert.
Bhushan boss, you can.
सिस्टर संभाल के रखो, संभाल के रखिए, यूज करेंगे.
एक सेकंड, let me just reposition. असं धर फक्त.
So you have taken the two vertical cuts. Now we are planning to take the horizontal cut.
Yeah, I'm doing the two vertical cuts just now. X-ray. So that's deviating, as that happens a lot. X-ray. So that's better. So I'm going near the first part.
So the Homan below is protecting all your soft tissue there.
And again, that's better.
The Homan below is protecting the soft tissue.
Sorry, I can't hear you with the saw blade on. Just give me a minute to finish the osteotomy. Blunt है सगळं त्याच्यावर. Blunt है.
बारीक ब्लेड.
इसमें छोटा ब्लेड है अपने पास, छोटा लगा देंगे.
ये चलेगा.
Bhushan sir, how much is the width of wedge you have planned?
So 8 mm closing wedge on the femur and 8 mm opening wedge on the tibia. If you can see the images, the JLC is quite high in this patient. So
Okay.
there'll be a lot of correction achieved by soft tissue also. So I've subtracted that. Down. एक मिनट in the right hand corner. It's always the posterior cortex which stops you.
Yes.
So that Homan position is very important.
8 mm is a pretty small wedge, I think, to take out and use. Will you use it in tibia?
This blade is bending quite a bit. I'm sorry. Just give me a second. That blade is bending quite a bit. So I just need to. Normally you do 2 clean cuts and then you're done. But unfortunately, this blade is a bit flimsy. It wants to bend when it's going inside. So I just need to see what I'm doing properly so I can do justice to this. I enter thoda sa plata. I think you can manage. So normally you would see a nice bone wedge coming out. Sometimes you don't see that. That's fine.
You're planning a biplanar in this, in femur?
I always do biplanar. X-ray now. Yeah, that's better. X-ray again. Yeah. Good. Again, yeah, that's better. Now it's going. Again, shoot. Yeah, that's better. You see what I was trying to do was flush onto the wire. So now that I have done the shoot now, so you can see the bone, majority of bone has been taken off. Now I will just do a biplane and then we'll try see if we can do any biplane osteotomy. Let's see. Chal. Saw blade again. तो बड़ा वाला देना मुझे वापस.
So what's the angle of plane that you will keep at the...
So if you see the osteotomy, a lot of you will think I'm too high, but the apex has to be at the supracondylar ridge on the medial side. And when I close the osteotomy, there shouldn't be a step. So these 2 limbs have to be perfectly parallel.
Yes, sir.
एक लैंगन बैग भी हाथ में आप ये पकड़ो एक लैंगन बैग दे सिस्टर्स को show me this part. So now I'm going to do biplanar osteotomy like that. There's a bit of space left for me to do biplane.
So what's the angle of plane that you will...
Repeat that question again.
What is the angle of plane? This angle.
So this is 110 degrees. That's a standard angle for every biplanar osteotomy. Good. Shoot. Yeah. So that's better. Almost done. Okay. Now we are going to see if my osteotomy is done or not. So first I'm going to just clear the biplane. Should normally it's always left. That part is always left. That's the rule. So I'll either take the saw again or try with my osteotome. If I can go through. Up. One osteotome on the floor, sister. I'm sorry. Thumb. X-ray there. Thumb. X-ray again. So this part needs to be cleared. If it's not cleared, you will find that your osteotomy becomes grossly unstable.
Bhushan sir, the biplanar part you do through and through?
Through and through.
And the
Otherwise, osteotomy will never close.
And the hinge is maintained at the supracondylar ridge.
Yeah. So can you see the image here? Can you see the screen here?
Yes, sir.
See the osteotomy closing?
Yes, osteotomy is closing.
Okay. Bas. Perfect. Bas. Okay. So you can see the osteotomy is almost closed now.
Yes, sir.
Okay. So that's the lateral distal femoral osteotomy done. I'm going to close it by a couple more degrees in a second. So all that is required is just axial pressure. That's all.
That's all.
So the hinge is not essentially broken yet. Can you see? Show that, please. See the hinge is intact?
Yes, sir.
Okay. Now he can push the hinge wire inside.
What's the threshold of a DFO? How much?
I'm sorry?
How much wedge do you maximum?
I normally go up to 12 millimeters.
Okay.
Beyond 12, it becomes difficult to save the hinge. If it's
Yes.
more than 12 millimeters, I do a double osteotomy. So I do osteotomy from medial side as well as lateral side at the same time then.
Medial of the femur.
So I'm writing that up. I'll soon show you. I think I presented that a few cases of severe deformity correction by doing a double osteotomy in the femur. So you do a lateral closing wedge and a medial opening wedge at the same time.
Same time on the same femur.
Same position.
Oh God. Only you can do it, boss.
It's something fun, man. You need to do something interesting in life. What's there about? If you don't get any adrenaline, what's the fun? Just hold the knee like that. Okay? Pass. So all that is required now is just putting the plate, sister plate. So can you see the osteotomy is almost closed?
Yes, sir.
Okay. So I'm just putting the plate. You can take a talk in the meanwhile, and then we'll come back to open the.
Sir, we are all with you. Not an issue.
Okay.
Arvind, do we have anything else to do?
Little bit.
कुछ और करना है सर कह रहे हैं कुछ और कर लो नहीं सर हम आपके साथ ही हैं सिद्धार्थ है
आप ही के साथ हैं
अरे बाप रे सिद्धार्थ
स्टेप बाय स्टेप
Bhushan sir
मुझे
we
tension
are
आता है।
mesmerized by your surgery please go ahead we are enjoying this
तसलीम होता है। मुझे एक कोई केवार दे दीजिए कोई भी एक मिनट
मैं मैनेज कर दूं।
एकदा एक्सरे करूया एक्सरे दाखव एक्सरे बंधू शूट so wonderful can you see the plate sitting there perfectly I'm just going to hold the
little down.
yes sir
yes
okay you can go down a bit slightly down it's fine
so can we
That's
have
enough.
a question Bhushan sir please
If we are not what is the tips? Any tips by
क्या चाहिए बोलो drill what do you want to know
वो नहीं कर पा रहा है कहाँ प्रॉब्लम है और उसको कैसे डील करना है
इसका स्लीप हाँ
वो दिखता क्या है
I'm sorry I can't hear you what you're saying
What is the
Can you
question?
repeat करेंगे तो मैं थोड़ा I can give justice otherwise
by doing closing wedge
ठीक है
Bhushan sir
हाँ
if we are not able to close the wedge then what could be the reason why the wedge is not closing
and
most common part is you haven't done a triangular correction give me 50 50 50 50 दे दो
or there may be spikes somewhere
50 on power possible है तो दे दो perfect sister क्या बात है
Basically, the cortex that is on the medial side is not too much malleable. Most of the time it's happened. It's closing wedge most of the time. So if you think it's not getting close, you can propagate little bit more this osteotomy. That's it.
चलो drill we'll put 3 screws first उसके बाद में करेंगे पकड़ा है
Already doing the
one more distance
osteotomy
screw
there.
this plate goes much more distal than expected so give me 60 sister now and one more 50
Shoot 60 only.
50 and 60 मैं पूरा drill नहीं किया so when you're putting this plate what you will find is that your osteotomy position has to be slightly proximal 50 60 भी दे दीजिए फिर the sequence of fixation is typical you fix the screws towards the joint first and after that you fix the screws in the proximal part now once I've got 3 screws I'm happy with my plate attachment to the bone so I'm going to lock them using a torque screwdriver so any plate you use
स्क्रीन पे थोड़ा लाइट ग्लेयर कर रहा है उसका स्क्रीन का एंगल थोड़ा चेंज कर सकते हैं तो
okay sister I will now need a cortical screw to compress अगर है तो इसमें cortical screw है सिस्टम में है ना हाँ चलो उसका डिफरेंट ड्रिल होता है
I don't think sir it is there.
नहीं है चलो गिव मी सेम ड्रिल चलेगा सेम ड्रिल
Langen back please.
सिस्टर सॉलिड फॉर्म में एकदम चलो आज सब कुछ दे रहे मुझे मांगा वो
You want to do proximal number?
Arvind
Yes, sir.
can I steal your sister
Boss, as you
मैं
wish. You
जो
are
मांगा
welcome.
before I ask that is there यार क्या बात है
Babies.
अभी कॉर्टिकल लगा गोल्डन स्क्रू सिस्टम हमें दिस इज 48 40 46 46 50 जो हाथ में मिलेगा
46
वो बाद में निकलने वाला है दैट इज ओनली टेम्पररी इसके बाद में सिस्टर विल टेक आउट दैट केवार any doubts any questions so far about what we have done
Could you tell about the placement of the plate? What are the landmarks we use or something like?
So what's important is before you start, before you put your guide wires, you need to make sure that you put the plate on the lateral side of on the bone. Exactly, Bandhu? Yeah. So it's could have been longer, but that's fine. Let's take this guide wire out and let's fix the plate proximally. Okay. Give me the drill sleeve. So another 5 minutes, we should be done with the lateral DFO. And while Aman is closing it, we will do a quick HTO. So what you need to do is every plate system is different. So the width of the plate where the osteotomy sits has to be marked on the bone before you proceed with anything. If you don't do that, you will end up having a screw hole over the osteotomy site. And that's a nuisance most of the times.
So before doing osteotomy, you always mark this with the
Put
plate.
the plate on the bone.
Yes.
Get an X-ray done. Confirm that you're happy with the position. Guide wires, because otherwise if you don't do that, suppose you're using a nuclear plate here, it will go far more, the osteotomy will be much more distal. Same with biotech.
Bhusan sir, there is a question from audience. Since
Yeah, go ahead.
it's already a closing wedge and it's very stable osteotomy, and you did in two planes. So they are asking about the advantage of doing biplanar closing wedge osteotomy on the distal femur.
So just all of us are trauma surgeons to begin with. Just imagine two fragments which are completely unstable, and that will happen, and that will cause a lot of issues if your osteotomy becomes completely unstable. So if your hinge breaks, which will happen in 60-70% of cases, give me 45, sister, and give me 36.
You are right, boss. At the same time, this gives rotational control also. At the time of closing, it sits completely over that, and you can appreciate that there is no mild rotation along with the closing of the wedge.
36, perfect. So once you got a few screws up and down, you're fairly happy with the security of the, or fairly happy with the stability of the osteotomy, and you're secure in your mind that it's not going to go anywhere. Okay. Now, I always like to fill all the holes. Some of you will say, what's the need to put the distal hole? And I might leave it today because that is slightly anteriorly. Anteriorly, leave it. Okay. So when I was fixing the osteotomy, a plate has come slightly anterior. So it's possible when I might struggle to put the screw in, but let's see. I would like you to see me struggle. So
Let it be something.
no, so what we can do, the advantage of peak plate is we can change the angle. So the basic advantage of the peak plate is that you can go, hang in back here, is that you can change the angle by about 12 degrees up, down, north, south, whichever way you want. So I can change my trajectory, and it's a unicortical screw. I'm happy. This will look a bit odd, but that's fine. And give me 30. So that screw is going to look a bit odd on the C-arm because it's going more anteroposterior. I'm trying to get an engagement of the screw in the cortex. Okay, so don't be alarmed about how it looks. The advantage of a peak plate is that I can change the angle trajectory of the screw by about 12 degrees in every direction. So I can still get locking of this screw. Okay, let's put two screws distally. Take it off. ये हो गया. Lying back नीचे लगाओ. Drill sleeve again. So just one more screw left, and I think we're done with the osteotomy. Good. It's 50. So DFO is actually, I feel, easier than a HTO because there is only single bone to work on, but at the same time, it's easier to get wrong. So if you're not careful enough, you might end up breaking the bone completely, and the hinge fracture is a nuisance when it happens in DFO. It's actually fairly easy to manage on the tibial side because you are Take. So that's your, let's have a look, X-ray guys. So can you see that? You can see the hinge is not broken. My alignment is already looking much better. So I'm just going to do a HTO. Sister एक gentamicin या vancomycin वाला swab दे दीजिए. सियाम पीछे ले लीजिए. अगर आपको सियाम इस तरफ से आना है, हम लोग इस तरफ से करेंगे.
हमें उधर जाएंगे.
चलो. चलो. Are we okay to continue, Arvind, or?
Yes, we are with you, sir.
चलेगा या? ठीक है. चल. Another 15-20 minutes for HTO and we'll be done then.
Yeah, we are with you, sir.
करूँ चालेल? So standard incision for your peak plate. Now I don't do a double incision for a peak plate. For tomofix, I will do 2 forceps and scissors. For tomofix, I will do a double incision normally. But for this, I think it's easier to do a normal incision. Cautery. Now, those of you who have seen me in action before know that I like to do a inverted L-shaped cut on the proximal medial tibia, such as that. Now, I'm a bit ruthless about your. ऊपर लगाने दो इसको.
Cameraman, थोड़ा incision पे focus करें.
You put it on this side.
बस perfect. ऐसे ही पकड़ना. दांत में पकड़ना. Okay, I'm just continuing. If you are not able to see, just stop me. I will wait for you guys.
No, you sir, continue, sir.
So I'm just using my diathermy for dissecting the pes fascia. थोड़ा आपका section पीछे ले लो. उनको दिख नहीं रहा. So I like to say subperiosteal as far as possible. So that's your pes fascia coming off, and about halfway through, I'll start seeing the MCL here. So in a minute, so can you see the MCL, guys?
Yeah, very nicely.
And that's the semity here. So we are going to be ruthless with the MCL. I think I've cut quite a few MCLs in my lifetime and have never regretted releasing the MCL fully. So that's the MCL coming off almost completely.
That is the key of one of the steps to release the MCL. Then only you can get an adequate.
Don't release the MCL, you're going to struggle big time with your surgery.
Yeah.
And if you see what I've done, I've turned my cautery. I bend the cautery tip. I'm just going to go behind the tibia and just clean the back of the tibia like that. Now the periosteum elevator is done to go and hit the back of the fibular head all the way. So that's your target. So I'm actually hitting the fibular head here. I like a curved periosteum elevator, but that's fine. That's not a must. Now we'll just do anterior dissection also. Now, since we're doing a biplane, sister, can I have scissors, please? Dissecting scissors and a small Homan. So now I'm going to isolate the patellar tendon here. You can do it in extension easily, or you can do it in flexion like that. So that's the patellar tendon isolated. We'll take a small Homan. जो है वो दे दो चल.
जो है वो चलेगा.
और अपने को 2 गाइड वायर लगेंगे. सियाम सामने से रेडी है बंधु आप? हम लोग 2 मिनट में रेडी हो जाएंगे. चल हाँ. अभी पहले जो दिया था भाई. थोड़ा पैर सीधा करें, थोड़ा पैर सीधा करें. बस. This is too big for us. So what I'm going to do is just put
it on the interior, sir.
Bhusan boss.
Yes.
We are shooting little bit time, so we'll come back to you once you finishing this HTO part.
Okay, so, come back in after one talk or something, and we'll be osteotomy by then.
So, and you have to also finish surgery quickly because you are the moderator of panel discussion of.
I will see if we can have time, but we'll see about that.
Yeah,
okay,
definitely you will finish on time, boss. So, thank you, moderator, for this live surgery. So, next we are moving to A to Z of patellar dislocation, and moderator is Dr. Sunny.
Sister, HTO का plate दे दीजिए हमें. ले लिया? शाबाश.
So moving to our next session, A to Z of patellar dislocation. Our chairpersons are Dr. Rajiv Kumar Gupta, Dr. Jivendu Chaudhary, Dr. Gyan Ranjan, Dr. Arun GR, and Dr. Vidya Sagar.
And Dr. Ayan, please join on the stage as a chairperson,
So-
please.
So So our first talk is MPFL reconstruction by Dr. Shwetab Rai.
Good evening, everyone. And thanks, Bihar Arthroscopy Society and Dr. Arvind for having me here. So my topic is MPFL reconstruction. And I'm going to share two cases, and before that, little bit of literature about the MPFL. So this soft tissue structure was first described by Kaplan in 1957 and later on named by Warren and Marshall. And they located that it is actually in the second layer of the anteromedial knee. As we can see from this beautiful anatomical specimen, the origin of the MPFL is from the back of the femur between the adductor tubercle and medial epicondyle, which is a saddle shaped structure known as Shortle's area, and is inserted on a broad insertion in the proximal part of the medial patellar border. The length is around 50 to 60 millimeters. And it is important to know that the MCL has a vastus medialis obliquus and magnus, adductor magnus are closely related. 60% of the medial restraining force during knee extension and early flexion against the lateral forces is contributed by the MPFL. And it can stretch only 18 to 20 millimeter, which is far less than the patella width, which is around 40 millimeters. So, and it has been seen that in about 50 to 96% of traumatic dislocation, it is deficient. So it is, we can say that the MPFL rupture or deficiency is actually the effect and not the cause of patellar dislocation. Coming on to the biomechanics, the femoral fixation point is the key because it significantly impacts the length change pattern and overall the result of the MPFL reconstruction. And this point has been extensively worked by various authors, and this is known as the Shortle's point, which actually lies 1.3 millimeter anterior to the posterior cortex extension line as shown in this figure, 2.5 millimeter distal to the posterior origin of the medial femoral condyle. But but this is actually described for the normal knees, and sometimes in hypoplastic knees or dysplastic knees, we need to have some other measure also. And if the anteroposterior size is 100%, then the MPFL attachment is 40% from the posterior and 50% from the distal and 60% from the anterior. So these various factors have to be kept in mind while deciding for the femoral insertion point. So in order to have a good result. If you look at the indications, it is basically indicated in symptomatic recurrent lateral patellar instability when the conservative treatment has failed, or if it is demonstrable that MPFL is insufficient on the basis of imaging or examination. And it is also used as an adjunct to bony and soft tissue procedures in more complex patterns of patellar instability. If we look at the graft choices, gracilis double bundle is actually having the most similar biology as compared to the original MPFL, but frequently semitendinosus and cordyceps tendon strip or even patellar tendon have been used. Allografts are used in revision cases, but between the various grafts, there is no clear superiority, but mostly hamstrings are used. But we should also have an idea to use the other grafts. The main principles are that you have to correctly assess the Shortle's point. For the patellar attachment, if we have noticed, it's a broad insertion. So it is a double socket is preferred, but then again, there is chances of iatrogenic fracture are more. And for the single socket, we go for the proximal 1/3, mid 1/3 junction. If you are going for two sockets, proximal 1/3 and center are taken. The graft is usually passed through a tunnel under the medial retinaculum in the second layer. We try to keep it extra articular. For the fixation, the patellar fixation is done first using anchors, or even suspensory fixation can be used. And with there's a lot of literature, but mostly the consensus is of having a knee at 30-degree flexion, keeping the patella in center of the trochlea. We should fix the femur with an interference screw or suspensory or anchors. And some lateral translation should be possible. We should avoid over constraint because it can lead to risk of patellofemoral overload, pain, and arthrosis. If you look at the outcomes, the recurrent dislocation after a good MPFL reconstruction is less than 5 to 10% in most series. And there is improvement of the various scores and high return to sport rates. Now, this is the first case. It's a case of a 26-year-old male who had complaint of pain and inability to straighten the knee and a sudden locking around a week back. His ACLR was done about 9 years ago. There was no generalized ligamental laxity. The Lachman was, anterior translation was exaggerated, but endpoint was firm. There was medial joint line tenderness, and apprehension test was positive. On the X-ray, the ACL tunnel seemed okay, and the MRI showed medial meniscus tear with intact graft and MPFL, which was normal. So for all these surgeries, we should always do a diagnostic arthroscopy first. And in this case, do the intra-articular work before. So the ACL was found to be lax, and there was a complex bucket handle tear. So the ACL graft was prepared using the peroneus longus, and the MPFL femoral tunnel was prepared by using C-arm. Then the partial meniscectomy and ACL tunnel preparation was done. And because I used the quadriceps tendon graft in this case using a open stripper, and this is how it was taken out. Then it was passed, and then the ACL was fixed, and this is the final follow-up showing good stability, and these are the X-ray pictures and function. The second case is of an 11-year-old girl who came with history of frequent falls and difficulty of straightening the knee, and there was no generalized ligament laxity. And this was the clinical picture with, as we can see, with every flexion, there was a dislocation of the knee. Now, patellar instability in children, it's a spectrum, and in this case, it was habitual dislocation flexion. So these instabilities are more complex with associated muscular problems also and associated rotational problems. So X-ray was done. In the lateral X-ray, we can see the patella is lying on the lateral side and it's outside the trochlear groove. The physes were not closed, the alignment was normal. MRI was done to look for any intra-articular pathology. And there is a hypoplastic MPFL which can be seen. So in this, because the problem is multifaceted, so you have to go on a la carte base. And initially, to start with, we have to go for the release of the lateral, superolateral structures and see how it is contained and check for the flexion. Then again, go for further procedures as required. And an MPFL reconstruction is done for a check rein effect. So this was the final picture. And this was the containment after the surgery, which was checked. So a lateral release, MPFL reconstruction and VMO advancement was done. And this is the final picture in which the patella is now positioned normally. And this is the clinical picture of the current follow-up. And these are the X-rays. So the take home is that MPFL reconstruction is effective for recurrent patellar instability when performed anatomically and combined with correction of underlying risk factors, and femoral tunnel positioning and graft niching are critical determinants of outcome. Thanks. Yeah.
You done with the talk?
Live चाहिए?
What
think,
percentage of your cases you are able to get away just doing a MPFL?
I think in
Live
most
जाएंगे उनको
traumatic
बताएंगे please.
cases, I am able to handle with isolated MPFL reconstruction, and in only a few cases, in my particular cases,
So
I
you
need
think-
to go for a bony
I
additional.
think 90% of the cases that would come to you
Ready?
would have a
खत्म हो गया,
traumatic
case खत्म हो गया, बोल दीजिए.
incident. So most of them,
दिखा रहे
while
बाबा?
getting down, they would have a fall, which they'll say they had a fall, but they already had something predisposing them to the dislocation.
So we always have to have a look at the bony anatomy with the help of a MRI and CT, and we look for the trochlear dysplasia. We look for the other our tibial tuberosity TG ratio, and on the basis of which we can decide whether
No,
we can.
I totally get that. But say, out of 100 cases you've done, how many times you have ended up doing something else? Just as a ballpark figure.
I think in my set of practices, I think I don't think more than 20-30% cases I actually need to do. In fact, I have never done a trochlear plasty, and sometimes in severe cases in adults, I have to need to do the tibial tuberosity transfer.
Thank you, Shotab, for the excellent talk. The next speaker is Dr. Amrish Jha, who will talk on tibial tubercle osteotomy, when and how.
Good evening, everyone. Good evening, Chairperson.
Amrish, they are just will take hardly a minute there in the OT.
Yeah.
They are ready with this. Sabnis boss?
हो गया surgery हमारा.
Listen, boss.
So you can, yes. You can see the lateral view done. It's all looking fine. The plate is slightly proud anteriorly.
Listen, boss.
हाँ सुनाई दे रहा है?
Am I audible?
Yeah. So can you show the screen यहाँ पे पीछे? Can you
Yeah,
see the alignment now? HTO done.
Yeah, it looks very good.
Okay. And can you show the AP view पहले का इसका पहले वाला view? So you have fixed it. I'll show you the AP view. Yeah. So that's the AP view. We have fixed all the holes now.
Yeah, it looks very good.
Okay.
Alignment वाला.
So everything done, and I just want to show you one thing. एक AP के लिए आ जाओ बंधु. Just one. I'll take it. Verendo. Siam आ जाओ. So I'll show you how the JLCA works, so you understand what I'm talking about. चलो AP के लिए आ जाओ यहाँ पे. You have to trust me that I've got the perfect alignment on the using the rods also. एक बार दिखा दो मुझे X-ray. Now you will see the joint is closing on the medial side. नीचे आ जाओ, मेरी तरफ आ जाओ, and you can see the JLCA is still causing some effect. Can you see that? Can you see that? It still looks varus, but now X-ray again. See that? So that's called the concept of hypomocleon. So when she starts weight bearing, the joint weight will cause the medial side to open and lateral side to close. And this is the normal alignment with the Mikulicz point about 57-58%. So we are signing off from here. Thank you all very much. Any questions? I'm more than happy to come and answer.
Thank you, boss. Very good demonstration of double level osteotomy. Usually, it's really very good surgery.
चलो छोड़ दो बात क्लोज कर लो.
Okay.
इनको करने दो अभी 50 मिनट ना. आप कर दे क्लोज. दोनों कर देंगे. चलो. Thank you very much.
Aman, you'll do it, huh?
So I would like to thank Bihar Arthroscopy Society and
ट्यूब हो गया ना इसमें. ऊपर नीचे दोनों कर.
for the invite. So my topic is tibial tuberosity.
Thank you.
Osteotomy.
Thank
It's
you.
a very commonly
ये नीचे गिरा है बाद में देख लेना.
nowadays. As we gradually our understanding about the patellofemoral mechanism is increasing, and instability and other problems are more frequently picked up by the surgeons. So we are gradually doing more and more tibial tubercle osteotomy. So it's a
the typical indications are patella alta, sometimes for the patellar instability and sometimes for the pain and osteoarthritis also. The goal is to move the tibial tubercle in a direction that will either improve patellar tracking or offload the medial or lateral patellar facet to decrease the pain. And isolated TTO is very rarely indicated. We should know the proper, the indications of other surgeries also. And most frequently we need MPFL reconstruction along with TTO. So the patient should be skeletally mature, and we should know about the lateralization and patella alta, and for that there are some index and some calculations. So we must know about these. And this is a screenshot of a lecture by Dr. Fulkerson, where he had clearly mentioned that trochleoplasty is nowadays very rarely indicated. So with regard to the next speaker, Sunita, but I had to mention this. So the importance of TTO has increased based on this also. So we must know about the few angles like Q angle. We must know about TTTG distance. So these are just the recapitulation. The juniors must know about these things. And these are few sulcus angle, patellar tent angle. And the important thing is this CDI. CDI is the proper, indication to measure the distance, and it indicates the patella alta if it's more than 1.2. And other indicators are also there, like insole salvati index. So I'm not going into detail of these calculations. So proper clinical evaluation must be there, and you should be clear why you are operating the patient, whether it's because of cartilage injury or because of pain or because of instability. So whatever may be the reason, if it's a cartilage because of relief of pain, offload of the patellofemoral joint, then it's just anteriorization. And if it's an instability, then you must know about the patellar apprehension at 45-degree flexion and J sign in extension. So jumping sign is a poor prognostic indicator for these surgeries. And in these cases, you must include some bony procedure along with the soft tissue procedure. So now indications being, if it's in instability, if the J sign is positive or the apprehension test is positive, and if the CD index is more than 1.4 and TTTG is more than 20, so it's a perfect case of TTO. So the TTO types there are so many types of TTO, but basically we deal with anteriorization and medialization and distalization. These three types are very common, and we should focus on that only. So the TTO was invented by Hauser in the year 1938, and this was just transverse translation of the tibial tuberosity. And then Fulkerson came with the concept of this oblique osteotomy, slope osteotomy, and it took 45 years just the transverse osteotomy to become oblique osteotomy. And depending on the types, it may be anteriorization TTO, and it is commonly indicated for pain relief and never for patellofemoral instability, but it's there for pain relief or to decompress the joint. Straight anteriorization TTO, it was classically done by Maquette anteriorization technique, and which later on modified by Fulkerson, and it gives good relief of pain if the cause of pain is patellofemoral overloading. Then medialization is there for some time, but nowadays we commonly perform anterior and medialization. Distalization TTO, when your CDI is more than 1.2, then you can do isolated TTO. And nowadays we say that the patella alta is less underdiagnosed. What we diagnose patella alta, it is underdiagnosed. Our incidences are much more higher. So we should be suspicious of patella alta in these cases. So anteromedialization is the typical Fulkerson procedure. And if the patient has normal proximal and medial patellar chondral surface, and the patient is having just instability problem, then we can go with this. So these are few pictorial, and this is the exact my way of doing Fulkerson's TTO. So after you do the intra-articular inspection and intra-articular procedures, then you go extra-articular. So this is just inspection of the patellar chondral surface. And if there is any chondral injury, and that should be dealt properly, and then you come to the open procedure. The skin incision is pretty simple. It's a midline anterior approach. You should not undermine the skin. You should have very good flap of skin along with fatty tissue to prevent the wound complication, because in enteromedialization TTO, the incidence of soft tissue problems are slightly higher as compared with the Hodger's procedure. Once you decide the level of osteotomy, you clear medial and lateral side of the tuberosity. You just put two K-wires just to mark the point of, fixation later on. Shit. Sorry. The patellar tendon should be cleared of tibial tuberosity and you should not damage it iatrogenically. And once drilling the guide wires or the K-wire, the proper osteotomy is performed. Your slope of osteotomy will dictate the anteriorization and medialization. So depending on your calculation, the slope can be decreased or increased. And then calculate how much you want to medialize, and accordingly you shift the tibial tuberosity and stabilize it in that new position, and then mark for the screw fixation, point of screw fixation. Once you satisfied with the position, drilling is completed, and you must countersink the screws to minimize the irritation of soft tissue.
Amrish boss.
Yes.
So this amount of enteralization as well as medialization, how you decide how much you should be doing that?
Medialization depends on TTTG difference. Suppose normal TTTG difference should be less than 20. Suppose if it's more than 20, 25, then you need to medialize by 5 mm. So it depends on the TTTG difference.
And enteralization?
Enteralization, it's all, just how much. Basically, there is no clear-cut guideline of how much you can enterize. So it depends on your clinical and arthroscopic, it's a guesswork. How much you want to relieve the compartment. There is no clear-cut calculation for that. For distalization, CDI index is good enough.
Yeah, definitely.
And
for suppose this enteralization, someone needs 1 centimeter, 10 millimeter, someone needs 5 millimeter. Suppose orthoscopically or by seeing the MRI, you have decided that 5 mm I'll enteralize in this case and 10 mm I'll enteralize in that case. So how you will perform the surgery at the time of osteotomy?
Medialization, you are asking about?
Medialization done. You are absolutely right.
Yeah, if you are increasing the slope.
Yeah, absolutely right. So
If you are
cut
increasing
angle,
yeah,
that will give you the amount of enteralization.
So
If you are cutting at more angle, suppose
then
45
will be
degree,
more, yeah.
yeah.
So
Around at 45 degree, it will be around 10 millimeter of enteralization. If you decrease the angle, so enteralization will be less. Suppose at 30 degree, it will be around in between 6 to 7 millimeter. Slowly, this will get decreases.
So for a 25-degree angulation, you get a correction 2:1. So 2 millimeter medialization will give you 1 millimeter elevation if you are.
No,
25
medialization will depend how much you are shifting toward the medial side.
No, so
This is direct.
that is also dependent, because what I'll tell you is this is a slope. So as you are ascending up the slope, the more you medialize, the more you are anteriorizing. So that angle, 25-degree angle, will give you a correction of 2:1. So 2 millimeter of medialization will give you 1 millimeter of anteriorization.
So iron, the maximum anteriorization will achieve at the edge when you place your osteotomy, tibial tubercle at the edge of osteotomy where you have cut. If you go more medial, this will go down.
No, but
because
that is
tibia
a
is
pretty
like
big
this.
piece, Arvind. So you see that the proximal part of that osteotomy, you are going through the metaphysis, that's a pretty big piece. So even like there have been situations where I've actually done almost like 12 millimeters of medialization. But that is a gross calculation. What you are trying to ask is
I'm just saying the amount of obliquity of your cut of tibial tuberosity, if will you give the maximum anteriorization? If you want to have suppose more than a centimeter of anteriorization, then minimum cut has to be 45 degree or even more than that.
So
if you are
45
cutting on less angle, yeah, definitely. This is
So 45 is 1:1. So if you go
Yeah.
45, then you for every
1 centimeter anteriorization, 1 centimeter.
But
yeah.
not to
Exactly.
forget, too much of interiorization will cause more of wound problem.
Yeah, wound problem.
you
Many a
should
time
be-
there will be compartment syndrome also. There will be wound dehiscence also.
And whenever you increase the slope, there are chances of,
Cutting the
iatrogenic-
tibial condyle increases.
Yeah.
Yeah.
So it should be judicious and should not
Absolutely
be 5 to
right.
10 mm.
Yeah.
So after fixing it, after you have countersunk the screws, normal wash and then closure. So the one thing to be noted is you should not anteriorize too much. Medialization is okay. Distalization you can add on whenever you want. So this is for TTO for anterior knee pain. I am not going because of paucity of time. Now we have come up with multiplanar TTO. So results are shown to be better than this, but it's still in the process of evolution and literatures are lacking on this. And outcomes have been shown very encouraging of TTO, and there is no need of further justification for that. There are hundreds of literature stating that the results are very good to excellent in almost all cases. And coming to complications, non-union are reported is less than 5% in most of the studies, but sometimes it may be more. And proximal tibia fracture is a growing concern. And you should be aware of this complication and you should take all the precautions to avoid this. And sometimes symptomatic hardware, that is not a big issue, and that can be, well taken care by for just removal of the implants. So low risk, the fracture risk is when there is notching. So Fulkerson told us clearly in the last meeting, if there is no notching, there are no chances of iatrogenic fracture post-operatively. So take-home points are TTO type depends on the anatomy, radiographic alignment characteristics, and you must know about these calculations and the presence of chondral defects, whether it's medial, lateral, whatever. And it should be done in properly indicated cases, of course, and should always be coupled with some other soft tissue procedure if indicated. And the notching should always be avoided to prevent fracture, and which is a growing concern. And excessive slope should it should also be prevented. And maintaining the distal hinge, if you are going for distalization, it reduces post-operative complications, especially non-union. Thank you.
Any questions from the audience? Our next speaker, any questions from the audience?
How many percentage of patient you in a revision reconstruction, or you have seen in your practice that only was done, it failed and you had to do TTO? Because TTO nowadays it is increasing more and more. We are concerning on TTO, but before 5 years, 10 years, everyone we used to do MPFL. And so do you find those of your patient, they have come to you that, okay, my knee has, patella has gone again?
No,
From floor also I wanted to know. How
If-
many of your MPFL has failed in those borderline 1.4 CD, CDI, trochlear dysplasia, C or D type, and you have done only MPFL?
Not yet, not my MPFL reconstruction failed yet, but there are certain percentage of cases where it may fail if your planning is not preoperative. Planning
So
should be
from theoretical, definitely we know type B, type D, we have to do trochleoplasty, but we are not doing trochleoplasty and we are happy with our patients.
So in case, as I told Amit, this patella alta is probably more frequent than what we know or we expect. So distillation procedure, probably it will help to reduce the recurrence after MPFL reconstruction. That is important. That message should be very loud and clear.
One question more. What is your take on immature skeleton, TTO in immature skeleton, around 15, 16-year-old boy?
15?
15, 16, yeah.
15, 16 is almost skeletally, you should treat it like a skeletally mature patient
But
only.
Pfizer line is still open and
15, 16, we consider everything in every aspect of, practice. 15, 16 is considered as skeletally mature patient.
Okay, what is your threshold age or the Pfizer line?
Mistake, I think, I mean, it goes same with the ACL reconstruction.
Okay.
No, the current guideline for doing the pediatric ACL is you need to assess with your endocrine friend that whether your child has crossed the peak growth potential or not.
Actually.
So peak growth potential usually a child tends to cross. Girls crosses a little earlier, boys crosses a little later. So 9 to 11 is where the peak growth potential is there. And the growing, I mean, the ends are only the femur, and the more the growth is there on the proximal tibia, distal femur compared to the proximal tibia.
Okay.
So the chances of affection of the growth in TTO is probably very less if you are doing it in the in 13 to 14 age group. So 13 to 14 is relatively safe, but I think you don't do in any 9 to 11 years.
Okay.
Of, so more or less rough guideline, but you need to assess all those hand
All
X-ray,
the things, yeah, yeah.
whether the child has crossed the pre-growth potential or not.
And if I reframe my question and ask the same question for trochleoplasty, then what is your take on?
Yeah, same. I think trochleoplasty is absolutely no if the child is skeletally immature.
Okay. Sure.
So I might, I mean, counsel the patient that I need to have MPFL, soft tissue MPFL currently, and this might require a revision surgery when the patient becomes, I mean, adult.
Sure.
So there's another procedure actually, the triple procedure that we use in pediatric, that's called the Roux Goldweight technique. So,
yeah, I mean,
so you can actually, as a distal procedure part, you can actually transfer the
realignment. Roux Gold is, I mean, for the
skeletally immature. So that works. It's a very standard procedure in pediatric patients.
Yeah. So I think Amrish has correctly said that the trochleoplasty is not a child's game. So that's why only the senior surgeons are allowed to do it, isn't it, Amrish? So I think, I mean, jokes apart, I think majority of the people are actually shifting away from the trochleoplasty because I think the complications are relatively high. The procedure is relatively a technically demanding procedure. But you do come across sometimes about some few cases where you think that probably this patient might need a trochleoplasty, particularly if you believe in the trochleoplasty procedure. I think if you look into this procedure, this is the MPFL is there, but I think it's attenuated. That is the majority of your patient with the MPFL tear, you will find this. But and the patella is laterally displaced quite significantly. But the most important thing what you need to understand in this situation is your trochlea is quite flat. You do not have any, I mean, the trochlear groove at all. So if this kind of flat, high-grade trochlear dysplasia, with where you are having a patient, you slightly worried that the only Chekren effect of the MPFL might not be sufficient in having this patient a long-term success. I think what you want is, Amit already has questioned about it, whether you require only MPFL is sufficient or not. But I think if your J sign is positive, that means each extension, your patella is subluxating laterally. So at when you are actually, the mechanism of patellar instability is at sudden point of degree of flexion when child jumps from any particular point, the quadriceps contracts very vigorously, and that leads to proximal and lateral displacement of patella. And at that point of time, if knee buckles, then probably patella glides through the lateral part. And if you have an central the trochlear groove is not there, then chances are high that that patella might glide laterally. So that's why probably you didn't need trochlear dysplasia correction sometimes. So I think if you quote the Digior's paper, he said that the trochlear dysplasia exists about 83% of patellofemoral instability. So that leads to my today's lecture, trochleoplasty indications, when and how. I think we need to understand this anatomy. This was described by the previous experts, speakers, so I will not go into details about the anatomy. I think but we need to understand that bony anatomy a little more detail. The trochlear groove is there, and it's probably the primary bony stabilizer, and MPFL are the primary soft tissue stabilizers. I think this, this classification we know since our childhood, that type A, B, C, and D is there by David Digior. I think, but recently he has come up with a new classification, which is probably a little better to interpret, and where he has said that there is a type 0, 1, 2, and 3, and in increased degree of severity, whether your sulcus angle is there or not, whether central bump is less than 5 millimeter or more than 5 millimeter. So I think, and another classification of trochlear dysplasia based on the lateral inclination is also there, but it's probably not that popular. And based on that, you can have the normal mild trochlear dysplasia or heavy trochlear dysplasia. So coming to the indications of trochleoplasty, there is no clear-cut indication. So that's why we really struggled even today when to do a trochleoplasty in which patients. But isolated mild trochlear dysplasia, I think MPFL works, and probably that is the majority of the cases of your patellofemoral instability. That's why people tend to think that probably only isolated MPFL is panacea for any sort of patellofemoral instability. So I think if you have an apprehension at 0 to 50 degree, or if you're in high grade dysplasia with lateral inclination of less than 11 millimeter with probably no degenerative change, then these are probably the ideal cases of trochlear dysplasia. And if you have an failed MPFL reconstruction and the CT scan, if you get this trochlear dysplasia, then probably you tend to think that this patient might have required trochlear dysplasia correction in the initial part. So I think that type of trochleoplasty, we know that the LB lateral facet elevation trochleoplasty is probably less known to a majority of us, and majority of us usually know that the de jure sulcus deepening trochleoplasty is more known to us. I think if you look into the technique of doing, you can see that this flat trochlea is there. Need to elevate the the synovial covering the suprapatellar patch, and you need to stitch this back once your procedure is complete. And then you need to start making groove just underneath your the trochlea. And what you need to understand, you need to keep a 5 millimeter of flap on both underneath this. So this flap should be 5 millimeter thick, and there are jigs which are there with which the bars are attached. So if you have the luxury of using that jig, then probably you can use the jig. So this is our present trochlear group, and then you need to draw your actual trochlear groove, where you need to make a new trochlear groove. And this is how I am using the arthroscopic burr and to make a flap. And once you make a flap, you should reach with the burr. You should reach up to the trochlea, distal part of the distal femur, and then trochlear groove. And once you do that, probably then you need to cut through at the point where your new trochlea should be kept, and then you need to put your flaps tied like this. And this is how your flap should be tied with this. I usually tie it with the suture only. I do not use any sort of anchor. And this is how your trochlea should look like at the end of your surgery. And then you close your wound after that. And the complications are the real reason why many people shy away from doing trochleoplasty. I think if you maintain the 5 millimeter sulcus, subchondral bone, David Duger in his paper has shown that there is very less chance of avascular necrosis of the flap. So that is the main complications. And probably complications of not doing trochleoplasty is probably even more. The patellofemoral arthritis is quite significant problem these patients tend to have 10 years, 15 years down the line. So I think this is one of the case example which this patient has patellofemoral instability. The patellar fragment was there, which has the long standing has turned round, and this is how this patient I mean, this is the J sign is also there. As you can see, the high grade of patellar dysplasia was there. Trochlea, this is the flat trochlea, and patellar aorta was also there in that patients. I think primarily we did this trochlear dysplasia correction and trochleoplasty, distalization of the tibial tubercle, and this is that patient. And 1 year down the line, as you can see, it has healed well, and there is no plasma. And the best, thing that this surgery is working, that this patient had the patellofemoral instability on the other side as well, and this patient came to me after 1 year to get his other side procedure done as well. So I think that's the one of the assuring finding that this patient is doing well with the trochleoplasty. So I think is rarely indicated. There is no doubt about it. But in high grade dysplasia, you can think about doing it, particularly if you are having an MPFL failure, and group deepening trochleoplasty is probably the way forward, and not doing anything is probably what in some certain situations. Thank you.
Okay. I just have one question for Sunita. What's
तू तो चेयरपर्सन था नहीं, तुमको जबरदस्ती बैठाए, सबको क्वेश्चन किए जा रहे थे आपसे.
नहीं, ये बहुत पर्टिनेंट क्वेश्चन है
बता.
कि ट्रोक्लियोप्लास्टी and MPFL, would you consider doing a trochleoplasty MPFL, or with all trochleoplasty would you want to add a TTO also?
No. I mean, TTO is completely different based on your CD ratio. If the CD ratio is 1.2 or more, then only TTO is indicated. Distalization I'm talking about.
But
and
medialization?
MPFL, no mediation, no medial. I don't do my mediation. I mean, because see, in the trochlear dysplasia correction, you can choose where you want to put your trochlear groove. Okay, so you can lateralize that part. So it's there in the mention how to do the trochleoplasty in Dijor's procedure only. So that way you can correct the TTTG distance. If you still think, because in trochlear dysplasia flat group, you don't know where your trochlear groove is. How do you measure your TTTG, whether it's
So that's the
increased or not?
question actually.
Yeah, so that we can we tend to lateralize it a little bit, so that the TTTG becomes normal. So we do not do the medialization procedure in any of our trochleoplasty cases. What we tend to, David Dijor in his lecture says that you do the trochleoplasty and then you track the patella. The patella tends to be quite stable. You don't need any additional MPFL reconstruction. But I think a majority of us, usually tend to add the MPFL in all trochleoplasty cases.
Thank you.
Thank you.
Sunil sir, in last case, the patella was coming in and jumping out. That was happening beyond 50-60 degree of flexion. The last,
no, not really. Not 50 to 60 degrees.
because in deep
Initial part only. I think you want to see. I think I'll show you.
Okay, so the next talk is on a very interesting topic, derotation osteotomy. Dr. Udipto Lodh will present.
I thank the chairpersons and the organizing secretary, Dr. Arvind Gupta sir, for this. So this is a controversial topic which has been entrusted to me. The problem is the recurrent patellar dislocations. We always try to manage with the MPFL reconstruction, which is the standard treatment. However, the unfavorable outcomes persist in some patients. And always the key risk factor is the femoral anteversion angle, which raises lateral force on the patella, risking the MPFL failure. And the proposed solution is obviously a derotational femoral osteotomy, which corrects the rotational deformity at the source, reducing the lateralizing forces on the patella. So this is a 21-year-old male, had a complaint of recurrent left patellar dislocation since the age 13. Now he's 21 years. And there was a positive patellar apprehension sign, positive J sign, increased patellofemoral mobility compared to the vis-a-vis the other knee. But the normal gait was seen and no hip pain preoperatively. So the Beighton's, Kujala, and the Lisham scores are given here. And the two dislocations and multiple subluxations in the last 4 years, and with a soft J sign we can see, and we can also see a significant tilt and a grind apprehension at 30 degrees. We do all the radiology and the imaging. We have ruled out other causes before deciding on any surgical. And the keton-to ratio is 1.2 in this case. And also we can see the TTTG ratio well under the 2 mark that we want. We checked the CT scan views also to get the femoral anteversion. And the pre-op imaging findings was the femoral anteversion was 44.99 degrees. The tibial external torsion was 33 degrees. The patellar tilt was 31 degrees, probably as a consequence of the femoral internal torsion. And the TTDG was 17.4 mm, so elevated, contributing to the instability. We stick the sulcus, it's a Dijo type C, and the LTI is also 21 degrees. So we have this entire thing given to us. If it's a femoral anteversion, we have a derotational distal femoral osteotomy, genovalgum, patellar tilt, everything is possible. However, we have to choose the surgical decision based on the findings that we have. So in our opinion, it was a femoral anteversion of 44.99 degrees, far exceeding the normal 15-20 degree range, which can be identified as the main cause of the patellar dislocation. And so we plan for 25 degree of rotation correction and fixation with a lateral femoral anatomic locking plate. As per any other procedure, the surgical technique involved diagnostic arthroscopy, lateral subversus osteotomy, an axial caver control to get the rotation corrected, and a locking plate fixation. And this was the immediate post-op results. And we can see the patella sitting properly in the trochlear groove in the skyline view. And since we used a locking plate, normal trauma implant, we could not get the plate to sit flush exactly in the anterior cortex as well. But the correction achieved was 21.47 degrees was a final femoral anteversion. The patellar tilt was again reduced and the TTG was also reduced. And this was the patient. So a patient who had who could barely walk in the pre-op, and he had a lack of confidence in all the activities that could participate in. He regained that confidence, and the patient is in a 2-year follow-up right now, and the patient is having no apparent complaints as of now. And might I add, in the MRI, the MPFL was there. It was slightly thinning, but it was still there. So we had thought of, if this did not intraoperatively did not give us the stability and the proper patellar tracking, we would have gone for an MPFL reconstruction as well, which we did not need to do here. At 3 months, the anterior knee pain significantly was relieved and the apprehension and J sign were negative. At 6 months, the patient was cleared for jogging, badminton, and two-out grade gradually normalizing. And at 2 years, there was no recurrence of patellar dislocation, and all the imaging parameters are apparently stable and normal as of now. So this is my submission. That promise. There are multiple papers which says the promising results follow derotational femoral osteotomy in patellofemoral instability. But the MPFL reconstruction alone cannot counteract the lateral stress from the femoral internal rotation exceeding 20 degrees. And derotational osteotomy might address the root cause and not just the soft tissue consequence. There are multiple systemic reviews as well, and this is one of the examples. Here they had a huge patient pool, 163 patient pool, both male, female. At the mean age was around 18, 28 years. And the patient had a long-term follow-up as well. And they could get like proper mean correction of around 20-25 degrees here, and with a huge improvement of the functional scores. And also we are aware that there are known complications of derotational osteotomies. There are non-unions, peroneal nerve palsies in one study. There is a patient with a loss of correction also in the follow-up. And there was one patient who had the anterior hip pain from the compensatory internal rotation post-derotation. And knee stiffness also was takes time to go away, which needs probably bouts of physiotherapy and encouragement of the patient. So the indications debate are still there. If the femoral anteversion threshold is more than 30 degrees or more than 20 degrees, where do we start with the thinking about the derotational osteotomy? So no consensus as yet. However, if the femoral anteversion angle is more than 30 degrees with a high-grade J sign, this patient is the strongest candidate for derotational osteotomy. And revision surgeries, the neglected FA has to be checked for before deciding on an MPFL or any other bony procedures, because this might be the cause of the failure as well. So the key takeaways is identifying the cause, always assess the torsional deformity of the full-length CT scan, and we have to treat the root. If the femoral anteversion is the cause, then we have to treat that. And we also have to watch for the hip. So the basic thing again is we have to get the train on the tracks rather than somehow managing to force the train on the tracks. And then we think of a check rim and maybe a trochleoplasty or maybe a tibial tubercle osteotomy. Thank you.
Thank you, Dipto, and thank
Thank
you,
you, Chairperson.
Chairperson. So we left with one panel discussion, and moderator is Dr. Bhushan Sabnis, sir. And the panelists are Dr. Sunit Hazra, Dr. Abhishek Gol, Dr. Teerth, Dr. Abhishek. Kindly join on the stage. Dr. Siddharth, please. And after that, there is 2 workshops. One is of meniscus, another is on rotator cuff. So those who wish to do hands-on workshop, can stay after that. And with the continuation of that, we'll have dinner also.
Can we get the screen down, please? Thank you. Can we get the screen? Okay, good evening all. I'm surprised so many of you are still here. So I think we heard a lot of it. Okay. Okay, so we'll just go through a couple of cases, guys. And once again, must have been covered multiple times here, but we'll come to that. Okay. So a typical patient profile is someone who comes with multiple episodes of patellar dislocation. They usually have undergone some medial plication, lateral release kind of surgery done, and you always see some valgus deformity. Now you decide whether you want to correct it or not. Not every valgus needs correction. You have few imaging studies that you need to see every time, and these are the things you have to have. So don't do any MPFL, any kind of surgery for patella unless you have the an MRI scan and you are able to measure TTTG distance, IS ratio, CD ratio, trochlear index, and trochlear morphology. So you want to see the type of the trochlea and the spur height. Anything else the panelists want to add? Anything else you want to do? So a CT rotational profile is not mentioned here. That
Scanogram also. Scanogram.
Yeah. So scanogram and CT rotational profile are a must before you start doing anything else. So this is a patient, mild valgus. We'll talk of valgus later. So this, we are talking about TTTG distance. So do you measure TTG distance on MRI, X-ray or CT? We'll start from the big guys.
Sir, MRI.
MRI
The
pe?
primary and CT. But
Okay.
primarily on MRI.
Anyone has a different opinion?
CT scan.
CT scan.
Yeah.
CT scan.
Okay. You?
Yeah, I do it in MRI, but if I'm doing CT, then I'll probably do it in CT. Otherwise, the majority of the cases is MRI.
Because the value of TTT distance is different on MRI and CT scan. So the higher limit of TTT distance is 13 on MRI, but 16 for a CT scan or X-ray. So remember that, guys. So this patient, the TTT distance is 9.5. But what is more important is this. So what ratios do we know of? We know the Insal-Salvati ratio, the Caton-Deschamps ratio, and the Blackburn-Peel ratio and the trochlear index. So what are the panelists' thoughts of using any of these techniques for measuring the patellar height?
CD is more sensitive, sir.
Okay.
CD 1.2 and IS 1.4 is my cutoff.
That makes sense. Anything different?
No, I'll go with CD.
So CD ratio is generally the preferred one. When you measure the ratio of height of patella from the anterior tibia and the whole width of the patella, and that ratio has to be around 0.9 to 1. If it's more than 1, that's considered to be abnormal. The Insal-Salvati ratio measures the width of the patella as a whole, not the articular surface, the whole of the patella, and the ratio of the ligamentum patellae length to that is measured. And if it's more than 1.2, it's considered abnormal. This is 1.5 and 1.2, so it's obviously abnormal. Now this patient obviously has recurrent patellar instability with a patellar height excess, but the TTG distance is normal. So obviously, okay, one more thing. The trochlear index is the superimposition of the patella and the trochlea, should be more than 0.5. If it's less, it indicates patella alta as such. So that's the rotational profile, and you can see there's some flattening of the trochlea. Now we just had a talk about excessive femoral neck anteversion associated with distal femoral intorsion. So what is the cutoff point for doing a derotation osteotomy? Anyone has any specific cutoff point?
Sir, I've never done it, but so far my understanding goes is 30-35 degree.
Okay.
No, I've never done it.
I don't have any guideline. Maybe more than 30, I think. Probably.
So 20 is the normal point. So that is 10 degrees of internal rotation. If it's more than 20 degrees of internal rotation, then that's generally considered to be a cutoff point. You can see the difference between the two knees. The other knee is about 3 degrees. So there's localized deformity only on one side, and the angle is measured between the posterior condyle axis along with the femoral neck axis, as you see on the other side. Okay, so options in this patient are now MPFL reconstruction and lateral release, a trochleoplasty and MPFL reconstruction, a TT transfer with MPFL reconstruction, or a TT transfer with distalization and MPFL reconstruction.
Four.
So everybody agrees it's a fairly straightforward case. So what we are going to do is you're going to take the graft, then you're going to do an osteotomy for the tibial tubercle such as this. I normally do the osteotomy from the medial side, so you can direct it posteriorly on the lateral side. So when you medialize the tibial tubercle, you are also anterizing it, creating some Mackay effect, because these patients always have some patellocondral damage. So that will offload that and you will get a good Mackay effect. Now, an important part when you're doing a TT transfer is releasing it proximally. I've seen a lot of surgeons just taking the distal part and moving it to one side. It has to be released from the proximal part. So you have to do a complete proximal release. And this is the only condition or only surgery where I do a proper lateral release. Does everyone agree with a lateral release with this? Otherwise, you can't move the tibial tubercle. A lot of time, the ITB also has to be released. So how would you do a distalization with this? Would you take off a bit of the tibial tubercle?
Around a centimeter.
Yeah.
Depending on the exact calculation of the distance.
So this patient, we have taken 8 millimeters of bone off from the tibial tubercle.
Your incision is very small.
That's enough normally. It's okay. So normally you don't need anything bigger than that. But so you need a towel clip to hold it. Every time you do a TT transfer, you need to release everything proximal and distally so that you can move the patella up and down medial laterally to show that you have released it extensively. And once you have taken the 8 millimeter off, you pull it down and you fix it with multiple screws. I have now shifted to putting 3 screws instead of 2 screws. With 2 screws, I found patients have some pain. If you put 3 screws, they are very happy. Does everyone do the same thing, or
3 screws?
3 screws are phenomenal.
Fully threaded screws.
3 bicortical screws, and you can make the patient start active range of motion very fast injured. And that's the distillation we have achieved. You can see where the original tibial tubercle was and how far it's come down. And that will essentially improve the tibial tubercle position and the patellar mobility as such. Now, on this image, you can see the 2 anchors are placed in the patella for your MPFL reconstruction, and the guide wire is at the shortest point where I will do a MPFL reconstruction using a standard system such as this. Anyone uses soft tissue technique only without putting anchors?
Yes, I do.
I prefer shortest point.
What do you do?
I prefer hybrid technique.
Okay.
A soft tissue procedure on the patella and screw on the femoral side.
So you put the graft on top of the patella?
Yeah, on top of the
and
patella.
stitch it.
And stitch it.
Periostal stitch.
Basket weave technique.
Okay. Anything?
In patella, I do 2 drill holes.
Yeah.
Here, loop the graft behind the lateral border of the patella.
Okay.
Or I take a tape and hold it in the tunnels via tape, which are tied on the lateral side.
So both are fantastic techniques.
But on the femoral side, I normally use a screw. Unless in immature, I have used anchors in an immature kit.
So this is my usual technique. I've done a decent number of cases with this technique. It works really well. We have published about it, and that's the kind of the graft position you want. You want an extra synovial position, extra articular position, exactly like this. You should see the imprint of the graft inside the knee and not the graft inside the knee. Otherwise, they get a lot of scarring. And if you do a good job, this is about 2 weeks from the surgery, 3 weeks from the surgery, the wound is healed and they're able to do everything nicely. So she had bilateral issue. I did both the sides, I think 1 month apart. And that's the side operated, I think 5-7 days back. And you can see she's still able to do a decent amount of range of motion. So that's her X-ray post-operatively. You can see it distalized. And this part, the distal part of the osteotomy always heals last. You always see a bit of a dimple there. That's a normal thing. Don't worry too much about that. As long as you got 2 or 3 bicortical screws, you are happy with this. So in any case of patellar instability, you always have to find the cause or the contributing factors and treat them specifically without worrying about the complexity of the case. Same, another case, exactly the same problem. These are the problems of instability, and this is 6 months post-op the same patient. So these are some of the happiest patients that you will ever get. They're able to do all the activities comfortably. They are very stable and they are able to go back to the normal life, which they have missed for quite some time because of a recurrent patella instability. A young chap, I think 16 or 17, this was done about 6 months before, 6 months before, and this video is about 6 years back. So he just came to see me a few months back saying that he recently got married at 22. Impressive. So that's the thing. Okay, one more case and then I think I'll wind up. So 14-year-old male patient, sorry, it's a female patient, my fault. First episode of traumatic patellar dislocation, but the knee is quite swollen. So it's not a happy looking knee, it's amazingly swollen. Anytime I see a massive hemarthrosis, I'm worried about
free bony osteocartilaginous piece.
fantastic, fantastic. So that's the MRI of the patient, and you can see the big cartilage, the whole medial facet of the patella is sitting in the lateral gutter. So that's a kind of fracture which, if not treated, will lead to very early arthritis in the patient. And secondly, it will also lead to recurrent instability because there's no stop for the patella to come out with a big defect such as this. I'll show you what. Now, as you can see, there is not much of cartilage inside. So that's the piece there. So nothing much is there. There's only cartilage and there is a big defect in there. Okay, what will you do? The options are fix. So first option is just take it off and don't worry about it. The nature will take its own course. Second is fix it with a screw or multiple screws such as this.
I do it with the Vicryl. I think Vicryl.
Yes, multiple sutures, Vicryl
I
nodes.
think everyone agrees to this as a technique. So options are multiple. You can do BMAX, stem cells for the defect. You can remove the fragment, do oats or mosaic plasty in future if required. You can fix the fragment with screws or sutures. But if there is no bone, screws will not work. The screws will just cut out and that it will lead to a complete failure. So the next option is to do a Vicryl suture fixation. So that's the fragment in question. It's a big defect there. You're trying to fix it back in the position. A lot of times you'll find that the fragment swells up when it's in the joint for a long time. So you might need to trim it to fix it perfectly. Then you fix it with a K-wire such as this. And the simplest thing you can do is use this, a straight needle on power to make multiple holes and use the same needle to pass Vicryl sutures through. So pass multiple sutures such as this. Our very own Dr. Goel has come out with a device for this as well, which I haven't used but seems pretty interesting. But exactly the same thing we are doing here. So multiple sutures in various configurations can be done. Essentially, you want 3 or 4 holes in the center, but multiple panning out sutures in the periphery. And that usually heals really well, despite just being cartilage, because the patient's age is only 14 and the blood supply here is very well preserved. So that's something that everyone should be aware of as a procedure. Would you do an MPFL or a medial plication or something with this normally?
MPFL, yes.
Okay, so and it's exactly the same. The opinion is divided amongst the board. Even internationally, people do either application, as I did in this case, works really well. I don't mind this. And you can see a nice stable patella with good tracking without any issues. Another case, exactly same. I did MPFL in this patient. So you can see the anchors, they're far away from the Vicryl. So there's no need to worry about, and that's the MPFL reconstruction done. Another case, exactly the same thing, MPFL reconstruction done. And you can see the fragment here. There is some bony part to the fragment as well. So as you can see, you can easily achieve a very good alignment of the joint by doing this technique. So this technique is something you should think of all the time. I'll just do one more quick case and I'll push off the. So fairly straightforward case. I think you just talked about all the problems that you saw in these patients. So similar looking MRI, but that's the CT rotational profile. Now you can see there is obvious excessive distal femoral intorsion. So this will be kind of an ideal case for a derotation distal femoral osteotomy.
Must be having valgus also.
Yes, so there is always some valgus associated. And the beauty of a derotation DFO is you can correct valgus at the same time. I don't know whether I've done it with this patient or not. And a key part of these kinds of patellae is that they dislocate in 60 degrees of flexion as well. So the dislocation doesn't happen in only 20 degrees of flexion. It also happens in slightly deeper flexion. Need a big incision such as this. You can see multiple K wires here. What we are going to do is this K wire and this K wire are going to come parallel when we rotate the distal femur with a derotation osteotomy. So we are going to make a complete osteotomy. That means I'm going to break the bone completely from lateral to medial, no hinge, nothing. But I'm going to do a biplane because that will help me in rotating the bone comfortably. You can see that biplane osteotomy is a double biplane as I call it. So it's a big lateral cortical chunk and then sloping to the medial cortex. Now, when you do that, you are able to rotate the bone like that. So this is called as a distal femoral derotation osteotomy, and you can get these two wires parallel. You always need something on the patellar tendon for tibial tubercle transfer, medialization, distalization. And that's obviously tracking nicely now, as you can see. And without doing the MPFL, now you add a MPFL at the end, and you can get a really good stable fixation in these patients. And they're generally very happy with their fixation. Now, a point you just made was a valgus correction. So this is the osteotomy which is parallel to the joint line. So you can put the same biplane that I took off on the lateral cortex and create a valgus correcting part of the osteotomy as well. So that's the post-op X-ray. I think I know I have some time, but I need to wind out. My flight is at 9:15. So can I?
Yes. Thank you very much. We'll take 2 minutes more.
Any questions?
Dr.
Please go ahead.
Dr. Sandeep Birari's birthday today.
Yeah.
So we'll do the cake cutting ceremony here.
Yeah, that's
Sandeep
very
boss,
nice.
please come on the dais.
Thank you, guys.
आ जाओ आप लोग आ जाओ कपिल आ जाओ आओ अभी गाना गाएंगे
क्या बात है गुड
आज केक खिला के वापस से फोटो करेंगे आने वाले सारे जोर से गाना पाइप पे
कौन सा गाना गाना बार बार ये दिन आए बार बार आए तू दियो हजारों साल हो हैप्पी बर्थडे टू यू हैप्पी बर्थडे टू यू
हम लोग सबको एक फोटो हो जाएगा हाँ बस बर्थडे बॉय को विश करिए स्पीकर पे देखिए राजीव बॉस का एग्जैक्टली सही टाइम पे फोन है आइए सबका एक ग्रुप फोटो भी हो जाएगा and after that we'll have this rotator cuff workshop आइए प्लीज आ जाओ कब आ जाओ everyone please everyone one case come up from the stage please for group photo please take out what you can Rajan please everybody
डॉक्टर पवन ज्वाइन ऐसा नहीं भाई क्षमा करती है मगर आप बताएं थैंक यू We will remember this day. Yeah, we will remember this day. तो याद रखिएगा.
So next session is rotator cuff workshop. So please stay here only, and after that we'll have dinner in the same hall. And I think snacks has already started. Those who want to take dinner, they can take the dinner also. And there is a rotator cuff workshop by Cyronics people.
So we'll be having rotator cuff repair workshop going on. So I invite Dr. Tabi Shukla to have his talk on case of delaminated cuff tear. Audiovisual team, can you please put up the presentation? Okay, Tabish, please. Can you please put up on the slides? Sides, please.
You people kindly come into the front, so we'll have better interaction. Manish, aajo. Rajan, come into the front. Akhil, come.
Please send me in WhatsApp, okay?
Yeah. So
Yeah, Tabish, please.
Let's try to wrap it up as soon as possible.
No issue. After your time.
So we'll start with the case of a delaminated cuff tear. We've got a 55 male, insidious onset pain, no trauma, nothing, no diabetic, conservative treatment failed, came to me in OPD. Examination showed restricted movements, no lag sign. These were his movements. Forward flexion was somewhere between around like 60-70 degrees. Abduction was also limited around 60 degrees. Pain was there. The conservative treatment has failed. And these are his MRI scans. The MRI scans did show degenerated cuff tears of both the supra as well as the infraspinatus. The subscap was normal, AC joint was normal, bicep showed some tenderness. So before going ahead with what I did, we need to revisit the anatomy first. Now have a clear look at this picture. This is how your supra and infraspinatus inserts on the GT. Contrary to popular belief, previously we used to think that GT is divided into anterior, medial, and posterior tuberosities. Supraspinatus is in the anterior half, infraspinatus is in the posterior half. That's not how it goes. The supra is gonna come and attach on only the anterior tuberosity and medial part of the middle tuberosity. That's it. It is your infra which is gonna wrap around the GT and from all the way posteriorly goes and inserts till the tip of the anterior tuberosity. A part of the infra always goes up till the biceps pulley. Now, what is superior capsule? Superior capsule is a static structure. It originates from the glenoid, inserts on the humerus. It is different from the tendon. So now attachment, look at this picture very carefully. Now, if you look at the picture on the left, the entire medial part, as pointed out by dotted line, is covered by your superior capsule. However, the part lateral to it is the part that is the attachment of the rotator cuff. So your static component is on the medial side. Your dynamic component, that is your rotator cuff, are on the lateral side. Now, what is the importance of superior capsule? If you look at this video, you will realize that after you've removed all the tendon and muscle tissue, your superior capsule is your primary restraint to your superior migration of the humeral head. This cadaveric demonstration clearly tells us the importance of superior capsule. Once superior capsule is resected, the superior migration of the humeral head is increased. Now, we also know from Sugaya studies that in a case of delaminated cuff, the superior lamina and the inferior lamina, they stain different, meaning they are different tissue. Both the laminas are not the tendons. So if you look closely at this MRI scans, in the first and second images, you actually could make out, in the middle image especially, you can actually make out that there is a superior lamina, there is an inferior lamina. Previously, we used to think that both these laminas are the tendons, but however, we should revisit the concept and we should think it like that the superior part is your rotator cuff and the inferior part is actually your superior capsule, which is most important superior restraint. So in this case, what did I end up doing? This is a diagnostic arthroscopy. I've cleared my rotator interval. This is the biceps tendon, type 1 degenerative slab. I just debrided it. This is your superior lamina. Now, this is your inferior lamina. We cannot afford to miss this finding because you have to make sure that we incorporate both the laminas in our repair. Now we'll go ahead with the repair in the standard manner. Since it is a big repair, I put in one anchor and then you could see here that I've already stitched inferior lamina differently. I'm passing just sutures through the inferior lamina, then I'll use the same sutures and then pass them through the superior lamina. This is I am taking control of the biceps because my tear is huge. I've got a very good biceps. So I always try to reroute the biceps and incorporate it in my repair to have better outcomes. After taking control of the biceps, you have to go and release the transverse humeral ligament so that the mobility of the biceps increases. And then using a whip lock knotless anchor by Ceronics, you can fix it up. Now, superior lamina repair, you can see the sutures, they are going through the inferior as well as the superior lamina. Take them and then put them in the knotless anchor in the lateral row, and this is going to be a final repair. Postoperatively, 5 months, the patient is able to do all these activities without pain, decent range of motion, and good strength. So the questions that needs to be answered is, does all delamination represent separation of cuff from the underlying capsule? Is superior capsule disruption the essential lesion that precipitates the full thickness tears? Should the individual layers be repaired separately to better recreate anatomy? And in the setting of large to massive repairable tears, should the capsule be reconstructed in addition to RC repairs where the capsule is deemed insufficient? I think the questions need to be discussed among the faculties, but there are none. Okay, thank you. Any questions?
The key point is the visualization of the delamination.
Yes, the key point is first the observing the delamination on your MRI scans, understanding the importance of the inferior lamina because it probably is your superior capsule. If you don't end up repairing it, a major part of the superior restraint of the humeral head won't be brought back to normal.
We will repair only a thin area of the cuff, and it will not prevent the superior migration.
Correct. So your outcomes might not be that.
So any key points in your visualization, which portal you will visualize through the delamination?
So first, after you have put in your scope through the posterior portals, did your standard diagnostic arthroscopy. Hopefully you are able to see your both the laminas through that. But at oftentimes, since it's a degenerative tear, the tear pattern might be haywire. Put in your scope in your lateral portal, and then you can visualize it end on and can try to make out.
That is the key
Always
point.
make sure you grasp the superior lamina, pull it up, and then put your scope beneath and have a good look.
If you have equal mobility, then you can do the same protocol like you.
Yeah.
Otherwise, you have to do a dual row repair, double row repair.
Otherwise, spend some time increasing the mobility of cuff. Try to go below the capsule and try to release it between the tissue and the glenoid. Try to release from the front, from superiorly, and then hopefully you can get it. If not, then as you said.
Then visualization, the mobilization and fixation. the
Correct.
cable creation. Thank you. So now I invite Dr. Abhishek Gaur, rotator cuff repair, single row vs double row.
So, good evening again. Myself, Dr. Abhishek Gaur. I work as an arthroscopy and shoulder surgeon in Rajkot, Gujarat. So, my topic is pretty much simple: rotator cuff repair, single row versus double row. So, we are just skipping this anatomy part because Dr. Tapis has explained it very well. So, etiology of the rotator cuff can be traumatic or degenerative. And we should always check before repairing rotator cuff, whether it is size, atrophy, location, extension, and most importantly, atrophy of the tendon. So clinical presentation of the rotator cuff repair is largely varies, which can be severe pain at the time of injury, more pain during night, pain with overhead activity, positive painful arc, and weakness of the involved muscle. This is very important because after some times pain can be decreased, but weakness will be persistent, and secondary adhesive capsulitis. So why do we need to repair rotator cuff? As we all know, rotator cuff are not definitely rudimentary structures, and a steroid cannot heal the cuff tear. So some of the important factors are night pain, pain with overhead activity, and functional loss of daily activity. In all those cases, rotator cuff repair is mandatory. But we should always consider age, expected activity level, retraction, and muscle atrophy. So surgery is usually ruled for the patient with 4th and 5th decade. In older patient with 6th, 7th, and 8th decade with chronic tear, we should consider conservative option as well as. But unrepaired rotator cuff tear may progress and becomes irreparable and progress to rotator cuff arthropathy. That would be disaster. So there are 4 important factors of rotator cuff healing that are footprint contact area, footprint compression, ultimate load to failure, and gap formation after rotator cuff repair. So single row versus double row. In single row, we just put a single 2 or 3 anchors directly on the lateral part of the footprint. 2 anchors. So we always need to check reducibility of the cuff. If it is nicely reducible, we don't need to put double row anchors. So this was repaired. Using 2 anchors directly on the lateral part of the footprint using modified Mason Allen technique. And footprint was covered nicely to the lateral part of the GT. And very good results with single row also. Sometimes we need to go for double row repair. So in double row repair, first anchor is put near cartilage, and second anchor, lateral row anchor, is put lateral part of the footprint. So this is huge tear, hardly getting to the GT. So throughout release was done and it was repaired using double row technique. 3 medial row anchor was put and 2 lateral row anchors. And it was reduced nicely at the end. So I would protect this kind of rotator cuff with abduction splint for 1.5 months. And results. So there are various studies showing comparison between single and double row repairs. Many studies are showing both have same results. Some studies are showing double row repair is better than a single row repair. So confusion is always there. Single bed versus double bed. But sometimes we don't need double bed. So then we come to principle of the cuff repair. That is anatomical restoration, tension-free repair. It is must. And tendon to bone healing rather than tendon to tendon healing in case of L-shape cuff tear. So single row, there is some advantage and disadvantage of both techniques. Single row is cheaper. It produces less time, but in more than 3 centimeters of the cuff tear, there's less strength with single row, and with poor tissue quality, there is high chance of re-tear, and accelerated rehab is not possible with single row. In double row, it comes with high cost and comparatively more time, but it is very good in more than 3 centimeters of the cuff tear, and there are less chances of re-tear, and accelerated rehab is possible. So take home message is small and medium size cuff tear, single row versus double row, there is no difference. Large tear more than 3 centimeters, double row should be considered. Massive U-shaped tear more than 5 centimeters, use margin convergence sutures to reduce it. And then I prefer single row repair, tension free repair. And for L-shaped tear, double row repair, tendon to bone for better tendon to bone healing. And subacromial steroid is not advisable for cuff tears. Some of the memory from my South Korea fellowship. Thank you for patience hearing. Any questions?
Any questions? So that is the key of any rotator cuff repair. It should be tension-free repair. You should have adequate footprint coverage.
Yes.
Contact area should be more.
Yes.
Then
see, it should be easily reducible. Like it is not like we are stretching this cup tissue and the bites are getting cut through. We should not do that.
So it's many a time chronic massive cuff tear displays too much up to the level of glenoid.
I would
yeah, you want to
I would always check for atrophy and fatty degeneration.
Suppose fatty infiltration is not there is no atrophy, only it's retracted.
Right.
But on pulling, it's coming to the its anatomical area.
Right.
But still, it's looking like it's tight, very tight. So what you will do in that?
I'll go for double row repair.
we have muscle sliding for that.
Muscle sliding is one of the technique in case of massive retracted cuff. And when you put the stitches and on pulling it, it's coming to the articular surface, but it's anatomical area, but it looks very tight. So in that case, you can medialize little bit up to 4 or 5 millimeters medialization by taking out the cartilage near the footprint area is okay. This much of medialization of the footprint you can do. Another very good technique, usually done by very expert surgeon like some of us, is the muscle sliding. Yeah, absolutely right. Anything else in such type of cases, if you feel muscle, you have fixed it, but it looks like tight. So anything else you will do in such type of cases?
See, I didn't get your
question. Tapesh.
Single.
It's going double row. Absolutely right. In such type of cases, definitely single row is the only option because you cannot take it to the exactly lateral side of your surface.
Yeah, then
but when you feel even with the single row, even with the medialization of your footprint of the rotator cuff, it's tight. It looks like I have not done ideally. So what you will do in such type of?
See, I always add bicep tenodesis or
biceps.
kind of
Biceps SCR. That is one of the technique and muscle tendon transfer. So there is lot of literature says tendon transfer protect your repair cuff at the same time. It's also enhance the chances of healing of your repair cuff. So whenever you feel your repair is very tight, just take the lower trapezius, just in your surgical area only, add with the either semi-T or peroneus longus, whatever you think. And it's hardly 10-15 minutes job only. Once you have done 1-2 cases, you will feel it's very easy. You just pass through this, your grasper through this posterior part and take out your this tendon and fix it.
Sorry to interrupt.
Yeah.
Sometimes I don't even do cuff repair. I only do bicep rerouting and lower trap transfer.
Yeah,
Excellent
absolutely right.
results.
Yeah, it's very good.
Definitely,
result.
definitely.
Lot of literature nowadays, this having support for tendon transfer as well as biceps SCR. Yeah.
Young patient, demand patients, you should go for tendon transfer if there is extensor lag sign and all.
Yes, sir.
Definitely. Compromised cuff repair, it is better to have tendon transfer than a
Tendon
compromised
transfer is
cuff.
better than compromised cuff repair. Yes. Any questions? Any more questions? Okay. Thank you for
Tomorrow we
presentation.
will be having more and more discussions on shoulder. Like.
Yeah, absolutely right. Tomorrow is the day for the shoulder. Yes.
This is just a starter only.
Yeah. It's just warm up. Yeah.
Tabish.
Last time war चल रहा था, लाइट बंद हो गई तो ट्रेन से आया हुआ।
सबसे तकलीफ वाला एरिया में उनकी फ्लाइट हर समय रात के 2 बजे 4 बजे है।
Abhishek.
इतना था कि अब जब भी BSc होगा तब भी सिर्फ इतना डिस्कस सकता है। अभी तो एक फर्स्ट टाइम ही है, very good lecturers and very good. And may I request our secretary, Bihar Orthopedic Association, Dr. Parveen Sahu, can you join us on this? Thank you all for staying here till almost 8 o'clock, and kindly please join us for the dinner. And tomorrow we'll start at 8 a.m. With reverse shoulder arthroplasty workshop. Dr. Amit Priyadarshi, he is exclusive shoulder surgeon at Amrita Hospital. He will be doing demonstrating this reverse shoulder arthroplasty. So kindly join us at 8 a.m. tomorrow, same hall. Yeah. And kindly join for the dinner, please.